Re-
भूर्भुवस्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात् ॐ भूर्भुवस्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात् ॐ भूर्भुवस्वः
A very warm good morning to all the delegates and the faculty members. We begin with our second day of EPIC 2022. We began our journey with the end mission of achieving a good score in the exams to come out with flying colors. And we'll continue this journey with our day 2 of EPIC 2022. For our first session of the day, I would like to invite our chairperson, Dr. Indrani Hemant Kumar, ma'am. We welcome you, ma'am. Ma'am is professor and head of the Department of Anesthesia at King Edward Memorial Hospital and St. Gothandas Sundardas Medical College, Mumbai. We welcome you, ma'am. Ma'am is a very known figure. She has done numerous publications in various indexed national and international journals. Ma'am is a very active member and she's in RSCP. We welcome you, ma'am. And thank you for taking out time despite not being in India and she's currently abroad. She still had taken out her valuable time to be available for this session. Thank you so much, ma'am. Can you hear us, ma'am?
Thank you so much for this kind introduction. It's my pleasure to be part of. I can hear you. Can you hear me?
Yes, ma'am, we can hear you.
Can you hear me?
We can hear you, ma'am. You're audible.
Can you hear me now?
Yes,
All right,
yes.
Thank you so much. Thank you so much for your, thank you. Yeah, thank you very much for your kind introduction. It's always my pleasure to be part of, this EPIC, what do you call, teaching series. And y'all are doing such a fantastic job and it's my pleasure to be part of this. And without any ado, I would like to start the session with the first lecture. It's a pediatric regional anesthesia session on neonatal emergencies. And this will be delivered by Dr. Anju Gupta. Anju Gupta is an assistant professor in All India Institute of Medical Science, New Delhi. And notwithstanding, she is interested in pediatric anesthesia and especially in regional anesthesia and airway. She's been awarded the Padma Kant Award, the Chandrasekharan Award, and she's received multiple best papers. And she has more than 130 publications and she's authored more than 30 books. And she's also editor of SAE Barrage Clinical Anesthesia, which has been read by so many of our students, and not just our students, all over the world, and Dosh and Dosh textbook. Again, a Bible for all our students. She's assistant editor of JOACP, and she has got lots of awards and rewards. Over to you, Anju Gupta.
Good morning, dear students. Today I am going to tell you something about the regional anesthesia in children. So there are various pain management myths which are associated with pain management in children. These include that infants have an immature nervous system and hence they do not feel pain. They have no memory of pain. Untreated pain can be innocuous in children, and children do not tolerate analgesics well because there are a lot of side effects. But what are the facts? Infants from post-conceptional age of 20 weeks have a functional pain system. The analgesic pathways are well developed and they do mount a stress response which may be more intense as compared to older children and adults. CNS shows a high degree of plasticity and untreated pain can lead to long-term neurobehavioral changes. NMDA mediated wind-up central sensitization is more pronounced in neonates, And dorsal horn inhibitory pathways are immature at birth, so pain sensitivity is in fact more. So there are some general principles which we need to keep in mind before treating pediatric pain. We must acquire experience and dexterity with regional anesthesia in adults before employing these techniques in kids. So if you have done almost 100 regional anesthesia in regional anesthesia techniques in adults, you may barge onto the regional anesthesia in children. We should be aware of the anatomical differences and pharmacokinetic differences between small child and adult. But the type of lock is only limited by the skill and interest of the individual anesthesiologist, and it does not pertain to the age, specific age of the child. And even premature infants are very well can very well receive any kind of block. So now coming to the anatomical, physiological and pharmacological differences. The dural sac terminates low down, that is L3 at birth. So we should be using a lower approach to a neuraxial block, that is preferably L4-5 to L5-S1. But the saving grace is that the two-fier line, which we normally use a landmark, that is the spinous process line, the highest point of iliac crest, it remains the same because the two-fier line passes low down in infants. Hence, we can use that as a reliable landmark in this population also. The subarachnoid space is narrow, hence we need a greater precision and we need to avoid the lateral deviation. Coming to CSF, the CSF as a percentage of body weight is greater in infants. So the total volume of CSF is 10 ml per kg in infants as compared to 2 ml per kg in adult. So the end result is that the drug gets diluted into a larger volume of CSF, hence we need to inject more drug. The CSF hydrostatic pressure is less, that is 30 to 40 millimeter mercury. So in case we are planning spinal anesthesia, the CSF reflex may not be there, and hence negative spinal is very common in this age group. So larger dose of local anesthetics is required, but the effect is shorter lasting. The meninges are very vascular, and that is the reason of rapid reabsorption of local anesthetic and shorter duration of block in this population. Endoneurium is loose, hence the drug can diffuse in and out very fast. So there is a faster onset and offset of the block. The spine and ligaments are less dense, and the feel of loss of resistance may be less pronounced. The increased spinal flexibility limits the thoracic kyphosis and decreases the cephaloid spread. Lamina are cartilaginous, so we should avoid the paramedian approach in young infants, especially at all cost. Physiological differences, CSF, the advantage of neuraxial block in this population is that the hemodynamic suppression following any kind of neuraxial anesthesia is absent in smaller children, at least up to the age of 5 years, due to a smaller peripheral blood pool, immature sympathetic autonomic system, and compensatory reduction in the vagal efferent activity. Respiratory system, high level of block reduce the outward motion of the rib cage and may lead to paradoxical respiratory movement in children. However, as we all know that children are mainly abdominal breathers, and hence the diaphragm compensates for the loss of rib cage contribution in most of the cases. Physiology, there is a decreased minimal local anesthetic concentration which is required to block the nerve impulse because the nerve fibers have a smaller diameter and a shorter internodal distance. Nerves have a thinner myelin sheath. Hence, adequate surgical block can be achieved with smaller concentration of local anesthetic. Hence, even a 0.25% concentration of local anesthetic like bupivacaine can result in motor block. Coming to the pharmacology, a very important consideration in this age group is that there is an increased risk of toxicity with local anesthetic because of an immature hepatic metabolism, increased total body water leading to an increased volume of distribution and longer elimination half-life. The proteins or plasma proteins are less, so there will be more drug in free or active form. And there will be increase in blood level, rapid increase in blood level because of the higher cardiac output. Hence, we need to strictly follow the maximal dosing guidelines which have been recommended. And long-acting local anesthetic like bupivacaine, levobupivacaine, ropivacaine are commonly used in 0.2 to 0.25% concentration in this age group, which will provide 6 to 12 hours of postoperative analgesia. So the commonly used additives and recommended doses in this pediatric regional anesthesia is morphine is very commonly used as it provides a long-lasting analgesia. Morphine is used for in doses of 30 mics per kg for epidural or caudal use, up to a maximum of 50 mics per kg, and intrathecally up to 10 mics per kg. Fentanyl is used epidurally in 1 to 1.5 mics per kg. Then sufentanil is not available in India. Clonidine is available. Clonidine can be used in the doses of 1 to 1.5 mics per kg. And ketamine is used can be used in 0.5 mg per kg only by caudal route, and it can be used for peripheral nerve blocks, but it should be preferably preservative free as ketamine. We should remember that in younger infants, that is less than 6 months, we should avoid any kind of adjuvants. Recommended devices or equipment. Spinal anesthesia, we should use 24 to 25 gauge smaller length needles like 30, 50 or 100 millimeter long. This 30 or 25 to 30 is used for infants. As an alternative, neonatal lumbar puncture needles of 22 gauge have been used in literature, or Vitakre spine needles have also been used. Caudal anesthesia, generally short needles, that is 25 to 30 mm needles, and short beveled needles should be used, which are safer. And needles with stylet should always be used because there is a risk of epidermoid tumor if a skin tag is dragged inside. However, people have used IV cannula 22 to 18 gauge, especially in case we want to insert a epidural catheter, and occasionally pediatric epidural needle have also been used. Epidural anesthesia, Tuhi needles are used, but smaller gauge and smaller length Tuhi needles are used. Like 19 gauge needle is commonly used for infants in the length of 5 centimeter. Then as an alternative, Crawford needle, Vitakre and Sprotte needles have been used. Appropriately sized needles have been used. Coming to small information on spinal anesthesia, though it is less commonly used, it is also important mode of anesthesia in certain group of pediatric patients. Spinal anesthesia, as we all know, was introduced by August Bayer in 1898, but his first case was also a child, 11-year-old, with a thigh tumor, where he first gave the spinal anesthesia. After this introduction, it was extensively used in pediatric patients, and by 1933, it was even used for pediatric thoracic procedures. However, with the introduction of better general anesthesia technique and equipments, this technique went into disuse. Now, in 1984, Abejayan et al. Introduced it as an alternative to general anesthesia for high-risk preterm infants, because we all know that high-risk preterm infants are very much predisposed to apnea and respiratory depression. So, however, it is not used so extensively and openly in this population because of certain problems and concerns. Technical difficulties are there, they are very common. There is increased risk of bloody tap, and failure rate is as high as 1 in 5. There is a limited duration. Most of the cases, it is less than 60 minutes. There is a need for sedative in this population because their cooperation is unlikely to be obtained. Hemodynamic instability is less of a concern. In fact, hemodynamically, they remain most of the time stable. But in older children, this can be a concern. Total spinal block can be a concern. Then PDPH and neurological symptom meningitis remain a concern. However, we should know that all the complications, all kind of complications are less common in children. Spinal anesthesia in preterm infants. This is one population where in today's literature also spinal anesthesia is being advocated. So spinal anesthesia is an advocated technique for ex-premature infant less than 6 months of age, for lower abdominal surgery, which are expected to last less than 90 minutes. because of the increased risk of apnea, which has been found to be less with spinal anesthesia. In premature infants who are less than 44-week conceptional age, the incidence of apnea is as high as 30 to 40%. And the risk include anemia, preoperative anemia, hematocrit less than 30, post-conceptional age less than 44, but some say that it is up to 60 weeks. Then low birth weight, history of apnea, BPD, and use of GE or sedation. What are the possible causes of apnea in this population? Immature respiratory musculature and central control mechanism, unstable elastic cage. They are prone to upper airway obstruction, and lower airway is prone to collapse, or they are prone to hypothermia and anemia. So the usual doses of local anesthesia used in children, bupivacaine is the one which is commonly used in literature, and in doses of up to 0.5 to 1 mg per kg. And the effect is supposed to last up to 65 to 75 minutes. From infant to adolescent, the dose of bupivacaine is generally 0.3 to 0.4 milligram per kg. The adjuvants commonly described include clonidine 1 mic per kg, fentanyl 1 mic per kg, morphine 4 to 5 mics per kg. Now coming to patient preparation, the infant should be fasted similar to that we do for general anesthesia. Topical local anesthetic is desirable, and even amlacrene can be used in term neonates. We can give a pacifier coated with dextrose. Then a lateral or sitting position, both can be used. Sitting position has advantage of higher CSF hydrostatic pressure, which can give you a CSF reflex easier. Then 25 gauge Quincke needles are used, and bupivacaine in the dose of 0.08 to 0.1 ml per kg is used. The duration in neonates is expected to last 20 to 60 minutes only. So single injection is not suitable for complex procedures. Now coming to the commonest regional anesthesia technique used in children, that is caudal epidural. The first person to describe the technique was Meredith Campbell in 1933. So caudal block is nothing but the sacral epidural procedure. It is the sacral approach to the epidural block. Why it is so popular in this age group? Because it is very easy to perform. It is easily adaptable even to the ambulatory anesthesia practice. It can be used for catheter insertion for up to thoracic level, and anatomy is easy to identify. So the advantages are that it is simple, inexpensive, it is very easy to learn. We only need a syringe and a needle. We do not need a complex equipment to perform the block. So it can be easily performed in low resource settings. It is safe, hemodynamic stability is there, it is feasible when approach to epidural space is contraindicated, and catheter technique is also feasible even up to thoracic levels. However, the disadvantages are that there is wide anatomical variation in sacral bone. High failure rates have been described with the landmark technique. However, this disadvantage has been overridden by the use of ultrasound, where success rates of more than 95% are easily achievable. Risk of infection, meningitis, sacral osteomyelitis, abscess have been described. Then risk of dural puncture, especially in neonates, is there. And because the tip from the distance from the needle to the dural sac is very low, it is in some millimeters. So accessibility to the caudal area may be compromised in certain conditions, and we need higher volume of local anesthetic for certain procedures. So this is the very famous formula by Armitage. This is basically modified Armitage formula, where the doses of 0.5 ml per kg can be used for lower extremity and perineal surgery. A dose of 0.75 ml per kg is suitable for block up to T10 level, and 1 ml per kg has been used for lower thoracic level. So the landmark technique, we always need to use proper sterile precautions. Then chlorhexidine solution can be used for skin preparation. It is ideal. So one of the ways to identify this sacral hiatus is to place the middle finger and the thumb on the two posterior superior iliac spine. which form the base of a triangle, and when the index finger will be placed in a equidistant manner, then it will rest automatically on the sacral hiatus to form the complete equilateral triangle. However, remember that in younger children, the triangle may not be exactly equilateral. It may be an isosceles triangle. So now we should insert the needle at an angle of 45 degree to 60 degree to puncture the sacral hiatus at its apex. Then once we get a pop or the loss of resistance, then we need to lower down the needle to a flatter angle, and then we need to advance the needle. Be very careful to advance it only for 2 to 3 millimeters, so that there is a less chances of puncture of the dural sac, especially in neonates where the dural sac is low down. So in ultrasound era, we can identify the sacral hiatus. This is the sacral hiatus in a transverse plane. It forms a frog's eye. Now this is the sacral hiatus in a longitudinal plane, that is the sagittal plane, and this is the sacrococcygeal membrane, and this is this beak-shaped space. This is the caudal space, and we can do the needling from using in-plane approach from caudate to cephalad. In this direction, we can do the needling. I'm sorry. So this is basically the ultrasound guided caudal approach. These two mounts, these are the sacral cornuae. The membrane which is bridging is your sacrococcygeal membrane, and in this is the longitudinal in-plane approach where the needle comes from caudate to the cephalad direction. Okay, now coming to the another commonly used block in this population, that is the epidural block. Epidural anesthesia remains or analgesia remains a popular modality for intraoperative and postoperative analgesia in children for major abdominal surgeries. This technique is similar to adults, but there are certain differences. That is, one, the depth of epidural space is very, very small. So we just need to engage our needle into the interspinous ligament, and then immediately we should start using the LOR syringe to identify the space. Otherwise, we will directly land into the dural sac, which is low down in this population. Then midline approach is preferred as the lamina are cartilaginous. Ligaments are thinner, hence the appreciation of LOR may not be very concrete. So we may land into dural puncture. Administration of anesthetic at the midpoint of the dermatomal area is the most important determinant of getting a good analgesia. Hence, we should know what level of dermatomes would be required for the surgery, and we should choose the level appropriately. LOR syringe using saline is preferred in this age group. Though using air, the LOR becomes easier to identify. But the use of saline with air bubble technique is a balance of the two techniques, and it has also been recommended to be a safe and effective technique in this population. So most important thing about epidural block in children is knowing that the depth of the epidural space is less. It is very less. So what is the depth? What is the approximate depth of epidural block? The epidural space depth is approximately 1 mm per kg. So we also need to know what amount of local anesthetic is required for a particular surgery. For this, we need to choose the dermatome level. We need to know the dermatome level for which the incision will be given, and then at the midpoint of it, we will select to place our block needle. Most of the times, the half of the drug goes up, or say half or 60%, and then rest of it goes down. Accordingly, we will calculate for the number of dermatomes required. More than 10 years of age, the volume which is required per segment is 0.1 ml per kg per year. And for less than 10 years, the volume required is 0.04 ml per kg per segment. Another important consideration is the test dose. The test dose required is 0.1 ml per kg of lignocaine with adrenaline, 1 in 2 lakh. So adrenaline dose is most important, as the children will mostly be under general anesthesia, and we will only be able to identify the vascular puncture. So the dose for adrenaline is 5 mics per kg adrenaline. Now the usual doses of bupivacaine, I have told you about the doses in ml per kg per number of metameres, but there is another way. Less than 20 kg, the dose recommended is 0.75 ml per kg, and more than 20 to 40 kg, the dose has been mentioned as 8 to 10 ml or 0.1 ml per year per number of metameres. So the agent used is bupivacaine most commonly, or nowadays ropivacaine 0.2% is also used. So bupivacaine with 5 mics per ml of epinephrine can be used to prolong the duration of block because the space is very vascular. So for continuous infusion, we need to know that for infants less than 4 months, that is 3 months till 3 months, the dose is 2.2 ml mg per kg per hour, and the we should or if we can use bolus doses, that is 0.1 to 0.3 ml per kg every 6 to 12 hours. So for more than 18 months, we can use a higher dose for a longer period. For smaller infants, we should generally limit the continuous infusion to 36 hours and not beyond, because there will be accumulation. Adjuvants used infants less than 6 months, we should generally avoid, and we should generally use only one additive in a particular case. Morphine is the most commonly used adjuvant, which is used for epidural anesthesia in the dose of 10 mics per ml, or it can be used for 25 to 30 mics per kg every 8 hourly. Clonidine can be used 0.3 to 1 mic per ml, fentanyl 1 to 2 mics per ml. Okay, so complications are general complications which are there with the all epidural blocks, like respiratory depression with the use of opioids, damage to the neural structures, PDPH, epidural hematoma, paraplegia. Though these complications have very rarely been encountered in this population, complications may be higher, however, in infants who are less than 6 months, because the caudolumbar thoracic catheters are supposed to be better. In fact, instead of the cranial approaches, the caudolumbar thoracic catheters are better, because as we know, all the anatomical changes are more pronounced in this population of younger infants. So the space will be more vascular, the dura and the cord will be more low-lying. So these approaches are generally performed by selecting the caudal route. Now, there are those central neuraxial block remains a very popular block in this population. With the introduction of ultrasound, especially, we are moving more and more peripheral, because most of the large series of regional anesthesia in children, they have documented a very minimal or in fact absent complication with peripheral nerve block, and any kind of complication which have been reported are mostly for the central neuraxial block. Hence, peripheral nerve block are a boon in this population. There are certain, in fact, indications in certain group of patients where peripheral nerve block would be preferred over central neuraxial block, like patients who have coagulation disorders, children who have had spinal laminectomy or dysraphism, or in settings with limited post-operative monitoring or analgesic options, because a peripheral nerve block can be used very safely, and it is a safe way to improve pain control. There is with a single shot block also, there is a prolonged post-operative analgesia. In patients who had post-spinal fusion with instrumentation, central neuraxial blocks are generally not preferred. And there are many infants who present to us with a lot of anomalies like Vater syndrome, where hemivertebra or other kind of vertebral anomalies will be there, and we need to avoid central neuraxial blocks. So if you ask me today whether there is whether this central peripheral nerve block, is there any surgery where it cannot be employed? To my knowledge, almost all surgeries in infants, barring one or two, can be performed using peripheral nerve block, because peripheral nerve any site of the body nowadays is amenable to any to one or more kind of blocks. So nowadays, in fact, in peripheral blocks also, we are going on to more and more specific and distal peripheral nerve blocks instead of the more proximal nerve block to provide site-specific regional anesthesia. So the commonest blocks which are used in this population are brachial plexus block, femorosciatic block, popliteal adductor canal, lumbar plexus blocks, erector spinae block, penile block, intercostal block, peripheral nerve block, paravertebral block, TAP blocks. So almost all sites of all surgeries are amenable to regional anesthesia. We should always try to use the appropriate type of equipment, the smaller peripheral insulated needles, then hockey stick probe for smaller in neonates and infants, smaller syringes, so that we can be precise in dosing. So we should always go for age appropriate equipment. So ultrasound has definitely revolutionized the pain management scenario in children. Why? Because we have now unlimited option of providing pain relief to children. And it is now coming up in a big way, and its use is definitely inevitable in coming times. So ultrasound results in a lower local anesthetic dosing, increased block efficacy, more preciseness of localization of the structure, and decreased vascular puncture. All of these are very desirable features for pediatric regional anesthesia. And as you can say, central neuraxial blocks are increasingly the central neuraxial blocks are now increasingly going away in favor of the peripheral nerve block. Earlier, there used to be very low number of peripheral nerve blocks as compared to the neuraxial blocks. Now they are almost equally used. So one important concern for pediatric regional anesthesia is that we will be performing most of the blocks in either heavily sedated children or in under general anesthesia. So there was a concern that the nerve structure may be damaged under anesthesia. However, with large series, this concern has been unfounded, because there have been very low complication under general anesthesia. And in fact, the complications are 7-fold more in the awake group. In the children where the blocks were performed awake, because of the lack of cooperation from children and unrestrained activity and movement from children, the risk of neural damage is even more. Hence, we need not worry about performing these blocks under general anesthesia, and they are very safe. So coming to local anesthetic doses, generally we should try to use the lowest concentration and lowest dose for a particular block. Though there is still not a very specific guidelines on this. There are many articles which describe the block, and for most of the blocks, the dose ranges from 0.1 to 0.3 ml per kg. So we should always try and limit ourselves to the well below the toxic recommended doses. So what we should do is first calculate the maximum permissible dose, and then divide that then we should go for the lowest possible local anesthetic dose or volume with which we can successfully perform the block, and we should use the lowest possible concentration also, so as to limit the total local anesthetic volume, because local anesthetic toxicity is a very big concern, and there have been very unfortunate reports of even local anesthetic toxicity related deaths also in this population. So we should never take these blocks very lightly, and we should always limit the total dose. So we should use the lowest possible concentration and doses by always calculating the maximum dose first and going and selecting for the lowest possible concentration. So in pediatric population also, like in adults, lipid emulsion is the specific antidote, and the dose is more or less same. It is 1 ml per kg over 1 minute, and we can repeat the dose up to maximum of 3 ml per kg to a maximum total dose of 30 ml per kg over 30 minutes, 10 ml per kg over 30 minutes, and maintain an infusion of 0.25 ml per kg per minute until the circulation is restored. So coming to some common blocks, brachial plexus block is very commonly used, and among the brachial plexus, the axillary approach is the most commonly used because the complications are supposed to be the least, because the pleura is not there, so pleural puncture risk is not there, and the pleura is higher up in infants. So this is one very safe approach. Interscalene and supraclavicular approaches, however, provide better analgesia for upper arm and shoulder, and they, with the advent of ultrasound, even these can be used safely. So complications, we need to be aware of pneumothorax, hemidiaphragmatic paralysis, and subarachnoid blockade. So coming to supraclavicular block, the procedure is more or less same with ultrasound. We need to visualize the nerve trunks cephalo anteroposterior to the subclavian artery, and the difference is that the nerve structures, they are more hypoechoic because of lack of much connective tissue, and there will be very, very superficial. You can see within a centimeter most of the brachial plexus will be located. Dose is about 0.3 to 0.5 ml per kg of 0.25% bupivacaine. So some complications are there which we need to be cautious even in adults. Duration will be 8 to 12 hours, which can go up to 24 hours even with the use of adjuvants like clonidine and dexmedetomidine. Distribution is basically, the divisions are blocked with this approach, and it reliably covers almost all upper extremity. However, it spares the suprascapular nerve and may provide incomplete shoulder coverage. However, we should always be very, very cautious of vascular puncture in this age group, because there can be very many accessory and unexpected vessels in our pathway. So we should always use Doppler and check and rule out. Coming to interscalene block, those shoulder surgeries are less common in this age group, but still they are performed, and then clavicle surgery also are performed. So in this these kind of surgeries, the interscalene block is the most useful. So here the nerve roots are blocked, and there is a increased risk of interscalene block under GA. There was a concern of risk of nerve damage with the use of this block under general anesthesia. However, even for interscalene block, the latest ISRA guideline, they have said that it is safe to perform this block in this population in children, because there is a very low risk of complication. However, the risk of hemidiaphragmatic paralysis is still there. So children where there is a bilateral lung pathology or other contraindication, we should be careful. Then femoral nerve block is another common block which is used in this population for surgeries on anterior thigh, femur, patella, knee, hip fractures in the dosing of 0.2 to 0.4 ml per kg. So nerve lies below the fascia iliaca, and it is basically covers the anterior medial thigh, knee, medial leg and foot. So surgery on hip, knee, ankle joint, it is used for analgesia. So coming to another common block, that is popliteal sciatic block. This block is used for most of the foot surgeries. So the foot surgeries are commonly performed in this age group is for club foot, which is a common surgery in this age group. So this is a useful block. So it is commonly combined with saphenous nerve block for complete analgesia for any surgery below the knee in the dose of 0.3 to 0.5 ml per kg. The complication being intravascular injection, nerve injury, and the duration is 8 to 12 hours. This, however, with ultrasound guidance, the risk of nerve injury is very, very low. So this is the femoral nerve which lies beneath the fascia iliaca and just next to the femoral artery. So it is a very, very easy landmark to identify with ultrasound, and in-plane needling can be done. Popliteal sciatic block we have spoken about. Now coming to ilioinguinal and iliohypogastric nerve block, this is one of the commonest peripheral nerve block performed in this age group because hernia is a common surgery. So it is performed similar to adults. The muscle layers are identified, that is the external oblique, internal oblique, and the transverse abdominis. And ilioinguinal and iliohypogastric nerves, they lie between the internal oblique and transverse abdominis, they can be identified next to the circumflex iliac artery, and it can be blocked in plane from lateral to medial. And ASIS, that is anterior superior iliac spine, remains a reliable landmark in this area. So basically, three landmark guided blocks were done earlier using fan-shaped injections. However, nowadays ultrasound is increasingly being available, so we can just visualize these nerves running between running this in this plane, TAP plane, at this level, and we can give the injection directly next to the nerve. Now, another commonly used block is the TAP block, which can be used in various approaches. The commonest one being the lateral TAP approach, where the injection is a facial plane block, and the injection is performed in the facial layer between the internal oblique and the transverse abdominis. And this is the local anesthetic which has been deposited by using an in-plane needling. This is the needle coming from in-plane, from anterior to posterior. So the local anesthetic is deposited here in a lenticular manner, and it is suitable for most of the surgeries around and below the umbilicus. So the duration is around 8 to 12 hours, and the complications are very, very less, like peritoneal anterior bowel injury. They are rarely reported. Then another facial plane block which is used is rectus sheath block. Rectus sheath block is a useful block for midline surgeries like midline laparotomies or umbilical hernia. It is a very useful surgery. So it is a good option for midline abdominal surgery. Here the injection is performed between the rectus muscle and the posterior rectus sheath. So the dose of 0.1 ml per kg on each side is sufficient, and the duration is 8 to 12 hours. Coming to another common block, that is the infraorbital nerve block. It anesthetizes the part of the lower lid, upper cheek, and part of the nose and upper lip. So the surgery where it is used commonly is the cleft lip surgery. So it can be done with landmark guidance. It is quite a successful block using landmark guidance because the landmark is very easily palpable between it is in the straight line between the pupil, the ala, and the outer angle of the lip. So in this straight line, you can palpate this infraorbital foramen, and we can just inject 0.5 to 1 ml of bupivacaine on each side, 0.25%. One buccal approach is also there, which you can go through. Recently, ultrasound guidance has been described, which provides a safety against the vascular puncture, which commonly happens here. We identify the foramen and we just inject the drug here. Then another approach, another technique which is commonly used is the penile nerve block. Penile nerve block is very useful block for surgeries like superficial surgeries like circumcision or myotomy. It provides analgesia for the distal dorsal nerve of penis for the distal 2/3 of the penis, for all kind of surgeries on the distal penis, including hypospadias and the circumcision myotomy. And the landmark guided approach, the subpubic approach, or at the base of the penis, these approaches are also very, very successful. But recently, ultrasound guidance, as it has invaded to all kind of blocks in pediatrics, even this block also is being done by ultrasound guidance. This is one of my images where a child with congenital heart disease, we performed solely under sedation and this penile nerve block. So this is the local anesthetic which is deposited under the buccal fascia. So now coming to the new block, new kid on the block, that is the erector spinae plane block. It is the nowadays the most fancy block which is in vogue, and it has been described for almost all kind of truncal surgeries, and even nowadays it has been described for for the lower limb surgery. For the limb surgeries also it is being described, like hip surgery. So this is the in-plane needling which is being done, and the local anesthetic is deposited from either craniocaudal or from caudal to cranial, and it blocks several dermatomes. This is the needle coming in plane. So it blocks several dermatomes at one go. And so it is suitable, the dermatomal level can be selected depending on the type of surgery, and So we can make the injection at the midpoint of the dermatomes. Sorry, at the midpoint of the dermatomes, we can make the injection. So initially it was described for rib fracture, some thoracic neuropathic pain and abdominal surgery. Nowadays, even hip surgery, pelvic surgery, cervical surgery, all kind of surgeries it is being used, and even sacral approach has been described recently. The main advantage is that there is a reliable landmark of transverse process, which is a very easy landmark with overlying 3 muscles at the level of thoracic level. We have 3: trapezius, rhomboid, and erectus spinae. These muscles can be identified, and in-plane needling can be done from either cranial to caudal or caudal to cranial. And the injection can be, it has a very good safety profile as compared to the thoracic paravertebral, which was performed earlier more commonly. This approach is more superficial, less invasive. The paravertebral space is much deeper and it is closer to the lung pleura. So the chances of pneumothorax and other complications are much less with this approach. And it has been found to be equivalent to deeper approach like paravertebral block in many surgeries. So the target is the facial plane deep to the rectus spinae muscle above the transverse process, and the complication obviously are very rare, and duration is likely to be at least 8 to 12 hours. However, I have found that the analgesia lasts up to 24 hours if you use adjuvants like clonidine or dexmedetomidine, and at least the opioids are avoided. We can manage the post-operative pain with things like this PCM and diclofenac or ketorolac. Non-opioids can conveniently manage the pediatric pain with the use of block like erectus spinae plane block. So the points to ponder regarding regional anesthesia in this population is that we should always choose the most appropriate age-appropriate equipment and needles. We should use the safest route, drugs, and doses. We should always obtain informed consent and assent from the parents and the child who is suitable age, that is more than 7 years, before barging onto any kind of regional anesthesia. We should always wait for the onset of block before we allow the incision. Then we should inject after careful aspiration. We should always keep intralipid handy. It has been said that wherever you are performing regional anesthesia, you should know the location of intralipid in your OT. Then we should document all the blocks, and we should always timely audit regarding any kind of complication which have arisen due to the use of regional anesthesia in children, so that we can establish the safety norms and we can improve the practice. And we should always keep ourselves abreast with the latest literature. Thank you very much. So I would conclude by saying that the pain is inevitable and suffering is optional. We should always try to give our best to this vulnerable population, and we should not shy away from regional anesthesia in this population. But only requirement is good skill and knowledge and a dedication to do your best. Thank you very much, and wishing you all the best for your exams. Thank you.
The question answers will be taken up at the end of the session. You can introduce the next speaker. Indrani ma'am. Ma'am, you're mute right now. Your video is closed. You can introduce the next speaker. We can.
Anju, that was in-depth presentation on regional pediatric.
Thank you so much, ma'am.
That was a very in-depth presentation. Thank you very much. Right now, I don't see any questions. We move to the next. Yeah. Can you hear me?
Yes, ma'am, we can hear you. Yes, ma'am, you're audible.
Can you hear me?
Yes, ma'am, you're audible.
Can you hear me?
Yes, ma'am, you are audible, ma'am.
Can you
We are
hear
audible,
me?
ma'am. You're audible, ma'am. We can hear you.
Can you hear me? Can you hear me?
Yes, ma'am.
तो म्यूट नहीं है
नहीं, नहीं.
Okay. Okay, I'm audible. Thank you so much, Nitin. Okay. We move on to the next. We move. Yeah, thank you, sir. Thank you very much. Yeah. We move on to the. We move on to the next. We move on to the next presentation, which is on neonatal emergencies, and that would be rendered by Dr. Anshu Gupta. She's an associate professor in Lady Harding Medical College, New Delhi, and she's interested in pediatric anesthesia, USG guided nerve blocks, and CPR. Over to you, Anshu.
Good morning, everyone. I, Dr. Anshu Gupta, Associate Professor in Lady Harding Medical College, would like to thank Dr. M.D. Kaur ma'am and Dr. Nija ma'am for giving me this opportunity to speak on such an important topic, neonatal emergencies. So it is an important topic from case discussion point of view also, and from theory questions also. I'll be telling you during my talks what are the probable questions which can be asked. Let's come to a scenario where a 38 weeks old 2.5 kg newborn male was admitted to neonatal ICU and intubated due to severe respiratory insufficiency. Chest X-ray revealed left posterior lateral diaphragmatic hernia with intestinal loops in the left hemithorax. So this can be a case scenario which can be given to you during the examination. You can see this child, how it looks like. You can see that there is a scaphoid abdomen and there is a bulging in the chest. So what is CDH? It is a defect in diaphragm which develops early in gestation where there is herniation of intra-abdominal organs into thoracic cavity, and incidence is 1:2500 to 5000 and more common in more so on the left side. The clinical features consist of a classic triad of cyanosis, dyspnea and dextrocardia. On physical examination, you may find cyanosis, then scaphoid abdomen is present, there is bulging of chest, decreased breath sounds, distant or rightly displaced heart sounds, and there are bowel sounds which can be heard in the chest. CDH is more common on the posterior lateral side, which is known as Bogdalex hernia, which is present in 80% of the cases. Then second commonest is paroesophageal hernias, as you can see in the diagram, 15 to 20%, and the third commonest is Morgagni, 2% of the patients it is present. Bogdalex hernia is the most common defect present on the left side in 75% of the patients. Now CDH is associated with various syndromes like Beckwith syndrome, coloboma of heart, atrasia, coni, retardation, then genital and ear, which is known as Chart syndrome. Then there can be trisomies 13, 18, 21 and 45 present. It is also associated with various anomalies, of which commonest are CNS abnormalities, spina bifida and hydrocephalus. Then there can be serious anomalies like ASD, VSD, coarctation of aorta and TOF. Then GIT anomalies, malrotation of gut or atresia may be present, or genitourinary tract anomalies like hypospadias may be present. Now let's have a look at the development of diaphragm. It may be asked during your Viva case discussion that how diaphragm is developed. So in the first month, there is a single pleuroperitoneal cavity. At 4th week, there is a septum transversum and dorsal mesentery of the foregut which meet in the midline to form a central tendon of diaphragm, as you can see in the diagram. At 4 to 9 weeks, pleuroperitoneal membrane is formed. So there is complete formation of diaphragm. And at 9 weeks, developing gut returns from yolk sac to the peritoneal cavity. Now how this is relevant to us? During CDH, what happens is either there is early return of midgut to the peritoneal cavity before 9 to 10th week, or there is delayed closure of pleuroperitoneal canal beyond the 9 to 10th week. So there is midgut which is present in the thoracic cavity. Now coming on to pathophysiology of CDH, which itself is a long question which may be asked during examination, that discuss the pathophysiology and the pre-anesthetic management. So what happens in pathophysiology? There are effects of viscera in the thorax. Viscera in the thorax leads to compression atelectasis, mediastinal shift, and bilateral pulmonary hypoplasia. And bilateral pulmonary hypoplasia is associated with surfactant and enzyme deficiency. And there is pulmonary hypertension which is present, which further leading to persistent fetal circulation and patent ductus arteriosus and patent foramen ovale, and ultimately right and left heart failure can be present. Now, pulmonary hypoplasia, how this is occurring? First, let's have a look at the lung development. Lung development begins at 4 weeks. Airway development begins by 10th to 16th week, followed by alveolar development. So you can see here in the diagram that from 9 to 16th week is the time when there is alveolar development which is occurring. So by 16th week, number of airway generations are similar to adult and alveolar development. So between 9 to 16th week is the time when CDH is also occurring, and the contents are herniated into the thoracic cavity. So there is pulmonary lung hypoplasia, and there is decreased in terminal bronchioles, decreased alveoli, and surface area for gas exchange is decreased. Also, there is pulmonary hypertension which occurs because there are pulmonary vascular changes. In pulmonary vascular branches, there is decrease in the cross-sectional area of the pulmonary bed because of increased advential and mediastinal thickness of small blood vessels, which leads to fixed pulmonary vascular resistance. And this increase in pulmonary vascular resistance leads to right heart strain with right ventricular heart failure, and there is right heart failure. So how this persistent fetal circulation is occurring? What is happening is there is increase in pulmonary artery pressures. Pulmonary artery pressure, when it exceeds the systemic artery pressure, there is right to left shunt which is occurring across the PDA, which lowers the postductal PaO2. Look into the diagram here. And when there is increased right ventricular load, which increases right atrial pressures, there is right to left shunting which is occurring through patent foramen ovale, which lowers the preductal PaO2. So there is right ventricular failure, decreased left ventricular failure, and decreased cardiac output, further leading to hypoxemia, acidosis, and systemic hypotension. So as we had discussed that due to the presence of viscera in the thorax, there is mediastinal shift, there is compression atelectasis, and lung hypoplasia. Mediastinal shift, what will happen is it will lead to decreased venous return, decreased cardiac output, and metabolic acidosis. Due to compression atelectasis, there is hypoxia and hypercarbia leading to respiratory acidosis, and lung hypoplasia will lead to hypercarbia and respiratory acidosis. And one should remember that pulmonary hyperplasia due to herniated contents on the ipsilateral side and secondary mass effect on the contralateral side is present. So there is hypoplasia which is occurring on both the sides. There are various diagnoses and prognostic factors. Prenatally, ultrasound can detect the presence of CDH in 50% of the cases, which includes by the presence of polyhydramnios, dilated intrathoracic stomach or liver, lung to head ratio, and lung to transverse thorax ratio is also used, usually at prenatal ultrasound at around 15 weeks. Fetal echo may be helpful to define the degree of pulmonary hypoplasia, and fetal MRI may be done to detect the fetal anomalies. Now, prognostic factors include assessment of severity of pulmonary hypoplasia can be done by ABG. Alveolar arterial oxygen gradient is used. If it is more than 500 mmHg on FiO2 of 1, it predicts non-survival. If it is between 400 to 500, there is uncertain survival, and less than 400 is better prognosis. Also, assessment of severity of pulmonary hypoplasia can be done by ventilation or oxygenation index, which can be calculated by mean airway pressure into FiO2 into 100 divided by PO2. And if it is greater than 40, it signifies poor prognosis. Also, we can use Bones or ventilatory index, which is mean airway pressure into respiratory rate. If PaCO2 is less than 50 and ventilatory index is less than 1000, it indicates good survival. If PaCO2 is greater than 50 but VI is less than 1000, or PaCO2 is less than 40 but VI is greater than 1000, that indicates poor survival. Now, how do we diagnose shunt? It is again very, very important viva question which may be asked. The pulse oximetry from the upper preductal or the lower umbilical, that is the postductal arteries, and ABG help to identify right to left shunt through ductus arteriosus. How? When when there is, how to diagnose patent ductus arteriosus? When preductal PO2 is greater than postductal PO2 by at least 20 mmHg, and preductal SpO2 is greater than postductal SpO2, greater than 10%, then there is significant PDA which is present. Also, we can detect patent foramen ovale when preductal PaO2 less than 20% of normal predicted PaO2, then it indicates patent foramen ovale. Now, again, this is a long question. Preoperative management of a neonate with CDH. What are our goals in preoperative management? First of all, remember that CDH is not a surgical emergency. So you have to stabilize the child first, and you may take time from 24 to 48 hours to 3 weeks in some neonate. And after stabilization, delayed surgical repair can be done. So what are the preoperative management goals? First is to reverse the pulmonary hypertension to decrease the right to left shunt, improve ventilation and oxygenation, correction of acidosis, which can be metabolic and respiratory, and correction of systemic hypotension. So let's have a look at the pre-op management. Early placement of nasogastric tube should be done, and correction of hypoxemia and respiratory acidosis is done. For that, there are certain ventilatory and oxygenation targets which are set to maintain the preductal saturation above 85%. Peak inspiratory pressure should be kept below 25 centimeter of water, allowing PaCO2 to rise to 45 to 55 mmHg. Here, conventional ventilation with permissive hypercapnia is favored because we want to maintain PaCO2 between 45 to 55 mmHg, targeting pH of 7.25 to 7.35, and FiO2 is titrated to maintain preductal saturation 85 to 95%. Now, pre-op correction of metabolic acidosis is very important. Sodium bicarbonate can be given, and one should insist on improvement of circulation with fluid therapy. And correction of persistent pulmonary hypertension can be done with inhaled nitric oxide, prostaglandin E1, sildenafil, milrinone, and ECMO. Now, how does inhaled nitric oxide helps to some extent? It is a selective pulmonary vasodilator, and it relaxes the pulmonary smooth muscles. So it is the first line of treatment with severe PPH, and we start at 20 ppm. Complete response to inhaled nitric oxide is when there is increase in ratio of arterial oxygen tension to fraction of inspired oxygen by greater than 20 mmHg post inhaled nitric oxide therapy. Prostaglandin E1 can be given. It sometimes helps when there is severe PPH. By maintaining the ductal patency, it allows bypass for right ventricular to offload and reduces right ventricular afterload. So consider echocardiogram after PGE1 and to document right ventricular flow and functions. Start at 10 nanogram per kg per minute and titrate according to clinical response or echo findings. Sildenafil is also important. It can be used for refractory PPH where inhaled nitric oxide is not effective in reducing oxygenation index. Again, you must, if you name sildenafil, then you should know the dose also. IV infusion dose is 0.04 mg per kg over 3 hours followed by 0.07 mg per kg per hour. Milrinone can be given, and it is considered with sildenafil in patients with severe pulmonary hypertension. It has inotropic effect as well as may reduce pulmonary vascular resistance. ECMO it decreases right to left shunt by diverting cardiac output and allows growth for hypoplastic lung. Patients with severe hypoxemia, hypercarbia, acidosis, and pulmonary hypertension who do not respond to conventional respiratory and pharmacological interventions are benefited by this. Other pre-op preparations include IV administration of fluid through peripheral venous access, inotropes if required, and hypothermia management. Inotrope or vasopressor drugs, they are helpful in maintaining adequate organ perfusion. Systemic vasodilation and improvement of cardiac function occurs by use of inotropes. Also, they decrease right to left shunt by thereby improving postductal oxygenation saturations. Choice of agent is according to echo findings and individual preference. The agent used are dobutamine, milrinone, noradrenaline, and dopamine. Now, what is the end point of pre-op stabilization? Surgery is to be delayed so that there is hemodynamic stability, there is reduction in pulmonary hypertension, appropriate ventilation, and patient is on minimum ventilatory support. There is correction of acid-base status with normal physiological state. There is resolution of pulmonary hypertension, improvement in pulmonary compliance, and resolving pulmonary and radiological abnormalities can be looked for. Investigations to be done include hemogram, BGCM, ABG to be done because there may be mixed respiratory and metabolic acidosis, serum electrolytes to be looked for, blood sugars as it may be associated with Bequin-Wedman syndrome, cross-matching is to be done, and blood should be kept ready, chest x-rays to be done, and echo to rule out congenital heart disease, assess right ventricular functions, and measures pulmonary artery pressures. So always remember, when answering during Viva question, you should know the reasoning of each and every investigation, why you need it to be done. Now again, I have taken these questions from 10 years paper. There is a long question, anesthetic considerations and intraoperative management of a 1-day-old male with CDH. So what are the anesthetic considerations? First of all, we have to decompress the gut. So insertion of nasogastric tube is to be done. An IV line is taken and preferably in the upper limb. Why? Because return of abdominal contents may compress in IVC and there may be decrease in venous return. One has to avoid bag and mask ventilation to avoid barotrauma as there is pulmonary hypoplasia. Avoid pulmonary hypertension by maintaining normoxia, normocapnia, normothermia, and correction of acidosis. Correct the acidosis prior, and mechanical ventilation. It is to be done with gentle ventilation with low tidal volume, limited peak inspiratory pressures, limited PEEP, and permissive hypercapnia is to be kept. Now coming on to anesthetic management, IV line is secured in upper limb as we have discussed. Nasogastric tube is inserted and decompression is done. Pre-medication with atropine is done. Arterial line in preductal artery, radial artery cannulation is done so that we can have the monitoring and know about the preductal and postductal saturations. Induction and intubation is to be done by pre-oxygenation. Then inhalational induction with spontaneous breathing is preferred. Then after that, sevoflurane and halothane and intubate without any muscle relaxant. Why? Because see, bag and mask positive pressure ventilation is avoided till intubation because high inflation pressures is to be avoided as there is pulmonary hypoplasia and there may be barotrauma. So we prefer spontaneous breathing and induction without any muscle relaxant. Or we can do RSI, rapid sequence induction with propofol or thiopentone and opioids with succinylcholine. One has to avoid nitrous oxide. Why? Because it distends intrathoracic gut and again it will lead to compression of lung tissues, further compressing the pulmonary functions. Distended gut causes difficulty in abdominal closure and may cause increased abdominal pressure and compression of IVC and hypotension may occur. In monitoring, continuous ECG monitoring is to be done Precordial or esophageal stethoscope is placed for continuous monitoring intraoperatively, and for SpO2, two pulse oximeters are placed. Excuse me, two pulse oximeters are placed, one in the right hand and foot for preductal saturation and another for the postductal saturation. Capnography is to be done, NIBP or intraarterial BP monitoring is done, and frequent ABG monitoring is done from preductal arteries, that is right radial or right temporal arteries. For monitoring, CVP monitoring to maintain intravascular volume is important. Intraoperative urine output monitoring is to be done. Inspiratory pressures to be monitored. Temperature monitoring is important, and blood loss is to be monitored. You should remember that hypothermia is to be avoided at any cost because it will lead to increased pulmonary vascular resistance, leading to decreased oxygen delivery, worsening acidosis and shunting, which will increase the pulmonary hypertension. Excuse me. Intraoperative complications. Patient has, now there is a scenario which can be given to you during the Viva examination. You may be given a scenario where patient had sudden respiratory distress with bradycardia, fall in BP, fall in saturation and increase in EtCO2. So what can be the cause? There can be many causes to it. One of them is, which should come to your mind, is pneumothorax. It occurs due to hypoplastic lung, increased high airway pressures required to inflate the lung. So what will be the clinical features? There will be sudden decrease in compliance and SpO2. Hypotension may be there. There will be bradycardia, and for prevention, low airway pressures are to be kept. And management includes immediate ICD to relieve the tension, pneumothorax. Now, another cause can be increase in pulmonary vascular resistance, which may lead to right to left shunt due to hypoxia, acidosis, hypothermia or pain. It is treated by analgesics, maintaining the temperature, and hyperventilation, which improves oxygenation and decreases EtCO2, and pharmacological therapy, vasodilators may be used. Now, another complication which can occur is abdominal compression syndrome. It occurs due to closure of abdominal wall, which may cause respiratory distress and decrease in venous return. There is underdeveloped abdominal cavity, and when the contents are placed in the abdomen, there may be compression of IVC. So management includes opening of abdomen to relieve pressure on great vessels. Patch closure with temporary cierlistic pouch may be formed. Abdominal closure in secondary stage surgery may be done later on. Post-operative care includes post-operative elective ventilation is planned depending on pre-op respiratory status, size of the defect, tension on abdominal wall, and associated CHD, etc. Opioids and adequate muscle relaxation is to be given if patient is on ventilator. Maintain normothermia. There should be control of intravascular volume status and prevention of rebound pulmonary hypertension. Ventilation and FiO2 are adjusted up to maintain PO2 between 80 to 100 mmHg, PaCO2 25 to 30 mmHg, pH 7.55, low tidal volume and airway pressures, and high respiratory rate. Now, coming on to our second case scenario. A 3-day-old male born with 37 weeks gestational age by vaginal delivery. A nasogastric tube could not be passed into the stomach and progressive abdominal distension was noticed. Patient was given a diagnosis of tracheal esophageal fistula with a large fistula diameter of 5 mm just above the carina. No other anomalies existed. Baby was scheduled for surgical correction. Discuss the anesthetic considerations and management of this child. So this is again a theory question which I have taken from a 10-year paper. So what is tracheoesophageal fistula? It is abnormal connection between trachea and esophagus. And esophageal atresia is failure of esophagus to form continuous passage from pharynx to stomach. So what are the types of tracheoesophageal fistula? It can be a pure esophageal atresia type A, then there may be communication of the proximal esophagus with the trachea. This is type B. Type C is the commonest, where the distal esophagus communicates with the trachea and there is a esophageal atresia. Type D is when there is proximal and distal fistulas both communicating with the trachea. And type E, also known as type H, is the fistula in which there is no bifurcation of the esophagus and there is no esophageal atresia, and both of them meet at the trachea. Now, what is the pathophysiology? Due to tracheoesophageal fistula, inhaled air bypasses the lung and it reaches the stomach, causing hypoventilation and gastric distension, which leads to acidic stomach contents reflex via fistula into trachea, causing aspiration pneumonitis. Also, esophageal atresia leads to proximal bile portion ending into a blind pouch, where there are secretions from the hypopharynx pool here and they cause drooling of the secretions. TEF is incidence is 1:3,000 or 4,000 births. Again, more common in males than females, 25:3. Antenatal history can be suspected by polyhydramnios and it is mostly diagnosed postnatally. And up to 50% of infants have other congenital anomalies associated with TOF or esophageal fistula. Embryological development. Division of foregut occurs at 4th to 5th week of intrauterine life. Division of foreguts result from fusion of longitudinal lateral ridges which form the septum, and imperfect division of this septum results in a communication fistula. There are certain congenital anomalies which may be associated with tracheoesophageal fistula, which includes vectoral anomalies. What vectoral signifies, V is for vertebral anomalies, A is anal canal defects, anal atresia, C is cardiac malformations, which are commonest of these. VSD are the commonest. ASD, TOF and right-sided aortic arch or PDA may be present. Then T is tracheoesophageal fistula, R is renal dysplasia, and L is the limb defects. Diagnosis is made by there is excessive salivation on feeding, there is choking, cyanosis and coughing occurs, which may lead to aspiration pneumonia. There is failure of passage of catheter down to the stomach, which is diagnostic except in type H. Prenatally, polyhydramnios is present and diagnosis is confirmed by chest X-ray. Catheter in the blind upper pouch may be seen. Investigations to be done include complete blood count, electrolytes, as there can be various electrolyte abnormalities due to poor feeding, arterial blood gas ABGs to be done, packed red blood cells should be typed and cross-matched. Plain chest X-ray is done to assess the presence and severity of pulmonary disease and aspiration pneumonia, and CHF may be present in CHD. Radiopaque OGT seen coiled in proximal esophageal pouch, whereas abdominal X-ray there is air in stomach and bowel. Echocardiogram is mandatory as there may be major cardiac defects. If severe TEF is present, correction is required. Also, it detects right side aortic arch because remember this requires positioning of infant with opposite side down from the usual. Spinal plain films are required to exclude the vertebral anomalies, and renal ultrasound is to be done to rule out anomalies and hydronephrosis. Now, preoperative risk assessment is done using Spitz classification. Spitz group 1 is birth weight greater than 1.5 kg and there is no major cardiac disease involved. The survival rate is maximum 96%. In Spitz 2, birth weight is less than 1.5 and there is major cardiac disease which is present. And in Spitz 3, the birth weight is less than 1.5 kg and major cardiac disease is present. The survival rate is only 38%. Also, there is a Waterston and Kulik classification, which is divided into A, B1, B2, C and C1, C2. So, according to this classification, the type of repair to be done is decided. When weight is greater than 2500 gram and child is well, total repair is to be done immediately. But if body weight is between 1800 to 2500 gram and child is well, or body weight is greater than 2500 gram and there is moderate anemia and congenital heart disease present, then staged repair is done where gastrotomy is to be done first. Then if body weight is less than 1800 gram or body weight greater than 1800 gram with severe pneumonia and congenital heart surgery disease, then surgery is to be postponed. Now, there is another system of classification, Montreal system of classification. Now, this is the recently used one because nowadays birth weight is not a limitation as we have better neonatal ICU care available, which has improved the outcome of low birth weight babies, and it is no longer an independent risk factor for mortality. So, according to this classification, high risk factor is a life-threatening. High-risk cases are the one which have life-threatening anomalies or major anomaly and ventilator dependency, and low risk are the all other patients. Surgical repair can be primary complete repair or two-stage repair. Primary repair is if distance between upper and lower esophageal segments is less than 2.5 centimeter and infant condition is good. Then primary repair is done in which there is division, ligation of the fistula is done and end-to-end anastomosis of proximal and distal segments of esophagus is done. And in two-stage repair, distance between two esophageal segments is large and condition of infant is poor, then first TEF is ligated and gastrotomy is done, and it is in the second stage where both proximal and distal esophageal segments are anastomosed. Now coming on to the anesthetic considerations which are preoperative. First coming on to preoperative consideration and optimization. There may be copious secretion. So catheter is placed in proximal esophageal pouch and intermittent suctioning is to be done to minimize expiration of oral secretions. And the child, for the risk of aspiration, is not to be fed, and IV replacement of fluid and glucose is to be done. Antibiotics are given to treat pneumonia. Dehydration may be present due to poor feeding and copious secretions, so IV fluid is to be given. Acid-base disorders may be present. Metabolic acidosis may be there because of poor hydration and shock, and treatment requires IV fluids and correction of electrolytes. Respiratory acidosis may be present due to pneumonia, shunting, hypoxia, and atelectasis, and treatment requires ventilation and IV antibiotics. So, what is the role of gastrotomy? It prevents gastric distension and rupture, so it improves ventilation and venous return. So, whenever we are ventilating the child, one should, if gastrotomy is present, it should be kept open. It prevents reflux of gastric contents into lung, allows proper nutrition of the baby in pre and post repair period, and it prevents elevation of diaphragm, so avoiding respiratory distress. Anesthetic management include first of all, what preoperative preparations we make, we shift the patient supine with head up in 30 degree, which minimizes reflux of gastric fluids into the lungs. 2 IV cannulas are to be placed, and avoid placing IV line excess in the right arm. Why? Because it is the one which is elevated during right thoracotomy, so there is a limited access to the right arm. Pre-medications, sedatives are to be avoided, and if gastrotomy tube is present, always remember to leave it open. Now, in intraoperative considerations, we have two main considerations: oxygenation and ventilation, and securing the airway. First of all, during monitoring, we apply the basic standard monitors, and besides that, one should place a precordial stethoscope. Why it is important? It is to be placed in left dependent axilla, so that to monitor the dependent lung, which detects, so you can auscultate and detect the kinking of left main bronchus due to traction on the dependent lung or obstruction of endotracheal tube by blood or mucus. So precordial stethoscope is very, very helpful. ABG is to be done by invasive intra-arterial blood pressure monitoring, and it can be used for continuous ABG also, the invasive line. 2 pulse oximeter are to be placed if there is CHD you are suspecting, and intraoperatively body temperature is to be monitored. Now, coming on to the induction, there are various methods which can be followed. One is inhalational induction with gentle IPPV with spontaneous breathing. followed by spray of vocal cords with lignocaine and intubation without the use of muscle relaxants, so that by avoiding the muscle relaxant, we avoid the excessive pressure to the lungs, and we avoid the mm, reaching the air to the stomach, and so that there is no problem in the ventilation and operative part. Another technique is IV or inhalational induction after muscle paralysis, which requires gentle IPPV, and there has to be gastrotomy which has to be present, so that there is no risk of distension of fistula and distension of stomach with positive pressure ventilation. So if gastrotomy is present, and then you can plan to give muscle paralysis and leave the gastrotomy open. Awake intubation is not at all recommended, as it may be difficult, and besides this being difficult, it is distressing for the baby. It may be associated with oxygen desaturation and trauma, and sometimes there may be increase in intracranial pressure or intraventricular hemorrhage which may occur. Now, when you intubate, remember endotracheal tube is placed just above the is to be placed just above the carina, below the opening of the fistula. So, to ensure that we are placing below the fistula, first pass the tube in the right main bronchus, then gradually withdraw it until breath sounds are heard and they are bilaterally equal. Endotracheal tube position is confirmed by auscultation of both lungs and stomach. By fiber optic bronchoscopy, carina is identified and endotracheal tube is pulled back with fiber optic inside the endotracheal tube until the fistula is visualized, because we want the tube to cross the fistula so that there is no distension of the fistula. Now, ETT is advanced just distal to the fistula, or by placing we can also check by gastrotomy tube. Place the gastrotomy tube in a beaker of water and apply positive pressure ventilation. If there is absence of bubbling, that means your tube has crossed the fistula and it's a good positioning. But if there is presence of bubbling, then it means that more advancement of tube is required. For very large tracheoesophageal fistula, one technique used is you can occlude the fistula with either endotracheal tube or a 2 or 3 French size Fogarty catheter placed before the tracheal tube under bronchoscopic visualization. Remember, you may ask this in a Viva question also, like if it is a very large tracheoesophageal fistula, how will you manage the induction of this patient? So in this, you will pass a Fogarty catheter or endotracheal tube under bronchoscopic visualization. Following the placement, balloon of the Fogarty is inflated and bronchoscope removed, and placement of endotracheal tube is carried out in a standard manner. Advancement of Fogarty catheter through fistula can also be carried out through a gastrotomy tube if placed, but it has got certain disadvantages, like neonate with respiratory compromise may not be able to tolerate interruption in ventilation that occur if rigid bronchoscope is used to pass the catheter. And it is difficult to place. It can dislodge, can cause central airway obstruction, can damage esophageal mucosa at the site of balloon inflation. Another option is one lung ventilation in left or right main stem bronchus until fistula is ligated. One lung ventilation can also be achieved by Fogarty catheter placed in main right bronchus in addition to the one placed in the fistula, but both maneuvers should be performed under bronchoscopic guidance. Intraoperative management includes maintenance by oxygen and air, sevoflurane and spontaneous ventilation, and muscle relaxants are given after the fistula repair has been done. Though spontaneous ventilation with inhalational agent till the fistula repair is technically challenging, but there is a fear of gastric distension and mediastinal instability, so we do not give muscle relaxant before the fistula is repaired. And controlled ventilation is with sevoflurane and muscle relaxant can be done after the repair. Now again, endotracheal tube may enter fistula when infant is turned or during surgical manipulation. This is one of the complications. And how will you suspect this? That intubation of fistula has occurred. There will be difficulty in ventilation, as well as there will be decrease in oxygen saturation and end-tidal carbon dioxide. So what you have to do, ask the surgeon to stop and see that surgeon is able to palpate the tube. If it is in the tube of the, if it is in the fistula, it may be palpable in the tip may be palpable in the fistula of the field. And remember, similar situation occurs when lungs are packed during surgery. So ask the surgeon to remove the packs also. After fistula is ligated, anesthetist passes a catheter from nose into esophagus, which meets the one from the stomach. So you may be asked to pass a catheter, and anastomosis is done over the catheter, then which is withdrawn just above the suture line, which acts as a guide for suctioning also. Just a minute. Now, other problems may be, there may be repeated episodes of desaturation. So ask the surgeons for intermittent release of lung retraction to improve oxygenation and ventilation. They may be bradycardia due to traction on the hilum, or mobilization of the esophagus due to vagal nerve stimulation, or due to halothane. Management includes IV atropine, and obstruction of airway may occur due to kinking, as trachea is soft, and there may be clots or secretions may be obstructing the airway. Management is that auscultate with the precordial stethoscope and find out the cause, and there may be repeated suctioning which may be required. Now, extubation and recovery. Extubation is planned according to the clinical condition of the patient, and remember that tracheomalacia or defective tracheal wall at the site of fistula can lead to collapse of the airway. So some prefer to keep the trachea intubated to avoid the gastroesophageal tube in place for several days and avoid reintubation and damage to the tracheal repair. If there are pulmonary complications or inadequacy of ventilation, then you continue with the controlled ventilation. For the pain management, IV opioids are given intraoperatively and postoperatively. Generous dose is to be used if definite indication for post-op ventilation is present. If extubation is planned, regional anesthesia is advantageous to avoid, and one should avoid opioids which decrease the risk of post-operative respiratory depression. Epidural infusion can be given if epidural has been placed. 0.1% bupivacaine can be given along with fentanyl 0.5 microgram per ml at the rate of 0.1 to 0.2 ml per kg per hour. Caudal catheter can be advanced up to T6 to T7 provided there are no significant vertebral anomalies. Intercostal nerve block can be asked to be given by the surgeons before the wound closure, and intrapleural catheter may also be placed. Coming on to exophthalmos or omphalocele. So omphalocele is a central abdominal wall defect which involves herniation of abdominal viscera into umbilical cord. Membrane consists of Wharton's jelly, peritoneum and amnion, and it covers the viscera, and liver, spleen and ovaries may be present in the sac. The cause of development is at 10th week failure of midgut to return to abdominal cavity or incomplete closure of the anterior abdominal wall around the umbilicus occurs. So it can be exophthalmos minor or major. In minor, there is a small defect 2 to 5 centimeter in diameter. In major, there is a large defect greater than 10 centimeter, and it involves liver and spleen. There are poorly developed abdominal and thoracic cavities, and pulmonary hyperplasia is present. Omphalocele, remember that congenital anomalies are more common in omphalocele rather than gastroschiasis. Congenital anomalies majorly are cardiac, and there can be chromosomal abnormalities, cloacal or bladder extrophy, Beckman-Wedman syndrome, or pathology of Cantrell. Smaller gastroschiasis. What is gastroschiasis? It is the smaller defect of abdominal wall located to the right side of umbilical cord. It is not central in position, and it occurs due to the occlusion of omphalomesenteric artery with ischemia to the right periumbilical area. There is complete intestine which is herniated through the defect, but testis, ovary and liver are less commonly involved, unlike your omphalocele or Exophthalmos. There is no membranous covering present in gastroschiasis. Herniated bowels are directly exposed to the contents of amniotic cavity, and there may be very few congenital anomalies like GIT or intestinal obstruction, intestinal atresia, Meckel's diverticulum, and intestinal duplication. You can see these children, omphalocele and gastroschiasis. You can see it is a central defect. It is in the periumbilical area, and there is no membranous covering in the gastroschiasis. So the difference between two we have discussed. There is on omphalocele, there is failure of gut migration from yolk sac into abdomen, and in gastroschiasis there is occlusion of omphalomesenteric artery with ischemia to the right periumbilical area, and omphalocele is located within the umbilical cord. Gastroschiasis is periumbilical. Prenatal diagnosis can be made by ultrasound in both, and peritoneal covering is present in omphalocele but not present in gastroschiasis. Location is central in omphalocele, and gastroschiasis it's lateral, and there is high incidence of congenital anomalies associated with omphalocele but not with gastroschiasis. Now again a question from 10-year paper: discuss the anesthetic management of omphalocele repair in a neonate. I'm discussing both omphalocele and gastroschiasis repair, and we can compare the differences also along with it. Now, exophthalmos is elective surgery unless a rupture of the sac which is occurring, but gastroschiasis is an emergency. When small defect is repaired, it is done in a single stage, whereas larger defects require formation of cystic pouch and gradual reduction. But exophthalmos major and gastroschiasis, they require a staged surgery. If exophthalmos is extremely large, contents will not return to abdominal cavity even with pouch formation. Sac is left intact and allowed to slowly epithelialize. Anesthetic concerns are treatment of sepsis is to be done with antibiotics, and lung hypoplasia may be present in infants with large omphaloceles, so it has to be taken care of. Bowel decompression is to be done with nasogastric tube. Investigations to be done include routine full blood count, capillary blood gases, RFT and KFT, BGCM, chest X-ray, abdomen and chest X-ray, ECG, renal ultrasound, and head scan is to be done. Anesthetic management include anesthetic concerns include they may be associated with congenital anomalies, especially omphalocele. There may be difficult airway in patients with Beckwith-Wiedemann syndrome. They have a large tongue. Their care of herniated bowel or viscera is to be taken. If membrane is ruptured, it is to be covered with saline-soaked gauze and nursed in left lateral position. And bowel is to be supported, as you can see in this picture, that this is covered in a polythene and it is supported. Prevention of heat loss is to be done by bowel covered with waterproof cellophane bowel bag. Temperature regulation for this they have to be nursed in incubator to reduce the heat loss, and fluid resuscitation is to be done appropriately. For prevention of heat loss and hypothermia, the neonate is transferred to operating room in a warm incubator, and in operating room, the prevention of heat loss is done by theater temperature of 27.8 degrees Celsius. Place the neonate on a warm mattress and heat and humidify the inhaled gases to 36.8 degrees Celsius. IV line is to be secured in upper limbs because impairment of venous return from lower body may be occur due to abdominal distension. Now, induction should be rapid sequence induction. Nitrous oxide is to be avoided as there may be bowel distension. Muscle relaxant of choice is atracurium, and watch for abdominal compartment syndrome. Avoid hypotension. Volatile anesthetics to be used in moderate to low concentration. Serial glucose monitoring is to be done because hypoglycemia may be associated with Beckman-Wiedemann syndrome. Intraoperative challenge may be there after amniotic membrane removal because there is large volumes of fluid loss from the exposed abdominal viscera. Fluid lost is extracellular fluid, and so it should be replaced with a balanced salt solution even in neonates. Now, there may be abdominal compartment syndrome which may occur due to tight surgical abdominal closure. There may be hypotension secondary to compression of liver and vena cava. So there is decreased venous return, decreased cardiac output, and decreased organ perfusion. And bowel necrosis, perforation, and necrotizing enterocolitis may also occur. So to avoid an abdominal compartment syndrome, always monitor for the lower extremity BP and SpO2. Identify the circulatory problems. Watch for lower extremity congestion and cyanosis if there is decrease in venous return, and watch for decrease in peak airway pressures or decrease in tidal volume or decrease in SpO2, which is indicative of non-feasibility of primary closure. Now, extubation is planned according to the condition of the patient. Continue ventilatory support postoperatively for large gastroschiasis and omphalus major. Neonates are to, if extubated in minor exomphalus minor, then they should be extubated when fully awake. In the postoperative room, watch for the signs of abdominal compression, and one should be given TPN. Coming on to HOPS, hypertrophic obstructive pyloric stenosis. Now, this is present between 2nd to 6th week of life. There is hypertrophy of the pyloric smooth muscles with edema of the pyloric mucosa and submucosa. Progressive obstruction of pyloric wall causes a persistent vomiting and loss of fluids and electrolytes. Diagnosis is made on the basis of symptoms and ultrasound. Clinical features. Now, again, there is a question in the 10 years paper, clinical features and preoperative anesthetic management of a 1-month-old child with pyloric stenosis. Cardinal features are there is non-villous projectile vomiting with visible peristalsis. There is hyponatremia, hypochloremia, hypokalemia with metabolic alkalosis may be present. There may be dehydration and lethargy. Metabolic alkalosis is there, which causes compensatory respiratory acidosis, shift of ODC to left, and there may be hypocalcemia and convulsions which may be present. Pre-operative concerns include always consider these children to be full stomach, and there may be metabolic alkalosis with hypochloremia and hypokalemia present, and there may be severe dehydration. Always remember that pyloric stenosis is a medical emergency, not a surgical emergency. So patient is operated only after adequate fluid and electrolyte resuscitation. Resuscitation fluid includes balanced salt solution and potassium after urination starts. When is resuscitation considered to be adequate? When there is normal skin turgor, correction of electrolyte imbalance, where sodium level is greater than 130 milliequivalents per liter, potassium level at least 3 milliequivalents per liter, chloride level greater than 85 milliequivalents per liter, and urine output is decreased to 1 to 2 ml per kg per hour. In anesthetic management, large orogastric tube is to be inserted to aspirate the stomach contents, which reduces gastric fluid and aspiration chances. RSI is to be performed because there are chances of potential volume of contents in the stomach. Awake intubation is not preferred. After intubation, orogastric tube is repositioned and left in place. Air can be insufflated in stomach to test for mucosal perforation after hypertrophied muscle is split. At the end of the case, patient should be wide awake before extubation, and apnea monitoring is to be done for few hours. Remember, there is high incidence of postoperative apneic spells. Pain management includes bupivacaine, maximum for infiltration, where maximum dose is 1 ml per kg of 0.25%. Rectal paracetamol may be used. Tab block can be given, or ultrasound guided for postoperative pain relief. Local infiltration can be done at the laparoscopic port sites, and IV or rectal acetaminophen can be given. Note that opioids are to be given minimal because there is post-op apnea risk in these patients. With this, I end my talk, and I hope you enjoyed listening to my talk. Thank you.
Start. Yeah. 1 minute.
Indrani ma'am. Indrani ma'am, am I audible?
Yes, sir. You are audible, sir.
I think ma'am perhaps
Uh,
has some connection. Oh, okay.
Dr. Anshu,
Yes, ma'am.
can you hear me now?
Yes, ma'am, I can hear you.
Am I audible?
Yes, ma'am, you are audible.
Am I audible?
Yes,
Yes,
ma'am, you are
yes.
audible, ma'am.
Yes, ma'am.
Okay. Thank you very much, Anshu. That was a very good lecture, very good content,
Thank you, ma'am.
very good lecture and content. And there are a couple of questions.
Yes, ma'am.
One question is about precordial stethoscope.
Yes, ma'am. So,
Yeah, what is it about the precordial stethoscope? One question is on precordial stethoscope.
yes, ma'am. Ma'am, in CDH we place a precordial stethoscope. In CDH
One
and TEF,
question is on precordial stethoscope.
I can hear you, ma'am. Shall I answer? We place a
Hello?
precordial. Yes, ma'am.
Yeah,
Am
what
I
is
audible
it?
to you?
Hello?
Yes, ma'am, I am answering. Hello, ma'am, can you hear me? Am I audible?
Yes, yes,
Dr.
you're audible. Yes, yes, yes. Anshu ma'am, you're audible. You can
Yes,
give the
yes.
answer.
So I'm answering the question. We place the precordial stethoscope in the left side,
See,
left
so
axilla.
one.
Yes, ma'am. We place the precordial stethoscope in the left axilla because in TEF we are performing right thoracotomy. So in left one is the dependent
Yes,
lung.
please.
Yes, ma'am.
Yes.
Left lung is the dependent lung, and it is one of the common complications that there is
Yes.
obstruction of the left side by secretions, or
Yes, please go ahead.
that there may be obstruction of the left side of the lung by the secretions, left bronchus by the secretions, or there may be kinking because surgeons are performing the surgery. So what we do is we paste the stethoscope with the help of an adhesive and we fix it there. So intraoperative monitoring, because it is not easily accessible when the patient is painted and draped, so we place the stethoscope there so that we can auscultate whenever we want, and it has a very important role, and none of the devices can replace this method of monitoring. So precordial stethoscope is very important in TEF patients. It should be used regularly, and we are using in our institute whenever we are getting the TEF cases done. Ma'am, shall I answer the next question?
You can go ahead. You can go ahead. What is the
Yeah.
role of analgesis in sudden drop of saturation in CDH patient intraoperative due to elevated vascular resistance?
Yeah, as I have discussed that first we look for pneumothorax, then the second cause may be rise in pulmonary vascular resistance. And there are 3-4 factors which we should keep in mind while dealing with pulmonary vascular hypertension, that there may be hypoxia, acidosis, hypothermia and pain. So pain is one of the factors. So we will hyperventilate the patient by giving, so it will improve the saturation and decrease the EtCO2, and we will give the analgesics. So pain
Okay,
may
what
be a
is the role
component.
of analgesics?
So
Yes.
pain may be a component
yes.
leading to increase in pulmonary vascular resistance. So we should give analgesics along with hyperventilation, and after we have ruled out the pneumothorax also. So analgesics are also helpful in decreasing the pulmonary vascular resistance. I hope the person who asked the question, it's clear now. Shall I
Ma'am,
move
it
to
would
next
benefit
question?
them. Yes, ma'am. What if you're not able to intubate a patient of TEF? What will be the next?
See, whenever we are inducing a patient of TEF, as I have already discussed that we will not give muscle relaxants. So we are doing spontaneous induction, in which we are giving inhalational agent. We are deepening the plane of anesthesia, and then and we can give some opioids, and then we are doing the induction. So if we are not able to visualize anything, then we may wait for the help. As we have not given any any relaxant, we can wait for the help. Or what we do in our institute is we
Yeah,
keep the
and
video
about
laryngoscope.
yes.
We keep the video laryngoscope ready, and the intubation is much easier, especially in neonates with video laryngoscope. And suppose the problem is regarding the fistula, that we are not is maybe the person wants to ask that if fistula is at such a location that we are not able to perform the intubation, then we keep the rigid bronchoscope also ready, but it has got its own limitation that we have to keep the patient non-ventilated for some time, so we don't prefer it as the first method of intubation. So we can do the under bronchoscopic guidance, we can perform the intubation. So these are the options if we are not able to intubate.
Unmute, sir, please. Please unmute.
So this answers the questions that have been put up by the delegates. Indrani ma'am, are we audible to you? Hello, am I audible, ma'am?
Recording in progress.
I think we lost the connection with ma'am.
We have lost the connection. Any other questions, Nitin?
No, ma'am, there are no other questions. Ma'am, no. Shall we?
Dr. Indrani, are you there? Dr. Indrani?
There's some connectivity issue, ma'am, at her end.
There is some connectivity.
Yes.
Hanji, ma'am.
Thank you
Yes,
very
ma'am.
much. That was a fantastic session. And the speakers were great in presentation and content. Thanks a lot.
Thank you, ma'am.
Thank you, ma'am. Thank you so much. Thank the. Okay. So we'll move ahead with our next session.
Thank you, Mohandeep ma'am, and thank you, Indrani ma'am, for this opportunity. Thank you.
Thank
Thank you,
you,
ma'am.
ma'am.
Thank you to the speakers.
Thank
The
you, MD Kaur ma'am, and
speakers
thank you,
Yes, I am
Indrani
there.
ma'am. Yes, ma'am.
Yes.
Thank you, Indrani ma'am, for your encouragement.
Hello, Dr. Indrani. Can we conclude, Dr. Indrani?
Thank
Ma'am,
you
I
very
think
much.
Thank you, Indrani ma'am, and thank you, MD Kaur ma'am, for giving us this opportunity. And ma'am, we are blessed to be on this platform with you all, ma'am. Thank you, ma'am.
Dr. Indrani, may we close the session?
Maybe you can conclude the session. I think
Network
there's some
issues
issue.
with Dr. Indrani.
So I think it is getting delayed. With due apologies,
There's some lag. Yeah.
conclude the session. I'll write a message to her. Right. Thank you.
Yes.
Yes,
Yes,
ma'am.
we should. Kindly conclude.
Thank you. Thank you so much. We were losing the connection with you in between.
Thank you so much, ma'am. Thanks to Dr. Indrani, Dr. Anju, and Dr. Anshu for this wonderful presentation and for this wonderful session. Moving on to our next session, I would like to introduce the chairperson for this session.
Yes, thank you very much.
Thank you, ma'am. Thank you so much. This session will be chaired by Dr. Vijay Kumar Nagpal, Service Professor and Consultant at ABVIMS and Dr. RML Hospital, New Delhi. His areas of special interest are cardiac anesthesia and pediatric anesthesia. Welcome, sir.
I've done. Thank you, Dr. Nitin. I would like to start this session with the first presentation by Professor Dr. Manpreet Singh. I hope he's there. He is a professor at the Government Medical College and Hospital at Chandigarh, and his areas of special interest are airway management, resuscitation, trauma, emergency medicine, and critical care. Quite a wide array of interests, Dr. Manpreet sir. May I invite you to begin with your presentation.
Thank you, sir. Thank you. Thanks a lot, sir. Thanks to the organizers of APEC 2022. I am Manpreet Singh from Chandigarh, and my topic is crystalloids and colloids perioperative fluid therapy. It is a very vast topic, but very, very important for all the postgraduates who will be appearing for the examination. My objectives of lecture will be fluids and electrolytes, definitions, then certain perioperative fluids, then the crystalloids, details about few facts about crystalloids, then colloids, then their facts, and then complications of studies and the studies, and the liberal versus the restrictive fluid therapy, goal-directed therapy, and then electrolytes in the fluids and conclusion. You all know that 50 to 60% of the human body is the water, and it is divided into intracellular and extracellular compartments, and all the compartments are separated by the selectively permeable membranes, and they control the movement of the water in the solutes. This is what is seen in this diagram. If you see that this cell fluid 35 to 40%, rest is the water, and total body fluid is 50 to 60% of the body weight is the water. And you can see in this diagram, it is seen that newborn infant has 80% of the total body weight is the water. The transport of water and fluids definitions are certain. There are certain definitions which are to be remembered, like osmolality, that is the concentration of the solution determined by the number of dissolved particles per kg of water. And this osmolality controls the water movements and distribution in the body fluid compartments. Then diffusion is a random movement of the particles in all the directions. Active transport is when the solutes they across the membrane, they move and they require certain energy to the and that energy is the expenditure is done for that movement. Filtration is the transfer of water and solutes through the membrane from a region of higher pressure to the lower pressure. Then we have osmosis, that is the movement of water across a membrane from a less concentrated solution to a more concentrated solution. Then there are certain fluid pressures that ECF and ICF fluid shifts occur due to related changes in the fluid pressures in one compartment to the other. If you see this regulation of the fluid volume in the body physiologically, whenever there is hypervolemia, there is excess fluid volume, it inhibits the ADH release or aldosterone release, and thirst is inhibited, and ultimately the fluid volume is restored. Then if there is a hypovolemia, then there is a deficiency of the fluid volume. It stimulates the thirst and ADH release, and aldosterone is released, and then ultimately it causes the normal fluid volume is restored. There are 5 R's of IV fluid administration. Remember, resuscitation, routine maintenance fluids, then we have replacement, then redistribution of the fluids, reassessment. In a perioperative patient, there is increased permeability due to surgical tissue trauma, or there is a tissue hypoperfusion, or there is a ischemia and reperfusion injury, or there is sepsis or use of extracorporeal circulation is there, which increases the permeability. There can be third space loss into the spaces which normally contain minimal amounts of fluid. Anesthesia has its own effects on the fluid That is, the regional anesthetics, a variable amount of sympathetic blockade is there. And in young and healthy, well-hydrated patients, they tolerate the sympathectomy, and all anesthetics may blunt the normal physiological responses to hypovolemia and stress response. Intravenous inhaled agents, they have superimposed effect on the myocardium and venous return and the hemodynamics. And mechanical ventilation, when it is given, then it causes retention of sodium, decrease of the release of atrial natriuretic that hormone, then increase the release of ADH. IV fluid therapy has a range of physiological effects. The goals are to maintain the oxygen delivery through adequate perfusion and restore the previous body fluids losses, and then replace the present body fluid losses, maintenance therapy, and administer certain drugs, and then to maintain the nutrition, and then maintenance of the body temperature. The pre-operative evaluation of fluid status is, it is to be assessed first, that is a mental status, intake and output, blood pressure, supine and insupine and standing position, heart rate, skin turgor, urinary output, and then serum electrolytes and osmolarities. If you see the orthostatic hypotension, it is when the person is made to from supine to standing, there is a decrease of greater than 20 millimeter of mercury, the systolic blood pressure, and it indicates fluid deficit of 6 to 8% of the body weight. Compensatorily, heart rate increases, and if there is no heart rate increase, then it is an autonomic dysfunction, or the patient is on antihypertensive drug therapy. You have to assess the patient completely before giving any fluid. Urine output at least 0.5 to 1 ml per kg per hour, vital signs, and then the physical assessment is to be done, skin turgor or mucous membranes. Then IV monitoring, invasive monitoring is important, and then lab tests like periodic monitoring of heart hemoglobin and the hematocrit is to be done. If you classify the IV fluids, these are three types of maintenance fluids, replacement fluids, and the special fluids. If you see that these can be, otherwise it also is classified as crystalloids, colloids, or there can be special fluids, or there is a blood. In this classification, you can see that whenever you classify the IV fluids, then these are either blood and blood products or non-blood IV fluids. In non-blood, we have crystalloids or colloids. And crystalloids, we all know about dextrose containing fluids, then we have electrolyte containing fluids, or there are mixed ones. In colloids, we have proteinaceous and non-proteinaceous fluids. In proteinaceous, we have gelatins, hemaxils, and gelfusin, or there can be albumin 20% and 5%, or there can be non-proteinaceous, that is the starch and dextrans. In the starches, you all know about hydroxy starch, then pentastarch, tetrastarch, or interstarch. Crystalloid, if you see this diagram, there is a semi-permeable membrane through which there are solutes and water across the membrane, and it has been seen that the crystalloids pass readily through the membrane, whereas colloids do not pass through the semi-permeable membrane readily. That's why it has been classified into different fluids, and IV fluids are similarly classified based on their ability to pass through the capillary walls that separate the IV and interstitial fluid compartments. If you see the crystalloids are the smaller molecules. They diffuse freely from intravascular to interstitial fluid compartments. It contains water and electrolytes, and sodium chloride is the primary component. And if you see, some crystalloids are dextrose-based fluids also. This is the classification of the composition of the various IV fluids. That is the IV fluids, which 5% dextrose, then 5% dextrose, 0.45%. Then we have the Ringer lactate solution, lactated Ringer solution. Then we have plasma light A. Then we have 0.9% normal saline, mannitol. All these fluids have different osmolarities and the different electrolyte concentrations. So you have to remember and mark this chart for the exams, and what are the sodium containing fluids, what are the chloride containing fluids, what are the potassium, calcium, and magnesium containing fluids. In normal saline, it is the first fluid, if we discuss, most commonly administered crystalloid, has in 1 liter of the fluid, it contains 154 milliequivalents, and chloride is 154 milliequivalents. Each 100 ml contains sodium chloride of 0.9 grams, pH is 5.7, and the osmolarity is 308 milliosmoles. It is chiefly the extracellular fluid and maintains the osmolality of ECF. It expands the plasma volume and interstitial fluid volume. Total increase in ECF is slightly more than the infused volume, but it promotes the interstitial edema. So you have to be very careful, because large volume infusions may produce pulmonary edema or may produce hyperchloremic metabolic acidosis. The chloride content is more, that's why it causes increase in the chloride also. And then rationale of use is it is used as a replacement fluid and maintains the blood volume and blood pressure in the emergencies. The water and salt depletion area patients, when there are diarrhea or there is a vomiting, then this fluid is preferred. Treatment of hypovolemic shock, alkalosis, in salt depletion of hyponatremia, or there is initial fluid therapy in diabetic ketoacidosis, or treatment of hypercalcemia, fluid challenge. All these things and all these situations we use normal saline. There are certain limitations on normal saline also. We have to cautiously avoid in hypertensive and pre-eclamptics. Then edematous state, it causes congestive heart failure, in renal disease, and cirrhosis in the patients who have these diseases. Then dehydration with severe hypokalemia, this fluid should not be used. Then there is an increased chloride content in this. So you have to be very careful in the hyperchloremic metabolic acidosis if already the patient has. Disadvantages are it promotes the interstitial edema, you have to be very careful. Then promotes the sodium retention, decrease in renal perfusion, and then hyperchloremic metabolic acidosis may be caused and reduces the strong ion difference. Then we have the Ringer fluids, which is was given by Sidney Ringer in 1880. It contains calcium and potassium in the normal saline solution. And then Hartmann, Alex Hartmann in 1930, he added sodium lactate also to the Ringer solution. And this is now known as Hartmann's solution or Ringer's lactate. If you see the Ringer's fluids, it has two types, Ringer lactate and Ringer acetate. Sodium is everything is almost same, except that it has the little sodium more in the Ringer's acetate. Then we have Ringer lactate. Rationale of use is it is a most physiological fluid, as the electrolyte content is similar to that of plasma, and larger volumes can be infused without the risk of electrolyte imbalance. Rapidly expands the intravascular volume, effective in the treatment of hypovolemia. Lactate in Ringer lactate is metabolized to bicarbonate in the liver, and it is useful in correction of metabolic acidosis. Then correction of it also is used in correction of severe hypovolemia. Then in preoperative patients in burns, then in diarrhea-induced hypovolemia with hypokalemic metabolic acidosis, you can use Ringer lactate. Use in diarrhea is very important because it covers the dehydration in pediatric patients. In diabetic ketoacidosis, it is used because Ringer lactate provides glucose-free water and corrects the metabolic acidosis with the added advantage of potassium supplementation also. In critically ill patients with impaired lactate clearance, it is to be used with very cautious. It should not be used or not preferred. Then severe metabolic acidosis, it should be avoided. In Addison disease, in severe CHF, in liver disease, severe hypoxia and shock, you have to be very vigilant about using this. In vomiting, in calcium in Ringer lactate binds with certain drugs like amphotericin, thiopentol, or there can be ampicillin or doxycycline, and it reduces its bioavailability and the efficiency, so it should not be mixed with that. Then there are dextrose-based solutions like D5, dextrose with 0.9% normal saline, 10% dextrose, 25%, 50% dextrose. These 5% dextrose solution in 1 liter of fluid contains 50 grams of dextrose. It corrects the dehydration and supplies the energy. Therefore, D5 is the best agent to correct the intracellular dehydration. It provides 170 kilocalories per liter. The indications are of 5% dextrose are prevention and treatment of intracellular dehydration. Then cheapest fluid to provide the calories, adequate calories to the body. For pre and post operative fluid replacement, you can use for IV administration of various drugs. Then for treatment or prevention of ketosis in starvation, then diarrhea and vomiting and high grade fever, you can use 5% dextrose. Adequate glucose infusion protects the liver against the toxic substances, and the correction of hypernatremia this fluid can be used for that. Then limitations are in cerebral edema, this causes it is a hypotonic in nature, so it aggravates the cerebral edema. So do not use it. Neurosurgical procedures, it increases the intracranial pressure, so must be avoid these type of solutions. Acute ischemic stroke, in this condition, hyperglycemia aggravates the cerebral ischemic brain damage. Hypovolemic shock, it does not substantially increase the intravascular volume. In hyponatremia and water intoxication, you should not use it. Then hypernatremia, the rapid infusion of dextrose induces the osmotic diuresis, which can aggravate hypernatremia. Blood transfusion or hemodialysis and clumping can be there. That's why it also increases the uncontrolled diabetes and severe hyperglycemia, and can cause hypokalemia, hypomagnesemia, and also hypophosphatemia. Then another is the DNS, that is the 1 liter of fluid contains glucose 50 grams of chloride and 154 milliequivalent sodium 154 milliequivalent. Each 100 ml contains 5 grams of glucose per 0.9 grams of sodium chloride. This fluid has advantage of both 5% dextrose and isotonic saline, which provides the salt. And like 0.9% isotonic saline, it rapidly corrects the sodium chloride deficit of ECF. As DNS is distributed chiefly in ECF compartment, unlike D5, it does not correct intracellular dehydration. Rationale of use is it supplies major extracellular electrolytes, energy, and fluid to correct the dehydration. And as DNS increases only ECF volume, it can be considered in treatment of dehydration with hypovolemic shock. Then indications, we have correction of salt depletion and hypovolemia, correction of vomiting, and then fluid compatible. It is a fluid compatible with the blood transfusion. Then another fluid is dextrose with half strength saline, that is 0.45% of normal saline. It contains 77 milliequivalent per liter each and glucose 50 grams per liter. So 50% salt as compared to the DNS. Then we have, it is used for calories and more water and less salt. Dextrose with half strength saline is used as a fluid therapy in pediatric treatment of severe hypernatremia and maintenance of fluid therapy and in early more post-operative period. Then we have 10% dextrose and 25% dextrose, which is used as a hypertonic crystalloid fluid and provides the energy and catabolism, and it is used in the hypoglycemic coma or hypoglycemia patients, which corrects fast hypoglycemia. Then we have 10%, then indications are rapid correction of hypoglycemia in liver disease. It is given as a first strip, then nutrition to the patient and treatment of hyperkalemia with insulin. We have then Isolite G, which is a gastric fluid, which is used, which has a glucose, sodium, chloride, potassium, and ammonium. And then it is used as a gastric replacement fluid. Then we have the Isolite M, which has a glucose, sodium, chloride, potassium, phosphate, and acetate. and it is the richest potassium source fluid which is used in the hypokalemia secondary to diarrhea or bilious vomiting. As parenteral fluid therapy, it is ideal maintenance fluid for when the potassium is to be given. It is the isolite M. Then we have isolite P, which is use a pediatric maintenance fluid which contains glucose, sodium, potassium. Then we have the acetate and magnesium, and it can be used in the pediatric maintenance fluid, excessive water loss or inability to concentrate the urine. Limitations are do not use in renal failure or hypovolemic shock or hyponatremia. Isolite E, it has a glucose, potassium and chloride potassium, and then sodium and then calcium acetate, magnesium citrate. This isolite E, it goes into the extracellular replacement fluid. Indications are in diarrhea and metabolic acidosis. You can use in this. Then we have a hypertonic saline. That is the fluids containing sodium concentrations more than the normal saline. It is 1.8%, 3%, 5%, and 7.5% or 10% solutions of sodium. It is basically used in the hyperosmolarity. It creates a gradient that draws the water out of the cells. So ultimately, it causes the cellular dehydration and much more effective at expanding the extracellular volume than the isotonic crystalloid fluids. This basically the hypertonic saline is used for in the patients of hyponatremia, but when it is fast given or the large volume is given over a lesser amount of time, then it may cause central pontine myelinosis. So you have to weigh the rate of the giving the hypertonic saline should be less. And if you see this composition, I have already described you. It has already been discussed of all the crystalloids. Then we have a newer crystalloid, which is plasmalite A, which is more of a isotonic. Like it has a pH of 7.4 that is similar to the body pH, and then it is sterile, non-pyrogenic and isotonic solution. Each 100 ml contains you can see that 526 milligram of sodium chloride, sodium gluconate, sodium acetate, trihydrate, and then we have the magnesium sulfate, then we have the potassium chloride, and there is no antimicrobial agent. And the pH is adjusted with the sodium hydroxide with this solution. So what happens is this fluid is more of a isotonic, and it has all the electrolytes. It is a magnesium contained fluid, potassium containing fluid. So you can use it as a maintenance fluid and the replacement fluid. The characteristic of the fluid, if you can see that mostly the physiological are plasmalite A and ringer lactate. Then the fluids which are rich in sodium are isotonic saline and DNS. Rich in potassium is isolite G, M, and P, which corrects acidosis. We have ringer lactate, isolite E, P, and M. Then we have which corrects the alkalosis. We have isolite G. Cautiously used in ringer lactate renal failures. We have ringer lactate, isolite M, G, P, and E. And avoid in liver failure. We have ringer lactate. We should avoid that and isolate G. Then we come to the colloids. Colloids are basically the fluids which have the molecule sufficiently large enough to prevent the transfer across the capillary membranes. So basically it contains the solutions stay in the space into which they are infused. They do not pass readily from the plasma to the interstitial fluid. So thus they create a osmotic force and holds the water in the vascular compartment. And this example is hetastarch, then albumin or dextrans. The types of colloids are semi-synthetic colloids or naturally occurring colloids. In semi-synthetic, we have gelatins, dextrans, and the starches. Then we have the naturally ones are the human albumin, plasma protein, and the fresh frozen plasma and immunoglobulin solutions. In human albumin solution, albumin is the principal natural colloid which comprises 50 to 60% of all the plasma proteins. It contributes to 80% of the normal oncotic pressure and 5% solution is the iso-oncotic and leads to 80% initial volume expansion, whereas 25% is hyper-oncotic and leads to 200 and 400% increase in volume within 30 minutes. So you have to choose which percentage of albumin I require in which patient. That is important because this fact has to be remembered in your mind. Indications are emergency treatment of shock due to loss of plasma, then an adequate management of burns, then in clinical conditions of hypoalbuminemia, you have to give the liver cirrhosis, albumin dialysis, or liver transplantation you can use, or in the spontaneous blood peritonitis. Advantages are natural colloids. These are the natural ones and greater degree of volume expansion. Principal binding protein, it contains antioxidant and scavenging effects. Disadvantages of albumin are it is not cost effective, it is very expensive, and volume overload can be there. Then we have dextrans. Dextrans are now widely used. 6% solutions with an average molecular weight of 70%, 70,000 is the molecular weight. So it is called as dextrans 70. This 70 indicates that it has a molecular weight of 70,000. Then we have a 10% solution with an average weight of 40,000, that is dextran 40. Indications are it also improves microcirculatory flow in microsurgical reimplantations, extracorporeal circulation during the cardiopulmonary bypass. Advantages further 100 to 150% increase in the intravascular volume. It improves the microcirculatory flow by decreasing the viscosity, and thus it inhibits the erythrocytic aggregation. Then we have disadvantages of these dextrans are anaphylactic reactions. The most important anaphylactic reactions and the coagulation abnormalities and interference with the cross match. It is also precipitates the renal failure. Then we have gelatins, which lead to degree of volume expansion. Is the gelatins lead to 70 to 80% of the volume expansion, but duration of action is shorter in comparison to both albumin and starches. So it's not that much preferred. The indications are hypovolemia due to acute loss, acute normovolemic hemodilution, or there can be extracorporeal circulation. Then we have the volume preload prior to the regional anesthesia. Gelatins are cost effective, no limit of infusion, no effect of renal failure or impairment, but disadvantages, it may cause anaphylactoid reactions, and effect of coagulation is not yet clear, and circulatory disturbance it may cause. And then we have the hydroxyethyl starches. These are the most commonly used, and it comes into various concentrations of 6%, 10%, hetastarch, hexastarch, pentastarch, tetrastarch, and it is. You can remember the hydroxyethyl starch preparations are classified by the ratio of hydroxyl radical substitution per glucose polymer. This is an important thing to remember. It is classified by the ratio of hydroxyl radical substitutions per glucose polymer, which is called the molar substitution ratio, and ranges from 0 to 1. So this 0.7, 0.6, 0.5, 0.4, this is more important, which is written on the bottle also, whether it is 0.4%, 0.4, whether it is 0.5, 6 or 0.7, and concentration is also written. Then the important thing in this hydroxyl-ethyl starches are that the molecular weights, the molecular weight of the content, the glucose polymer is 450 kilodaltons, 200 kilodaltons. So you have to remember how much is the important. The tetrastarch is the most important, that is 130 kilodaltons, which is more or less physiological. If you see that 130 kilodaltons and 0.4 this glucose polymer substitution, this is important and it is more physiological. Indications are stabilization of systemic hemodynamics and anti-inflammatory properties. Then we have the advantages: cost effective, maximum allowable volume is covered, The hydroxyethyl starches have disadvantages also because it reduces the factor 8 and Willebrand factor level with prolongation of PTT and APTT time. It can also interfere with platelet adhesion and clot formation by reduction in the GP2 and 2B and 3A availability, and it can increase the serum amylase activity. It can also cause anaphylactoid reactions. We have this hydroxyethyl starches. If you see that, the most expensive of the tetra starches, but it is a very important. It does not have any clotting disturbances, or there is no evidence of risk in the renal transplantation. These are the most commonly used, and these are helpful. Composition of colloids, you all have to know what are the electrolytes which are available, what is the osmolality, how much oncotic pressure which causes increase or decrease, and then fresh frozen plasma is also one of the IV fluids which can be used as a colloid. Basic principles of perioperative fluid therapy, let's come to that. It provides daily basal fluid requirements, rehydration of fluid deficient patients, then maintain the normovolemia and hemodynamic stability. It enhances the microvascular blood flow, and then maintain the adequate plasma colloid oncotic pressure to avoid the tissue edema formation. It prevents or moderates the trauma-induced activation of cascade systems, guarantees the adequate transport of oxygen to the tissue cells, and promotes or monitor the diuresis. In perioperative fluid, it is always related to the perioperative morbidity risk. So we have the preoperative fluid therapy whenever a patient comes for the operation, any kind of operation. Intraoperative fluid therapy and postoperative fluid therapy. You all know about these things. The preoperative fluid therapy, you should know about correction of hypovolemia, correction of anemia, and correction of other disorders. First of all, you have to stabilize the patient. You have to see the PCV, and if balanced, then place the patient on fluids, as most anesthetic agents will alter the fluid hemostasis. Then you have to check, first of all, preoperative fluid management. In the fluid management, you have to check the dehydration status of the patient, the hours of fasting, how much fasting is the patient. You have to see how much the patient is fasted, and what he or she has taken in the last fasted time. And if they have taken anything, it is easier to maintain the zero balance if the patient is in normal euvolemic state before the surgery. Then how much the patient has taken, the carbohydrate rich drink can be given 2 to 3 hours before the surgery. There are certain changes in now the IRAS protocols about the fasting guidelines are revised now, but you have to see how much fluid was going along with that. What was the losses, whether there was a gastric loss or what the electrolyte loss. This you have to assess before giving the coming to know about the fluid status preoperatively. Then preoperative hypovolemia, you have to correct with the 0.9% normal saline, ringer lactate, or colloids or whole blood. And then you can use this because it can be there due to vomiting, nasogastric suction, or fever, or diarrhea. Then we have the anemia correction and other disorders. If the anemia is there, then you have to transfuse the blood and packed cells. And if there are other disorders, then correction should be done with the fluids and accordingly with the electrolytes. Intraoperative fluid therapy, you can calculate with the how much blood which is lost, what is the basically the anesthetic induced hypotension, or there is a replacement of the significant blood loss is done or not, how much gauge pieces are there, how much is the suction. You have to accordingly see and judge, calculate with the how much is the intraoperative fluid therapy to be given. The IV fluids intraoperatively, crystalloids or colloids can be given for fluid replacement, for rapid restoration of volume in acute hypotension, and we can use the colloids and the ringer lactate normal saline or the 5% dextrose. Then main aim of intraoperatively is to maintain the euvolemia and minimize the electrolyte imbalance, and insensible losses are to be covered accordingly. The maintenance fluid basic crystalloid infusion rate is 1 to 1.5 ml per kg per hour, and volume therapy is to be given with the boluses of IV fluids, typically 250 ml of, to assess the volume responsiveness. According to the type of surgical trauma, the least trauma is when there is no fluid loss. Minimal trauma, you have to give 4 ml per kg per hour. If there is a moderate trauma, that is 6 ml per kg per hour. And if there is severe trauma intraoperatively, then it's a 10 ml per kg per hour. Surgery with the least trauma, like ophthalmic surgery, you just have to give 2 ml per kg per hour of the hypotonic maintenance fluids. Usually D5 can be given, or you can give normal saline. Surgery with the minimum trauma is the nasal septal repair, that is 4 ml per kg per hour can be given in addition to the maintenance fluid of 2 ml per kg per hour. And then if there is a moderate trauma, then you can give 6 ml per kg per hour. If there is a, in addition to the maintenance one, so total will be 8 ml per kg per hour. If there is a surgery with severe trauma, you have to give the 10 ml per kg per hour plus the 2 ml per kg per hour of the maintenance fluid. Total is 12 ml per kg per hour. Intraoperative fluid therapy either can be given preloading or co-loading, or there is a concept of maintenance fluid, replacement fluids, preoperative deficits, and compensation, or the fluids or blood loss, insensible losses, or third space loss. This is all 4 sectors are to be covered intraoperatively. In preloading or co-loading, preloading is the rapid administration of crystalloids 1 to 1.5 liters prior to initiation of the intrathecal injections. And co-loading is that rapid administration of the crystalloids 10 to 20 ml per kg initiated at the time of the intrathecal. You have to simultaneously, when you are giving, then it is called as co-loading. If it is giving prior to that, then it is a preloading. Then we have the maintenance fluid rule is 4 to 1. You all know about it. I will not go into the detail of holiday and cigar. The drawback of 4 to 1 is that it increases the chances of hyponatremia, or there is overestimation of energy expenditure. There can be fluid overload due to overstimulation, or there can be underestimation of the sodium requirement. Then we have the third space losses and deficit. You can always calculate number of hours of NPO into the hourly maintenance fluid. Then we have the third space losses, that is the isotonic transfer of ECF from the functional body fluids compartment to the non-functional compartment, like meningomyelocele fluid, like in the intestinal obstruction fluid, peritoneal fluids. Those are the third space losses. Replacement fluids are insensible losses you have to give, like which are there with the evaporation. Then 2 to 5 ml per kg per hour of the third space loss can be given, like nasogastric or urine losses. Then blood loss can be replaced. 3 ml of crystalloid solution per ml of blood loss can be compensated. So you have to give accordingly. Post-operatively, the goals are to maintain the hemodynamics, then urine output, the normal temperature, warm skin, and the respiration, and the normal sensorium. So need for fluid therapy post-operatively is in the major surgeries like bowel resection and the anastomosis. Few days of the post-operative fluid therapy is required. In the short operative procedures, then only maintenance fluids are sufficient. Then usually the post-operative fluids, I am not going to the details, but it has been covered by me. Then fluids given to replace the additional losses in post-op patients is when there is prolonged vomiting or nasogastric suction, then you have to give the normal saline with potassium. Then fluid loss due to small bowel fistulas causing diarrhea, then you should give ringer lactate because it contains the electrolytes also, and bicarbonate and potassium supplementation to cover the metabolic acidosis and hypokalemia. Then when there is a loss of fluid blood, then you have to give 3 times for 1 time of the blood, and you can cover with normal saline and ringer lactate. In minor or major surgery, if you see that, administer 1 to 2 liters of balanced electrolyte solution whenever there is a minimal or moderately invasive surgery. And if there is a major invasive surgery, the concept of restrictive zero balance approach comes into being. There is a concept of restrictive or goal-directed approach. I will go into detail right now. There is a zero balance approach. nowadays. Zero balance is that there should be euvolemia at all the times, and restrictive and liberal. There are two types of views this has been replaced latest by the zero balance fluids. You have to maintain the euvolemia at all the times. It is also it is a term that the American Society for Enhanced Recovery has given. And according to it, cellular level in the zero balance approach, there is inadequate fluid administration. Whenever there is an inadequate fluid administration, insufficient perfusion pressures are there, reduction of oxygen delivery is there, and there is increase in the anaerobic metabolism. So thus it causes cell death and the end organ failure. And if there is an acute kidney injury, it is the most common perioperative manifestation in this. Whenever there is excess fluid administration, then it raises the hydrostatic pressure, increases the ANP, and damages the glycocalyxes. So there are leaky capillaries and tissue edema. It causes pulmonary edema. So the zero balance approach always has to be there. It has to maintain the euvolemia. Do not give the fluid, or do not over giving of the fluid should be there. This is a newer approach of the perioperative fluid management. It should be individualized. Then fluid therapy is guided by the predefined physiological targets of the hemodynamic monitoring. Goal-directed therapy is the best way to manage high-risk surgical patients. Then the intraoperative Butener et al. Told that intraoperative goal-directed therapy was associated with increased fluid administration, whereas Lopes et al. Told that during the high-risk surgery, it decreases the incidence of post-operative complications. Ultimately, if you see that, you can use Vigilo or flow track monitors which increase the hemodynamic stability, and you can use these for the goal-directed therapy. Basically, goal-directed therapy is a strategy of the fluid administration, specific and highly individualized for each patient. There are no standard rules that one rule is for everybody, but you have to set the goals for each and every patient at all times. So then the esophageal Doppler can be used for that. This is a chart you should remember. This is a hemodynamic algorithm. Goal-directed hemodynamic algorithm is given, which has initial assessment and the treatment, further intraoperative optimization. This you have to learn, you have to see. I will not go into the detail in this. This goal-directed therapy is a continuous dynamic process that targets defined physiologic endpoints. Then various tools are to measure the physiologic targets of goal-directed therapy. These are vital signs, physical examinations, lab investigations like fractional excretion of sodium or urea, and then lactate levels in the blood, then oxygen extraction and venous oxygen saturation, then central venous saturation. Then you can use Doppler or echo for calculation of left ventricular end diastolic volume, stroke volume, cardiac output, or the cardiac index. Then transesophageal echocardiography, transesophageal Dopplers. There can be use of pulmonary artery catheterization or arterial wave analysis can be done with the Vigilio or flow track. These are the non-invasive monitors which can be used. There can be bioimpedance based technologies which can be used, or electrical bioincidence based technology which can be used for measurements of invasive and non-invasive cardiac outputs. Big question is which plasma volume expander to use. It is still controversial. Let me tell you. Remember that tonicity describes the effective osmolarity of the fluid, which is the ability of the fluid to alter the water movement across the cell membrane. There can be hypotonic solutions, hypertonic and isotonic solutions. Few facts are that most common fluid which is used is sodium chloride, and it defines the ECF. Then we have it causes, if more amount of sodium chloride is given, it causes hyperchloremic acidosis. Then crystalloid preparations which contains the glucose, it is also important. With water loss plus excess of electrolytes, it is uncommon. So, and loss of water plus without the loss of electrolytes is also rare. So next is you have to remember that there are certain controversies of colloids. There is no evidence for albumin to support that routine administration of albumin is in the hypovolemic states. It is beneficial in some states, I have already told you. In dextrans, gelatins, or hydroxyethyl starches, there are importance of physiochemical structures in the characteristic in the hydroxy starches. Degree of hydroxylation is ethylation is important for duration of volume effect. For concentration, initial values of volume effect is very important. Substitution pattern, I have already told you and discussed. It defines the serum kinetics of each and every hydroxyethyl starch. C2C6 ratio defines how much is the intravascular half-life. Then molecular weight is the volume, which defines the volume half-life. So all are important. You have to know about these starches. Then third generation hydroxyethyl starches has certain effects on the coagulation. It says that blood loss and transfusion requirements can be significantly reduced by using this HES 130 by 0.4. It is much preferred at all times. It is more of a balanced times. It comes into the volumen or hydroxyethyl starch. Then we have the effects of the colloids on the kidneys. It has concluded that the administration of hydroxyethyl starches have no influence on renal function or need for RRT. This is the critical care now. Then in critical cares, usually the starches are not used because sometimes, most of the times, the patients are having some sepsis or something like that. Then we have let me go fast because time is very less. There are certain balanced solutions which are to be used. These balanced solutions contain the sodium, potassium, calcium, magnesium, and the colloid solutions. And there is a concept of liberal versus restricted fluid strategy. Liberal fluid strategy when more than 5 liters are given, and restricted fluid strategies when less than 3 liters are given. But it is said the liberal fluid strategy increases the morbidity and mortality, particularly in high-risk patients. And individualized goal-directed therapy is the key to success. Always go for that. So importance is, then there is one important thing which I want to discuss is fluid challenge test. Fluid challenge, previously the people used to do the clinical test with the CVPs, but now it uses, there is a venous return directly, it is based on the venous return directly proportional to the cardiac output. So it is based on the Frank-Starling mechanism. In this, what happens is when you give the fluid, it increases the preload, increases the ventricular filling, and increases the end diastolic volume. There is increase in cardiac myocyte sarcomere length, and there is increase in the force of contraction. Thus, ejection of the blood from the heart is increased. In fluids, the aim is in fluid challenge is to expand the stressed volume. It is defined as that the body contains stressed fluid and the unstressed fluid. So what happens is, if you see this diagram, whenever this is a stressed one, this is unstressed one, when there is an increase in the mean systemic filling pressure, this stressed one is increased, that goes for the requirement of the fluid of the post-fluid challenge. This is the important thing. In the pre-fluid challenge, there is no fluid is given, so the body is divided into unstressed and the stressed fluid. In this model, you can see. And if you give the fluid, that stressed one is increased, and it is because of the elasticity of the capillaries or the elasticity of the vessels. That is the which rises. So that increases the mean systemic filling pressure. So fluid challenge, basically it can be measured with the echocardiography also, with the left hand diastolic volume and all those cardiac index and cardiac outputs. That causes nowadays we can be used. And for volume, you can give 4 ml per kg of crystalloid can be given for the fluid test. Words of caution about the fluid. Let me complete fast. That crystalloid solutions, normal saline large volumes causes the hyperchloremic metabolic acidosis. Ringer lactate causes lactate metabolic alkalosis. Ringer lactate and plasma light are the potassium containing fluids, and calcium in the ringer lactate, it prohibits its use in the presence of the citrated blood products. Then colloids always are related to the coagulation abnormalities. Hydroxyethyl starches are the safer ones. Then which fluid to use? The optimal fluid choice remains poorly defined. Fluid choice can have an impact on the outcome and patient factors. You have to see the patient factors and the fluid factors before choosing the fluid. Replacement versus maintenance fluid you have to read. Then whenever there is a potassium to be added, you have to add accordingly in the hypokalemia. Magnesium concentration is to be done in the hypomagnesemia. You can use plasmalite A. Then calcium concentration is to be seen. Then lactate has its own impact. Whenever large amount of lactate containing fluids are given, it causes elevations in the lactates. Then in special condition, you see gastrointestinal surgery, you have to cover with the colloid administration, which should be goal directed. Then in laparoscopic GI surgery, it contains only 60% of that needed in the open abdominal surgery. So you can use ringer lactate in this. In the vascular surgeries, you can always use balanced hydroxyethyl solution with the crystalloids. Then in the daycare surgeries, you can use liberal fluid administration, and you can use 1 to 2 liters of fluids. Then in OBS and gynae procedures, you have to be very particular about goal-directed therapy. And then in the perioperative fluid consideration in pregnancy, it is a full chapter. You have to see accordingly what is the type of anesthesia which is given, regional or the GA. Then in preeclampsia, you have to be very cautious about the fluids. Then in perioperative fluids consideration in pregnancy, always care for the pulmonary edema. There has to be co-loading or preloading. It has to be seen. Goal-directed therapy has the most important component which can be used in the pregnancy. In plastic surgery, always large volumes of crystalloids are used. And then patients with renal diseases, always be cautious, because aim is to rectify or lessen any previous damage, maintain the adequate flow or diuresis and the oxygenation. Fluid therapy, you have to be restricted whenever there is the renal problem is there. Always in renal diseases, you have to see the fluid, overfluid. A small amount of overfluid can cause the pulmonary edema, or the patient may go into the CHF. Then I will not go into details of this. Let me conclude now, because these are the things you have to read yourself. In the burns, you have to follow the Parkland's formula, and ringer lactate is the best one which can be used. And the rest of the things, if I say that, take-home message is the fluid therapy, although routinely practiced and extensively studied, it is still misunderstood. Many crystalloids, colloids are available. Selection of the right one is the art. Liberal versus conservative approach is an ever-evolving discussion, and the individualized approach should be made as per the patient, procedure, and other factors. Need to implement the goal-directed fluid therapy, you have to do that. Thank you so much. I'm thankful to. Thank you, sir, for the video which has been presented. And today is the era of video presentations side by side, because it saves time. And I'm thankful to the chairpersons.
Thank you, Dr. Manpreet. This topic is very, very wide, and it is very difficult to cover in, say, 40 minutes to 1 hour.
Yeah.
I could understand that you were hurrying through the subject, but I am appreciative of your extensive slide making, covering nearly each aspect of it. Although the time did not permit you to speak all of whatever was written in the slides, but thank you very much for an exhaustive presentation.
Yeah. There is one question, sir. There is one question in
I
the
hope there are no
box.
questions. If there are any, Dr. Nitin will ask from you.
So there is one question. What is the maximum amount of colloid fluid that can be given for intraoperative blood loss?
Yeah, actually, what is the important thing in this is that colloids, we have to see which colloid.
Dr.
First.
Manpreet, please, please.
Yeah. First of all, we have to see which colloid is to be given. That is most important. Then accordingly, the dose can be adjusted. And the dose depends on the age of the patient or the which scenario, whether in the intraoperatively, which type of surgery is going on, how much blood loss has already been done. And so the best is the volume which is used, which is has the 130 kilodaltons and 6%, and 0.4 is that hydroxyethylation of that. And you can use 50 ml per kg of maximum, which can be per day, can be used accordingly.
Hi, this is Dr. Ambesh here from SGPGI.
Yeah. Good morning, sir.
Could you hear me?
Yeah. Good morning, sir. Good
Yes,
morning.
sir.
Okay.
We can hear you.
Yes. It was a really very nice and comprehensive presentation. I must congratulate you. I understand that it's not easy thing to describe everything in 40 minutes or 1 hour. From my side, I would say that no crystalloid or colloid is ideal or can be used as a silver bullet in all clinical situations.
Yeah.
What I feel is that all the clinicians must remember the various constituents of each crystalloid and colloid fluid. I mean the pH, the osmolality, the sodium, potassium, chloride, magnesium, etc., etc. Okay, so that is one thing. And then see the milieu interior of the patient. Milieu interior of the patient in terms of sodium, potassium, other electrolytes, pH, and how much fluid the patient needs. So that then you can decide. Okay, further, it's also important to keep in mind whether the patient is not suffering with the renal failure or hepatic failure or cerebral edema. So according to all these things, keep everything in mind, and then you select the fluid. Say, for example, if the suppose this is based on my own experience, I would say that 80% of our PGs who have gone under examination, whether it's an MD or DNB in anesthesiology, I found that they do not know the constituents of the various fluids, and they just say that इसमें हम ये दे देंगे, इस particular disease में हम ये दे देंगे. It's not like that. You have to see the milieu interior. You have to see the electrolyte of the patient. Suppose, say, for example, plasma light is supposed to be like the universal fluid. You can give plasma light. But if the patient is having hyperkalemia,
Yeah.
because plasma light contains 5 milliequivalent of potassium. But if you give a plasma light to a hyperkalemic patient, then it's a disaster. You cannot give it. Okay, so it's like that. So I will not go further because the time is limited, already exceeded, I know. So thank you so much. Nice presentation.
That's why, sir, the concept of goal-directed therapy and zero balance fluid was come. And I think the students must read this goal-directed therapy. It is a hot question for the coming exams always. So it's a newer concept which has been formulated again. Thank you so much. Thank you, MD Kaur ma'am. Thanks, Dr. Nagpal. It is Dr. Sushil. It always has been a great pleasure to talk to you, sir. Thank you.
Yes.
Thank you,
Thank you,
ma'am.
Manpreet.
Thanks.
Thank
Thanks
you.
a lot. Thanks a lot. ma'am.
Thank you, sir. Thank you for beautifully
Thank
covering
you,
up this
everybody.
topic.
Thank you. I
Thank you.
now conclude the session.
Thank you.
Thank you.
Thank you, sir. So moving on to our next session, which is a long case So moving on, next we have is a pop-up on NRS and VAS by a senior resident, Dr. Sheetal Singh. She's a senior resident at ABVMS and Dr. RML Hospital. And her areas of special interest are difficult airway, pediatric anesthesia, and obstetric anesthesia. Over to you, Sheetal.
Thank you, sir. Good morning, everyone. Today we'll be discussing about numeric pain scale and visual analog scale. Why we need to study about these pain scale? As an anesthesiologist, pain is our main concern throughout the perioperative period. These scales, which we'll be discussing today, are mainly used to evaluate acute pain during postoperative period. Now, what is pain? According to International Association of Study of Pain, it is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. How do we assess pain? By doing a detailed medical history of the patient, clinical examination of the patient, and if required, doing specific investigations. Now, what are the various methods to assess pain? They can be either unidimensional or multidimensional. Multidimensional methods are mainly used to assess chronic pain, so we will not be discussing them today. We will be mainly focusing on unidimensional methods, which are used to mainly study acute pain. These include verbal rating scale, binary scale, numeric pain scale, visual analog scale, faces rating scale. Coming to numeric pain rating scale, also known as numeric rating scale, numeric pain scale. As the name suggests, it is a type of numeric rating scale used to measure pain severity. This format uses a discontinuous and segmented scale. Thus, whole numbers are reported. What I mean with this is that number will be reported as whole, like 1 or 2. There's nothing between 1 and 2. There's no 1.5, 1.4. The most common style include a horizontal bar or a line format. The line is marked with whole number from 0 to 10, where 0 represents no pain and 10 represents the worst possible pain. However, some scales may use different ranges such as 0 to 5, but they are not commonly used. Most common format used is between 0 to 10 only. The patient is asked to mark on this scale to rate their pain, and then that number is recorded. Now, what is visual analog scale? As the name suggests, it is analog format. What is analog format? It is a continuous format. In this, we use a horizontal line measuring exactly 10 centimeters, where the start of line represent no pain at all and end of line represent excruciating pain. Patient is asked to mark on the line, and then line is measured and recorded in millimeters and centimeters. The length of line is important for this outcome measure since this tool has been evaluated in this format and the measurement relies on the line being exactly 10 centimeters long. What I mean to say with this is that every time your line should be exactly 10 centimeters. If you vary the length of the line, your results will also vary. Now, what are the similarities between these two pain scores? In terms of time consumption, both methods take less than 1 minute to complete. In ease of use, both methods are easy to use. No specific training is required. Both methods are minimal language translation difficulty, so can be used across cultures and languages. Reliability, both methods are valid and equally reliable in measuring the pain intensity. The common drawback of both the methods is that they evaluate only one component of pain experience and they do not capture the complexity and idiosyncratic nature of the pain. Now, coming to the differences between the two, NPS is more objective while VAS is more subjective. NPS can be done on paper, pencil, verbally, or even telephonically. For VAS, we need to have a paper and pen. It cannot be done verbally or telephonically. NPS scale can be reproduced using photocopy and printout without worrying about any dimension. While in VAS, we need to be very, very careful about dimensions every time we reproduce it. NPS is less sensitive to small changes while VAS is more sensitive to small changes. NPS Scoring is quite simple in comparison to VAS, which is little complex than NPS. Data collected is in numbers in NPS, while it is in interval and ratios in VAS. NPS is better for comparing across a group of individuals at one point of time. VAS is less useful for comparing across a group of individuals at one point of time. Now, what are the other uses beside using these scale for pain? We can also use them for other symptoms like discomfort, stiffness, dyspnea, and itchiness. Please don't confuse NPS and VAS with Wong-Baker Faces Pain Rating Scale, which is commonly used in pediatric patients to evaluate pain. These are my references. Thank you. Thank you, MD Gaur ma'am. Thank you, everyone. Thanks, MD ma'am, for giving me this opportunity. You have guided me from past 3 years during my whole stay in RML. I'm so thankful you gave me this opportunity to speak today. Thank you, ma'am. Sir, are there any questions?
No, there are no questions. Thank you, Sheetal.
Thank you, sir. Thank
So-
you, ma'am.
We'll have our first quiz for the day. I request the delegates to answer the questions as quick as possible. So the first question is, a young patient with incurable disease has which of the following types of pain? Physical pain, spiritual pain, social pain, or all of the above? The second is, all of the following are true for children with congenital dynamic hernia, except pulmonary hyperplasia may be present, dextrocardia is common, bag and mask ventilation is contraindicated, or the surgical management takes precedence over the medical management. Since we are already running short of time, we won't be going ahead with the tea break. We'll directly move on to the long case session. So today's long case is on morbid obesity, which is a 39-year-old female with a BMI of 45 kg per meter square posted for bariatric surgery. And as an external examination, we have a very renowned anesthesiologist with her, Dr. Sonia Vadhavan. Ma'am is Director Professor at Department of Anesthesia and Critical Care at Maulana Azad Medical College, New Delhi. Ma'am has several publications to her credit in various indexed national and international journals. She is an ACLS provider and instructor and has been actively involved in training courses. Ma'am is the founder member of Airway Management Foundation. She's a faculty in Airway workshops and PG assemblies, has been faculty at various national conferences. She has been the postgraduate examiner for various universities, included DNB examiners as well. She is member of ISA, IPA, ICA, RSAPICON, and Obstetric Anesthesia Society. And her areas of special interest are airway, obstetric, and pediatric anesthesia. We welcome you, ma'am. Moderating the session with Dr. Sonia, ma'am, we have Dr. Shubhi Singhal. She is specialist at Delhi Cantonment General Hospital, New Delhi, and her areas of special interest are obstetric anesthesia, pain and palliative care, and difficult airway management. The PG for this session is Dr. Mansi Mittal. She's a third year postgraduate student at ABBIMS and Dr. RML Hospital. Over to you, ma'am, for proceeding the session.
Thank you so much, Dr. Nitin, for such a generous introduction. A very good morning to everybody. At the outset, I would like to thank Dr. Kaur, Dr. Nirja, Dr. Nagpal, Dr. Akhilesh, and the whole team for this excellent academic extravaganza. And I'm sure it will benefit all the postgraduates who are going to be a part of this academic meet. And before any further delay, I would like to ask Dr. Mansi to start, and Dr. Shubhi, a warm welcome to you too.
Good morning. Good morning, everyone. My case, Mrs. Sunita, is a 38-year-old female, a resident of Patel Nagar, New Delhi, and is a telephone operator by occupation. She is Hindu by religion. She presented with chief complaints of progressive weight gain since 5 years and loud snoring since 6 months. My patient was apparently all right 5 years back, which is when she started experiencing weight gain, which was gradual in onset and progressive in nature over the 5 years. She gained a total of 35 kilograms and her current weight is 110 kgs. It was associated with lethargy and tiredness. The distribution of fat is primarily over lower abdomen, hip and thigh areas. She also reports of snoring since past 6 months as informed to her by her husband, which was gradual in onset, occasional in frequency and faint in intensity initially. But now she snores for most of the night, which is loud enough to be heard across closed doors. It is aggravated by lying supine and is slightly relieved by lying head up on 2 pillows. There was no history of sudden awakenings from sleep, early morning headaches, or daytime sleepiness. There was no history of decreased appetite, cold intolerance, or hair loss. There was no history of menstrual abnormalities, dry skin, or constipation. There was no history of blackish discoloration of neck or axilla, and no bluish marks over the abdomen. There was no history of intake of medications like oral contraceptive pills, steroids, or antidepressants. My patient gave no history of breathlessness, chest pain, palpitation, or any syncopal attacks. There was no history of cramping pain or swelling in the legs. There was no history of heartburn, regurgitation, or upper abdominal pain. There was no history of joint pain or back pain. History of past illness. My patient is a known case of hypertension since past 4 years, which is controlled on oral medication. There was no history of tuberculosis, diabetes mellitus, bronchial asthma, thyroid disorder, or any psychiatric illness. There was no history of any surgery, previous anesthetic exposure, or blood transfusion. Treatment history. For the past 4 years, patient is on tablet amlodipine, 5 milligrams once daily, and is compliant to treatment. The patient has unsuccessfully tried reducing weight by means of diet restriction a few times before, but apart from that, she has not taken any treatment for weight gain. Family history. There was no family history of obesity, and father is hypertensive, which is controlled on medication. There was no similar complaints in mother or sibling. Personal history. She is married, having 2 children, 8-year-old son and a 6-year-old daughter. Husband is a shopkeeper by occupation. She is non-vegetarian by diet. She is non-alcoholic and non-smoker. Bladder and bowel habits are normal. Her appetite is normal. Socioeconomic status. She belongs to lower middle class. Menstrual history. Menarche was attained at 13 years of age. Menstrual cycles are regular with normal flow lasting for 3 to 4 days. Last menstrual period is 5th February 2022. Obstetric history. She is gravida 2, para 2, live 2 with full term normal vaginal delivery at hospital and no exposure to any anesthetic agent. General physical examination. The examination was done after taking consent from the patient. Patient was conscious, cooperative, and well oriented to time, place, and person. She was sitting comfortably on a chair. Her weight was 110 kilograms, height 155 centimeter, BMI 39 kg per meter square, waist circumference 90 centimeter, hip circumference 100 centimeter, waist to hip ratio 0.9. Her pulse rate was 84 beats per minute, recorded in right radial artery, which was regular, good in volume and character. There was no radioradial or radiofemoral delay. All the peripheral pulses were palpable. The blood pressure was noted to be 130/88 mmHg, measured in right upper arm in sitting position using appropriate sized cuff. Her respiratory rate was 16 beats per minute, which was regular and abdominothoracic in nature. Her room air saturation was 96%. She was afebrile and there was no pallor, icterus, clubbing, cyanosis, or lymphadenopathy. Edema was not elicited. JVP was not raised and venous access was found to be difficult. Airway examination. There were no visible maxillofacial abnormality. There was no apparent deformity of nose and cheeks. Both the nostrils were patent. In dentition, there were no loose, bugged, or missing teeth. Artificial teeth were not present. Good oral and dental hygiene was present. Her mouth opening was more than 5 centimeter. Modifying Mallampati grays were grade 3. She has a large tongue and a double chin present. On Calder's test, lower incisors were anterior to upper jaw, that is normal functionality of the temporomandibular joint. The upper lip bite test was class 1. Neck circumference was noted to be 40 centimeter, and a slight hump was seen over the back of the neck. Neck movement were normal as demonstrated by a Delican's test. Her hyomental distance was recorded to be 6 centimeter, thyromental distance 6.5 centimeter, sternomental distance 12.5 centimeter, cricoid cartilage was palpable, and she has large breast. Cardiovascular system. On inspection, there were no precordial bulge, no visible pulsation, no venous deformity. Apex feet was not visible. There were no scars, sinuses, dilated veins in any part of the thorax. On palpation, inspectory findings were confirmed. Apex fleet was not palpable, and there was no palpable thrill or panasternal heave. There were no pulsations felt. On percussion, cardiac borders could not be adequately appreciated. On auscultation, S1 and S2 were heard in a fifth intercostal space, 1 centimeter medial to mid-clavicular line, and there were no murmurs heard. Respiratory system. On inspection, the shape was found to be normal. Trachea appeared to be in the center. Respiratory rate was 16 beats per minute, regular and abdominothoracic in nature. Bilateral chest movements were equal. There were no swelling, scar, or venous pulsations noted over the chest wall or back. There was no audible wheeze or stridor. Usage of accessory muscles of aspiration was not there. On palpation, inspectory findings were confirmed. Surface temperature was normal. Trachea was midline in position. There were no tenderness or bony deformity. Chest wall movements were equal. Focal frematives was normal and equal. Chest expansion on inspiration was 3 centimeter. The diameter of anterior-posterior was 42 centimeter and transversely 54 centimeter on end inspiration. And on end expiration, it was 39 centimeter and 51 centimeter respectively. On percussion, reduced resonant notes were noted in all areas. On auscultation, bilateral vesicular breath sounds in all areas were heard. There was no added sounds. Vocal resonance was normal. A bedside pulmonary function test, subrachis breath holding test was 45 seconds. Single breath count was 40. Forced expiratory time was 4 seconds. Cough test, she was able to cough with moderate strength, and there was no productive cough or self-propagated paroxysm of coughing. Other tests could not be performed due to non-availability of equipments. On inspection, abdominal examination. On inspection, the shape was enlarged, pendulous in nature. All quadrants moving normally with respiration. Umbilicus was centered in position and inverted. There were no visible scars, sinuses, or venous pulsation. There was no visible lump, no visible pulsation or peristaltic movements. Stretch marks were present over lower abdomen. On palpation, inspectory findings were confirmed. All the 9 quadrants were palpated. Normal temperature. There was no superficial tenderness. There was no fluid thrill or any organomegaly. On percussion, tympanic was noted. Shifting dullness was not present. On auscultation, normal bowel sounds were heard. Central nervous system examination. There was no significant neurological deficit. Her higher functions, cranial nerve and center motor system was found to be normal. There was no abnormality detected. Spine examination. On inspection, head position and hairline was in midline. There was no short neck and a slight hump was noted on the back of the neck. The curvature of spine was normal. There were no visible scars, sinuses, or swelling. On palpation, local temperature was normal. No tenderness or any palpable swelling. Intervertebral space could not be well appreciated. So my provisional diagnosis is Sunita, 38-year-old female with grade 2 obesity and hypertension, which is controlled on medication, posted for laparoscopic sleeve gastrectomy.
Okay, that was quite a detailed history and examination, Mansi. I would just like to know what are the positive findings in your history and examination in this particular case?
In my case, positive findings in the history are weight gain, which is gradual and progressive over the 5 years, and it was associated with lethargy and tiredness. Then she also reports of snoring since past 6 months, which has increased, which is loud enough to be heard across closed doors. And she is a known hypertensive since past 4 years and is on tablet amlodipine 5 mg OD, which is controlled on medication. On examination, BMI is found to be 39 kg per meter square. and the venous access is difficult. Airway examination shows various positive points. Malampatti grade of 3. She has a large tongue and double chin. She has a large breast, and neck circumference is also 40 centimeter, which is borderline. Yes.
So these are the positive findings. So you have put this patient in what you said, grade 2 obesity. Can you classify obesity based on the BMI?
Obesity can be classified on the basis of BMI. If it is less than 18.5 kg per meter square, it is taken to be underweight. 18.5 to 24.9 is normal. 25 to 29.9 is overweight. 30 to 34.9 is obese class 1. 35 to 39.9 is obese class 2. And more than equal to 40 is obese class 3, which is also called morbid obese. And more than equal to 50 is super obese. So,
okay. So this patient, since her BMI is 39, so you have put her in grade 2 obesity.
yes.
And she has also got associated hypertension. Now this patient is posted for laparoscopic sleeve gastrectomy. What are the various surgical procedures a patient is posted for corrective surgery or a metabolic or a bariatric procedure? What are the various, just broadly to classify them?
There are 3 types of procedures, predominantly restrictive, predominantly malabsorptive, and combined procedures. In restrictive procedures, there is gastric volume reduction, and it includes sleeve gastrectomy, laparoscopic adjustable gastric banding, and vertical gastroplasty. In malabsorptive, there is bypass is created to decrease the absorption of the fat, and it includes procedures like biliopancreatic diversion, duodenal switch, and gastroileostomy. In combined procedures, it includes a Roux-en-Y procedure and duodenal switch along with sleeve gastrectomy.
Okay, so this patient is for a restrictive procedure, and as per your history and examination, it is basically appears to be a lifestyle disease in her case. And unlike what she says that she has normal diet, she must be definitely consuming much more than required, and that is how she has landed up with a BMI of 39. There is nothing to suggest that there's some associated metabolic or any endocrinology disease associated in her case. Rest we will try to rule out as per the investigations. So if you have to anesthetize this patient who is being posted for laparoscopic sleeve gastrectomy, what are your basic concerns? Can you broadly enumerate the concerns?
Ma'am, in this patient, my patient is a grade 2 obesity with hypertension. So anesthetic concerns will be difficult positioning, difficult airway, difficult IV access. There are more increased episodes of desaturation perioperatively. Their decreased ability to tolerate apnea. The drug dosing is different. She needs a OT preparation is different. She needs a OT table of appropriate size, cuff and monitors of appropriate sized, and a goal-directed fluid therapy.
Okay. So you have broadly classified it on the basically taking into account her obesity. So you have said that a specific type of a OT arrangement has to be prepared. There should be sufficient staff, and the staff should be specifically trained to manage obese patients. The anesthesiologist should be trained specifically for anesthetizing and perioperative management of these patients. You need special equipment in terms of the trolley, the bed, and you need to have a difficult airway cart in all these patients, and with each of the draws specifically mentioned so that you don't waste time in case you need to get any of these equipment. Rightly said, the airways more often than not difficult, but manageable in these patients. The apnea time, as you said, they desaturate easily. Some of them who are into super obese or morbidly obese patients, they may have pre-existing decreased respiratory reserve. Then the drug dosing becomes very different as compared to a non-obese patient. Then, of course, since with the OT table, the positioning of the patient, securing of the airway, intraoperative fluid and blood management, intraoperative and postoperative analgesia, And all this, and along with that, the comorbidities which are associated with obesity. In this patient, she has hypertension, but more often than not, most of these obese patients have type 2 diabetes, which itself has a whole subset of problems associated. Some of them may have associated CAD, or other cardiac abnormalities may be there in terms of arrhythmia. So we have so many things to take care of, along with the concern of the surgery. There are certain surgical concerns, the positioning of the patient and the intraoperative requirement. And so these are the broad aspects that we need to take into account. Now, keeping all this in mind, what are the investigations you would like to conduct, and how will you optimize this patient preoperatively who is going to be posted for an elective laparoscopic sleeve gastrectomy?
Ma'am, I would like to get investigations, which is a complete blood count, which includes hemogram, total leukocyte count, and platelet count, fasting blood sugar and postprandial blood sugar. Then liver function test, which includes serum bilirubin, liver enzymes, and serum proteins. Kidney function tests with along with serum electrolytes. Thyroid function test and serum cortisol. Although serum cortisol, it is not applicable in a patient, but we can get it to rule out any Cushing disease or hypothyroidism. Coagulation profile, which includes PT, APTT, and INR levels. Acid-base gas analysis. Chest X-ray, pulmonary function test, and 12-lead ECG, 2D echo, and polysomnography.
Okay, so when you mentioned about ABG, you can routinely do it, but it is 100% or definitely indicated in some situations. Could you enumerate some of the situations where you would like to definitely have an ABG?
Ma'am, if the patient complains of snoring or gives history of observed apnea, if patient is a known OSA patient, obstructive sleep apnea, and using CPAP, or patient is giving history of cessation of breathing during the night and repeated arousals. So we like to get an ABG.
So basically, you would like to rule out in patients who have what kind of respiratory compromise is there in these obese patients predominantly?
In obese, predominantly restrictive pattern is seen.
Okay. So the pulmonary compliance decreases, there is a restrictive lung disease kind of a pattern. Along with that, most of these patients will have some or the other degree of obstructive sleep apnea. So wherever you are having a high degree of suspicion, you would definitely like to go ahead with an ABG. A baseline ABG will be helpful in to see the change also in the intraoperative and the perioperative period, and also to predict the possible need for postoperative ventilation, and also to decide as to the risk that the patient is going to undergo for the surgery and anesthesia. So what do you understand by obstructive sleep apnea?
Obstructive sleep apnea is defined as cessation of airflow for more than 10 seconds despite respiratory effort, and there are more than equal to 5 episodes per hour of sleep, and the saturation level is dropping up to 4% or more than 4%.
Okay, so can you classify on the basis of severity?
We can ask for a questionnaire, stop bank questionnaire to the patient, and we will classify them accordingly, according to the risk.
What do you understand with the stop bank questionnaire?
In stop bank, we will ask these questions. From S, we'll ask for snoring. If the patient is snoring and it is loud enough to be heard across closed doors. For T, it is tiredness. Patient is tired and fatigued. Then O, observed apnea. And P is blood pressure. For B, it is BMI levels, more than 35 kg per meter square. A is for age, more than 50 years. N is neck circumference, more than 40 centimeter for females and more than 42 centimeter for males. And G is for gender, which male gender. Each question will be responded either in form of no, and each yes is given a point, 1, and score is calculated. If the score is 0 to 2, it is mild risk, 3 to 4 is moderate risk, and more than equal to 5 is high risk.
Okay, good. So basically, our patient comes under which risk? Mild, moderate, or severe?
Ma'am, my patient comes under moderate risk. She has snoring, she has tiredness, blood pressure, and BMI is greater than 39 is 39 kilogram per meter square. So it's a total of 4, and it comes
Okay.
under intermediate risk.
Okay. So what is this obesity hypoventilation syndrome? You mentioned polysomnography. If there is OSA, if there is obesity hypoventilation syndrome?
In obesity hypoventilation syndrome, it is a long-term sequelae of OSA. In this, there is nocturnal central apnea, that is cessation of breathing for more than 10 seconds, but without any respiratory effort. It is because of desensitization of the respiratory system, desensitization of the respiratory system in the brain to hypercarbia. So the patient is chronically hypercarbia and hypoxemic. And
Okay.
it can lead to further respiratory acidosis and pulmonary hypertension, and finally right heart failure.
Okay. So you have mentioned about PFT and echo findings. What do you expect in our patient? What would be the effect on the echo? What would be the positive findings in echo?
Ma'am, in echo, we can find the chamber dimensions. In my patient, there can be left ventricular hypertrophy, left ventricular strain pattern, and we can see the valve area and calcification if present, and left ventricular ejection fraction, left ventricular diastolic dysfunction. Then regional wall motion abnormalities can be there if there is hypokinesia or akinesia.
Okay. So so then moving ahead in your investigations, what are the rest of the investigations? You've covered all of them?
Yes, ma'am.
Okay. So after all these you have, I would like you to, give me a little detailed description about the polysomnography.
Yes, ma'am. Polysomnography, it is a diagnostic test for various sleep-related disorders. There is simultaneous recording of multiple physiological parameters related to sleep and wakefulness. And they are indicated for various sleep-related disorders, CPAP titration in OSA, or to assess the treatment result in obstructive sleep apnea. Various parasomnias, narcolepsy, paroxysmal arousal, and seizure disorder. Recordings include, we will record the EEG, electroencephalogram, to see the electrical activity of the brain during sleep. Then EOG, electrooculogram, for eye movements that will represent REM or non-REM sleep. Electromyograms are recorded in the two form, at the level of chin and at the level of leg. In the chin, it will see the arousal and activity of upper airway. In the leg, it will monitor the leg movements. Nasal and oral airflow using airway microphones. Elastic belts over the chest and abdomen are attached for respiratory efforts. Infrared video camera for changes in body position during sleep. Then capnogram, electrocardiogram, and blood pressure, the pulse oximetry. We'll record all these parameters, and the result will be given in the form of apnea-hypopnea index. The total apnea-hypopnea index is total number of episodes of apnea and hypopnea divided by total sleep time. It is categorized as mild if it is 5 to 15 events per hour, or moderate if it's 15 to 30 events, and more than 30 events are categorized as severe. We can calculate total arousal index also, which are total arousal during the sleep per hour. And respiratory disturbance index, which is a combination of apnea-hypopnea index and total arousal index.
Okay. So now after you've done these whole battery of tests, and in our patient, the patient has a good exercise tolerance. Most of these investigations are all in the acceptable range. Simultaneously you would start doing you would give some advice to optimize the patient's condition. What all can you do, and what do you have in mind to basically ensure that it is optimized prior to surgery?
Ma'am, to improve the pulmonary function, we will advise some breathing exercises and incentive spirometry. We will like to give a DVT prophylaxis in the form of pharmacological or non-pharmacological. We can, I'll give pneumatic compression devices to my patient, and I will advise the patient to go for a nutritionist and get advice on the caloric restriction to get a very low caloric diet, including liquid diet in most of the meals.
Okay. So, and you would have explained the whole procedure to the patient in detail. So yes, you would like to talk about the nutritional status and suggest a dietitian to take care of the diet at least 5 to 7 days prior to the surgery. You would try to optimize the chest condition by increasing the reserves and decreasing the atelectasis if at all. And for that, you would advise incentive spirometry, the breathing exercises. You can also give nebulization with bronchodilators if required. And DVT prophylaxis is very important because these patients, because of their obesity, may be less mobile and it's a pro-thrombotic condition, obesity. So there is always a chance of thromboembolism in the perioperative period. So you would like to, and you have correctly said, it can be pneumatic, it can be pharmacological or non-pharmacological. In pharmacological, which one would you suggest and what dosage?
Lower molecular weight heparin in 40 milligrams subcutaneously once daily.
Okay. So no low molecular weight heparin is basically done according to the adjusted body weight. There is a lot of controversy whether it should be lean body weight or adjusted body weight. And but the more important thing is to titrate it to the factor 10A levels. And when should we stop if we are giving it as a prophylactic dose prior to surgery? Suppose you started, there is a reason to suspect that there is deep vein thrombosis, and there is diagnostic modalities have confirmed it. So when would you, I mean, there is a high degree of suspicion, then when would you like to stop it?
I would advise the patient to stop at least 12 hours prior to surgery. Night
Okay.
before surgery, she can stop it.
Okay, so if it is on a prophylactic dose, it's once dosage, so it is stopped 12 hours prior to surgery. In other cases, it may be different depending on if it is on a therapeutic dose, you may need to stop it 24 hours prior to surgery. And we do continue with the pneumatic stockings. So either you have the graduated compression stockings or you have the pneumatic calf compression devices. So coming on from here, moving on from here, what would be your preoperative advice to this patient and anesthetic management thereafter on the next day of surgery?
Ma'am, preoperative advice will include, I would advise for NPO orders, which is same for non-obese patient, that is 8 hours for solid and 2 hours clear liquid. Then anti-aspiration prophylaxis in tablet ranitidine 150 milligrams and tablet metoclopramide 10 milligrams night before surgery and 2 hours before surgery. Then anxiolysis we will give in the non-pharmacological way, a reassurance to the patient and motivate the patient about the benefits of the surgery. Then I will advise the patient to continue pneumatic compression devices the night before surgery and to bring the device in the intraoperative period. And I will advise the patient to continue breathing exercise, incentive spirometry. Then I will advise the patient to take, I will take a written informed consent and arrange cross-match blood and blood products.
Okay. So what about the anxiolysis? Would you like to give anxiolytic to these patients?
We will try to avoid anxiolysis in pharmacological way in pre-op period, because these patients are more prone for upper airway obstruction. So we will just reassure the patient and try to allay anxiety.
Yeah, so these patients are normally quite motivated for the surgery. It is going to be basically they have there are metabolic disorders which they have associated, and there is a lifestyle change associated. So these patients are pretty motivated, but you need to have a good detailed discussion with them regarding their apprehensions regarding the surgery and post-operative course, and a lot of it would have been done by the nutritionist and the surgeon, but your role as an anesthesiologist, you would need to discuss in details, and that more often than not allays the anxiety. So we would like to avoid anxiolytics since they are not going to be monitored, and these patients do have, even this patient has OSA, and it's about moderate, so we will avoid anxiolytic. Now, on the morning of surgery, what all would you ensure in your operation theatre prior to shifting the patient to the OT?
In the operation theatre, I will check the anesthesia workstation. I will ensure the presence of defibrillator, multi-para monitors, and suction. I will check the emergency drugs and induction drugs. Then I would check the OT table if it is appropriate for my patient. Availability of adequate staff for handling and shifting of the patient. Then the presence of a difficult airway cart and pneumatic compression devices for the use in
what all should be there on a difficult airway cart?
In difficult airway cart, I would keep appropriate size nasopharyngeal airway, appropriate sized Gudel's oropharyngeal airway, endotracheal tube stillet, gum elastic bougie, then cuffed endotracheal tubes of 7, 7.5 and 8, laryngoscopic blades 3 and 4, Macintosh laryngoscopic blade, and then I will keep a McCoy blade, CMAC D blade of video laryngoscope. Then I will keep different handles, a regular handle of laryngoscope and a short handle. I would keep laryngeal mask airway, second generation, ProSeal LMA number 4 and 5. I can keep iGel 4 and 5 and tracheostomy surgical set in case of emergency, fiber optic bronchoscope if it is available.
Okay, good. You said you will keep a supraglottic second generation supraglottic device like an iGel or a ProSeal. Suppose we are unable to intubate our patient, this patient, would you like to go ahead with the conventional technique? Would you like to go ahead with the ProSeal as a rescue device in this patient?
Yes, ma'am. If you are not able to ventilate and not able to intubate, then we'll go for ProSeal.
See, we're not able to ventilate. Yes, that is another thing, that if there is a difficult bag mask ventilation you're expecting, then it can be used as a conduit to provide oxygenation till the time we are making an intubation attempt. Okay, we are not talking about a CICO condition, intubation and ventilation condition. So, but suppose this patient had a BMI of 50 or 55. Would you still like to use a supraglottic airway device? Is there any cutoff BMI which is suggested beyond which we should preferably not use a supraglottic airway device?
Cutoff, I'm not aware of that.
So it is roughly taken as 40 BMI. So our patient just comes within that. So yes, it can be used as a stopgap to provide oxygenation to the patient. And but as a definitive airway device, we do not generally prefer a second generation supraglottic device if the BMI of the patient is more than 40. So you have enumerated all the equipment in the difficult airway cart. You've also talked about the flexible fiber optic bronchoscope.
Yes, ma'am.
So what is up if you have all these and you have to intubate this patient, which would be your choice of laryngoscope or fiber optic? What would you choose amongst these devices?
For my patient, I would choose D-Blade CMAC video laryngoscope. Since she's grade 2, ASA 2, and she's hypertensive, I would like to prevent any pressor response. So I would choose a video laryngoscope.
So you are anticipating the airway to be slightly difficult. You said it's Mallampati class 3. She also has OSA intermediate, and on top of that, she also has hypertension, though it is controlled. So you would like to use video laryngoscope, and CMAC D-Blade is used for difficult airway. Very good. So what is the advantage of a video laryngoscope over a conventional laryngoscopy in this patient? You also have a McCoy laryngoscope blade, but still you chose CMAC. What is the advantage over conventional laryngoscopy?
Ma'am, we will decrease the apnea time, and these patients are prone to desaturation, and we'll able to see the properly and choose the tube accordingly beforehand.
So you don't need to align all the 3 axes. One is that with the video laryngoscope, and second, as you said, patient is a hypertensive, so the stimulus is less. So the response to laryngoscopy and intubation would be less. Coming back to the preparation, you have talked about the difficult airway cart, OT, adequate personnel. Anything, have you completed the list of how you would like to prepare the OT, or there's something you would like to add?
Positioning, I will ensure presence of a ramp.
Okay, so you will have a special OT table which can accommodate the weight of this patient. You will have adequate support for the arms and for ramping. So for ramping, do you know of any particular pillows which can be used to provide the ramp or the help position? How would you do it in the operation theater?
Ma'am, wedge ramp is available in our OTs for positioning in the ramp position. And I will position the patient in health position, that is head elevation laryngoscope procedure.
Okay, so we now shift the patient to the operation theater. You have rechecked and reconfirmed her NPO status and tried to rule out that there is no other fresh finding from the previous day PSC, and all is in order, and you get the patient shifted to the operation theater. How will you proceed further?
Ma'am, I will take the patient to the OT with the help of adequate staff, and attach all the 5 ASA monitors, including electrocardiogram, non-invasive BP, according to adequate size cuff. And I would attach SpO2 monitor, EtCO2 monitor, and temperature monitoring. I would like to attach BISC monitor and neuromuscular monitoring in the patient. And then I will I will do the head-up positioning of the patient beforehand, and attach nasal cannulas with oxygen flow of 8 to 10 liters per minute. Then I will take a wide bore IV.
I'll just like to clarify, Mansi, when you are attaching a nasal cannula, we don't give beyond 6 liters, no, because we don't get a better FiO2, and then it is too high. So normally we keep it at 4 liters, and you are para-oxygenating, basically pre-oxygenating and then para-oxygenating after that. Any other way of improving the oxygen reserve? This patient is got a reasonably good respiratory reserve, but if we have a patient with a BMI of 50, 55, 45, we may do a particular thing prior to improve the oxygen reserves or the apnea time in the patient, which the patient might have been receiving prior to that also.
CPAP or BiPAP patient may be having. We will continue.
If the patient is already receiving CPAP, we can continue with that in the preoperative till the time we are inducing the patient to increase the apnea time. You said you would like to put the patient in the ramp position. What are the advantages for putting the patient in a ramp position?
It will align the axis of external auditory meatus and suprasternal notch for ease in laryngoscopic intubation. It will also increase the apnea time by facilitating pre-oxygenation.
Okay, so basically, as you have said that these patients tend to have some amount of extra pad of fat in the back of the neck and the shoulder. So they tend to be more in a flex position. So to optimize the position so that the 3 axes are aligned when you're going to do a laryngoscopy, and to make it more easy, you have to ramp up. So you put sufficient either a pillow, the specific pillows which come, like the true pillows which come, or you can keep the sheets under the upper part of the shoulder and the neck and the head to give the ramp position. And along with making intubation easier, it also increases your safe apnea time. Like you said, it improves the respiratory mechanics and oxygenation which you are doing. Also, it decreases the possibility of regurgitation of fluids or the gastric juices from the stomach into the oropharynx and hence aspiration. So all these 3 benefits are there. What is the help position? What do you understand by that?
Ma'am, in health position, we will elevate the head up to head elevation laryngoscopic procedure, position.
Position. So you can either call it the help position or the ramp position, and these are the advantages you get. After positioning, have you secured the IV line?
Yes, ma'am. I will secure a wide bore
monitors.
I will secure a wide bore 18 gauge cannula and start the fluid administration, ringer lactate fluid.
Okay. And then how will you proceed further?
Then I will pre-oxygenate the patient with the 100% FiO2 and continuous positive pressure of 8 to 10 centimeter for 3 minutes. And then I will start the induction agents. Induction drugs, I
You
will
have a
give.
more objective, you have a more objective method of knowing that your pre-oxygenation is adequate instead of just keeping it time-based. Yes, mostly if we are having a good seal with the mask onto the face and we are able to do a good 3 minutes of pre-oxygenation, it is sufficient. But nowadays we have advanced anesthesia workstations and monitors. There's something which tells us that our pre-oxygenation is adequate.
At tidal oxygen values more than 90, we can take as adequate pre-oxygenation.
Okay. Go ahead.
Then I will give this start the induction. I will give injection fentanyl. 2 microgram per kg. That is for my patient, it is 90 micrograms. And then injection propofol, 2 mg per kg, 90 mg. And I will check ventilate.
Just a minute, Mansi. How do you decide which drugs are given on what? Because what is ideal body weight, what is lean body weight, and what is adjusted body weight? These are the three, and total body weight, of course, we have of the patient. So these are the 3 or 4 terminologies. Whenever we are talking about drugs, it will be talked about that this drug we give it on the basis of this body weight, and these drugs we give on the basis of this. But ultimately, it's a take-home message for all the students is that you always have to titrate. You always have to titrate the drug's effect, and it is not a rule of the thumb that this drug has to be given according to the lean body weight, and if less or more is required, we do not adjust it. So, yes, Mansi.
Ma'am, actually, drugs are divided into lipophilic and hydrophilic agents. And if lipophilic agent is there, in obese patients, there is increased volume of distribution. So we'll give according to total body weight. According to new guidelines, but it has changed, and it is according to lean body weight in most of the cases and adjusted body weight. So it is calculated with these formulas. Ideal body weight can be calculated by Broca's formula, that is height minus 100 for males and 105 for females. Lean body weight
in centimeters, minus 100
in
males and minus 105, and that is the most simplest and easy formula for ideal body weight. Okay, for lean body weight?
Lean body weight, we have to use these formulas. For female, it is 1.07 into total body weight minus 148 into total body weight upon height whole square.
So the important thing to remember is that most of the drugs, as we will talk about subsequently, are calculated according to the lean body weight. So whenever you have to administer these drugs to the patient, please calculate the drug required prior to starting the induction and maintenance sequence. We all know the patient's weight, height, BMI before we shift the patient into the OT. So all the drug dosage of the drugs that you're going to be using for the patient should be calculated prior to shifting the patient in, so that you don't waste time, or there is no, because the lean body weight drug formula is a little longer, and you need to calculate the appropriate dosage. Now, coming back to the drugs, which of them are given administered on the basis of the lean body weight, and which on the basis of the adjusted body weight? These are the 2 most commonly. Total body weight is restricted to barely 1 drug now, mostly, which is suxamethonium, because there is increased plasma cholinesterase level. So it is still administered, though it is not lipophilic, so it's still administered according to the total body weight. And more often than not, we are using suxamethonium if we are anticipating a slightly difficult airway and the anesthesiologist feels safer giving suxamethonium over a non-depolarizing. So suxamethonium is total body weight. Rest of the drugs are either lean body weight or adjusted body weight. And adjusted body weight is nothing else but ideal body weight plus 0.4 of the difference between the total and the ideal body weight. Okay. So what are the drugs that we give according to the lean body weight?
Drugs given according to lean body weight are propofol, both loading and induction doses. Then fentanyl, remifentanil are also given according to lean body mass. Various muscle relaxant, including atacurium, rocuronium, and vecuronium. And according to adjusted body weight, we will give neostigmine.
And so in the lean body weight, you also give lignocaine, bupivacaine. You've talked about opioids. You've talked about non-depolarizing muscle relaxants. You've talked about propofol and thiopentone sodium. Propofol, yes, the loading dose is according to the lean body weight. And the lean body weight is normally not taken as more than 100 in the male and not more than 70 in a female, irrespective of the total body weight of the patient. So that is another criteria. And coming on to the adjusted body weight, you very rightly said neostigmine. What else?
Propofol infusion we'll give in the form
Good.
of adjusted body weight.
Okay.
And
so Sugamadex also, and antibiotics, and low molecular weight heparin acid can be either lean body weight or it can be according to the adjusted body weight. But important to remember is that the 10A factors have to be monitored to see the appropriate dosage for the low molecular weight heparin. Okay, coming back to your induction sequence.
yeah, ma'am, I have given a fentanyl citrate, propofol, and I've check ventilated. Then I will give the muscle relaxant injection atacurium. It is given according to lean body weight, which is 27 milligrams. Then I will intubate the patient after 2 minutes with the help of video laryngoscope, deblade, and appropriate size endotracheal tube. And I will ventilate the patient on volume control mode with the tidal volume of 10 to 12 ml per kg. According to ideal body weight, we'll adjust the tidal volume, then respiratory rate of 12 to 14 per minute, PEEP of 5 to 10 centimeter water, and we'll keep the ETCO to 35 to 40 milligrams of mercury. Then,
so basically, you are keeping the patient on volume control mode of ventilation.
Yes, ma'am.
Yes. So there is, both are acceptable. It will be titrated according to the type of patient. In our patient, we can definitely use the volume control mode of ventilation. And otherwise you can have the pressure mode. So in your patient, are you administering any PEEP for the patient?
Yes, ma'am, I will give a PEEP of 5 and it will
can take it
help
up
the
to
patient.
10.
10, we can take it up to 10.
Okay. And you said you would keep a tidal volume of how much?
10 to 12 ml per kg, and it is taken according to ideal body weight.
And what are the problems? Because all these surgeries are now laparoscopic surgeries. You don't have bariatric procedures happening, open procedures. Initially, when it was started, it was open procedures, but then they are all now laparoscopic procedures. So any problems associated because of laparoscopy?
Ma'am, because of laparoscopy, there will be high levels of CO2 and pulmonary compromise. Since our patient is obese patient, already have decreased FRC, there will further decrease in FRC, functional residual capacity, and total lung capacity. There will be, and if the positioning was also head low, Trendelenburg, then further decrease in FRC. So we have to keep a PEEP of 10, at least 10 for these patients in laparoscopy. Then in the cardiovascular system, directly.
In this, mostly it is not reverse. It is not Trendelenburg. It is mostly reverse
Mostly
Trendelenburg.
head up position. Yes.
Okay. And yes, go ahead.
Ma'am, in cardiovascular system, there can be activation, sympathetic activation, and heart rate, blood pressure can increase. There can be increased load on the cardiac myocardium, and it can lead to ischemic heart disease, perioperative MI.
Okay. So now coming back to this patient, you said you have positioned the patient after securing the airway and securing properly, strapping the patient on the table. That's very important because the patient is very heavy, can easily slide, and also supporting the arms. There are any particular other concerns how long is the surgery normally? A lap sleeve gastrectomy, how long does it go on for? What is
It
the average
usually-
duration of surgery?
It usually goes for 1.5 hours to 2 hours, maximum 2 hours.
Okay. Okay. But there are certain concerns if you are making a patient who is so obese lie on an operation theater table. Any things which come to your mind which could...
Nerve injuries are common in this patient. We will properly pad the patient with the cotton padding around the pressure areas.
Very good. So very, very careful padding. You may even have gel pads or you may have special padding for these patients. These patients have so much of soft tissue. There can be a chance of rhabdomyolysis if you have not taken care of the pressure areas. So all that needs to be taken into account. And as anesthesiologists, it's our responsibility to ensure that we have kept this in mind. Otherwise, we may first time see the problem in the post-operative period because of rhabdomyolysis. Okay. What else? You said monitoring. What are the monitoring that you would like to do in this patient?
I would like to do ECG monitoring, then non-invasive BP monitoring, SpO2, EtCO2, and temperature monitoring. I will attach BIS monitor and neuromuscular monitoring.
Okay, why temperature monitoring? It is now anyways an essential part, but why more so important in this patient?
We have to avoid hypothermia in this patient.
Yes.
It will lead to
so these
further,
patients are actually having a very large body surface area, so they are more prone to hypothermia. Hence, to prevent that, you have to take all due precautions. You have to ensure there is active warming, and you have to prevent hypothermia. We all know what are the problems if hypothermia sets in for the anesthesiologist, for the coagulation system, all of it. Okay, and why would you, what if you're doing a BIS monitoring, what level of depth of anesthesia will you keep?
In 40 to 60 level, we'll keep the anesthesia level.
Okay. And what is, you have induced with propofol, you have achieved neuromuscular blockade with, you said atracurine, bisalate?
Yes, ma'am.
So now how will you, what are the anesthetic agents that you will use to maintain the anesthesia?
I will maintain the anesthesia with 50% of oxygen, 50% air, and inhalation anesthetic agent of desflurane. Then I will start Dexmed infusion in this patient. And loading is given according to 0.5 to 1 mics per kg, according to lean body weight. And the infusion is started at 0.2 to 0.7 mics per kg. It will decrease the
So
dose.
why would you like to prefer dexmedetomidine? Why not opioid? You have given an induction. At the time of induction, you used fentanyl. But why would you like to give, what is the benefit of giving dexmedetomidine intraoperatively?
We would like to avoid opioid-based analgesics in prop as well as post-op. These patients are prone to respiratory depression in post-op period. So we will decrease the use of opioid, and Dexmed will help in analgesia intraoperatively and post-operatively.
Okay. So the intraoperative procedure, at any time, the surgeon needs to come to the, the assistant needs to come to the head end or ask for your help in this particular surgery?
Yes, ma'am. The surgeon may ask the anesthetist to insert a bougie up till the pyloric antrum. It will help them to identify the lesser curvature of stomach and to not to cut too much of stomach. So we have to insert a bougie, which is of 32 French or lowest French available, lowest size available.
Okay. So either you would be asked if you are a regular, if you have been a part of the anesthesiologist, the whole team as an anesthesiologist providing anesthesia to bariatric patients, or the surgeon might be having their own assistant who comes. So you have to always ensure that it is mandatory in all cases, but more so in these cases where taking care of difficult airway, that the tube fixation has to be very good right from the beginning. And this particular procedure is a mandatory part of sleeve gastrectomy. Now the surgery goes on uneventfully. If at all there would have been an unexpected blood loss because of a bleeder, what is the blood volume in these patients as compared to the non-obese patients?
In this patient, the blood volume is taken as 45 to 55 ml per kg, and it is
Okay.
calculated with the help of total body weight.
Okay.
So
So
we
basically, we know that the excess body weight is because of fat, and fat is a very poorly perfused organ. So that is why the total blood volume is, instead of 65 to 75 as for the females and males in adults, it becomes 45 to 55 ml per kg body weight. Now, at the end of the surgery, it has gone on uneventfully, and you have to reverse the anesthesia, awaken the patient, and extubate the trachea. How will you go about the reversal procedure?
I will stop the anesthetic inhalation agent and start with 100% FiO2. I will put the patient on pressure support mode, and with pressure support of 10 to 12 centimeter water and respiratory rate of 12 to 15 with along with the PEEP of 5 to 10 centimeter water. Then I would ensure the availability of a difficult airway cart, and in head up, and I will do the head up positioning again to 25 to 30 degrees. Then I will ensure if there is adequate reversal of neuromuscular blockage, and then I will start the reversal agent injection neostigmine, which is 3.6 mg in my case. It is calculated according to adjusted body weight, and then injection glycopyrrolate of 0.7 mg IV. Slowly, I will give the reversal agent, and after ensuring the patient awakening and proper neuromuscular reversal, I will extubate the trachea and do gentle oral suctioning in head up positioning only, and start the oxygen supplementation.
Okay. So as compared to the other patients, why are we more worried in these patients about hypoxemia, post-extubation hypoxemia, or other concerns post-extubation? What are our concerns in this patient?
In post-op concerns, the patients mostly ventilation, and they have there are more chances of desaturation post-op area. We have to be vigilant in and keep the patient in semi-fowler position.
Why are there more chances of desaturation or hypoxemia post-operatively immediately after recovery from anesthesia?
There is decreased FRC, and the patient is also not completely out of this.
Yes, so exactly. So there can be effect of the residual effect of anesthetic agents that you have given that can add on to any amount of obstructive sleep OSA that the patient already has. And also that the reserve, like you said very correctly, there is decreased reserve, but the demand is there. But if there is a mismatch between the supply and the demand, there can be hypoxemia. So these patients, they tend to have a very so much of fat in the neck, in the shoulder, and around the airway that it can collapse. The upper airway can collapse when the patient comes out of anesthesia. Hence, like you have rightly said, patient should be fully awake when you are going to extubate the trachea, and after a good oral suctioning, so that there are no secretions which can trickle down after the extubation. Because if such an event happens and the patient is slightly lighter, not awake completely, can go into a laryngospasm. So like for a plane, the takeoff and the landing both are important. So our problem about the airway is not solved once we are able to secure it at the time of induction. Getting the patient out of anesthesia, successfully extubating the trachea, and ensuring that patient remains oxygenated post-operatively is equally important. That is all our responsibility, and you have to ensure that your the BIS has come much beyond, it's gone much above 60, patient has fully awakened. Your TOF guard, which you are using for neuromuscular monitoring, shows a recovery of more than 90%, and patient is cooperative. At the same time, patient should not be bucking on the tube. So when you put off your inhalational agents, or when you're putting off your dexmedetomidine, it has to be at a time that you are ensuring even when the patient gets up, the patient is tolerating the tube to some extent, but fully awake and generating good tidal volume, and the respiratory parameters are acceptable. Okay, after extubation, where would you like to shift this patient?
I would like to shift the patient to HDU and start oxygen supplementation in semi-fowler position. At least for 12 to 24 hours, I will continue the patient in HDU only, and monitor the saturation and ABG. Then
So we are nowadays all heading towards ERAS protocol, where we want early recovery after surgery and anesthesia. So our aim is to provide good analgesia in the post-operative period. How can you ensure in this patient? What would you do to?
we would give
good pain relief?
opioid sparing analgesia generally, IV paracetamol, 1 gram, 6 hourly, and we can give non-steroidal anti-inflammatory drugs. Then we can start with the we can give Taplog in these patients.
Okay, so you prefer the multimodal analgesia, you'd use opioid sparing drugs, and you can give blocks like Tablogs with the help of ultrasound. Thank you, Mansi. You've presented your case well and negotiated the questions very well. I would hand over the mic to Dr. Shubhi. I'm sorry I've exceeded the time, but Dr. Shubhi, without delay.
Thank you.
Thank you. Good morning, everyone. I will now summarize the topic, anesthesia for bariatric surgery. The term obesity is derived from the Latin word obese, which means fattened by eating. It is defined as abnormally high amount of more than equal to 20% of the ideal body weight. Let us see the various definitions which would be useful to understand the topic. The body mass index, which is weight in kilograms divided by height in meters square. The ideal body weight, which is calculated as per the Broca's index, which is height in centimeters minus X, where X is 100 in males and 105 in females. The lean body weight, which is total body weight minus the adipose tissue, and it comes out to be 80% of the total body weight in males and 75% of total body weight in females. The adult body fat composition in percentage can be derived from Durenberg equation, which is 1.2 into BMI plus 0.23 into age minus 10.8 into gender minus 5.4, where age is in years, and for gender, 1 is given for male and 0 for female. If the adult body fat percentage is more than 25 in males and more than 32 in females, it is considered as obesity. The etiology of obesity is varied and ranges from genetic predisposition to medical disorders, namely Cushing's disease, hypothyroidism, intake of various drugs like corticosteroids, antidepressants, and antihistaminics. There might be an energy imbalance between intake and expenditure. Psychological factors may also result in obesity, namely depression. Ethnic influences are also present as various races like Africans, Mexicans, and Asians are at high risk of developing central fat distribution. Obesity is mainly found in the affluent society. The types of obesity are mainly two, that is central or android obesity, in which there is a truncal distribution of fat. Increased risk of cardiovascular disease is seen in this type of obesity. Whereas in the peripheral or gynecoid obesity, the fat distribution is predominantly in the hip area, and it is less commonly associated with cardiovascular diseases. Obesity can be classified based on BMI, where BMI less than 18.5 is underweight, BMI 18.5 to 24.9 is normal, 25 to 29.9 is overweight, 30 to 34.9 being class 1 obesity, 35 to 39.9 class 2 obesity, 40 to 49.9 is morbid obesity or class 3 obesity, and BMI greater than equal to 50 is classified as super obesity. Obesity causes various pathophysiological changes in our body, affecting the airway, breathing, circulation, blood distribution, endocrine system involvement, fluid changes, gastrointestinal changes, and affecting hypercoagulability. Let us see what obesity does to the airway. It results in limited atlantoaxial joint and cervical spine movement. It results in deposition of cervical pad of fat. It may result in a short, thick neck, more than 40 centimeters. There can be decreased thyromental distance, accumulation of suprasternal, presternal, and submental fat. It may result in large breast, excessive tissue folds in the mouth and pharynx, and a modified Malampatti grade of more than 3. Obesity is also very commonly associated with a condition which is named as obstructive sleep apnea. It is defined as cessation of airflow for more than 10 seconds, despite continuous ventilatory effort 5 or more times per hour of sleep, associated with decrease in saturation of greater than 4%. Various symptoms which are associated with OSA are snoring, frequent arousal during sleep, daytime sleepiness, impaired concentration, and early morning headaches. Associated with OSA is obesity hypoventilation syndrome, which is a long-term sequelae of OSA. It results in nocturnal episodes of central apnea, resulting from desensitization of respiratory center to nocturnal hypercarbia. OHS is also characterized by hypoxemia, hypercarbia, respiratory acidosis, pulmonary hypertension, all resulting in right heart failure. Pickwickian syndrome is an extension of OHS, which is OHS plus cor pulmonale. The diagnosis of OSA is mainly based on stop bank questionnaire. However, the definitive diagnosis is made by a sleep study or a polysomnogram. This is the stop bank questionnaire, which primarily focuses on asking questions related to history of snoring, T for tiredness, O for observed apnea during sleep, P for raised blood pressure, P for body mass index more than 35 kg per meter square, A for age more than 50 years, N for neck circumference more than 40 centimeters, and G stands for gender, that is more commonly seen in males. Now the answers to this question is in yes or no. For each yes, a point of 1 is designated and the total score is calculated. If the score falls in the range of 0 to 2, patient is at low risk of developing OSA. If the score comes out to be 3 to 4, it is an intermediate risk. And if the stop bank score is greater than or equal to 5, patient is high risk for developing OSA. The definitive diagnosis for OSA, as we have seen, is polysomnography or sleep study. It is a comprehensive test which is conducted in a sleep lab while the patient is asleep, and various parameters are assessed, namely EEG, which assesses the electrical activity of the brain, electrooculogram, which differentiates between REM and non-REM sleep, electromyographs for chin, which assess the arousal and activity of upper airway, mainly the genioglossus and the digastric muscles, the two-leg EMG, which monitor the leg movements during sleep, airway microphone, which assess the nasal or oral airflow. Elastic belts are placed over chest and abdomen to look for the respiratory efforts during sleep. Infrared video camera is placed to look for change in body position during sleep. They also measure capnogram, ECG, blood pressure, and pulse oximetry. Having conducted this comprehensive test, the result of polysomnography is interpreted by means of apnea-hypopnea index. It is the total number of episodes of apnea and hypopnea, which is divided by the total sleep time and is categorized as mild, moderate, and severe. If the events are 5 to 15 per hour, it is mild, 15 to 30 per hour, it is moderate, and more than 30 events per hour is classified as severe. The other term is total arousal index, which is defined as total number of arousals per hour. And the respiratory disturbance index is the sum of apnea-hypopnea index and arousal index. Obesity also affects the respiratory system because it results in fat accumulation over the chest wall, decreasing the chest wall movement and decreasing lung compliance. Pulmonary compliance is going to decrease the FRC, your vital capacity, and total lung capacity, which will result in shallow and rapid breathing, increased work of breathing, and it limits the maximum ventilatory capacity. Obesity also has effect on lung volumes. It decreases the expiratory reserve volume, which in turn result in decrease in FRC. The decrease in FRC can be such that it comes below the closing capacity, resulting in premature airway closure. Obesity also has the circulation. It results in increased blood volume, increased cardiac output, 20 to 30 ml per kg. Because of obesity, there is insulin resistance, which results in catecholamine secretion, that is primarily norepinephrine, which results in sympathetic activation and hypertension. Atherosclerosis is also seen in obesity, which predisposes the patient to ischemic heart disease. There is a left ventricular wall stress resulting in dilatation, hypertrophy, and thereby obesity cardiomyopathy. Cardiac dysrhythmias may result because of the fatty infiltration of the conduction pathway, hypoxia, electrolyte imbalance, and increased catecholamine levels, all resulting in various types of arrhythmias. Cor pulmonale because of the OSA, resulting in right ventricular hypertrophy and failure. So in obese patients, primarily there can be a biventricular failure because this obesity, it is, as we have seen that it results in OSA or OHS, which results in a chronic hypoxic state, causing pulmonary hypertension, right ventricular overload, hypertrophy, finally failure. Also, obesity results in increased blood volume, cardiac output, which increases the load on the left ventricle, resulting in left ventricular hypertrophy, failure. So there is right ventricular failure as well as left ventricular failure. Thereby, it is a biventricular failure state. In obesity, the drug dosing is different, as we have already discussed, but let us quickly revise it. In obesity, most drugs are calculated according to the lean body weight. Because if in obese patient, we calculate drugs on total body weight, there will be excessive plasma concentration because the adipose tissue has a very low blood flow. So as a dictum, lipophilic drugs with a large volume of distribution should be given on total body weight, and hydrophilic drugs whose peak concentration is independent of the volume of distribution, they should be given on lean body weight. This is a table which shows the weight basis for dosing of common anesthetic drugs in obese patient. As we have discussed, propofol, the infusion, the antibiotics, LMWH and neostigmine, Sugamadex, they are given according to the adjusted body weight. And the induction dose of propofol, fentanyl, rocuronium, etra, VEC, or the various muscle relaxant and the local anesthetic, they are based on the lean body weight. Obesity is also associated with difficult venous access and difficult positioning. As far as the endocrine system is concerned, there are various endocrinopathies which cause obesity, namely hypothyroidism and Cushing's disease. And certain endocrinopathies are caused by obesity, like diabetes mellitus, metabolic syndrome, or syndrome X. Let us see what is this metabolic syndrome. The presence of at least 3 of the following signs indicates metabolic syndrome, that is large waist circumference, high triglyceride levels, low level of HDL cholesterol, glucose intolerance, and hypertension. Fluid requirement in obese should also be based on lean body weight with the goal of attaining euvolumia. One should avoid dehydration. However, rapid replacement of fluids should also be avoided as it can result in cardiac decompensation. Gastrointestinal system has varied changes in obesity. There is increased volume and acidity of gastric contents. Delayed gastric emptying is noted. Patients are more prone to hiatus hernia, and there is gastroesophageal reflux disease, all of which predispose the patient to increased risk of pulmonary aspiration and severe pneumonitis. As we have seen that in obesity, OSA is associated, which is a chronic hypoxic state. It results in polycythemia. There is increased abdominal pressure from the fat around the waist area. There is venous stasis due to immobilization. Increased fibrinogen levels are noted because of the chronic inflammatory state. Decreased fibrinolysis seen in obesity, all of which predispose the patient to increased risk of DVT and pulmonary embolism. Other changes are also noted in the body in an obese patient, that is more prone to osteoarthritis, compression fractures, urinary incontinence, skin infection, candidiasis, varicose veins, and lymphedema. Having seen that obesity affects each and every system of our body, we would surely like to know the treatment for obesity. It starts from the non-pharmacological treatment, namely patient motivation, lifestyle modification, namely caloric restriction, exercises. Pharmacological treatment is indicated in patients with BMI more than 30 kg per meter square and BMI more than 27 kg per meter square in patients with associated comorbid conditions. Various drugs are used to treat obesity, namely phentermine, orlistat, Contrave, liraglutide, which acts via different mechanism of actions. Bariatric surgery is indicated in psychologically stable and motivated patients with BMI more than 40 kg per meter square or more than 35 kg per meter square in patients with associated comorbidities and in patients with failed medical and dietary therapy. The bariatric surgical procedures are classified as predominantly restrictive, malabsorptive, and mixed procedures. Coming to the anesthetic management of obesity, starting with the preoperative evaluation, we take a detailed and thorough history, focusing on the associated comorbidities present of OSA or OHS, asking for symptoms of gastroesophageal reflux, assessing the exercise tolerance, the drug history related to various comorbid conditions. We also ask for previous anesthetic exposure and anesthetic records. A detailed physical examination is done pertaining to the airway, the general examination, systemic examination. We also look for the peripheral and central venous access site availability. In the airway examination, we look for the predictors difficult intubation, Mallampati score of 3 or more, neck circumference more than 40 centimeter measured at the level of the thyroid cartilage, thyromental distance less than 6 centimeter, decreased interincisor gap, limited mobility of the temporomandibular joint or the atlanto-occipital joint, presence of short, thick neck, large breast, and pretracheal fat thickness more than 2.5 centimeter on USG of obese patients, as we have already discussed. The preoperative preparation ranges from availability of special equipment, availability of trained personnel, and anesthetic expertise. In equipment preparation, there should be availability of appropriate sized BP cuff, presence of Troop's head elevation pillow, difficult airway cart, and also availability of video laryngoscopy. In the preoperative advice, the NPO guidelines are same for the obese as for the non-obese. Aspiration prophylaxis must be given. One must, as they are very prone to the respiratory depressant effect of sedatives. DVT prophylaxis must be given. OSA patients who are on CPAP at home, they must be instructed to bring it along with them to the hospital. Written informed consent must be obtained and blood products must be arranged. In the intraoperative management, proper positioning is the key to successful tracheal intubation. Head elevated laryngoscopy position must be maintained. Ramp position or elevating the upper body and the head of the patient is done to align the external auditory meatus and the suprasternal notch. This is the HELP position, and here the picture also demonstrates the Troop's head elevation pillow. You can also see the inflatable multi-chambered pillow and air pal ramp, which can also be used as a substitute for Troop's head elevation pillow. Ramping has certain advantages. It improves the laryngoscopic view. Also, the gradient for passive regurgitation is reduced and the safe apnea period is increased. For monitoring, standard ASA monitoring including ECG, NIBP, SpO2, EtCO2, and temperature probes. Invasive BP monitoring can be done by means of radial artery cannulation in case patient has certain cardiovascular diseases. Neuromuscular monitoring, urine output, CVP, and BIS monitoring. In induction, proper OT preparedness must be established. Proper positioning is a must. Pre-oxygenation and para-oxygenation using nasal prongs or CPAP in 30-degree head-up position using 100% oxygen for at least 5 minutes. In case of difficult bag and mask, two-hand technique or supraglottic airway device can be used for ventilation. Awake fiber optic intubation can be done if indicated based on the airway examination. For maintenance, desflurane is the inhalational agent of choice because it has a consistent and rapid recovery. The blood gas partition coefficient is 0.45. So desflurane is very least soluble in blood. So there is a rapid recovery. Nitrous oxide should be avoided because of the high oxygen demand in obese patient. Nitrous is also an emetic. It results in intestinal distension and more prone to pulmonary hypertension. Short-acting opioids are preferred. Adequate fluid administration must be done, which should be goal-directed. And one must maintain normothermy. For ventilation, high FiO2, tidal volume 10 to 12 ml per kg of ideal body weight, PEEP of 5 to 10 centimeter of water, maintaining EtCO2 35 to 40 millimeters of mercury. Reversal should be done in 45-degree head up position. The airway must be cleared and gastric decompensation done. Cuff leak test can be performed. Airway recruitment strategies must be done. Extubate patient when patient is fully awake with intact upper airway reflexes. During extubation, airway exchange catheter can be used and CPAP must be used. We should also be ready to re-intubate in case of any catastrophic event. Patient shifting can be challenging in obese patient, so adequate number of personnel must be available, and this patient shifting can be done with the help of pad slider patient roller. Patient should be managed post-operatively in semi-fowler position, that is head up position at an angle of 30 to 45 degrees. Supplemental oxygen must be provided for 24 to 48 hours. Patients who are diagnosed with OSA or OHS, who are on CPAP or BiPAP, they should be put on the same. Pulse oximetry and respiratory monitoring must be done. Patient should be encouraged for early ambulation. Effective cuffing, deep breathing exercises, and incentive spirometry is very helpful. Patient should continue use of pneumatic compression stockings in the post-operative period. For analgesia, multimodal analgesia should be used with an aim to minimize the use of opioids. Local anesthetic wound infiltration of port sites must be done. Use of non-opioid drugs like IV paracetamol, NSAIDs must be encouraged. Epidural patient-controlled pumps are very helpful in these patients, and one can also use blocks like tab block in the patient. Thank you.
Yeah, I think there is one question, Dr. Nitin. I'll just take that question. Somebody, Dr. Diksha Gaur has asked that suxamethonium, that is calculated as per the total body weight, because as I mentioned earlier, it is based on the higher plasma cholinesterase levels. As far as neostigmine and Sugama-Dex, that is calculated according to the adjusted body weight. And formula for adjusted body weight is ideal body weight plus 0.4% of the difference between the total and ideal body weight. So according to that, we calculate the dose for neostigmine and Sugama-Dex, but there's always a rider, always titrate the dose, also see the total amount of neuromuscular blockade that you have required and the timing. So along with the neuromuscular monitoring. Thank you. And Dr. Shubhi has, I think, summed it up very well in all her slides.
Thank you, ma'am.
Thank you, ma'am, for this excellent case presentation. And you have beautifully covered all the important anesthetic aspects, right from the preoperative till the postoperative phase for a bariatric patient. Thank you so much, ma'am. Thank you, Dr. Shubhi. Thank you, Sonia, ma'am. Moving on to our next session, which is dedicated to critical care medicine. I would like to invite the chairperson of the next session, Dr. S.P. Ambesh. Sir is professor and head of the Department of Anesthesiology at SGPGIMS Institute at Lucknow. Sir's area of special interest are bedside invasive and non-invasive interventions in ICU, pancreatitis, and nutrition in ICU patient. So sir is the most apt person for chairing this session. Over to you, sir. So can you unmute yourself?
Okay, thank you, Madam Mohandeep Kaur. Thank you so much. Thank you, Nitin, for being with you. I think we have two. I was supposed to chair for the basic modes of mechanical ventilation. Is Dr. Mridula Pawar is not there?
No, sir. Ma'am is not there. Unfortunately,
Okay,
she
it's
couldn't be
fine.
there.
It's fine. I thought she is there, so and because she was designated for this lecture. So anyhow, no problem. So you can see Dr. Mohandeep Kaur, she's already on, and I can see her achievements. She's professor and head department of anesthesiology at ABVIMS Medical College and Dr. RML Hospital, New Delhi. She's really, she has done a lot of work on critical care, and her area of interest is also critical care. So trauma, resuscitation, behavioral management. And I'm really very happy that she is delivering the talk on her own interest topic. So let's enjoy the topic and we will discuss later on. So madam, you can start, please.
Thank you. Now I shall be talking on an important topic, that is nutrition in critically ill patients. First of all, defining malnutrition. Malnutrition is a state resulting from lack of intake or uptake of nutrition, which leads to altered body composition, decreased fat-free mass, and body cell mass. Now, what are the effects of malnutrition? There is a diminished physical and mental function, metabolic abnormalities, decreased tissue and organ function, negative nitrogen balance, and loss of lean body mass. 30% weight loss is associated with significant mortality. Now, there is an acute phase response, which leads to a cascade of SIRS, leading to MODS, leading to multi-organ failure. And in total, it leads to increased ICU stay with the poor patient outcome, that is increased morbidity and mortality. So now, what are the learning objectives of the talk? We shall be knowing about nutritional risk assessment in critically ill patients, then goals of nutritional support, risk and benefit of enteral nutrition, estimating energy and protein requirements, enteral and parenteral routes of nutrition, prescription, formulation, and complications. Then most important is nutrition in specific situations. Now, how to do risk assessment? On admission, all the critically ill patients should undergo nutritional assessment, and there are various tools available for that. One is Malnutrition Universal Screening Tool, which is based on BMI, weight loss, and acute disease effect score. Second, Nutritional Risk Screening, NRS 2002, which is based on the comorbidities and clinical condition of the patient. Then we have one third very important tool is Subjective Global Assessment. And this is most often employed in Indian malnourished patients. This is an inexpensive and quick bedside tool. It is like this Subjective Global Assessment form. This is attached to the files in ICU. And we can go through various points like weight loss over 6 months, then dietary intake over past 2 weeks, then gastrointestinal symptoms, if at all associated, functional status of the patient, disease states affecting nutritional requirements, and a few more points. And then this rating is from 1 to 7 in all points. And this is how we calculate subjective global assessment. And this is a structured approach. Weight change, both chronic, which is over a period of 6 months, and acute, which is over a period of 2 weeks. Both these weight changes are noted. Then changes in food intake, gastrointestinal symptom, as we had read from the form, then functional impairment, all these are taken into consideration. Then another method, indirect calorimetry. This is respiration is performed through a mask connected to the gas analyzer module. Airflow and respiratory gas samples are continuously obtained and analyzed by gas analyzers. And what do we need to find out? Oxygen, volume of oxygen consumption and carbon dioxide produced, VO2 and VCO2. These are derived and displayed on the monitor. Then how do we estimate energy and protein requirements? Then we calculated from VO2 and VCO2. If indirect calorimetry machine is not available, then ASPEN recommends that if this is not available, indirect calorimetry, VCO2 is obtained from the ventilator, and VO2 can be derived from a pulmonary artery catheter. And then this is how we calculate the energy expenditure. Then one important point is respiratory quotient. This is VCO2 upon VO2. It's an important guide for planning of nutritional therapy. And values, I told you, are obtained by indirect calorimetry. Range of respiratory quotient stays between 0.7 to 1.2. And then various components of diet, have different RQs. For fat, it is 0.7. For protein, it is 0.8. Carbs, 1. Then respiratory quotient more than 1. What does it imply? Excessive carb and calorie provision. In less than 7 could be underfeeding or use of ketones as fuel. Then this is again a chart showing the same thing. Then various monitors of nutrition. Once we start nutrition in a critically ill patient, we have to have some monitoring of it. And this is initially done every day. Following investigations are done. And these include mostly blood sugar, WBC count, electrolytes, blood urea nitrogen, LFTs, plasma lipids, urine urea nitrogen, and serum proteins, which are albumin, pre-albumin, retinol binding protein, and transferrin. And then, various half-lives we must know from the chart. And here we can see that pre-albumin and retinol binding proteins, they have a half-life of 2 days and 10 hours respectively. And so these proteins have a better value in monitoring nutrition status because albumin has a T-half of 20 days and approximately 3 weeks would be required to see any changes in the albumin level. Then immune function and urine studies, I've already told you, 24-hour urine urea nitrogen. And then, we have some negative acute phase proteins and positive acute phase proteins. Negative ones, the levels decrease in critical illness and decrease in critical illness and increase during recovery, whereas positive acute phase proteins like C-reactive protein levels increase in critical illness and decrease in recovery. Then how do we classify malnutrition? Mild, moderate, severe, depending upon the various levels of visceral proteins. And then, total leukocyte count less than 800, this is severe. This is monitors of nutrition. Nitrogen balance is calculated as protein intake minus urinary nitrogen plus 4. And then goal of nitrogen balance is to maintain positive balance of 4 to 6 grams. And you must remember each gram of urinary nitrogen represents 6.25 gram of degraded proteins. And critically ill patients are usually in negative nitrogen balance. These are the important aspects. Why give nutrition, when to start, how much is to be given, then calculating the calories and protein requirement, what route is feasible, what are the contraindications to it, then monitoring the nutrition and special situation needs. Now, what are the advantages? The nutrition attenuates the adverse effects of metabolic response to injury and prevents a cascade leading to sepsis. The same cascade of SIRS to MODS to MOF, and this improves nitrogen deficit and prevents and treats macro and micronutrient deficiencies. Goals of nutritional support are to prescribe doses of nutrients as per existing metabolic condition, preferably via enteral route. Then find compatible route of nutrition and avoid complications related to technique of dietary delivery and hereby then improve the patient outcome. Now, what is important? Estimating energy and protein requirement. We have certain feeding equation known as Harris-Benedict equation, which is different for males and females. This can calculate the demand for us and then calculate the BMR, that is the basic metabolic requirement in kilocalories per day. Then the drawbacks are that this is a time consuming and often overestimates the energy requirement. Aspen practice guidelines, feeding is to be tailored here as per the patient's requirement and level of tolerance. Protein requirement for most critically ill patients is in the range of 1.2 to 2 gram per kg body weight per day. And calories should be in the range of 25 to 30 kilocalories per kg body weight per day for most critically ill patients. Then another important thing is ratio of kilocalories to nitrogen, which is 120:1 or even 100:1 in severely hypercatabolic patients such as extensive burns and polytrauma. Normally it is 150:1. These are the micronutrient requirements per day. Then how do we calculate the daily requirements? Like I am calculating it here for 60 kg euvolemic patient with moderate stress. Here, first of all, the fluid requirement is same as calorie requirement. 30 ml per kg per day for 60 kg, it amounts to 1800 ml per day. Then calorie requirement is calculated at the basal level as 25 kilocalorie per kg per day. For a 60 kg, this would amount to 1500 kilocalories per day. Then protein requirement, I told you, this should be calculated as 1.5 to 2 depending upon the associated condition of the patient. But baseline calculation, we are taking protein as 1 gram per kg per day, that amounts to 60 grams per day. Fat requirement, 40% of the total calories would be required as fats source. And so here, out of the 1500 calories, 40% amounts to 600 kilocalories, and 1 gram fat, gives us 9 kilocalories. So, if we divide 600 by 9, the figure of 67 is there. So 67 gram of fats is required to provide 40% calorie requirement in this patient. And now carbohydrate requirement, it is easier. 60% of the total requirement, and easy to make it easier, total kilocalorie requirement minus the calories of fat from the fat. This gives us the carbohydrate requirement, and 1 gram dextrose is equivalent to 4 kilocalories. So we need to give 225 grams of dextrose to this patient to get calories of 900. So 50% dextrose provides 50 gram per 100 ml. So to provide 225 kilocalories, 450 ml of 50% dextrose needs to be infused. And similarly, electrolyte trace elements and vitamins, they have to be added as per the daily rationing. So there are two routes of nutritional therapy. One is enteral and the other is parenteral. Enteral is more physiological, uses gut and is the cheaper way. Parenteral uses venous access, and this could be peripheral venous access or central venous access. Central parenteral this is used in gut failure. The enteral nutrition, how it is important, it stimulates splanchnic and hepatic circulation. I told you it is more physiological. This improves the mucosal blood flow, prevents intramucosal acidosis, and then prevents permeability disturbances of mucosa, eliminates need for stress ulcer prophylaxis, and prevents bacterial translocation from gut, hence prevents sepsis. Now, ESPEN recommends enteral nutrition be started within 48 hours of ICU admission, and preferably once hemodynamic stability is achieved. Tube feeding is to be considered if even 50 to 60% of nutrition targets are not met adequately within 72 hours of oral nutritional support. And most of the patients in ICU, they require NG feeding only, not to be interrupted in case of diarrhea. We have to modulate the diet. These are the various routes for enteral feeding. Tube feeding, this could be gastric tube, duodenal tube, or jejunal tube, and depending upon for how long this is required, it could be non-invasive method, semi-invasive or invasive. Non-invasive being your nasogastric tubes, nasoduodenal and nasojejunal tubes. Then semi-invasive are your ICU techniques like PEG or PEJ, percutaneous gastrostomies, and then we have invasive method which are surgical gastrostomy and jejunostomy. These are the equipments for enteral feeding pump and feeding tubes. These pumps are important as continuous feeding is to be given for thick and viscous feeds, and then precise rate of administration can be maintained with these. So commercially, these are available as mixtures of macro and micronutrients in various proportions to suit various varied needs of patients. So these are available as standard polymeric formula feeds, and these are preferred over blenderized feeds in a critically ill patient as they ensure uniformity and minimize risk of microbial contamination. Proteins used could be intact protein formulas. These are polymeric proteins or peptide-based or semi-elemental formula. Then, we have elemental diets which are monomeric in nature. Intact protein formulae require fully functional GIT. Elemental and semi-elemental are often required in case of compromised GIT. Carbohydrates again can be given as starches, oligosaccharides, disaccharides, monosaccharides, fats, medium chain triglycerides, long chain triglycerides, phospholipids, omega-3 and omega-6 fatty acids in various compositions. And we have fibers and trace elements added to this enteral feeding formula to make it a complete nutrition. What is the approach to enteral feeding? Trophic feed and full feed. Trophic feed is when we give a smaller amount of feed, increases from 10 to 20 ml per hour, that is 1 kilocalories per ml. We start from a smaller feed and keep on building it up. This is given during the initial phase of feeding. It is better tolerated with fewer GI complications and it is safe. And then, full feed is the total calories being given by the enteral route. Then how do we establish enteral feed? This is very simple. Place nasogastric tube, elevate head end by 30 degree to 45 degree, then check for right placement. Test feed is given at the rate of 1 ml per kg plain waters and see the aspirate after half an hour. If aspirate is 30 ml or less than 30 ml, that is half the amount of the feed that you had given, then continue with the enteral feed. Now, how to minimize the gastric aspiration, which is an important complication. Confirm that the tube is placed correctly before each feed, then prop up the patient by 30 to 45 degrees. Check the gastric residual volume every 8 to 12 hours and consider continuous subglottic suctioning in ventilated patients. For minimizing the gastric aspiration, prokinetic drugs are added, and these are mostly erythromycin is the first line drug, 250 milligram IV or enterally every 6 to 8 hours is added. Then metclopramide as second line drug or additive. Then you have to minimize the use of narcotics and consider transpyloric or postpyloric feeding if it is not tolerated. Now, intolerance to gastric feed, this is again an important point. And this is assessed using the residual gastric volume, which is measured by syringe aspiration or by ultrasonography. And 300 to 500 ml is considered the optimal cutoff range in Indian scenario. Even with these high gastric residual volumes, continue feeding with reduced volumes. Trophic feeds are continued. Prokinetic agents such as erythromycin, metclopramide may be recommended in patients with intolerance, and I've already discussed. Then post-pyloric feeding indication. This is an evidence-based data that patients who are unable to tolerate gastric feeding or have delayed gastric emptying and poor intestinal motility, these may benefit from post-pyloric feeding. And the indications of parenteral feeding now. In nutrition requirement, when it is not met adequately with enteral nutrition, even after 7 days of ICU admission, then we think of parenteral feeding. And these are the following are the and other indications like in diffuse peritonitis, intestinal obstruction, intractable vomiting or diarrhea, severe acute pancreatitis, high output fistulas, ball ischemias, and complete bowel obstruction, we start parenteral nutrition. Now, what choice of parenteral nutrition? Catheter device. How would we give this parenteral nutrition? If we have to give short term, then we use CVCs, non-tunnel, or PICC lines and peripheral IV catheters. Medium term, we can use PICCs, then tunnel catheters and ports. Non-tunneled central venous catheters are discouraged in home parenteral nutrition. Then long term is when we have to give it for more than 3 months, often given through tunnel catheters or totally implantable devices. Then peripheral parenteral nutrition, this is also very important, and it is an adjunct to enteral nutrition when nutritional support up to 2 weeks is desired in case of low platelet count and coagulopathies where central lines are contraindicated, or the osmolarity here of the parenteral nutrition fluid that we are giving has to be less than 850 or 900 milliosmoles per liter, that is 3 times the plasma osmolarity. Then lipids can be given 10% to 20%, glucose 5 or 10%, and amino acids 2 or 4% can be given through the peripheral route. Total parenteral nutrition, this is again diagrammatic description showing that infraclavicular subclavian route is preferred. And a port is designated exclusively for TPN. Feeding sets are changed every day, given as separate nutrients or 3-in-1 total nutrient admixture. Single container has 24 hours nutrient supply. Then what is the basic composition of TPN solution? It has got carbohydrates as dextrose 20 to 30%, amino acids varying towards 10 or 3 to 15%, fat emulsions mostly 10 to 20%. Then these contain soybean, safflower oil, egg yolk, phospholipid, and glycerin, plus minerals and vitamins. Then what are the complications of nutritional therapy? Parenteral feeding, I told you the major risks associated are diarrhea and pulmonary aspiration leading to pneumonia. Prolonged enteral tube feeding with elemental diets is a risk factor for developing Clostridium difficile colitis. So nasogastric tube, if placed, the complications include malpositioning, difficulty in swallowing or coughing, then discomfort, sinusitis, and nasal tissue erosion. For enterostomy, the risks are associated with insertion, displacement, and infection. One very important complication, that is hyperglycemia. Critically ill patients become insulin resistant as part of stress response, and this leads to hyperglycemia. Overfeeding is another thing which is responsible for this. Tight control of blood glucose results in reduced ICU stay and mortality, number of ventilator days, incidence of septicemia, and requirements for both dialysis and blood transfusion. Mostly in post-surgery patients who stayed in ICU for more than 5 days benefit the most with tight control of blood glucose, and less than 150 milligram deciliter is targeted for at least first 3 days of admission. Actually, tight control implies keeping glucose to 120 milligram per deciliter, but this is what is the evidence. Then, complications of parenteral feeding, then these could be central venous catheter related risks. You are very familiar with these: pneumothorax, arterial or nerve damage, then infections, central vein thrombosis, and erosion through the wall of vein or right atrium. This is an unusual complication. Then we have infection control is very important. While the patient is on total parenteral nutrition, these bags must be sterile and discarded within 24 hours of hang time. Sterile precautions while changing bags are important. Nursing staff has to be taught. Then predisposition to hepatobiliary disease like fatty liver cholestasis and acalculous cholecystitis are other problems. Then also avoid electrolyte imbalances and micronutrient deficiencies. Now, for diabetes mellitus, the total energy fat is to carbohydrate ratio is generally kept 50 to 35 to 40%, and this improves the lipoprotein profile, decreases the insulin requirement, and decreases infection and prokinetics required due to gastroparesis. You must give prokinetics here. Now, in COPD patients, nutrition essentially related to ventilation. Small frequent feeds without manipulating macronutrient composition give optimum efficacy of oral nutrition intervention in stable COPD patients. And acute respiratory failure, calorie dense formulations are recommended. A special high fat, low carbohydrate formulation is no longer recommended in patients on ventilator therapy. Ventilator is able to take care of the higher content of the carbon dioxide produced. That's why if the patient is not on ventilator, then we should be insisting on low carbohydrate formulation. And monitoring of serum phosphate concentration and replacement of phosphate is essential. And now hepatic failure in this end-stage liver disease and hepatic encephalopathy, malnutrition occurs. There is altered synthesis and absorption of nutrients and increased protein losses, hypermetabolism and inflammation. So enteral nutrition is preferred. Protein supplementation is recommended. Protein energy determination is based on dry body weight or usual weight instead of actual weight. A whole protein formula providing 35 to 40 kilocalories per kg body weight per day and 1.2 to 1.5 gram per kg for body weight protein is recommended. Sodium restriction is to be tailored. Then no beneficial effects of branch chain amino acid formulations have been observed in critically ill patients with encephalopathy who are receiving first-line luminal antibiotics. However, in the patients who do not have encephalopathy, these branch chain amino acid formulations are good because these are metabolized in the skeletal muscles. Then in renal failure, maintain strict DIO charts, diuretics had to be given, and decrease protein administration 0.5 to 0.8 gram per kg per day. But on dialysis, we increase protein intake to 1 gram per kg per day because of the losses involved during dialysis. And hemofiltration involves the loss of 4 grams amino acids per day. And hemodialysis involves the loss of 6 to 12 grams amino acids per sitting. And in acute kidney injury, significant protein catabolism occurs, abnormal carbohydrate and fat metabolism is there, and this is further complicated by renal replacement therapy. Standard enteral formula feed recommended in patients with AKI. High protein diet is recommended when the patient is on dialysis. And then provision of adequate non-protein calories is maintained to achieve total energy intake. Low potassium and low phosphate diets can be implemented when corresponding levels, serum levels are high. Then a word about the immunoenhancer. You can get a note on immune enhancing diets or immunonutrition. The first component about immunoenhancer is very important thing, glutamine. This improves antibody production, improves the colonocyte morphology and function. This is indicated in burn and trauma patients. It prevents diarrhea associated with enteral feed. Administration is both enteral and parenteral routes. Then we have omega-3 fatty acids. This is the second component, and it inhibits IL-1 and IL-6. And it has got anti-inflammatory role. So we substitute omega-3 for omega-6 fatty acids. Fish oil also helps in early weaning in case of ARDS. Then another one is arginine. This is a precursor of nitric oxide, increases cytokine levels, enhances wound healing. The other immune enhancing diets, growth hormone, antioxidants, and nucleic acids are to be named. Then Aspen recommends that immunomodulating enteral nutrition formula be enriched with arginine and omega-3 fatty acids. Nucleotides are superior to standard enteral nutrition formula in case of surgery and trauma. And in severe sepsis, immune modulating enteral nutrition may be harmful. Very important. Parenteral nutrition does not contain trace elements or vitamins because of instability and so requires separate prescription. Then ASPEN recommends single high dose vitamin D3 administration within a week of admission where 25 hydroxy vitamin D plasma concentration is less than 20.5 nanograms per ml. Actually, we should be giving it every week. Then there is another problem, overfeeding, associated with poor outcome, and uremia, hyperglycemia, hyperlipidemia, fatty liver, hypercapnia, and fluid overload are the problem when we are giving energy and calories over and above the calculated requirement. Propofol 1 to 2% is counted as 10% lipid, and when it is being used for sedation, it must be included in the calculations for nutritional support. And prefer underfeeding, aiming to meet roughly 85% of the calculated requirement. Refeeding syndrome, please try to understand. You can have a note on refeeding syndrome. Who are the at-risk patients? Severely malnourished patients with significant period of starvation, if vigorously refed, would go into refeeding syndrome. And starvation causes loss of intracellular electrolytes secondary to leakage and reduced transmembrane pumping, leading to severely depleted intracellular stores. Then, serum levels of the electrolyte may look normal, but however, the intracellular levels are low. Carbohydrate diet leads to an insulin-dependent influx of electrolytes into the cells, resulting in rapid and severe drops in serum levels of phosphate, magnesium, and potassium, calcium. And clinical features come up as weakness, respiratory failure, cardiac failure, arrhythmias, seizures, and death. So what are the precautions? At-risk patients should be identified and feeding must be introduced slowly, starting with only 25 to 50% of energy requirements and gradually increasing over 4 days. Then electrolytes should be generously supplemented at the same time as starting feeding and should be closely monitored. Then thiamine and other vitamin D to be given intravenously before starting feeding and then daily for at least 3 days. Then what is the role of immunonutrition in COVID? Based on various RCTs and meta-analysis, evidence for vitamin C, D, and zinc and their roles in preventing pneumonia and respiratory infections and reinforcing immunity appeared to look particularly promising. And however, ongoing research within the field of immunonutrition is further required. These are my references. And now I'll be taking drug viva for these various types of nutritions available, so as to give you a simulation on table viva of these drugs. Thank you so much. Yes, Hema, we are here to discuss the components of nutrition.
Yes, ma'am.
All right, both enteral as well as parenteral. And this will be a simulated viva, as the students sometimes are asked to select one drug out of it, and then the examiner asks you questions regarding it. So let us have this practice. So what are the monocomponents of parenteral nutrition that you can show me?
Ma'am, here one is dextrose, which is 50D, D50 dextrose, and
yes,
amino acid 10% and intralipid 10%. These are the monocomponents which is available in 3 different ways. So from dextrose, carbohydrate source, from amino acid, protein source, and from intralipid, we'll get the fat source.
Okay. Now I have told you how to calculate the kilocalorie requirements, and so how many calories are available in D50?
Yes, ma'am.
Because everything has to be calculated in calories. When we are writing prescriptions, we first see how many calories are required by the patient, and then we have these various components for which we should be very clearly understanding that this would give me so many kilocalories from this source and so on. So kindly explain how many kilocalories would be possible out of this D50?
Yes, ma'am. Ma'am, this D50 is 100 ml solution, which is 50% weight by volume. So it contains 50 grams in 100 ml. 1 gram gives 4 kilocalories. So here for this 100 ml, we have 50 into 4, which is 200 kilocalories.
So in case we have to give 600 kilocalories from the carbohydrates source, how many of these wax would be prescribed?
I will give 4 wax of this D50, ma'am. So 3 wax of this D50 to make it 600 kilocalories.
600. So accordingly, you know how to calculate. This is clear to you?
Yes, ma'am. Yes.
Then come to the amino acid component. Show me that amino N solution. This is available as 10%. What are the various percentages in which it is available?
Ma'am, it is available in 3.5%, 5%, 7%, 8.5%, and 10%.
Even 15% is also there, right?
Yes.
So how much would be there in this 10% solution?
Ma'am, this 10% is present in 100 ml. So this contains 10 grams per 100 ml. So we have 10 grams.
We have 10 grams per 100 ml. So how do you prescribe it?
Ma'am, the normal.
How do you calculate the proteins? And this is a non-caloric thing, no? We calculate the calories from carbohydrates and lipids. And this is a nitrogen source, which you have to give in addition, because any critically ill patient is hypercatabolic and is having a negative nitrogen balance, and proteins have to be substituted. Okay. So how do you calculate the protein requirement?
The requirement is 1 to 1.2 gram per kg per day. So this here we have 10 grams per 100 ml. So if we take a 60 kg patient, so if we take 1 gram, if we consider 1 gram, then he requires 60 grams. So I will give him 6 packs of this 10% amino acids, which provides 60 grams.
So you can write 2 wax 8 hourly or so, right? Yes. So make it 6, you know, we'll give it over the time, no? We'll give it 8 hourly, then 2 wax to complete this requirement, right? 1 gram per kg per day. So it's clear? Now come to lipids. Show me the lipid. This is 10%.
Intralipid.
This is intralipid 10%.
Yes.
And how much is the volume?
Ma'am, this is 100 ml, 10% intralipid.
100 ml or 500 ml?
100 ml. Sorry, 500 ml, ma'am.
Yes, this is available as 500 wax in 2 strands, 10% and 20%. Now explain how you would calculate the lipid calories and how would you prescribe?
Ma'am, the lipid will be minus from the total carbohydrate source. So first I'll calculate how much it is required for the patient. Total energy required will be 25 kilocalories. So from that I'll calculate 30 to 40% source will be given for the lipids. So from the carbohydrate source, how much it is coming, I will minus that from total energy, and rest will be given in the form of lipid.
Lipids. So how much is this going to provide kilocalories to the patient? 10%, 500 ml.
10% gives 1 kilocalorie per ml. Since it is a 500 ml bottle, this gives 500 kilocalories.
No. 1 gram of fat gives us how much?
9 kilocalories totally.
9 kilocalories. So how many grams are there in it?
And this contains 10 grams.
So this will be 50 grams of lipid, which would give us how much?
50 grams of intralipid.
450 kilocalories. No? 50 into 9.
Okay.
This will give us 450 kilocalories. Similarly, 20% is double the strength, and that's going to give us 900 kilocalories, right?
20%
is it clear?
2 kilocalorie per ml. This is 1 kilocalorie per ml.
Oh, yes. So that anything, do we have some simplicity of giving it together? We have some 3-in-1 kind of things available for total parental nutrition. Can you show that to me? Have you used it?
Here it is available in our institute. We have this in total nutrient admixture, which contains all these
Yes.
components in one solution now. So the first component of this is the first component, which is dextrose. This is the second component, which is amino acids 10%, and this is the third component, which is lipid. So we have to mix all these three solutions, and then it will be given to the patient as a single nutrient therapy.
Yes. So can it be given peripherally?
No, ma'am. It can usually we have separate peripheral parenteral nutrition also, but 3-in-1 mixture, when we combine all these things, the osmolarity will be more than 900. So we prefer it giving through central line.
Yeah, but when we have a parenterally given total parenteral nutrition, then the osmolarity is less than 900, because here you have 10% intralipids and how much? 40% dextrose and
10% amino acid.
Amino acid. There it would be, 10 or 20% intralipid, both can be given peripherally. You know that.
Yes,
then how about that dextrose? If it is available as 5 to 10%, you can give it peripherally. And what about the these amino acid solution?
3 to 7% we can give peripherally.
Up to 3 to 7% you can give peripherally. So in all there, you are going to have osmolarity less than 900, and it can. What about the enteral nutrition?
From here, this is the enteral nutrition what we use here.
Yes. What are the contents?
This contains carbohydrates, protein, fat, and vitamins, minerals, and also fiber is also present in this, along with sucralose.
So this is how much is this weight-wise?
Totally, this is 400 gram bottle we have, and we have to.
How do you constitute the diet? If you have to give one diet 250 kilocalories, generally we give in one diet enterally. How do you make it?
Ma'am, here this contains 4 scoops contains 50 grams. So I will dilute the scoop in 200 ml of water or 250 ml of water, or sometimes either depending on the patient condition, I can dilute with milk also. So after diluting, then I'll give to the patient. So it is like 1 ml contains 1 kilocalorie. So if this 50 grams is diluted in 200 ml, then it becomes 250. So it becomes 250 kilocalorie. So for a 50 kg patient whose total requirement is 25 kilocalories, so then it almost becomes 1250 kilocalories, and 250, then I can give it in 5 divided doses totally.
Say again.
Ma'am, for a 50 kg patient,
you take 50 grams of the powder, and then you dilute it to make it a 250 ml solution. You don't add 200 ml water. Idea is to make the volume 250 ml to give 1 kilocalorie of 1 ml solution, right?
Yes, ma'am.
Okay. So we have 8 diets of 250 kilocalories in this box, one single container.
Total contains 8.
Total calories. So 250 into 8 means how much total kilocalories are there in this?
2000 kilocalories will be there.
2000 kilocalories. And diet is calculated as how many kilocalories, and every time you gave it 3 hourly dosage, or that is the generally we give. When we are giving intermittent enteral feed, we are writing every 3 hourly.
Or 4 hours.
The patient would be given this enteral feed, and generally we give 6 feeds in a day, because at night we give a break. So we mostly give 6 feeds a day, and these 6 feeds would amount to 1500 kilocalories every day. And this contains all vitamins and minerals, and this is a good diet in itself. What is the advantage of giving this diet over the diet? They make a job giving this diet over that diet.
From here, by giving the enteral feed, the gut integrity is maintained, so that
No, and that too you will maintain by giving the diet prepared in the hospital kitchen also. Why we prefer giving this?
it contains extra minerals and calcium also, like
Yes, we
vitamins
know
and
the calculated amounts of the minerals and vitamins that we are given. We can at the most calculate, the carbs, fats and proteins that we are giving in that diet. But vitamins, minerals are all fully fortified in this diet. One. And second, handling is less when we are giving this kind of a food. So, the infection rate is less. All right? And diet-induced diarrhea sometimes happens. So that is, the chances are less when we give this kind of a diet. Right? Thank you so much, Hima. Thank you. I hope the students must have been benefited by this small, interaction with you. Thank you so much.
Thank you, ma'am.
Thank you, madam. It was really a very good presentation. In fact, you covered all the aspects. So I would just say just few key points, basically, like say, for example, enteral nutrition should be preferred over parenteral nutrition. That's a accepted thing. Second thing is enteral nutrition should be resumed as early as possible. Third thing is the nutrition should be decided on various factors, like say, for example, whether the patient is in medium or high catabolic state or low catabolic state. Secondly, what are the renal functions, what are the hepatic functions of the patient, whether the patient is on ventilator or off ventilator, he is breathing or she is breathing room air, or what is the requirement of oxygen. And secondly, whether we are going to wean off the patient from ventilator, because during weaning also the catabolic state and the oxygen or what we say the respiratory quotient changes. Say, for example, if a COPD patient is having high CO2 levels, high PCO2 levels, and if we give more carbohydrate diet, I mean the diet contains more carbohydrate, then he will produce more CO2, and the respiratory quotient will go up, and the weaning will be difficult. So it depends on so many factors, and of course the type of respiratory failure he or she is. So there are a number of factors. I think you have covered most of the things very nicely. Third thing I would like to communicate to my PG students that they must know what is the yield of each constituent of the diet. I mean, it's protein, fat, and carbohydrate. Many of our residents don't really know. Of course, madam has repeated the things in many slides, the 4 grams, 9 grams, like that in the fat, and protein and carbohydrate contains 4 grams of 4 kilocalories per grams. So it's like that. So what constituents are required? And of course, the nutritional other like say vitamins, minerals, trace elements, antioxidants, they also have important role in the nutrition. So madam, thank you so much. It's a very nice and enlightening presentation. And the interaction with the PG student was really very good. Thank you so much.
Thank you. Thank you so much.
So now I would invite Professor Dr. J.V. Devatia, and you all know that he's professor and head Department of Anesthesia, Critical Care and Pain at Tata Memorial Hospital, Mumbai. And he has so many achievements in his credit. He has been the past president of Indian Society of Critical Care Medicine. He's the past editor-in-chief of Indian Journal of Anesthesia. He has published, I think, more than 200 papers, and a lot of research he has done. And he is a very good teacher, I would say. And from my point of view, I would say that Dr. Devatia is the best person to tackle the topic which he is going to speak upon. That's a basic mode of mechanical ventilation. So now I invite Dr. Devatia, please.
Thank you very much for inviting me to this prestigious meeting and for asking me to speak on the basic modes of mechanical ventilation. Now, the ventilator looks extremely complex and high-tech and intimidating, but at the end of the day, every ventilator does only one thing. Any ventilator pushes air into the patient in inspiration. That's the only thing that the ventilator does. It does this by means of a compressor, which pushes gas into the patient, and two valves, an inspiratory valve and an expiratory valve. Inspiration begins when the inspiratory valve opens, while the expiratory valve is closed. Then gas goes into the patient. During the period of inspiration, you can close the inspiratory valve in inspiration. So this means in inspiration, you've closed, the expiratory valve is already closed. You also close the inspiratory valve by pressing a button called the inspiratory pause or the inspiratory hold button. And this is a period of the inspiratory pause, right? So you've got inspiration, and if you close the inspiratory valve in inspiration, you have an inspiratory pause. Then expiration begins with the inspiratory valve closed and the expiratory valve now opens, right? And the gas goes out to atmospheric pressure or the positive end expiratory pressure, okay? Just like you give an inspiratory pause in inspiration, you could give an expiratory pause in expiration when both the valves will be closed at the end of expiration. So essentially what the ventilator is doing is it is directing the flow of air into the patient with the inspiratory and the expiratory valves. And please remember, the ventilator only controls the inspiratory phase. Expiration is an entirely passive process, and all that the ventilator does, it allows the air to come out to atmospheric pressure. Okay, so this is again a sort of graphic description of what I told you. This is the patient on this side. This is the inspiratory limb, the inspiratory valve, the expiratory limb, and the expiratory valve. Now, this is the flow rate versus time, and the part above the x-axis is the inspiratory flow, and the part below the horizontal line is the expiratory flow rate, right? Now, so when the inspiratory valve opens, right, when the inspiratory valve opens, gas rushes into the patient, okay, and then it reaches the sort of flow rate that it's supposed to reach. Then it stays at that throughout the inspiratory time. Now I can close the inspiratory valve in inspiration. Remember, this is not expiration because the expiratory valve is still closed, but in inspiration, the inspiratory valve is now closed. And when you close the inspiratory valve in inspiration, the flow rate comes down to 0, right? So when the flow rate comes down to 0, there is no flow during inspiration. And this is called the period of the inspiratory pause or the inspiratory hold, right? So this is what has happened over here. There is 0 flow in inspiration. This is the inspiratory pause, right? And then the expiratory valve opens, and then the gas comes out and expiration begins, right? So this is how the gas flow is directed, and this is how the flow patterns look. This is the inspiratory part. And remember, this is what the ventilator controls. Expiration is an entirely passive process, and no matter what mode of ventilation you have, expiration is always the same. It is completely passive and depends on the characteristics of the patient's respiratory system. Okay. Now, there are two essential ways in which the ventilator controls the inspiratory flow. One is it acts as what we call as a pressure controller, where the airway pressure is held constant, right? The airway pressure in yellow is held constant, and the tidal volume delivered depends on the resistance and the compliance of the respiratory system. So and this is called a pressure controller or pressure control ventilation. The airway pressure is held constant. The tidal volume which is delivered to the patient is variable, and it varies with the resistance and compliance of the respiratory system of the patient. Okay. On the other hand, you have something called volume control or flow control ventilation. And most of the times we refer to this as volume control ventilation, but it's more correctly should be constant flow or the flow control ventilation, because the constant tidal volume is given by the constant flow rate multiplied by the time for which that flow occurs. So the ventilator adjusts the time at which constant flow occurs, and that's how you get a fixed tidal volume. Okay, so essentially mechanically it is the flow rate which is being controlled, but in medical terms we prefer, or we simply call it, volume controlled ventilation, because the tidal volume is held constant. Now, when you hold the tidal volume constant, the pressure which is developed in the airway depends on the resistance and compliance of the respiratory system. And this is what we call as volume controlled ventilation. So you have guaranteed a tidal volume because that is held constant by the ventilator, but the resultant airway pressure will vary depending on the resistance and compliance. Okay, so this is again just to tell you the differences between volume controlled ventilation and pressure controlled ventilation. Volume controlled ventilation is good because you get a guaranteed set constant tidal volume. So the tidal volume is guaranteed, there is no danger of hypoventilation. With pressure controlled ventilation, the tidal volume delivered is variable depending on the resistance and compliance of the respiratory system. And if your respiratory system resistance is high or the compliance is low, you may get a low tidal volume delivery for the same pressure which is being held constant, and that can result in hypoventilation. In volume control ventilation, while the tidal volume is constant, the pressure which is developed varies, and therefore you can get the risk of high airway pressures developing. In pressure control, this is what is being held constant. Okay. Now this part is extremely important. I would like you to pay attention to this graphic. Okay. So this is the flow rate versus time graphic. And like I mentioned, the part above the horizontal line is inspiratory flow, below the line is expiratory flow rate. And here, this is a pressure time graphic where you get the time over here and the airway pressure over here, right? Now, in volume control ventilation, the flow rate is held constant, right? That's what we defined as volume control. It's actually a constant flow rate ventilation. So here, once the inspiratory valve opens, it reaches that flow rate, and it is held at that level constant for a period of time throughout the inspiratory time, which guarantees the tidal volume. So the constant flow rate over a inspiratory time is, so this is a square wave sort of pattern of inspiratory flow. With pressure control ventilation, please remember that the inspiratory flow rate or the inspiratory flow pattern is always decelerating. It reaches a peak and then the flow rate keeps decelerating throughout or reducing throughout the inspiratory time. And this is a decelerating flow, which is a hallmark of any pressure limited or pressure controlled mode of ventilation. So in volume control ventilation, the flow rate is held constant throughout the inspiratory time, whereas in pressure control ventilation, the flow rate decelerates throughout the inspiratory time. And again, remember I said that the ventilator only controls the inspiratory part of the respiratory cycle. So this is different. The flow rate patterns are different for volume control and pressure control, but the expiratory patterns are identical because expiration is a completely passive process and it reaches a peak expiratory flow and then gradually decays till it reaches the baseline, both in volume and in pressure control ventilation. In volume control ventilation, you said the pressure varies throughout the respiratory cycle, whereas in pressure control ventilation, the airway pressure is held constant throughout the inspiratory time. Okay, so these are the differences between volume control and pressure control ventilation. And please remember, the hallmark of pressure control ventilation is a decelerating flow. And why is the flow always decelerating during pressure control ventilation? This is your ventilator pushing gas into the patient at a, let's say for an example, maintaining a pressure of 20 centimeters of water. At this time, initially, the lung is deflated and therefore there is no pressure in the lung, and the gradient between the ventilator and the lung is 20. Right, 20 minus 0 because the lung was empty, and so therefore there's a very rapid flow rate into the patient. So there's a very high flow rate into the patient. As the lung starts expanding, the pressure in the lung starts increasing, and the gradient between the ventilator and the lung starts decreasing, and therefore the flow rate reduces. So as the lung starts getting full, the flow rate, the gradient between the ventilator and the lung is reduced, and therefore the flow rate keeps decelerating. And when the lung is almost full, the flow rate will start decelerating towards the baseline or 0, right? So nearly full lung, the flow rate will have decelerated to a significant extent. So please keep this concept in mind. It's just a nice important concept to remember. Okay, so flow rate during pressure limited ventilation is always decelerating. So again, to sum up, with pressure control ventilation, the tidal volume varies with changes in the respiratory lung characteristics. right? And whereas with volume control ventilation, it is always held constant. The problem with volume control ventilation could be that because the flow rate is held constant, you can get patient ventilator asynchrony if the patient's breathing pattern changes. For example, if a patient is breathing normally, he's quite at ease and comfortable, the flow rate will not be high. And if you set a low flow rate, the patient will be well matched. But suppose the patient becomes breathless, he becomes tachypnic, he has a very high flow rate, requires a very high flow rate. And unless you change the flow rate set on the ventilator, there will be a clash because the flow rate which you had set earlier is not adequate for the patient's high flow demand, right? So there is a greater chance for patient ventilation asynchrony with volume control. With pressure control ventilation, the flow rate is adjusted to meet the patient's flow pattern, to meet the patient's breathing pattern. While the pressure set remains the same, the flow can change to meet the patient's ventilator demand. So in many ways, pressure limited modes of ventilation tend to synchronize better with patient's respiration. Because the tidal volume is fixed, if there is a leak, whatever goes out through the leak is not compensated for, so the patient will get hypoventilated. With a pressure control ventilation, with a small leak, the pressure will keep rising, the flow rate will keep rising so that the set pressure is reached. So you will not get, so there is what we call as leak compensation, because the flow rate keeps increasing to meet the set pressure, right? Okay, so these are the essential differences, pros and cons of volume and pressure control ventilation. Now, this is again a nice important graphic to remember. So, when the inspiratory valve opens, now this is volume control ventilation. When the inspiratory valve opens, the gas flows into the patient, and when it enters the lung, it has to overcome the resistance in the airway and the stiffness of the lung. So essentially, the pressure which is developed will depend on the pressure required to overcome the airway resistance as well as the stiffness of the lung. In other words, this pressure, which is called the peak inspiratory pressure, depends on the airway resistance and the lung compliance. Okay, so the peak inspiratory pressure depends on the resistance as well as the compliance. So the resistance is high or the compliance is low, the peak airway pressure, the peak inspiratory pressure will be high. Now, when you close the inspiratory valve in inspiration, remember we said the flow rate comes down to 0. When the flow rate is 0, there is no resistive element in the circuit. Because there is no resistance, the pressure now depends purely on the compliance, right? Now, remember that now at this point, gas has already gone into the patient and this lung is full. So now what you're seeing in this phase of the inspiratory pause is the pressure of the distending lung. And that depends only on the compliance of the lung. So the plateau pressure, this pressure is called the plateau pressure or the pause pressure, but we now call it the plateau pressure. That is equivalent to the pressure inside the distended lung, and it roughly reflects the alveolar, the pressure of inside the alveoli. And that is why it's an extremely important pressure to understand and to measure, because it reflects the pressure of the distended lung. And we know that over distension of the lung causes lung injury, volutrauma, right? And so if we measure the plateau pressure and if it is less than 30, we are reasonably assured that the lung is not over distended. If the plateau pressure is more than 30 centimeters of water, we think that the patient has an over distended lung and can get volutrauma. So the plateau pressure is an extremely important pressure to measure. Okay. Now, because the plateau pressure only depends on the compliance, right? So the difference between the peak and the plateau is actually an index of the resistance of the lung. So the peak pressure depends on resistance plus compliance, and the plateau pressure depends only on compliance. And the difference between the peak and plateau, therefore, tells you what is the airway resistance. So if the airway resistance is high, the peak will be high, the plateau will be normal, right? And there will be a big gradient between the peak and the plateau pressure. Now, the importance of this is also when you need to monitor the patient. You know that during volume control ventilation, because of airway pressure varies, you must monitor the peak and the plateau airway pressure. And you must also monitor the exhaled tidal volume, because with leaks, you can get a drop in the delivered tidal volume. And therefore, you must have low tidal volume as well as low pressure alarms, which can pick up leaks. During pressure control ventilation, there is no point in measuring the pressures because of keeping pressure alarms because the pressure is always held constant, but you must monitor expired tidal volume and the expired minute volume because they can vary with as the compliance and resistance of the patients changes. Okay, now, every breath that a ventilator delivers, again, I said the ventilator looks extremely complex, but essentially any breath that is delivered by a ventilator, and remember again, it is an inspiration which is controlled by the ventilator. Any breath can be described in terms of what triggers the breath or what opens the inspiratory valve, what limits the breath, or whether it leads whether it's the flow rate limit which is reached or the pressure limit which is reached, and what cycles of breath or what opens the expiratory valve, right? So any breath can be described in terms of trigger, limit, and cycle. So what triggers the inspiratory valve to open? What makes the inspiratory valve open? Now, one of the factors could be time. So if the patient is absolutely not breathing, is sedated and paralyzed, and you set a respiratory rate of 12 per minute, that means the ventilator will open the inspiratory valve every 5 seconds. So that is a time trigger. Okay. Very often you will want the patient to be breathing, and you want the patient to initiate the breath and then the ventilator to deliver the rest of the breath. This is all you want to do if you want to reduce work of breathing, is for the patient to initiate the breath and then the ventilator gives the breath, right? So you need some signal to tell the ventilator that the patient is attempting to breathe or has started initiating the breath. And one of the signals is the airway pressure. So the airway pressure during spontaneous breathing, a negative pressure is generated, and that allows flow of gas into the patient, and that pressure, that drop in pressure initiates the opening of the inspiratory valve. So you have a sensor which senses the drop in pressure, and that opens the inspiratory valve. On the other hand, you could have flow, because when there is a flow, when there is a change in flow with the onset of inspiratory effort, the ventilator can sense the flow rate change, and that can trigger the opening of the inspiratory valve. Now, in general, in engineering terms, flow triggering is much more sensitive than pressure triggering, because the sensors can change flow rate much faster and better and respond much faster to flow rate changes than to pressure changes. So most of the ventilators today are flow triggered, right, rather than pressure triggered. You can have a new mode, a new form of triggering called neural triggering, and we'll just talk about that. Now, like I said, this is a pressure time graphic, and you can see that there's a drop in pressure with the initiation of the spontaneous breath, and that is a drop in pressure below the baseline, which tells you the patient is attempting to breathe, and then the ventilator is now giving a positive pressure breath. And this is a breath which is not triggered by the patient. It's a pure ventilator breath which is initiated by the patient ventilator, and that's probably a time cycle breath. So all triggered breaths will have this deflection in the airway pressure below the baseline. Now, the impulse to breathe originates in the respiratory center, and that neural impulse travels all the way down through the spinal cord, the phrenic nerve, activates the diaphragm, right? The electrical activation of the diaphragm takes place, the diaphragm contracts, and that's what causes movement of air, chest wall, and lung expansion. And the current signals that we use to trigger the ventilator measure this process at the end of the sort of inspiratory signal, right? So there's changes in airway pressure, flow, and volume are what are sensed and the ventilator is triggered. In other words, there's significant delay between the patient wanting to breathe in the brain and the actual change in pressure of flow which occurs in the airway, right? So this can cause a delay and between the patient wanting to breathe and the actual breath being delivered, and again is a cause of asynchrony. We now have methods to sense the electrical activity of diaphragm, and when the sensor senses that the diaphragm is getting depolarized, it will trigger the ventilator breath. So it occurs much earlier, and you can trigger the ventilation inspiration as well as the expiration, because when the electrical activity of diaphragm fades away, it signals that the patient has gone into exhalation. And that you now have a mode called neurally adjusted ventilatory assist, where you've got a sort of Ryle's tube with modified Ryle's tube with electrodes placed in the esophagus, which sends the electrical activity of diaphragm, and that triggers the inspiratory valve to open and also cycles the expiratory valve to open when the electrical activity in the diaphragm recedes. So that is triggering. So that has started the breath. Once the breath starts, one or more, there has to be something which limits the breath, right? So in volume control ventilation, the breath is limited when the flow rate is reached. In pressure control ventilation, that breath is limited when the pressure is reached. And then once that limit is reached, it continues at that limit throughout the duration of the inspiratory time. So inspiration is not terminated when the limit is reached, it continues at that limit till the inspiratory time is reached. So in volume control ventilation, it continues throughout, that flow rate will continue throughout the duration of inspiration. With pressure control ventilation, that pressure will be maintained throughout the duration of inspiration. And then something has to tell the ventilator to change over from inspiration to expiration by opening the expiratory valve. Now, the commonest mechanism is time cycling. Okay, so when a certain time is reached, then the ventilator will change over to expiration. In some modes, you've got flow cycling. Okay, and we'll talk about that. Pressure cycling no longer is there. Very old birds ventilators, they were pressure cycled, and what happened was that as soon as the pressure was reached, it shifted over to expiration, right? So that was pressure cycling. Now this happens in modern ventilators only when a high pressure alarm limit is reached. When an alarm is reached, then it will change over to expiration. It's a protective mechanism, but otherwise cycling is almost always time cycled, and sometimes in pressure support it's flow cycled. And expiration is a completely passive process, and the pressure reaches the baseline pressure or the positive end expiratory pressure. Types of breaths are mandatory if the ventilator determines the start and the end of inspiration. So inspiration and expiration are both determined by the ventilator. It is an assisted breath if the patient has triggered the breath and then taken over by the ventilator. A spontaneous breath is where the start and end of inspiration are determined by the patient and not by the ventilator. The ventilator only follows the inspiration and expiration. And it's supported if the inspiratory pressure during that spontaneous breath is higher than baseline. Okay, so we'll just go over some of these. Now, the problem with all these modes of ventilation is, that all very confusing because there are so many acronyms and names which are given, volume control, PCV, PRVC, autoflow. And the problem is all ventilators give different names purely for trademark considerations and for patent considerations. Essentially, in many modes, which are called different names in different ventilators, the mode or the pattern of for the breath delivery is identical, but just the names are different. And what we need to do is not focus so much on the names as to know as what is happening, how the breath is delivered in that mode. And any mode can be described in terms of whether it's pressure controlled or volume controlled, whether it's spontaneous or mandatory, and some other information which we have. And we'll go over some of these. So the simplest mode to understand is what we call a CMV, or controlled mode ventilation, or controlled mandatory ventilation, whatever you want to expand it to in different machines. All breaths are mandatory. In other words, the patient is not breathing. The patient is probably deeply sedated or paralyzed, and you have set a respiratory rate, you've set a flow rate or inspirator, or you set the tidal volume, right? Or you set a pressure. So it could be pressure controlled or volume controlled. They are time triggered because the patient is not breathing. It's time triggered, and most of them, they are volume limited in or flow limited in volume control ventilation, pressure limited in pressure control ventilation, and they are usually time cycled. Okay. So now if you look at this graphic, this is the flow, the inspiratory flow pattern, right? Can you see this is a descending flow? So this is a pressure controlled ventilation. And if you look at the pressure time graphic, there is no deflection below the baseline. So these are not pressure patient triggered breaths. These are all ventilator initiated breaths, right? So this is pressure controlled CMV, right? Or pressure controlled CMV. This is, you can see over here, this is a square wave inspiratory flow pattern. So this is a volume controlled mode. And you can see again, there is no deflection below the baseline in the pressure time graphic. And these are mandatory breaths, which are volume controlled. So this is volume controlled CMV, right? So this is CMV. Now, once the patient starts breathing, what you would like to do is you would like the patient to start the breath and then the ventilator to take over. And you have a mode called assist control ventilation, where all that the patient has to do is initiate the breath and then the ventilator takes over. And in this mode, each and every breath that the patient takes is assisted by the ventilator, right? So it is like CMV, but now all breaths are assisted are triggered by the patient and only assisted by the ventilator. And again, they could be volume controlled or pressure controlled breaths. Right? Now, so let's say even if you set a rate of 10, if the patient breathes at a rate of 30, every breath that the patient takes will be triggered and will be assisted. So the patient will now, so if you set a respiratory rate, tidal volume of 500 ml, the of 500 ml, if his respiratory is 30, and he'll hyperventilate with 15 liters per minute. And that can cause problems. It can wash out CO2. You can also get hemodynamic compromise because the patient is spending a lot of time in positive pressure. Now, so assist control ventilation is excellent because it reduces work of breathing. All that the patient has to do is start the breath and then the ventilator takes over. But there are side effects like you can get hyperventilation, low CO2, and you can get hemodynamic compromise. So, it was an excellent mode, but there are some downsides. And therefore, what engineers did, when doctors said that this is the problem, they said we can fix this by creating a mode where you tell how many breaths you want the ventilator to assist. The ventilator will assist those many breaths, and the rest of the breaths the patient will take on his own without any assistance from the ventilator. In other words, this is what they call as intermittent mandatory ventilation. So for example, you set a rate, you say you want only 12 breaths per minute to be assisted. So the ventilator will give 12 breaths. If the patient breathes a rate of 30, the remaining 18 breaths will be spontaneous breaths completely unassisted by the ventilator. But 12 breaths will be assisted by the ventilator, right? Now, there could be a clash because you could have the patient wanting ventilator giving up inspiration, but the patient want to exhale. There could be a clash. So instead of intermittent mandatory ventilation, they devised a mode called synchronized intermittent mandatory ventilation. So let's say how was that achieved? Let's say you set a rate of 12. In other words, every 5 seconds, the ventilator has to give a breath. So what the engineers did was they said, okay, at 5 seconds, plus half a second and minus half a second, for example, right? So between 4.5 and 5.5 seconds, the ventilator will look for a patient breath. If it sees a patient trigger or a patient negative pressure deflection, it will synchronize the ventilator inspiration with the patient inspiration. So we'll try to synchronize the patient's inspiration with the ventilator breath. So this was synchronized intermittent mandatory ventilation. So in other words, if you, so some breaths were assisted by the ventilator, triggered by the patient, right? So synchronized with the patient effort. The remaining breaths, if the patient was breathing at a faster rate, the remaining breaths would be completely unassisted. Now, this solved the problem of hyperventilation. It solved the problem of hemodynamic compromise because you didn't spend so much time in respiration. And people thought, wow, this is fantastic. They said when the patient is sick, we will give a higher SIMV rate. So we'll give, say, 18 breaths or 20 breaths. And as the patient gets better, we will start reducing the SIMV rate to 8, to 12, to 10, to 8, and so on. And so SIMV could be a ventilation mode when the patient is sick. It could be a weaning mode when the patient is getting better. So this was actually thought to be wonderful. But actually what happened is when patients did weaning trials, especially in patients with COPD, they found that, the pressure support breathing was the best, or TPs were very good modes, but SIMV was the worst mode. And the reason was that in SIMV, okay, the in-between breaths, which the patient was taking unassisted, actually increased the work of breathing. And that led to respiratory muscle fatigue or inadequate rest of the respiratory muscles, and led to weaning failure. Now, so this is what SIMV mode looks like. So this is pressure control. You can see a decelerated breath, right? Now this breath is triggered by the patient and assisted by the ventilator. This breath is unassisted. This is a completely spontaneous breath, right? And this is another, so some breaths are assisted and some breaths are unassisted spontaneous breath. So this is synchronized, and these breaths are synchronized with the patient effort. So this is synchronized intermittent mandatory ventilation. Good tidal volume, low tidal volume, spontaneous breath, and good tidal volume. So if there are lots of spontaneous breaths and the patient, this can actually increase the work of breathing of the patient and therefore may not be very good for weaning. Okay, so the last mode is what I want to talk about is pressure support. Now this is a completely spontaneous mode. The patient triggers each and every breath. So you must make sure that there is a backup mode, because in case someone accidentally gives sedation, you must have a backup positive pressure ventilation for this. Otherwise, the patient will just stop breathing and there will be, patient can have this thing. It needs the patient to trigger the breath, right? So when the patient inspires, pressure rises to the set preset pressure. And remember now here, the ventilator doesn't know how, there's no time cycling over here. The ventilator has to decide when the patient wants to exhale. And remember I said that in a pressure limited mode, the ventilator knows the lung is almost full when the flow rate has decelerated to a certain percentage of the peak inspiratory flow. So when the flow rate has decelerated to a certain percentage of the peak inspiratory flow, the ventilator assumes the lung is full and initiates exhalation and opens the expiratory valve. So this is a patient triggered, pressure limited and flow cycled breath. So let me explain this again. So this is a peak inspiratory flow. As the lung gets full, the flow rate decelerates. And when it reaches, say, for example, 25% of the peak inspiratory flow, the ventilator thinks that now the lung is full and initiates exhalation and opens the expiratory valve. So expiration starts over here. And because it is cycling takes place based on the flow rate that is reached, this is a flow cycle ventilation. So this patient initiated, pressure limited, right? And flow cycle, right? So so as you increase the pressure support level, the tidal volume delivered increases. And so it's a very good mode because it's well synchronized, because it's pressure limited. You can control the tidal volume by increasing the pressure support level, and it decreases the work of breathing because each and every breath is supported, right? And now using pressure support, you can overcome that one limitation of the SIMV mode by giving pressure support to the spontaneous breaths. So while SIMV alone is not a good mode, SIMV with pressure support is a good mode, right? So remember, so this is again a pressure limited ventilation. So patient triggered, synchronized, spontaneous breath, which is pressure supported, and this is a mandatory breath, which is given the set tidal volume. So this is SIMV with pressure support. Okay. Now remember, there are many other modes of ventilation. We've only described the basic modes, but in the biggest trial, the ARDS trial, which showed a difference in outcome with mechanical ventilator strategy, this mode used was the simplest volume assisted control mode, right? Simplest mode was used. So it is not so much the mode that is important, it's the ventilatory strategy which is important. And all your strategy must be tailored towards the goals of ventilation to have adequate oxygenation, acceptable CO2, reduce work of breathing, and prevent ventilator-induced lung injury. Finally, please remember 3 golden rules. Never silence an alarm unless you've identified the problem and sorted it out. When in doubt, AMBU the patient. So you have a 15 lakh ventilator in front of you, but make sure you have a 1,500 rupee AMBU bag to sort out any urgent problem. So every ventilator must have an AMBU bag at the bedside. Remember general care of the patient, give them a fast hug. This is the acronym it stands for. And remember the KISS principle, and its KISS principle stands for keep it simple, stupid, get your basics right, read your ventilator manual, because different ventilators are slightly different in the way they do certain things. But please read your ventilator manual, be familiar with your ventilator. And thank you very much for listening. I'll be happy to take any further questions.
Thank you, Professor Devatia. I think Professor Devatia has taught this very basics of basic modes of mechanical ventilation in a very simple and understanding way. I feel our PGs must have understood this intriguing topic. It's a little dry topic, but we as anesthesiologists and critical care physician must learn the basics of mechanical ventilation. Of course, there are further topics on ARDS and the different modes of ventilation later on. So thank you, Dr. Devatia. And any questions from our house?
No, sir, there are no questions in the chat box.
Thank you, sir. Thank you so much.
Thank you. Thank you very much for inviting me to speak at this meeting.
Thank you so much, sir.
Yes.
Thank you. So in continuation to the ICU session, we have another session on ICU. And for that, I would like to invite our next chairperson. The next chairperson for this session is Dr. Mukul Chandra Kapoor. Sir is Director of Anesthesia at Max Hospital, Saket, New Delhi. And sir's area of special interest are cardiac anesthesia, teaching, and low flow anesthesia. Over to you, sir, for the proceedings of this session.
Thank you very much. It's a pleasure to introduce the next speaker. The next speaker is a very prolific speaker and a person and a personality, I would say. And Sheila Nayan Mitra is well known across the country and across the world, I would say. She is the president-elect of the Indian Society of Critical Care Medicine, and she is also chairing the Intensive Care Medicine Committee of the WFSA. She is the past president of IDA. She is a prolific writer, and she's got more than 100 publications internationally, and she is considered a subject eventually, and she's because of this she's on the committee of international experts for ASA and PUMA guideline projects, and she's also been involved with the WHO for developing the oxygen algorithms in different resource settings. And I don't know how much to describe. She's a prolific person, really, she can do wonders. And I'm sure all of you are going to enjoy what she's going to teach you all. Over to Sheila, please.
Thank you very much, Dr. Kapoor, for that very kind introduction. Thank you very much. I know it's a post-lunch session, but I'm very grateful because I had Professor Diwatia, my boss, speaking just before me. So I'm sure he's kept everyone awake. I just request that I be allowed to share my screen. Sorry. So at the outset, I'd like to thank the organizing committee of APEC for giving me this opportunity to speak at this meeting. It's the first time that I am speaking at this symposium, and it's really indeed a great pleasure and honor. I've been listening to some of the talks yesterday, and I think it's an excellent teaching and training program, and really delighted and honored to be there. Greetings from the Tata Memorial Hospital. I'm going to be speaking about ventilation in ARDS, a topic that's very dear to my heart and also something, an area of my research. But because this is largely a student audience, I'm going to stick to the basics of mechanical ventilation, not go into too much advanced things, but of course you can ask me at the end if you wish. So I'll try to cover just things that are asked in the examination and cover the fundamentals and put you through the pathophysiology and put you through how you should ventilate a patient in ARDS and how it's different from ventilating a patient with normal lungs in the operating room. Now, I'm sure most of you who have spent some time in the intensive care unit have seen x-rays like that. You see bilateral fluffy shadows in these x-rays. And this is what a patient of ARDS, the x-ray looks like. And remember, ARDS is acute respiratory distress syndrome. It's no longer adult respiratory distress syndrome. So you could have ARDS in an adult as well as in a child. Now, there's wide variation in what people understood by ARDS. And so in 2012, we had the Berlin definition, not the most perfect definition, but it's important that we're all speaking the same language, especially when you are trying to do research. You have to be on the same page. So what we mean by ARDS, and this is important to understand, that what do we mean by definition, ARDS? So it's something that occurs within 1 week of a clinical insult with worsening respiratory complaints. You have to have bilateral opacities, and this should not be explained by some effusion or just some collapse or some lung nodules or something. And the origin of this edema could, should be of respiratory failure. Should not be of cardiac origin. Okay. So earlier, when we put PA catheters, we were talking about pulmonary artery occlusion pressure less than 18. But now we need more objective assessment. We all do bedside echocardiography. So we should exclude that this is not hydrostatic anemia. This is not because of cardiac failure. And then it's broadly divided into 3 categories based on the P2F ratio: mild, moderate, and severe. So, mild would be P2F ratio less than 300, less than 200 for moderate, and less than 100 for severe. And of course, this should be in a patient who's receiving at least more than 5 of PEEP. So fairly simple definition, not much different from the previous definition, but some more criteria, especially the echocardiographic criteria. Now, why do you get this ARDS, and what are the risk factors for it? So it could be just a pneumonia, again, bacterial, viral, fungal etiology, but also remember, in the Indian setting, you have to also think about conditions like malaria or leptospirosis or other infectious diseases that are unique to our country, that also result in patients going into complex ARDS. Aspiration, pulmonary contusion. So all these direct lung injuries or some indirect lung injuries, like could be sepsis, pancreatitis, burns, trauma, or even drug overdose, transfusion related. So where there are various risk factors for a patient going into ARDS, and you should keep this in mind while you're treating the patient. So what's the problem that we face? So primarily hypoxemia, severe restrictive lung disease. There's it's difficult to ventilate these patients because it's a high price you have to maintain, because you have to maintain your adequate blood gas levels and at the same time you have to avoid ventilator induced lung injury. And one of the prices we have to pay with giving low tidal volume is a hypercapnia, because we have to give protective lung ventilation that I'll speak to you in a bit. And then there's also the worry about the secondary lung infections. Now it's important to understand the natural history of this disease and how it progresses, so that your ventilator strategies and what you do could match, treatment options could match. So you have the exudative phase, and then there's a transition phase, and this all happens in a matter of days. And then after about a week, you go into a proliferative phase, and then later there are fibrotic changes. And these are the different, you can see these various curves. Of course, there are individual variations, but this is by and large how the disease progresses. So, the therapeutic strategies in line with the Berlin definition are as follows. So if you look at the x-axis, you have mild, moderate, and severe, again classified by the P2F ratio. Now, whatever type of ARDS you have, it's uniformly low tidal volume ventilation that you should use. Even if you're using non-invasive ventilation, you should make sure that the tidal volume doesn't exceed 6 ml per kg idle body weight. Regarding the PEEP, when it's mild ARDS, you could consider low to moderate PEEP, so somewhere between say 5 to 8, and then you could consider higher PEEP strategies for moderate to severe ARDS. Prone ventilation should also be considered when the P2F ratio is less than 150. I'll talk in detail about all these strategies. The ones that are marked in blue have high evidence. Non-invasive ventilation for ARDS, neuromuscular blockade, and extracorporeal CO2 removal, and even ECMO, HFNO. The evidence is there, but it's not as strong as for the other interventions. So this is largely how we go about with the mechanical ventilation in these patients. So before I go on to the ventilating strategy, I want you to understand some basics. So what is the kind of lung injury that you see in ALI or ARDS as we call it? So remember, you see these on X-ray, you get a 2D image. So you're seeing these bilateral opacities, but this is very non-uniform. So you have 3 different types of areas. You have completely aerated areas, then you have the non-aerated areas. So these are like collapsed, but they are recruitable. And then you have the non-aerated areas that are not recruitable. And this was proposed by, with repeated CT scans, this phenomena was observed and described by Luciano Gattinoni. So you have this kind of non-homogeneous kind of lung involvement. And that is why the ventilation in these patients becomes very important. Unlike in the operating room where we ventilate normal lungs, we have to keep in mind certain strategies. And I'll try to explain the rationale behind these strategies. So if you look at the aerated lung, it's only a third of the actual lung that you have available that is normal. So these patients have what you call as the baby lung. So this would be the normal lung, but like I told you, only about a third of this lung is available to these patients. So this is how you would ventilate the normal lung. On the other hand, when you have a baby lung where only the third of the lung is actually aerated, and you give the same tidal volume of 8 to 10 ml per kg of ideal body weight to this patient, you will land up causing over distension including high pressures in this lung. And this is what the volutrauma or the stretch induced lung injury that occurs in ARDS. And that is why we need to use low tidal volume in these patients. The other phenomena that we see, and here you can see the airway pressure curve during mechanical ventilation. And here you can see that when you ventilate the normal lungs, okay, these are the alveoli, they don't completely collapse. And then there is inspiration and expiration, and you will see that the alveoli completely open up and then they go back to the baseline level. And this is what happens when you ventilate a normal lung. However, when you have a patient who has an ARDS lung, some of these alveoli are completely collapsed. Okay, so you need higher peak pressures to open these alveoli. They're completely collapsed, and some of the recruiter valves you'll be able to open it, but then they go back into this completely collapsed condition. And this cycle goes on repeating one after repeated. And what happens is you get a kind of injury called shear stress. Now, what is a shear stress? Because this alveoli completely collapse, and then again it opens, and then again it collapses. So this cyclical opening and closing of these completely collapsed alveoli results in the shear stress, and this is at the margin of the these alveoli at the junction along with the normal alveoli. that are being ventilated, and this produces the lung injury. In addition to this, the volute trauma that I described because of the baby lung and the shear stress because of the cyclical opening and collapsing of these completely, collapsed alveoli, they result in biotrauma. Biotrauma is the release of the inflammatory mediators, like your IL-6, IL-12, the different inflammatory mediators. And this not only causes further pulmonary damage, but it also affects the extrapulmonary organs. You see a patient with ARDS, and after a few days, you see them having renal dysfunction, cardiac dysfunction, liver dysfunction, and you wonder, hey, the problem was in the lung. Why are they going into multi-organ failure? It is because of this biotrauma and the release of these inflammatory mediators. Now, I think Professor Devachi has explained this very beautifully, but it's important to understand the plateau pressure and the peak pressure. Throughout anesthesia, we always focus on the peak inspiratory pressure. We are taught, watch the peak pressure, don't make the peak pressure go too high, because we're worried about barotrauma. Peak inspiratory pressure is associated with barotrauma. You might have bullae, which will rupture, or pneumothoracis, etc. But what we are interested when we ventilate a patient with ARDS is not the peak inspiratory pressure, but the plateau pressure. Now, this is during volume controlled ventilation. And as you can see, during inspiration, you will see this has already been explained, but I'll still tell you. You can see this is the peak inspiratory pressure. Now, if you give a 0.5 inspiratory hold, there will be a dip, and the pressure that you see is the plateau pressure. Some of the ventilators measure this automatically. Now, as you will see, during this time, both the inspiratory and the expiratory valves are closed. You're giving, at the height of inspiration, you're giving a 0.5 second inspiratory hold. Okay, so the lungs are completely distended. There is no flow, right? So you are directly, there is no resistive flow. So what you are measuring, of course, you are measuring at the tube end. So it is a surrogate measure for the alveolar pressure. Okay, that will give you some reflection of the compliance. And that is the plateau pressure that you're measuring. So you can see the distended alveoli and the entire respiratory tree up to the tube is completely in communication with no flow. So it's a surrogate way of measuring it, and that's how you measure the plateau pressure. And this is the pressure that is very important in ARDS, because this gives you an idea of the compliance and the pressure that the alveolar pressure, which is what we are interested in, and not the peak pressure that is used to overcome the resistance and the compliance to ventilate the patient. And of course, when you release this 0.5 second expiratory hold, you have the exhalation. And what is important throughout ARDS is that you should try to maintain the plateau pressure less than 30. Now they say even less than 27. So these are some of the principles. Avoid the volute trauma, the stress-induced lung injury. Avoid the shear stress. How would you avoid the shear stress that is preventing the alveoli from completely collapsing and reopening? Is by giving them PEEP. So at the end, instead of them going completely into collapse state, if you give them PEEP, they will remain partially open and you will avoid the shear stress. So for volute trauma, low tidal volume, to avoid the shear stress, you can give them PEEP. And of course, you try to keep the plateau pressure less than 30. So these are some of the broad strategies. So I'll just tell you why we moved away from the traditional tidal volume to the low tidal volume strategy. So the traditional tidal volume, I remember when I was a resident, we used to give even 10 to 15 ml, because the whole thing was keep the patient, the lungs open, well oxygenated, and not, you're giving anesthesia, muscle relaxant, there's retraction, and, there's atelectasis, and you want to avoid all that. So conventionally, anesthesiologists always like to give much higher tidal volume. But in patients with ARDS and ALI, when you try to give this higher tidal volume, as I mentioned, you produce stretch-induced lung injury in this baby lung, resulting in endothelial damage, epithelial damage, hypoxia, atelectasis, lung inflammation. All this releases inflammatory mediators, causes further lung inflammation and other organ injuries. So what we have to do is try to avoid this stretch-induced lung injury by giving a low tidal volume strategy. And this is what we mean by giving lung protective ventilation. Of course, when you use a low tidal volume strategy, there is a price you'll have to pay, because your minute ventilation will go down. So you can compensate for that by increasing the respiratory rate. When we ventilate patients with the ARDS, we don't use respiratory rates of 10 and 12. We use something like 20, 25. You can go up to 35. So the trade-off for this low tidal volume may be increase in PaCO2 and some respiratory acidosis. But this is the rationale for the low tidal volume strategy. So just coming very quickly to non-invasive respiratory support, and we've seen this a lot in COVID. People don't want to intubate the patients, and we've been giving a lot of non-invasive respiratory support to this patient as a kind of bridge and also to avoid tracheal intubation in these patients and mechanical ventilation. So we have two strategies, different strategies available as a bridge to complete invasive mechanical ventilation. And these non-invasive strategies, is either you can use the oxygen mask, but we have more superior ways of non-invasively ventilating these patients, where you can use NIV, that is pressure support along with PEEP, or you can use high flow nasal cannula oxygen. So both these strategies will give you PEEP. If you keep your mouth closed, then you can get PEEP even using high flow. Of course, it's less than when you use NIV. And these are the non-invasive strategies. Have they been compared head-on? Yes. The first and the largest randomized controlled trial comparing non-invasive ventilation with high flow nasal cannula oxygen was in France. It's called the Florali-1 study. And this was a multi-center study with a large group of patients. They took patients with P2F ratio less than 300. And what were the interventions? So either they used standard oxygen therapy or high flow nasal oxygen or non-invasive positive pressure. And the primary outcome was a 28-day mortality, and secondary outcome was 98 days and number of days free without ventilation. And what did they find? If you look at the need for intubation, there was no difference between the three arms. But in the patients who had a PaO to FiO2 ratio less than 200, there was a clear benefit with using high flow nasal oxygen in comparison to NIV and oxygen therapy. And when you looked at the 90-day mortality also, there was a survival benefit with using high flow nasal cannula oxygen, though no difference for the 28-day mortality. So you could conclude in this study, this was the only big randomized controlled trial that compared head-on these three strategies. So in patients with non-hypercapnic acute hypoxemic respiratory failure treated with HFNO versus standard or NIV, it did not result in significant difference in the intubation rates, but there was a significant difference in the 90-day mortality with a benefit for high flow nasal oxygen. So definitely this scores better in acute hypoxemic respiratory failure. But of course, when you have a mixed type of respiratory failure, or you have, say, a patient presenting with acute exacerbation of COPD or cardiac failure or something like that, then NIV may be more suitable in these specific cases, but not in acute hypoxemic respiratory failure. And we recently wrote this review with Jonathan Casey. I was very fortunate to write this with Audrey de Jong and both of them, where we talked about, we put the evidence together and summarized this, the non-invasive respiratory support before and after mechanical ventilation. And we talked about three phases: the initial oxygen strategies in acute hypoxemic respiratory failure, during tracheal intubation, and after extubation. I will, of course, only stick to the first part, that is in patients who present with acute hypoxemic respiratory failure. So if you see the evidence, definitely high flow nasal oxygen is superior to using conventional oxygen therapy. You can provide some PEEP and further decrease the work of sleep breathing. However, when you look at NIV versus HFNO in this trial, the primary outcome, there was really no difference, but definitely in patients with P2F ratio less than 200, HFNO scores above NIV in these studies. Then you have another study called the Lung Safe study. And this was the largest multi-center study. It was an observational study that actually looked, close to 3,000 patients, that looked at how patients were ventilated in ARDS, and a subgroup of that study. So this was the largest global study conducted. They just looked at the NIV arm and they looked at mortality. And NIV failure occurred in 22%, 43%, and 47% of the patients with mild, moderate, and severe ARDS. And what was very interesting is the hospital mortality in patients with NIV success and failure. There was a difference of 16.1 and 45%. So NIV was associated with higher ICU mortality in patients ventilated with PaO to FiO2 ratio less than 150. So don't just go by the saturation or just look at the patient. If the P2F ratio is less than 150, these patients should not be on an IV because the mortality is extremely high in these patients. And of course, COVID exposed one more thing to us. We had these patients who were maintaining saturation, who seemed to be breathing, but they had this high respiratory drive. And you will see in these patients, of course, COVID pneumonia is also a type of ARDS. They had impaired gas exchange and impaired respiratory mechanisms. And we saw a typical phenomena of increased respiratory drive. So with the same, even very low pressure support, they would generate very high tidal volumes. And this caused lung injury, what we call PSILI, or patient self-inflicted lung injury. So high tidal volume, increased drive, further increase in the pleural pressure swings, and this further led to increased capillary leak, increased pulmonary edema, and this vicious cycle of self-inflicted lung injury. And we did learn that in COVID, when you give NIV to these patients, these are the patients that even if they're maintaining the saturation or they have those happy hypoxic, these are the patients where you should consider an early intubation, because keeping these patients on NIV who are generating very high tidal volume can actually result in worst outcomes. So remember that just because the patient is tolerating that mode and is maintaining his parameters, the respiratory parameters and hemodynamics on spontaneous breathing, that's not enough, because they could have high transpulmonary pressures. So this is the airway pressure. What is transpulmonary pressure? It's the airway pressure minus the pleural pressure. So for example, if a patient is receiving NIV, pressure support of 12 and PEEP of 8, so your peak airway pressure is about 20. And if he's generating, he has a high drive and he's generating a negative pleural pressure of say minus 20, okay, and he breathes with this strong respiratory drive. So you're talking about this 20 and adding on the minus 20. So you're actually talking about a high transpiratory pressure of about 40. So very high driving pressures, and then high cyclical collapse, increasing the shear stress, worsening the lung injury. So you have to be very careful about this, and also active expiration. So all this will, kind of promote the alveolar collapse. So you have to be very careful about patients with ARDS, spontaneously breathing, who have this kind of high transpulmonary pressure. They probably should be intubated and given protective lung ventilation. And this is exactly what we saw in COVID, where NIV was given to the hypoxia, patients who are in this patients who are hypoxemic or non-invasive ventilation support maintaining, but you avoid mechanical ventilation. So the risk of this self-inflicted lung injury, and we have to be very, very careful in monitoring these patients from the physiological point of view, and also promptly detect those patients who need endotracheal intubation and make sure they get positive pressure ventilation. You also must know a bit about the ROX index, so this hasn't been extensively validated. What is the ROX index? Now, this was a ROX index was used more to predict which patients, especially on HFNO, would to predict which ones needed mechanical tracheal intubation and mechanical ventilation. It's the saturation divided by the FiO2, and that divided by the respiratory rate. And then this was again measured at different time points, 2 hours and 6 hours, and again subsequently at 12 hours. And depending upon the different ROX index, you had a kind of prediction model. You had lower cutoffs in the beginning, and then the cutoffs were a little higher, but not very accurate, but some kind of guidance for, especially in units which are managed by non-intensivists or anesthetists, to know which patients to intubate early. Now, what's important for us, again, while we ventilate, go to invasive mechanical ventilation, is focus on the ventilator-induced lung injury. Remember, why do we ventilate patients with ARDS? So it's like a disease. You have to give time for the lung to heal. So you are ventilating, you're taking over the role of the ventilation, but at the same time, your ventilation can produce some harm, what we call ventilator-induced lung injury. So while using these ventilator strategies, we have to make sure that we're giving the lungs adequate rest, but we're not producing any further harm. And if you remember what I told you about the 3 types of injury that you see in these patients with ARDS and ELI, they are the over-distension because of the high tidal volume that we use, the shear stress, because which can be overcome by the low tidal volume, the shear stress because of the cyclical opening and closing of the completely collapsed alveoli, and third is the biotrauma, which is a resultant effect of these 2, which results in the release of inflammatory mediators that cause further lung injury and also other organ damage. So if you look at the ventilatory strategies then in a patient of ARDS, you want to prevent alveolar overdistension for the reasons I told you. So you limit the plateau pressure, not the peak pressure, the plateau pressure that I explained to you, and you keep that below 30 centimeters. In fact, now the cutoff is somewhere like 27, try to limit it even further, and tidal volume of 4 to 6 ml per kg, and this is ideal body weight, not the actual body weight. And also you try to keep the alveoli not completely collapse at the end of expiration. So you try to keep them open. That's the open lung concept. To keep the units open by using appropriate PEEP, at least 5 of PEEP. When there's mild ARDS, you could use about 5 to 8 of PEEP, and then you could go up to about 14. Now, this is the landmark trial, one trial that has really stood its test of time. And this was done in the year 2000, where they used the conventional strategy of traditional tidal volume and compared with it with a low tidal volume strategy. In fact, the benefit of the low, and the outcome was, primary outcome was 28-day mortality. In fact, there was such a significant benefit with the use of low tidal volume that they actually had to stop the study in the midway, and there was a clear benefit. And this is the only one of the very few strategies in critical care that has not done a complete U-turn and has stood the test of time. So this is something we definitely need to follow in patients with ARDS and ALI. You start with 6 ml per kg ideal body weight, and you try to maintain the plateau pressure less than 30. If your plateau pressure is say 32, then you go down further to 5 ml per kg. If it is still 30 or 31, you come down to 4 ml per kg till your plateau pressure goes down below. So the goal is to keep the plateau pressure less than 30 and to give protective lung ventilation using about 4 to 6 ml per kg tidal volume. And to maintain the minute ventilation, of course, you need to increase the respiratory rate. You can't give them respiratory rates of 8 and 10 when you are going down on the tidal volume. So even with the secondary outcomes like organ failure, inflammatory betas, there was a clear benefit with the use of low tidal volume. So in this paper, the goals of therapy were the PaO2 FiO2 ratio was maintained between 55 to 80 and saturation anywhere between 88 to 95. So you're not aiming for 100% saturation, okay, except in some cases where there was pregnancy, intracranial hypertension, and plateau pressure, as I mentioned, less than 30, and arterial pH between 3 and 3.5. And this was basically you trying to prevent the ventilator-induced lung injury. How about selecting PEEP? Now, this is one of the most challenging things to do. What I like to do is use exactly what they use in the paper. They have a beautiful PEEP FiO2 titration table. So this was a huge trial where the intervention worked. So why not use the same strategy where, for different FiO2s, for example, if you're on 0.7 FiO2, you would use a PEEP of 10. So this was the PEEP FiO2 titration table that they use. And we use this in our intensive care unit as a kind of arbitrary way to judge. And this was a study where they used high PEEP and low PEEP. So high PEEP to all unselected patients is not beneficial. Anatomical recruitment is available, but functional recruitment does not predict the anatomical recruitment happens well. And there's no simple method to really identify this because patients are likely to benefit from high PEEP, but of course they can also be over distension. Remember, you have different areas. It's not homogeneous, right? So you might land up over distending. And if you look at even recruitment maneuvers that a lot of people do, there is transient improvement in oxygenation. You feel very good because the saturation goes up, but these had transient effect, no real benefit on the mortality. In addition to this, this high PEEP and recruitment maneuvers also result in hemodynamic compromise, which may be an issue and can further worsen the right ventricular dysfunction. You can also individualize the PEEP. Of course, if you are able to do it and you can look at the compliance. Now, the level of the PEEP can be associated with the best static compliance. So how do you measure the static compliance? This is the tidal volume divided by the driving pressure. And what is the driving pressure? The plateau pressure minus the PEEP. That is a set PEEP and also the intrinsic PEEP, right? And the plateau pressure, most ventilators calculate it on their own, or you can give a 0.5 second inspiratory hold and measure the plateau pressure and you can get the static compliance. And this, of course, requires the inspiratory hold for estimation of the plateau pressure. And this is all done during volume controlled ventilation. And then, based on this, you can adjust your PEEP level. So this is one way of doing it, or you can actually look at the pressure volume curves. Now in the pressure volume curves, why are you essentially giving PEEP? You are trying to keep this, your PEEP should be above. This is the pressure volume curve that you're seeing. And this is the lower inflection point, and this is the upper inflection point. So below the lower inflection point, there is alveolar collapse. So your PEEP should be set, at this junction. And of course, this is the point of over distension, right? The upper inflection point, because any more tidal volume that you're giving is going to land up over distending the lung. So if you're looking at the graphics and you can plot PV curves like Amato did in his trials, you can actually find out the best PEEP that can give you the best results in terms of compliance by looking at the graphics. But this is all kind of, very complex to do. And what people largely follow is they use the low PEEP strategy in mild ARDS, and moderate to severe, they may go up to 14 on PEEP. And this is a more recent study that is published in JAMA, where they actually titrated the PEEP. They looked at the transpulmonary pressures. They actually measured it using the esophageal pressures measured with the esophageal balloon. And on the other side, they just looked at, it used the routine empirical high PEEP and FiO2. And interestingly, the finding, they really showed that there was no significant difference between the two strategies. So we really don't have the correct answer, but definitely going too high is not good. And in mild ARDS, you could just be in about 5 to 8 of PEEP. So you prevent the strategy largely is you prevent the alveolar distension, keep the bladder pressure less than 30, or I would say 27, limit the tidal volume and keep the lungs open using appropriate PEEP, and open the collapsed lung. Now, recruitment maneuvers and whether you use a higher PEEP, this has very poor evidence and no benefit really of using these recruitment maneuvers except, a transient increase in blood pressure. Now, again, these are just some trials with recruitment which have really shown no benefit. I'll not go into details, but they actually showed worse outcomes in patients in whom recruitment maneuvers were used, and also higher PEEP was used, whether it was 6 months mortality or decrease in the number of ventilator-free days, or increased pneumothorax and increased risk of barotrauma. So perhaps we're better off with a little more balanced approach, but we don't have very robust evidence in how to ideally set the PEEP. Then people say that you should use the driving pressure rather than just go by the plateau pressure, and the CRS is strongly related to the volume of the aerated remaining functional lung, as we know, and you can measure the driving pressure, which is the tidal volume divided by the compliance of the respiratory system. So numerically, this can be calculated, and this was a study in which close to 4,000 patients with ARDS from various centers in which they use this driving pressure based thing. I won't go into details, but they use different lung strategies, and what the results of this is that yes, mortality is associated with driving pressure, not specifically with PEEP, and increasing the driving pressure with the fixed PEEP leads to higher mortality. Increasing the PEEP with the fixed driving pressure did not actually affect the mortality. That was the various combinations that were in the graphics. I don't want to waste time explaining that. But when increasing the PEEP, it leads to decrease in the driving pressure, survival improves. So definitely we need to look at the driving pressure, measure it, and the mortality difference was associated between difference of having driving pressure, keeping the driving pressure at the lower side, and the cutoff value was driving pressure. If the driving pressure was more than 14, then the mortality was increased. So if you're measuring the driving pressure, this is not a recommendation, but if you're measuring the driving pressure, then you should try to keep it low and try to keep it less than 14. What about the oxygen? How high should you go to? Should you target for 100% oxygen or very high FiO2? So we've had different trials, the ICU ROCKS, the LOCO2 trial, and more recently the HOT ICU trial. Different patients, different strategies. 90 to 97 and usual care showed no difference, or you keep lower PaCO2s and saturation 88 to 92 versus higher saturation more than 97. And there was a trend towards higher mortality and more mesenteric ischemia in the conservative group. But the more recent HOT ICU trial, where they kept PO2 60 versus 90, there was really no difference in the mortality at 90 days. So one could say that you could safely use a more conservative strategy in these patients, provided you are able to maintain the oxygenation and you do not target saturation of 100% or very high PO2s, because it's really shown no difference in these trial. What about the use of muscle relaxants? Now, a lot of times you need muscle relaxant, not only for tracheal intubation, but there's a lot of patient-ventilated dysynchrony, especially in the first 48 hours when you're trying to ventilate these patients. And these were one of the earlier trials that was done with muscle relaxants in patients with severe ARDS. Both were NEJM trials where they looked at early administration of neuromuscular blockade. And here they used cisatracurium, and they showed increased benefit in patients without any increase in muscle weakness in patients who got neuromuscular blockade in the first 48 hours. And more recently, we have the PETAL trial where they use early neuromuscular blockade in ARDS. And here, interestingly, they found no significant difference in mortality in 90 days between patients who received early continuous cisatracurium and those who were treated with usual care and lighter levels of sedation. Because as you remember, when you're using a lot of neuromuscular blockade, you also have to use deeper sedation. You can't keep the patients awake. So deep sedation itself causes worse outcomes. So unless, I would say, unless you really are having patient ventilated dysynchrony, or you're unable to maintain protective ventilation without giving neuromuscular blockade, you shouldn't use it. And if at all you use it, you should use it in the first 48 hours. And this is a very nice graphic that they've given after the PETAL trial. So they've recommended against use in all ARDS patients, especially in mild ARDS, you don't use it. In moderate to severe ARDS, if you're able to achieve lung protective ventilation with light levels of sedation, you need not use it. But if you're not able to do this with judicious use of deep sedation, you could use intermittent neuromuscular blockade. And despite continuous sedation and neuromuscular blockade, if you're not able to achieve protective lung ventilation, or as I mentioned, if there's patient ventilator asynchrony, then you could use neuromuscular blockade, and preferably for 48 hours. The other important strategy is prone positioning. Now, why do we prone these patients? It improves oxygenation, allows ventilation with lower tidal volumes, pressures, FiO2, drainage of secretions, rise in the PO2. The problems, of course, it's a nursing nightmare, your, pressure ulcers, facial edema. If the patient's hemodynamically unstable, you cannot prone them because you can't give CPR in prone positions, difficult. Lines and tube can get dislodged. And also 20% of the patients may be non-responders. Now, there were a lot of trials that really didn't show much of a benefit, but the landmark trial that you must know is the PROSEVA trial. And this was done in France, almost 500 patients, and they looked at 28-day mortality. And what they did is 16 hours of proning and 8 hours, followed by 8 hours of supination. So earlier trials use lesser duration and variable strategies, but this was a strategy that showed to work. You can see 16% versus 32% mortality difference, and even a 98-day mortality difference. Both were significant. So if you prone these patients, don't do them very early. Do it when the P2F ratio falls less than 150. Then you should start proning these patients and prone them for a period of minimum of 16 to 18 hours, not less than this, not like 4 or 5 hours of proning and then make them supine. If you want to see the benefits that was appreciated in the, the SYNC trial. So the last part I'm going to come to is, despite this protective lung ventilations, you still see this kind of situation where you have the PO2, say of 50 and FiO2 is on 100%. Then you have various approaches for this kind of refractory hypoxemia. So most importantly, you should rule out other technical complications. Is there a pneumothorax? Why is there acute deterioration? Why is this patient becoming, deteriorating like this? Is there a bronchial intubation? Is there a collapse? Because sometimes it's just a mechanical problem that you can sort out. It's not that the compliance is going, the lungs are getting worse. So assure that there's patient ventilator synchrony, paralysis, lung recruitment, optimal PEEP, prone positioning, that should be tried. And then other strategies like pulmonary vasodilators, and you can give extracorporeal life support is the way that you can go forward. Rescue treatments like high flow HFO and extracorporeal ECMO. HFO, both the trials, I won't go into detail, but there have been two. It was very popular at one time, but both these trials really showed no difference in these patients. In adults, it's used a lot in pediatrics, but no role for HFO currently in, in ARDS in adult patients. ECMO, of course, and this was the CSER trial, one of the largest trials, but I won't go into details about these trials. I just want to tell you that these are rescue therapies. These are not therapies, as a lot of centers in India are just using ECMO left, right, and center because they have ECMO available. There are definitive, timelines when you should consider starting ECMO in these patients. Another thing you need to consider is acute cor pulmonale. A lot of these patients have, acute cor pulmonale because of the bad lungs, extensive alveolar collapse, and severe hypoxia, hypoxic pulmonary vasoconstriction, and high extraalveolar vessel resistance. So the high PEEP and the high tidal volume can actually precipitate this. So in these kind of patients, you should use much lower PEEP in these patients, and they might even benefit. And the incidence isn't that low in patients with the ARDS. In the various series, you can see that the incidence of acute cor pulmonale is quite high. So you should keep this in mind when you see this. Do an echo, and you should try to come down on your PEEP. There are various complications also associated with your mechanical ventilation in the ARDS itself. You can trigger ventilation-induced lung injury, pneumonia, right ventricular failure, various complications that can occur because of your ventilation itself. So remember that when you're giving your protective lung ventilation, as we're taught in medicine, at the least, cause no harm. So you're trying to do something to benefit the patient, to give time for the lungs to heal, and you shouldn't be resulting in ventilator-induced lung injury. So keep in mind that there are complications related to mechanical ventilation in these patients. So the best way to protect the lung is first use low tidal volume, limit the plateau pressure, use moderate PEEP, reduce the overall amount of dispiratory energy, control the driving pressure. If you're able to measure it, keep it less than 14, low to moderate respiratory rate, prone position when the P2F ratio is less than 150. And then, of course, as for rescue oxygenation in refractory cases, you can use extracorporeal support. I'd really urge those of you who would like to know about mechanical ventilation, this is a very beautiful guideline that is written on the management of ARDS, and it describes the ventilation very beautifully for the various strategies. I'll just go through it very briefly to tell you what is the current evidence with these strategies. Now, just a summary, I won't take more than 2 minutes. So if it's tidal volume, 6 ml per kg of predicted body weight should be used as the first approach. And then in the absence of severe metabolic acidosis, including mild ARDS, this is done to reduce mortality, of course. So you should try to limit your tidal volume, come down to even 5 ml or 4 ml to keep the plateau pressure less than 30. So plateau pressure should not exceed 30. And even if you have, your tidal volume is on the lower side and your plateau pressure is now less than 30, still don't increase the tidal volume unless you are having some issues of persistent hypercapnia that is there. Otherwise, you maintain at whatever tidal volume that you have. Driving pressure data, not very strong data that you should, adjust your ventilation based on driving pressure, but this is definitely the future. Looking at PEEP, it is essential for the management. Don't use less than 5. You can use high PEEP in moderate to severe ARDS. You can go up to 14 or 15, but not beyond that, not shown any benefits. So you can reserve high PEEP for moderate to this thing, but in mild ARDS, you can use something like 5 to 8 of PEEP. HFNO, recruitment maneuvers, etc., not really shown any benefit in outcome. Neuromuscular blockade, you can use in select patients, especially when you have patient ventilator asynchrony and in the first 48 hours. Prone positioning, definitely in patients with P2F ratio less than 150, you should consider proning them early. If you prone them, keep it for 16 hours with 8 hours of minimum of 16 hours, 16 to 18 hours, depending upon your infrastructure. And then, of course, things like venous ECMO, etc., can be considered at rescue strategies, but only in those patients with a P2F ratio less than 80. You shouldn't just start it without having tried neuromuscular blockade, without having tried prone positioning. People directly put the patient on ECMO, and that's not justified. About low flow extracorporeal CO2 removal and inhaled nitric oxide, we still need more data, but these are definitely things for the future. I'll leave you with this kind of table that is from the article. It's really beautiful. You reassess the ventilator settings every 24 hours after initiation. So initial initiation, you're trying to screen this patient to see if he's ARDS. Once you've confirmed ARDS, tidal volume 6 ml, plateau pressure less than 30, PEEP more than 5, check for hypercapnia. If the P2F ratio goes below 200, then you increase the PEEP to improve the oxygenation. Once the P2F ratio goes below 150, you use neuromuscular blockade, prone positioning. And when the P2F ratio is less than 80, then you should discuss using your veno-venous ECMO, not before having tried neuromuscular blockade and your prone position. This is a paper I really had the fortune of writing with this expert group. And it was almost my dream to share an article with Luciano Gattinoni, and that came true. So we wrote this review on personalized mechanical ventilation in ARDS. And definitely you understand that individuals are different, the disease is heterogeneous, and you cannot have one fixed tidal volume and one fixed plateau pressure and one fixed PEEP that you're using. So definitely we haven't understood enough, but from the evidence that we have, this is the best approach. But we are moving towards a more personalized approach, which will be, a tidal volume that is not just a fixed tidal volume of 6 ml, but perhaps we're just looking at we will be looking at the driving pressure, and we will be, based on the driving pressure, we will be setting the PEEP and the tidal volume. We will be looking at mechanical power, the gas exchange, not just the P2F ratio, but also considering the dead space. So there are various ways in which the future of mechanical ventilation in these ARDS patients, again, depending upon the phenotypes also, we will have different strategies. Today, recruitment isn't working because we're doing a one-size-fits-all approach. Perhaps a more personalized recruitment, criteria for in which patients will benefit and select those patients may be the way forward. So this is what we described in this review, a more futuristic approach to this. So I'll just end, sorry for exceeding by a minute. My take-home message is the mortality with ARDS remains high, especially in moderate to severe. And non-invasive techniques, both HFNO and NIV, should only be tried in mild ARDS, not in moderate to severe, with very careful monitoring. Make sure that you're not, these patients are not, you're not delaying tracheal intubation. Low tidal volume is a must, irrespective of whether you're using non-invasive or invasive mechanical ventilation. Do not allow the tidal volume to exceed 6 ml per kg. High or low PEEP doesn't really make a difference. Don't exceed about 15. Neuromuscular blockade early, first 48 hours, and only if required, especially when you have patient ventilated asynchrony. Prone positioning, definitely in patients with P2F ratio less than 150, and try to extend it for at least 16 hours, 16 to 18 hours. And then ECMO, of course, should be used as a rescue therapy in these patients with refractory hypoxia, especially when the P2F ratio goes below 350. So I'll just leave you with this table regarding the various strategies. And I'd like to emphasize that the one thing that has stood the test of time is the low tidal volume ventilation. And this is something very important today. Even in the operating room, we are not using very high tidal volume. Even in normal lungs, we are more gentle, and we're using about 6 to 8 ml per kg ideal body weight. Thank you so much for your attention.
Thank you, Sheila, for an enlightening speech. As usual, you were very clear and concise. And it's a very important topic for people who work in critical care, of course, and even for others. I mean, even for anesthesiologists who work at times in critical care. It's a very important topic. There are a few questions which have come. One question is from Dr.
Before you
Diksha.
say that, I would not say for people working in the ICU, because sometimes you may have an ARDS patient coming to the OT, for an emergency surgery, and then you should know how to give protective lung ventilation to this patient. Yeah. Yes.
The first question is from Dr. Diksha Gaur. She wants to know what is stress index and in ARDS and what is its significance.
Yeah, so I didn't deliberately get into this because there is the strain and the stress that is measured. Again, depending upon the mechanical power and this is more, it's very theoretical. It is all in experimental phase. So I wouldn't go into details about that, but you can individualize there's a stress index that's calculated. There's a very good paper on that. And based on this, you can individualize the mechanical ventilation. So this is a paper by Gattinoni, where, there are different stress indices, and then based on that, they have calculated. So essentially it is, I would say, a way of individualizing your mechanical ventilation based on parameters. I wouldn't be able to explain it to you on this forum, but you can measure the stress and strain, individualize this from the scans and the physiological parameters and the things that you see on the ventilation, and then calculate the stress index and then individualize your ventilation. But sadly, the data that we have is not very strong. It's not really recommended. I would say it's still in experimental phases. Yeah.
So you're mute, sir.
I can't hear you.
My connection was, my connection went off for a moment. That's the reason why. There's a second question actually addressed to the boss, not to you, but I don't think Dr. Divya is around now. So I think I'll ask you to answer it. It's from Dr. Priyanka Jain. She says APR mode and PRVC mode. Please explain what is PRVC, why PRVC is better than VC mode.
Why the PRVC is better? Sorry, yeah. So these are dual control modes, your PRVC. Yeah. So what happens is Dr. Divatia spoke about basic mode. So he talked about volume control ventilation and pressure control ventilation. So as you know, when you have pressure control, the volume is variable. And when you have volume control ventilation, the pressure is variable. And it again depends on how much pressure you generate and how much volume you generate. It depends on the compliance and the resistance of the lung. So we have control on one variable, whether we don't have control on the other variable. So that is why they said, why don't we have dual control modes where you have control on both the pressure as well as the volume. So in pressure regulated volume control, what it would do is, now supposing you're doing on you're ventilating a patient with volume controlled mode, you fix you put a set volume. Now the pressure will go on varying. So sometimes if your pressure exceeds, you won't be able to deliver that set tidal volume. So what happens in PRVC is every 3 seconds, it will sense what is the pressure required to deliver that tidal volume, and it will go on increasing or decreasing accordingly. So essentially it is a more automated kind of thing, in the sense that it is breath to breath, it is analyzing, and it is able to, essentially what these dual control modes do, it is able to overcome the problem of the clinician having to go at the bedside and saying that, oh, now I'm on pressure control ventilation and I'm not able to achieve this tidal volume, but he has to increase the pressure control. So, you can't do this all the time. So it's kind of giving you a feedback, and it is automatically adjusting this based on, a breath to breath. So something like VAPS, PRVC, these are all dual control modes which do the same. but that will come in
Thank you,
advance.
Sheila. I think,
Of course.
thank you, Sheila. Thank you for the wonderful talk. And I would say there are no more questions, but it was a great, it was a great thing hearing you today. And I'm sure the students would have benefited from it. Thank you very much.
Thank you so much. Thank you.
Thank you.
Over to the-
Thank you to the
Over to the
entire
organizers.
team. And thank
Thank
you, Nitin, and your entire team. Goodbye.
Thank you. Thank you so much, sir. Thank you, ma'am. Since we are already running a little delay from our time schedule, so we are skipping the lunch break. We'll continue with the forthcoming sessions. And in continuation to the ICU session, we have the next session. This session will be chaired by Dr. Harish Sachdeva. Sir is professor and consultant at VMMC Medical College and Safdarjung Hospital, New Delhi. And sir's area of special interest are critical care medicine. And over to you, sir, for the proceedings of this session.
Yeah, since as you have already mentioned, we are running late, I hand over the session to the speaker, Dr. Kamalpreet Sondi. She has a long, I should say, an impressive biodata, and the talk that should be giving to you is one of the core topics dealing with the critical care, and that's the surviving sepsis guidelines and its management. Without any further delay, I hand over to you, madam, please. Dr. Kamalpreet, please.
Good afternoon, friends. My topic today is Surviving Sepsis Guidelines 2021. As the anesthesia residents, we ought to have one question at least on the sepsis, and most likely these guidelines being very new, so we might have a theoretical question on the Surviving Sepsis Guidelines. So I'll be just going through briefly covering all the aspects of these guidelines, but certainly before we go through the guidelines, we must know the sepsis definition, how we define sepsis. Actually, over the last 3 decades, numerous terminologies have been used to define sepsis, but what is being accepted as of date is the Sepsis 3 definition, which came up in 2015 and defines sepsis as a life-threatening organ dysfunction caused by the dysregulated host response to infection. Sepsis has been a major health problem with increasing prevalence, high costs, poor outcomes, and said to be amongst the top 5 most expensive conditions being treated in US hospitals, and more than 2/3 of the hospital healthcare expenditure being spent on sepsis itself. Not only the economic thing, what is more important is that in one of the studies published way back in 2008, it was seen that sepsis led to almost 8 times higher mortality as compared to other diagnoses in the hospitalized ICU patients. Talking about the Indian scenario, in this INDICAP study, which was published in 2016, this was the first intensive care case mix and the practice pattern study across Indian ICUs. It showed that around 1/3 of patients admitted had severe sepsis or septic shock, and almost double the ICU mortality, 34% in sepsis patients as compared to 18% in the normal ICU patients. So this was enormous. And the recent INDICAPS 2 study published just a few months back again showed that the sepsis incidence was almost the same, that is around 30% in the Indian ICU. So sepsis is a life-threatening condition which can lead to tissue damage, organ failure, amputations, death. And it's said that almost 1.7 million people in United States in 1 year had sepsis. And it's said to be the 3rd leading cause of death. And actually, what is more alarming is that 87% of sepsis cases, they actually start in the community and they're not actually health care acquired. In sepsis, it's all about time. Why so much of hue and cry? It's because the importance of time is there in sepsis. It has to be treated as a medical emergency as we treat the acute stroke or the acute coronary syndrome. Time is of importance. The risk of death in sepsis patients, it increases by almost 8% for every 1 hour delay in the starting of treatment. And as many as up to 80% of sepsis deaths could be prevented with rapid diagnosis and treatment. So vis-a-vis it has to be treated as a medical emergency, and symptoms have to be quickly recognized and treated accordingly so as to reduce the risk of death. So this is why there was so much of hue and cry about sepsis. This was the reason, because of the enormous mortality and preventable. This is actually preventable once recognized early and treated early. So the Surviving Sepsis Campaign, this is a global initiative. It's a joint collaboration of the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, which is committed to reducing mortality and morbidity from sepsis and septic shock worldwide. And Indian Society of Critical Care Medicine is a global partner of the Surviving Sepsis Campaign. And in the latest guidelines, we had two authors from the Indian ICUs, like Dr. Yatin Mehta was one of the guideline committee members, and which came up with this Surviving Sepsis guidelines published in October 2021. Before we talk about the recent guidelines, we must know this campaign timeline. Actually, this Surviving Sepsis campaign was started way back in 2002 in the Declaration of Barcelona, which was a collaboration between ESICM, SCCM, and the International Sepsis Forum. And thereafter, within 2 years, the first Surviving Sepsis guidelines for sepsis were given in 2004. And subsequently, almost every 4 years in 2008, 2012, and 2016, the guidelines were modified and revised according to the latest available evidence. And the latest ones, they just released in October 2021. And these are only for the adult sepsis patients. Along with these guidelines, the Surviving Sepsis Campaign has also given some bundles. There are sepsis bundles. As we talk about the infection control bundles, they've also given the bundles. Initially, it was a 6-hour and a 24-hour bundle, and subsequently it came to 3 hours and 6 hours. And in 2018, a 1-hour bundle was given for sepsis, which really actually stressed upon, like that was the 1 hour was the golden hour for the sepsis patients. So these bundles are actually not part of the guidelines, but we must know something about the bundles also. So following these guidelines, which are published from time to time, the in-hospital mortality for hospitalizations secondary to sepsis has certainly declined. The latest figure I could not get, but almost from 24% in 2010, the mortality came down to almost 15% in 2015. So let's talk about what the recent guidelines say. What are the recommendations? Actually, these recommendations, we have to know term to term, like what is the terminology and how they have defined it. The types of statements given in these guidelines are the strong, ungraded, which they have termed as the best practice statement. And all or almost all informed persons would choose this intervention. So they have given it as a we recommend. And this circular with a star in between, this is the sign for this. Then we have given a strong graded recommendation, where again, if it is for the intervention, it is in green with 2 exclamatory marks. And if it is against the intervention, it's in red, which says stop, don't use it, with 2 exclamatory marks. And weak graded recommendation, where it's just a suggestion by the authors and it has been given by a single exclamatory mark. And no recommendation, where the level of evidence is not sufficient to recommend for or against the intervention. So 2021 guidelines have been divided into actually 6 topics, wherein the screening and the resuscitation part, which comes as the first to go, then the infection, the hemodynamics, ventilation, additional therapies, and the long-term outcomes. So as anesthesia residents, we must be aware of these 2, 100%, hemodynamics and ventilation. Right? Okay, so we'll talk about all these interventions, like what has been recommended, what has been suggested, one by one. So for the screening of patients with sepsis and septic shock, the recommendation is that for hospitals and health systems, there has to be a performance improvement program for sepsis, including sepsis screening for acutely ill, high-risk patients, and SOPs should be there for treatment. Then in 2016, what came up was Q-SOFA. We'll be talking about what is Q-SOFA, but now over last 5 years, this recommendation has changed. The current recommendation suggests against using Q-SOFA as a single screening tool for sepsis or septic shock. And for adult patients having sepsis, we suggest measuring blood lactate levels. They have a suggestion for measuring the blood lactate levels. So Q-SOFA was widely used over the last 5 years. There were only 3 parameters: the hypertension with a systolic blood pressure of 100 less than 100, altered mental status, and tachypnea, that is a respiratory rate of more than 22 per minute. And any score of more than equal to 2, it suggested that patient might be having sepsis and likely to be benefited by shifting to the ICU, and it was being used widely across the hospital settings. But the current guidelines are strictly they have a suggestion against the use of, they do recommend that we should not use Q-SOFA as a single screening tool. When talking about the initial resuscitation, again, the recommendation is that treatment and resuscitation should begin immediately. This is the best practice statement. And for patients with sepsis-induced hypotension or septic shock, the suggestion is that at least 30 mL per kg of IV crystallized fluid should be given within first 3 hours of resuscitation. For adults with septic or septic shock, the suggestion is using dynamic measures to guide fluid resuscitation. We should use the dynamic parameters rather than the static ones like the CVP, which was being previously used. Now the recommendations are like the dynamic parameters like stroke volume variation, the pulse pressure variation, or even the simplest of all, the passive leg raising test or the echocardiography, bedside echocardiography for guiding the fluid resuscitation. Then another suggestion is guiding resuscitation by looking at the serum lactate levels, like what is the trend in the serum lactate levels. And for guiding resuscitation, another suggestion is using capillary refill time, which was not there in the previous recommendation. Mean arterial pressure for patients with septic shock on vasopressors, the recommendation is target MAP of 65 millimeters mercury, not higher MAP targets. This is basically come up, this recommendation has come up after the sepsis SAM study, which compared the lower blood pressure targets, mean arterial pressure targets, with the higher blood pressure targets, and there was seen that a MAP of 65 millimeter mercury had good outcomes. The suggestion again for patients with sepsis or septic shock, admit the patients to ICU for good outcomes within 6 hours. That is a must, that within 6 hours of sepsis, the patient should be into the ICU so as to be managed ideally. The infection part, this is what actually leads to sepsis. So the first recommendation they have given is for any patient with suspected sepsis or septic shock, but unconfirmed infection, like the infection is not confirmed. So we need to continuously reevaluate and search for alternative diagnosis and discontinuing empirical antimicrobials if any alternative cause of illness is demonstrated or strongly suspected. Like we have in mind that this fever or might be because of some non-infectious cause. So then there is no use of antimicrobials, and rather we should discontinue empirical antibiotics. For patients with possible septic shock or who have high likelihood of sepsis, the recommendation is administering antimicrobials immediately, ideally within 1 hour of recommendation. And for patients with sepsis without shock, who are not in septic shock, they have possible sepsis but not shock, the recommendation is rapid assessment of likelihood of infectious versus non-infectious causes again, and no hurrying for antimicrobials. For adults with a low likelihood of infection and who do not have shock, the suggestion is deferring antimicrobials. This is very important while continuing to closely monitor the patient. And for starting the antimicrobials, the suggestion is against, see this red mark, against using procalcitonin. Procalcitonin as a biomarker should not be used for starting the antimicrobial therapy. For patients who are suspected to be at high risk of MRSA, now the best practice statement says that the recommendation is using empirical antimicrobials with MRSA coverage rather than empirical antibiotics with a broad spectrum coverage. And patients who are not at risk of MRSA, then empirical antibiotics can be continued. Patients who have a high risk of multi-drug resistant organisms, patients who with sepsis or septic shock with high risk from MDR organisms, the suggestion is using two antimicrobials with gram-negative coverage. This is a suggestion, but level of evidence is not very good. But yes, they have suggested that two antimicrobials for GNB coverage should be started in patients at high risk of MDR organisms. And the suggestion is against using double gram-negative coverage once the causative pathogen and the susceptibilities are known. Once we have the culture report, then there is no use of using double gram-negative coverage. For adults with sepsis or septic shock at risk of high risk of fungal infection, suggests starting the empirical antifungal therapy over no antifungal therapy. Although similar is not the case for antivirals. There is no recommendation which has been given for using antiviral agents. But if risk of fungal infection is there, start with empirical antifungal therapy. That is the suggestion. How we give the antimicrobials, that is also important. The suggestion again is for using prolonged infusion of beta-lactams over 3 to 4 hours as per the drug itself. And the recommendation for optimizing dosing strategies of antimicrobials, that is important as per the PKPD principles or the specific drug properties. For patients where there is a specific source of infection, the emergent source control is again recommended. This is the best practice statement that once we have the anatomical diagnosis of infection that requires emergent source control, that has to be carried out as soon as medically and logistically practical. And if at all any intravascular device is responsible for causing sepsis, the recommendation against the best practice statement says prompt removal of intravascular access device. Then the suggestion for daily assessment of de-escalation of antimicrobials as per the clinical condition rather than using fixed duration therapies. And certainly the suggestion is again using shorter duration of antimicrobials rather than longer duration. And for de-escalation, the suggestion for using procalcitonin is there. Not for starting the antimicrobials, but for de-escalation. So this was all about the infection management. Coming down to hemodynamic management. This is one aspect of surviving sepsis guidelines which can be routinely asked in your examination. So for patients with sepsis or septic shock, the recommendation is using crystalloids as first line fluid for resuscitation. Crystalloid fluids, first line fluids. And suggestion for using balanced crystalloids instead of normal saline. The previous 2016 guidelines were using either balanced crystalloids or saline for fluid resuscitation. But the 2021 guidelines say they suggest using balanced crystalloids rather than normal saline. And they also suggest using albumin in large volume resuscitation, but against using starches and gelatins. See this red marks. This is a strong recommendation. This is a suggestion against starches and gelatins. So for as the first line vasopressor, norepinephrine is the drug of choice with a strong recommendation, strong level of evidence. And even the dopamine and vasopressin, they have the high to moderate level of evidence available. But once patient is on norepinephrine with inadequate mean arterial pressures, we are not achieving the target maps of 65 millimeters mercury. the suggestion is adding vasopressin instead of escalating the dose of norepinephrine. And for patients with septic shock and inadequate MAPs despite norepinephrine and vasopressin, you can add epinephrine. And for adult patients with septic shock and cardiac dysfunction with persistent hypoperfusion despite adequate volume resuscitation and arterial blood pressure, suggestion is adding dobutamine or the norepinephrine, that is the inotropes, or using epinephrine alone. Either adding dobutamine to norepinephrine or using epinephrine all alone. But for such patients, the suggestion is against using levosimendan. There is no recommendation. Rather, this is against using levosimendan. And once the patient is on vasopressors, the suggestion for using invasive monitoring of arterial blood pressures over the non-invasive monitoring as soon as practical and if resources are available. But this is a new suggestion that starting vasopressors peripherally rather than delaying. If we do not have an arterial central venous access, do not wait for the central line to be put in. Rather start the vasopressors peripherally, and then logistics have to be sorted out. There's insufficient evidence to make a recommendation on the use of restrictive versus liberal fluid strategies in the first 24 hours of resuscitation. In patients who are initially resuscitated within 3 to 6 hours, but still have hypoperfusion, volume depletion after the initial resuscitation. So the guidelines are not recommending for or against the restrictive vis-a-vis liberal fluid strategies. So summarizing the vasoactive agent management, use norepinephrine as the first line vasopressor, target MAP of 60 millimeters mercury, and for patients with vasopressors, consider invasive monitoring of arterial blood pressure. But if the central access is not yet available, consider initiating vasopressors peripherally. This is a suggestion. And if MAP is inadequate despite low to moderate dose of norepinephrine, consider adding vasopressin. But if the patient has cardiac dysfunction with persistent hypoperfusion, then consider adding dobutamine to norepinephrine or switching over to epinephrine. So this is the crux of vasoactive management for patients with sepsis or septic shock. Coming on to ventilation, another important aspect of sepsis patients which can be asked individually or as a part of the sepsis guidelines as such. But being the anesthesiologist, so ventilation is our bread and butter. So we need to talk about in detail, like how to ventilate and what to do, what not to do. So no conservative oxygen targets have been suggested in these guidelines. They say there is insufficient evidence to make any recommendation on the use of conservative oxygen targets in adults with sepsis-induced hypoxemic respiratory failure. But for such patients, there is a suggestion for use of high flow nasal oxygen rather than non-invasive ventilation, which we have been using as a first line over many years. Now the non-invasive ventilation has been given sidelined actually. So HFNO is the first thing which should be tried for hypoxemic respiratory failure. And these guidelines, they do not recommend anything like non-invasive as compared to the invasive ventilation for sepsis-induced hypoxemic respiratory failure. And once patients with sepsis-induced ARDS are there, again, the lung protective ventilation using a low tidal volume ventilation strategy, 6 mL per kg, and recommendation again for upper limit goal of peak plaques of 30 centimeter water rather than going for higher plaque pressures, and a suggestion for using higher PEEP over lower PEEP. These things will be discussed in detail in the ARDS, but yes, they are a part of the sepsis guidelines 2021, so we should be very much clear about these. Usage of HFNO and recommendation of low tidal volume ventilation, PEEP plaques of 30 centimeter water, and a suggestion of using higher PEEPs as compared to low PEEPs. And for sepsis-induced moderate to severe ARDS, again, suggestion is there for using traditional recruitment maneuvers. But against using incremental PEEP titration strategy. Other recruitment maneuvers can be used, but no, and not to be used as incremental PEEP. We can use decremental PEEP, but no incremental PEEP titration strategy as a recruitment maneuver. They have a strong recommendation for using prone ventilation for greater than 12 hours daily, at least 12 hours, more than 12 hours of prone ventilation for patients in the early stage of moderate to severe ARDS. Once patient is on ventilator, using intermittent neuromuscular blocking agents rather than continuous infusion. Intermittent NMBs are preferred. And when conventional mechanical ventilation fails, and in experienced centers where the infrastructure of ECMO is there, the suggestion for using veno-venous extracorporeal membrane oxygenation in patients with sepsis-induced severe ARDS, this has come as a suggestion. Coming on to additional therapies, there is a suggestion to use IV corticosteroids even in patients with ongoing requirement for vasopressor therapy. The 2016 statement was like there was a suggestion to use IV hydrocortisone to treat septic shock patients if adequate fluid resuscitation and vasopressor therapy are able to restore hemodynamic stability. If at all it has not been achieved, then only you tend to use IV hydrocortisone. But now even with ongoing requirement for vasopressor therapy, the suggestion has been given for using IV corticosteroids. For this polymyxin B hemoperfusion, there's suggestion against the use, not to use the blood purification techniques, which were previously being, although no recommendation was made, but now this is a suggestion against the use of hemoperfusion. Again, a restrictive transfusion strategy is recommended. Suggestion is against using intravenous immunoglobulins as part of sepsis therapy. If there is risk of GI bleeding, stress ulcer prophylaxis is suggested, and recommendation of using thromboprophylaxis. This with especially low molecular weight heparin as a VT prophylaxis. This is recommended. And the suggestion is against using mechanical VT prophylaxis. And once patients of sepsis or septic shock, they land up in AKI, the suggestion is using either continuous or intermittent renal replacement therapy. The glucose levels, they have to be targeted 180 milligram per deciliter. Once the glucose levels go beyond 180 milligram per deciliter, the surviving sepsis guidelines, they recommend initiating insulin therapy. A strict, I'll not say rather strict, but there is a suggestion against using IV vitamin C. There is lots of things being talked about the metabolic resuscitation using vitamin C and thiamine and whatnot. But surviving sepsis guidelines 2021 have made it clear that there's a suggestion against using high doses of vitamin C for septic patients. For adults with septic shock and hypoperfusion-induced lactic acidemia, the suggestion is against using sodium bicarbonate therapy. Again, just to improve the hemodynamics or to reduce the vasopressor requirements, we should not use sodium bicarbonate therapy. But patients with septic shock and severe metabolic acidemia, wherein the pH is less than 7.2, less than equal to 7.2, and AKI, with AKI score of second or third stage AKI, we do suggest using sodium bicarbonate therapy. So pH of less than 7.2 and stage 2 or 3 AKI. So you can use sodium bicarbonate. This is just a suggestion. And for patients who can be fed enterally, so the suggestion is again early initiation within 72 hours of enteral nutrition. Coming over to long-term outcomes and goals of care. For patients with sepsis septic shock, the recommendation says that discussing goals of care and prognosis with patients and families rather than no such discussion. So right at the beginning, once the patient comes to the ICU and you feel that patient is into sepsis or septic shock, the discussion about the goals of care, like what is the likely prognosis, that has to be discussed. And the suggestion is addressing goals of care early, like I talked about, within 72 hours. How much early? Within 72 hours rather than later. Then for patients with sepsis septic shock, again, the recommendation is the principles of palliative care, like based on the clinician judgment, if we are planning for palliative care, that should be integrated into the treatment plan, and so as to address the patient and family symptoms and suffering. So the palliative care has to be part of the sepsis management as such. Then for the goals of care, another recommendation is that the clinical team provide the opportunity to participate in shared decision making in post-ICU and hospital discharge planning, so as to ensure discharge plans are acceptable and feasible. Another thing, that reconciling medications at both ICU and hospital discharge must be done. And for adult survivors of sepsis and septic shock and their families, the recommendation including information about ICU stay, sepsis and related diagnosis, any comorbidity which might have occurred, like patient had AKI or something, the treatments, common impairments after sepsis in the written and verbal hospital discharge summary, that should be done. And patients who develop new impairments, like I was talking about the acute kidney injury, we recommend hospital discharge plans include follow-up with clinicians able to support and manage new and long-term sequelae. Like if the patient has AQI, recently the AKI guidelines have been released by the ISCCM, and they include a AKI follow-up bundle, which should be used, like for at what stage, like what type of AKI patient had, so which clinician to follow, whether an intensivist can be followed up or the follow-up has to be carried up with the nephrologist if there was stage 3 AKI. So accordingly, any new impairment, the recommendation has to be given for follow-up. For adult survivors of sepsis or septic shock, again, the recommendation is assessment and follow-up for physical, cognitive, and emotional problems after hospital discharge. This has been very much emphasized, that patient has to be followed up for especially the cognitive and functional and emotional problems after hospital discharge. And suggestion is for referral to a post-critical illness follow-up program if available, which is like in Indian setup that is not available, but in the Western world it is there. So a follow-up referral to post-critical illness follow-up programs. And patients like who had been receiving mechanical ventilation for more than 48 hours and an ICU stay of more than 72 hours, which is usually the case in almost all septic shock patients, the suggestion is for referral to a post-hospital rehabilitation program. So this was all about the 93 recommendations which have been given by the Surviving Sepsis Guidelines 2021. Sometimes the question might be asked, like, what is new in the 2021 guidelines? Like, what have been changed? What is the difference from the previous guidelines? So this also, I personally believe you should be knowing, because this itself can come as a question for you in the theory exam. So of the total 93 recommendations, several new recommendations have come up and several have been downgraded or upgraded. So I'll be just highlighting, we have talked about each and one separately, but just briefly, like what are the major recommendations which have changed from the 2016 guidelines. We recommend against using QSOFA compared with SIRS, MUSE or NEWS as a single screening tool for sepsis or septic shock. This was, I told you that QSOFA was not used in 2016 guidelines, but this was a maneuver wherein it can be used to identify sepsis. And this has come up as a strong recommendation in 2021 guidelines. And this is certainly a new recommendation against using QSOFA, not to use QSOFA as a single screening tool. For patients with sepsis-induced hypoperfusion or septic shock, it's a suggestion that at least 30 mils per kg of IV crystalloid fluid should be given within first 3 hours of resuscitation. So this recommendation has been actually downgraded. It was initially in 2016 guidelines, it was a strong recommendation. And they recommended that initial resuscitation should be carried out within first 3 hours with 30 mils per kg of IV crystalloid. But now they say that it is just a suggestion. So downgraded from strong to a weak recommendation. Then initiation of antimicrobials. This must be known. There is something different here because the 2016 guidelines, they were strongly in favor of administering antimicrobials immediately within 1 hour of recognition, right? But here they have divided the patients into two. Sepsis is definite or probable, or sepsis is possible, and if whether shock is present or shock is absent. So for adults with possible septic shock or a high likelihood of sepsis, but there is a high likelihood, the recommendation is whether or not the shock is there. Once we have a high likelihood of sepsis, administer antimicrobials immediately, ideally within 1 hour of recognition. But if for possible sepsis, like sepsis is possible and shock is there, again, we have to administer antimicrobials within 1 hour of recognition. But if there is no shock, like shock is absent, we are not sure that sepsis is there, it is possible, but there is no shock. So we can have a rapid assessment of infectious versus non-infectious causes of acute illness. And if still the concern for infection persists, administer antimicrobials within 3 hours. So this is another thing which has changed. And again, this is a new recommendation that there is insufficient evidence to make a recommendation regarding use of restrictive versus liberal fluid strategies in first 24 hours of resuscitation. Since we are talking a lot about the de-resuscitation programs these days, like more than resuscitation, we are talking, there are webinars and seminars going about the de-resuscitation protocols. But the Surviving Sepsis 2021 guidelines have not given any recommendation, and they say that there is insufficient evidence to make a recommendation whether to use restrictive or liberal fluid strategies. For patients with sepsis-induced hypoxemic respiratory failure, again, a new recommendation is like this is a suggestion for the use of HFNO over non-invasive ventilation. So this is a weak recommendation, low quality of evidence. For adults with sepsis or septic shock, suggestion against using IV vitamin C. Again, this is a new recommendation. We should not use IV vitamin C. For another is like we suggest offering written and verbal sepsis education, diagnosis, treatment, post-ICU, post-sepsis syndrome prior to hospital discharge in the follow-up setting. Like in the discharge summary itself, the whole thing has to be put down. So this is again a new recommendation which talks about the goals of care and the long-term outcomes. Other major changes are that blood lactate measurements are now considered a weak recommendation, although initially it was suggested as a strong recommendation. Use of capillary refill time has also been added as a weak recommendation for assessing the resuscitation or the perfusion. A new recommendation for adults with low likelihood of infection and without shock, now defer antimicrobials and continue to monitor the patient closely. High likelihood of harboring MRSA, appropriate antibiotics targeting the MRSA should be given rather than previous recommendation to give broad spectrum antibiotics. And then antifungal agents, again, if the suspected infection with fungal pathogens, then empirical antifungal coverage should be given rather than previous recommendation of to cover the all possible pathogens. Balanced crystalloids rather than normal saline are now recommended for, like they have a suggestion for using balanced crystalloids rather than normal saline. And recommended to start vasopressors peripherally rather than waiting for a central line to be placed. And for patients with sepsis-induced severe ARDS, another suggestion is using VV ECMO when conventional mechanical ventilation fails in centers with experience and infrastructure in place to support its use. And for patients with septic shock, ongoing requirement for vasopressor therapy, the suggestion is using IV corticosteroids. So if at all you have a question based on what are the major changes, you can enumerate all of these. I hope that these will be helpful to you, because we ought to know what has changed over time. Over the last 5 years, what has changed. So this is very much important, because it's more important to bring into practice the changes. So I again emphasize that what has changed from the previous guidelines, because once we are working and treating the septic patients, what practices we bring into like our culture, it's very difficult to change. So we must know what have changed, because the literature doesn't support the previous things. What other interventions were being carried on? The literature says that no, this intervention is not beneficial, right? So we need to change ourselves. So this is what has changed. So to conclude, the guidelines emphasize the importance of rapidity and appropriateness of the recognition and care of patients suspected to have sepsis. They're certainly an important guidepost for the busy bedside clinician in providing optimal care and incorporate the best contemporaneous evidence. But no set of rigid guidelines can actually replace clinical judgment by the bedside clinician in the face of complex clinical scenario, as is the sepsis. And the surviving sepsis guidelines, they strongly emphasize this important caveat. They say that clinical situations are unique and flexible approach may often involve deviation from the general recommendations. So we as bedside clinicians have to treat our patient individually. We cannot make the generalized statement. But yes, they can be helpful in our day-to-day clinical management. Thank you. I hope these recommendations, whatsoever we have discussed broadly, might help you cover this important aspect of surviving sepsis guidelines. Thank you.
Thank you, Dr. Kamalpreet. It was a very well conducted lecture, must I say. And I think the students must have benefited immensely. First, that you have delivered what sepsis has all been about for the last many years, and what the recommendations have made changes in the latest one in the last year's guidelines, because there were many, if I may say, the right word may not be loopholes, but it was open to interpretation. For example, in the ICU, what the intent, there used to be a difference opinion in the terms of treatment of whether intermittent or a continuous dialysis or a balanced salt solution or a normal saline. All these things have come in. There are some areas which would still be need to be addressed as newer guidelines come. But I think the session which has been targeted to the postgraduate students, I think it would do them immense benefit. They would have learned a lot of it. I think you've done full justice to the topic. If there are any questions, I think they could be taken.
No, sir, there are no questions.
I thank the speaker once again. Very well done. Very well done.
Thank you, sir, and for all the good words. Thank you. And thank you for making me a part of the BSMG. Thank you.
Thank you, sir. Thank you, ma'am. So we'll quickly move on to our next session. The next session is a short case on tracheostomy. And the examiner for this short case is Dr. Parul Malik. Ma'am is professor in the Department of Anesthesia at VMMC and Safdarjung Hospital, New Delhi. Ma'am's area of special interest is obstetric anesthesia. And she has been actively involved in teaching and training programs, especially ACLS, ATLS, and NELS, and has several publications to her credit in both national and international books. And the case will be presented by Dr. Nofia. She's a third-year postgraduate student at RML Hospital. And the moderator will be Dr. Ushkaran, who's a senior resident in RML Hospital. Over to you, ma'am.
Very good afternoon. And I thank the organizers for giving me the opportunity to participate in this session. I would like Dr. Nofia to start her presentation of case.
China? Okay. Good afternoon, everyone. Good afternoon, everyone. I'm going to present a case on Abdul, 70-year-old male, who is a resident of Karol Bagh, Delhi, a fruit seller by occupation, and the informant is his wife. His presenting complaints were headache, weakness right side of the body, and decreased level of consciousness 10 days back. He was apparently well 10 days back when he developed severe headache, sudden in onset, associated with projectile vomiting. This was followed by weakness in right side of the body and decrease in level of consciousness. For these complaints, he was brought to emergency within 5 hours of first symptom onset. And there he got diagnosed to have intracranial bleed, and he underwent emergency decompression craniectomy on the same day and was shifted to neuro ICU for further management. There, on day 7, a tracheostomy was done. He had no history of fever, trauma, seizures, blurring of vision, slurring of speech, no history of chest pain, breathlessness, similar history in the past. He is a non-case of hypertension for the past 30 years and was on irregular medication. No history of similar illness in the past. No history of diabetes, heart disease, TB, or any other medical illness, and no surgical history or hospitalization history in the past. Treatment history: he is now tracheostomized and on ventilatory support and receiving IV antibiotics, anticonvulsants, antihypertensives, analgesics, and other supportive medications. He is not on any inotropic support. Personal and diet history: he belongs to low socioeconomic status and he is a non-smoker and non-alcoholic and currently receiving enteral nutrition through Ryle's tube. He is moderately built and ill-nourished. No pallor or icterus or cyanosis or clubbing or lymphadenopathy or pedal edema or raised JVP, and was febrile to touch. Pulse rate was 96 per minute, regular in rhythm and normal volume, and SpO2 was 99%. BP was 130 by 80 millimeters of mercury, and respiration, he was tracheostomized and on ventilator support on SIMV mode of tidal volume of 420 ml and respiratory rate of 8, pressure support of 14 centimeters of water and PEEP 5 with FiO2 50%. CNS examination: his GCS was E2 VTM3. Pupils were central, mid-dilated, and equal in size and reacting to light bilaterally. Other cranial nerves could not be assessed. Motor examination showed tone increased on right side, bulk equal bilaterally. Power could not be assessed and no involuntary movements present. Sensory system showed flexor response and facial grimacing to pain. Reflexes showed brisk reflexes bilaterally, extensor plantar response on the right side and flexor response on the left side. Respiratory system: trachea central, chest normal in shape, bilaterally moving symmetrically with respiration, and no use of any accessory muscles of respiration. Patient is on ventilator support with tracheostomy tube in situ. Air entry is equal bilaterally. Vesicular breath sounds present and no added sounds. Cardiovascular system showed heart rate 96 per minute regular, S1, S2 normal, and no murmurs or adventitious sounds heard. Apex beat on left, fifth intercostal space and mid-clavicular line. Abdomen examination showed scaphoid shape, soft, no tenderness, no organomegaly, normal hernial signs, normal bowel sounds present, Ryle's tube and urinary catheter in situ. Local examination: patient is in propped up position with tracheostomy tube in situ and on ventilator support. A single human tracheostomy tube of size 8.5 millimeter internal diameter, cuffed Portex tube is present. Tracheostomy tube is patent, cuff is adequately inflated with an inflation pressure of 20 centimeters of water. Surrounding skin is healthy, no subcutaneous or laryngeal crepitus, no tracheostomy stoma site redness or bleeding or purulent discharge present. Provisional diagnosis is hypertensive patient with hemorrhagic stroke with right-sided hemiplegia, post-surgical intervention day 10 with tracheostomy tube in situ.
Okay, so Dr. Nufia, can you please tell us what is tracheostomy and tracheotomy? Hello, can you hear me? Hello?
Ma'am, I can't hear you.
Audible, ma'am?
Hello?
Yes, ma'am.
Am I audible?
Yes, ma'am.
So Nufia is saying she cannot hear me. Just check her system. Yes, Nufia, can you hear me? Hello?
Now, if you can check your speakers.
Am I audible? First, I would like to check mine. Am I audible?
Yes, ma'am. Yes, ma'am. You are audible,
Okay,
ma'am.
then I think Nufia needs to be like, she's not able to hear me.
Just tell her that you're.
Hello, ma'am.
Ma'am, you're not audible.
Hello, sir. I'm audible to you.
Yeah.
Sir?
Yes. It's fine now. It's fine.
Yeah. Okay, sir.
And we can continue. Sorry.
Yeah, Nufia, can you hear me?
Yes, ma'am. Yes, ma'am. I can.
Okay, now tell me, please tell me what is tracheostomy and tracheotomy.
Ma'am, tracheostomy is creating an opening on the anterior wall of trachea and then converting it into a stoma on the skin surface. Whereas tracheotomy is creating an opening on the tracheal wall, which is a step in tracheostomy. Sometimes both words are being used interchangeably, ma'am.
Okay, so what are the indications of tracheostomy?
Indications can be when there is a need for prolonged mechanical ventilation, like in severe COPD, or when there is an obstruction on the upper airway, as in case of infections like epiglottitis, or tumors of the upper airway, or trauma to upper airway, laryngeal trauma, tracheal trauma, or if there is an airway edema, as in case of anaphylaxis, or if there is bilateral vocal cord paralysis, or when there is a requirement for pulmonary toileting, as in case of bulbar palsy, or it can be done in association with other head and neck surgeries like CA larynx surgeries. And
okay, so what was the indication in your case for tracheostomy?
Ma'am, this patient had decreased level of consciousness, and there was an indication for prolonged mechanical ventilation, ma'am.
Okay, so all right. So tracheostomy was done on day 7. So is it early or late tracheostomy?
Since it was done before, on or before day 7, it was considered as an earlier tracheostomy.
So what is the advantage of early as compared to late tracheostomy?
Early tracheostomy, it can decrease the ICU stay for better patient care. Like if we have anticipated for a longer ventilatory support, if an early tracheostomy is done, this can decrease the patient's ICU stay and can help in patients weaning off from ventilator early.
See, basically, as per the Indian Society of Critical Care Medicine Guidelines 2020, early tracheostomy may basically reduce the duration of mechanical ventilation and the length of ICU stay. However, there is no difference in short-term and long-term mortality and the incidence of ventilator-associated pneumonia. Okay. So, all right. So, what are the advantages of tracheostomy over endotracheal intubation?
Ma'am, in tracheostomy, it increases the patient's comfort. It decreases the requirement of sedation and analgesia for the patient, and it decreases the tubal airway resistance, and decreases the increases the airway resistance and decreases the work of breathing for the patient, and it improves the patient's appearance, patient's airway hygiene, facial, nasal, and oral hygiene, and improves the patient's oral intake, and improves patient's oral communication, and also it decreases it helps in better weaning of the patient from ventilator and better mobilization of the patient also.
Okay, so what are the contraindications of tracheostomy?
Contraindications of tracheostomy. In case of contraindications of, if there is a unstable cervical spine, like relative contraindications will be, ma'am, unstable cervical spine fracture, or a patient with difficult or distorted neck anatomy, or a patient who are obese, where the anatomy is difficult, surface landmarks are difficult to identify, or the patient who requires a higher ventilatory support with higher PEEP requirement.
Okay, so these are basically the relative contraindications for tracheostomy. So there are no absolute contraindications to tracheostomy except for refusal of consent and infection at site of tracheostomy. All the contraindications are relative contraindications. Okay, so what are the types of tracheostomy?
It can be an elective procedure or a emergency procedure, or it can be a temporary or a permanent procedure, or based upon the level of tracheostomy, it can be high, mid or low tracheostomy, or it can, based on the procedure, it can be a open surgical tracheostomy, or a percutaneous tracheostomy, or a mini tracheostomy.
So what is high, mid and low tracheostomy?
If the tracheostomy is done at the level above the level of thyroid isthmus at first or second tracheal ring, it is called as high tracheostomy. But it has a risk of cricoid, cartilage, perichondritis, and subglottic stenosis. Mid tracheostomy, which is commonly done, it is at the level of thyroid isthmus at second and third tracheal rings. And low tracheostomy, which is done below the level of thyroid isthmus, but it has a risk of tube kinking at the suprasternal nodes and also increased risk of injuring to the vessels.
So what type of tracheostomy was done in this case?
In this patient, ma'am, an elective surgical tracheostomy at mid-level.
So what specific lab investigation would you want to see before this procedure?
Ma'am, complete blood count with platelet count and coagulation profile, including BT, CT, PT-INR and APTT will be asked for the patient.
Yeah, because these patients, it is very important to know about the coagulation status, because these procedures, they carry a bleeding risk. Rest investigations may be done depending whatever their patient specific can be done. Then, all right. So now suppose this patient is shifted to the operating room for elective surgical tracheostomy. So what will be your anesthesia plan and how will you proceed?
I'll do this procedure with general anesthesia and with muscle relaxation and a local anesthetic with vasoconstrictor application on the local site, ma'am. And then I have to assess about the patient's NPO status and written informed consent I have to assess. And then I have to reconfirm patient's current hemodynamic status, ventilatory status, and a tracheostomy tube condition. And before receiving
patient is not tracheostomized, better. Patient is posted for tracheostomy.
Endotracheal tube condition.
Yeah.
Then patient, before receiving the patient, I have to prepare the OT with adequate suction apparatus, adequate oxygen supply with ventilator, airway equipments with difficult airway card, fiber optic bronchoscope, then anesthetic and emergency drugs preparation, and I have to have a rescue airway approach in case if the patient's procedure gets into a failure. And then on receiving the patient, I have to connect the patient to a 100% FiO2 and I have to give adequate analgesia, sedation, and muscle relaxation. And then I have to adjust the ventilator support accordingly. And then position the patient in supine with neck hyperextended by keeping a bolster horizontally between the shoulders and the head in neutral position. Then once the surgeon starts the procedure, under direct vision, I have to withdraw the tube after cuff deflation to a level so that the cuff lies just below the vocal cord and reinflate the cuff and have to fix the tube there. And once the surgeon puts the tracheostomy tube inside and the cuff is inflated, I have to remove the breathing circuit from the ET tube and connect to the tracheostomy tube. And then I have to see whether the patient is getting adequately ventilated with a bilateral air entry auscultation and by waveform capnography. If the tracheostomy tube is adequately fixed, if the patient is adequately getting ventilated and the wound care is given, then I can remove the ET tube, ma'am.
Okay. All right. So over here, I like to add that there is another technique. Like instead of withdrawing the tracheal tube, okay, you can push it even further down the trachea just before the surgeon incises the trachea, so that the cuff is coming distal to the tracheostomy site. And by doing so, the patient can be ventilated while the surgeon is creating the stoma. And it is very useful in unstable patients with high PEEP requirements. So, and when the stoma is made, then the tracheal tube can be withdrawn proximal to the tracheostomy site. All right. Okay. So, all right. So now, just tell me, what are the complications that may occur?
Early complication can.
Or tracheostomy.
During the procedure, there can be a risk of hemorrhage, failure of the procedure or false track formation, or accidental extubation of endotracheal tube, or loss of airway with apnea and cardiac arrest of the patient, and also injury to the recurrent laryngeal nerve, posterior tracheal wall, esophagus, and pneumothorax can happen during the procedure. And intermediate complication can be dislodgement of the tube blockage, tracheal cartilage injury, and their perichondritis, and surgical emphysema. And late complications can be tracheal stenosis, subglottic stenosis, tracheoesophageal fistula, tracheocutaneous fistula, tracheoarterial fistula, difficulty in decannulation, disfiguring scar, granuloma formation.
Okay, so what is percutaneous dilatational tracheostomy?
It is commonly done on bedside procedure where the placement of a tracheostomy tube on the anterior wall of trachea is achieved by dilatation, blunt dissection of the pretracheal tissue, and then dilatation of the anterior tracheal wall through Seldinger technique.
Okay, so it is performed with the help of Seldinger technique, right? Okay, so what are the advantages of percutaneous dilatational tracheostomy over surgical tracheostomy?
For percutaneous dilatation tracheostomy, we don't have to shift the patient to OT, and it can be done in bedside itself, and it is less costly, and the learning curve is less, and there is less tissue handling. So there is less risk of bleeding, infection, and better wound healing is there, and the scar is also better, cosmos is also there.
Okay, so what are the conditions when you would prefer to do surgical tracheostomy over percutaneous tracheostomy?
Ma'am, in case of an emergency or in case of a non or anticipated difficult airway, if the patient is having a bleeding, like uncontrolled coagulopathy, or if the patient is having a higher ventilatory requirement, and if the patient is having an unstable cervical spine fracture, or an obese patient, in all these cases we may.
Or even if there are some, aberrant blood vessels on the at the site in front of the neck, then also you will want to go for a surgical rather than percutaneous technique. So what are the various types of percutaneous dilatational tracheostomy techniques?
There's a Seaglia's serial dilatation technique, then Blue Rhino single dilatation technique, Griggs guide wire dilating forceps technique, Percute twist technique, then Blue Dolphin balloon dilatation technique, then Fantoni's translaryngeal technique.
Okay, so basically the single dilator technique, using the single taper dilator technique may be used by the less experienced operators, because all these techniques, they don't differ in the incidence of complication rates, but it has been seen that the single dilator technique may be more easily performed. Okay. So, okay, so can you explain the procedure of percutaneous tracheostomy?
First, ma'am, written informed consent has to be obtained. Then NPO status of the patient has to be ascertained, and patient's coagulation profile has to be checked for. And after that, I have to gather all the equipments required for the procedure, including PCT test set and emergency airway equipments, including fiber optic bronchoscope, local anesthetic containing vasoconstrictor for local application and sterile drapings. And I have to do an ultrasonographic examination of the neck to find whether there is any vascular structures coming near the surgical site. Then I have to give adequate analgesia, sedation, and muscle relaxation for the patient, and position the patient. Then I have to set the FiO2 to 100%, and adequate ventilatory setting has to be given. Then position the patient with neck hyperextended and head in neutral position. After doing sterile draping, and then have to do the surface marking, and I have to prepare my PCT set also. Then with the help of an assistant, I have to insert the fiber optic bronchoscope through the ET tube, and have to examine the airway first, and then I have to withdraw the ET tube so that the cuff will come just below the vocal cord and fix it there, and the fiber optic bronchoscope to come just below the tip of endotracheal tube. Then with the help of then I have to infiltrate the local site and give a 2 to 3 centimeter long vertical incision over the on the skin overlying the I can feel the tracheal rings. Then at the level of second and third tracheal ring, I have to insert a needle, 14 gauge needle cannula assembly with a saline filled syringe with the bevel facing caudally and in perpendicular to the surface. And once that air aspiration is felt and a pop is felt, and I could see through the fiber optic bronchoscope that the needle is inside, I have to remove the syringe and needle, and through that cannula, I have to insert guide wire under vision, and then remove the cannula, and a guide wire, a pre-tracheal dilator can be used to dilate the anterior tracheal wall. After that, a guide wire sheath is introduced, and over which that taper dilator is introduced, and it is fixed with the guide wire sheath. And then with a twisting motion, I have to introduce the taper dilator, partially insert, then reinsert, and then remove, and partially again reinsert, so that a stoma is formed. Once the stoma is formed, and this taper dilator has to be removed, and then tracheostomy tube introducer loaded with the tracheostomy tube is inserted, and it has to be fixed to the fixed in position with the help of a neck flange, and then remove the tube introducer and guide wire with the guide wire sheath, and then suction the airway and cuff inflate the cuff and fix the tracheostomy tube in place with the help of a tube holder. And then the breathing circuit has to be disconnected from the ET tube and connect with the tracheostomy tube, and check for ventilation with the help of auscultation for bilateral air entry and waveform capnography. Once the ventilation for the patient is adequate and the tube is adequately placed, then I can remove my ET tube and give the patient post-op analgesia.
Okay, so what procedural modifications should be done in tracheostomy of a COVID positive patient?
Ma'am, in COVID positive patient, there should be, the procedure should be done by experienced group of doctors to avoid the number of manpower required for the procedure, and whoever performing the procedure have to wear the full PPE, and there should be periods of apnea when the breathing circuit will be open, and it is advised to give neuromuscular blockage during the procedure to avoid cuff reflex and all, ma'am. And we have to maintain an inline suctioning during for suctioning the airway. And to avoid and in post-op care also, ma'am, for humidification and all, humidification for the airway, it is better to avoid nebulization with like humidified oxygenation to avoid aerosol formation. And for decannulation procedure and all, it is better to defer the procedure till the patient turns negative, ma'am.
See, basically, when you are going to do tracheostomy for a COVID positive patient, first of all, you must see that you are doing it in a negative pressure room, or if that is not available, then there is a portable HEPA system in place. Okay. Then it's always wise to do a pre-procedural apnea test, okay, to assess if the person has physiological stability before doing tracheostomy. Okay. And like whatever you have said, the general statements, like you'll minimize the number of personnel, use of neuromuscular blockade, then always cuffed and non-fenestrated tracheal tubes are used. Then wound suctioning and use of electrocautery have to be avoided. Patient's cuff or tube's cuff has to be inflated all the time. Circuit disconnections have to be avoided. Closed suction method has to be used. Okay. HME filters with viral filters have to be used. Okay. And tube changes and decannulation plan, it can be delayed till the patient turns COVID negative. Now, we haven't spoken about the choice of technique. Now, in a COVID patient, what would you prefer? Surgical technique or open surgical technique, or would you like to go in for a percutaneous dilatational method? What would be the choice of technique?
Ma'am's percutaneous technique, ma'am. Less tissue handling and less airway.
See, basically what it is that when it comes to the choice of technique, it will depend on the local expertise, on the resource available. It will also depend on certain patient conditions that may favor a particular approach. And in general, open surgical procedures, they might be preferred over percutaneous, though percutaneous procedures are not contraindicated, okay? Because with open surgical methods, they are performed under direct vision and they are less aerosol generating. While percutaneous methods, there is a lot of airway manipulation and aerosol generation, and risk for, accidental extubation is also high. Plus, besides, whatever technique you choose, if you are using a percutaneous method, then you can, modification has been suggested in which aerosol generation will be less. So what it has been suggested is this, I think is in the latest 2020 anesthesia journal, that you can pack the hypopharynx and do continuous suction from the mouth, and better to use ultrasound guidance for puncture and paratracheal tube bronchoscopy to reduce aerosolization. And if in case a fiber optic is being used, a single-use bronchoscope should be. And you instead of withdrawing the tube, as I had told you earlier, you can advance the tracheal tube distal to the operative site and before the trachea is opened, and hyperinflate the tracheal cuff. Okay, and intermittently you can keep covering the operating site with gauze swabs whenever ventilation recommences. All right. Okay, so what are the options of one lung lung isolation in a tracheostomized patient? Okay, how will you do one lung isolation?
Ma'am, through the tracheostomy tube stoma, we may introduce a DLT tubes also, or we can use bronchial blockers through tracheostomy tube. Or we may use orotracheal intubation with DLT tubes, ma'am.
See, basically one point is there that you can take an oral access with a standard double lumen tube, Because if you put the standard double lumen tube into the tracheostomy stoma, because the length is small, it will get misplaced and malpositioned. So other options are that you insert a single lumen tube and by the side of it, you insert a bronchial blocker, or you can have a disposable cuff tracheostomy cannula with an independent bronchial blocker. Or, you also have specially designed short double lumen tubes. That is the Naruke double lumen tube, which is made specially for use for tracheostomized patients. Okay, so you can use the Naruke's double lumen tube, or else you can place a smaller size double lumen tube through the stoma. Okay, so what are the types of tracheostomy tubes?
It can be cuffed tubes or uncuffed tubes, and it can be fenestrated tubes, non-fenestrated tubes, or based upon the material, it can be metallic PVC tubes, silicone tubes, silastic tube, siliconized PVC tubes, or based upon special added advantages like tubes with armor tubes, tubes with speaking valves, with adjustable flanges, and tubes with subglottic suction area.
You didn't talk about single lumen and double lumen tubes. Okay, it can be a single lumen or double lumen tube also. Then depending on cuff design also, you can have high volume, low pressure cuffs. You can have low volume, high pressure, that is tight to fit, tight to shaft cuffs, or you can have foam filled cuffs. Now, there is this thing that you should know, that those tracheostomy tubes which have this subglottic suction tubes, ideally these are the tubes that should be used, because they have the advantage that they reduce the incidence of ventilator associated pneumonia, plus they allow the above cuff vocalization, and without the need to change to a uncuffed tube. Okay, so how do you do above cuff vocalization with these tubes is that the port through which you do the subglottic suction, you can attach oxygen over there. So there is a retrograde flow of oxygen which over the cuff, which moves out through the cords and helps in vocalization. Okay. All right. So okay, so what is Nufia, please can you tell us what is the tracheostomy care bundle?
Ma'am, we have to watch for like complication. We have to closely monitor the patient for post-tracheostomy complications. Then adequate suctioning of the tube in case of any audible trails or visible secretions on the tube, and humidification of the stoma to be done to avoid crusting. Then we have to do proper wound care, antisepsis of the wound and surrounding skin, then periodic cuff deflation, and to keep the cuff pressure below 25 centimeters of water.
See, when you are, this is a very important question. You can even get it as a question, as a written question in your exam besides being asked. So you should answer it well. Now, when you get to talk about a tracheostomy care bundle, then remember that there is this mnemonic track COMS, TRACHECOMS, track COMS. And with this, you will not miss out a point. Like first is T is tube care. So you check that your tube is secure, the inner cannula is cleaned 8-hourly, then the cuff pressure is checked, subglottic secretions are aspirated 8-hourly. Then R is research, that is you review for the red flag, that is inability to pass catheter, red flag signs, blood stain secretions, patient is getting anxious, using accessory muscles. So then A is your airway, you keep the airway clean, you do suction, which is done need based. Then taking care of the tracheostomy stoma, keep the skin dry, healthy. Okay, clean it with saline and gauze. Place pre-cut, keyhole dressings. Because if you cut on your own, what happens is that there is these threads from the gauze. They enter the stoma site and they cause a lot of irritation and granulation formation. So these should not be done, and contaminated ties should be changed. Then H stands for humidification. Now humidification there is this humidification ladder, which may be stepped up or it may be stepped down as required by the patient, starting from Buchanan bibs to HMEs to cold humidification to saline nebulization to heated humidification. All right. Then E will come for environment. That is, you should have bedhead signs in which there are algorithms, safety algorithms. Then the equipment has to be checked, per shift, that, besides the other equipment, spare inner cannulas are there, smaller size and the same size tracheostomy tube and tracheostomy tube introducers are present at bedside. Then CO is communication. Now you have to remember that these patients, they cannot speak. So they must have this presence of a paper and pen. Then there are certain charts and pictures, you can show to the patient and help in communication aids. Then M is mouth care. So you have to brush the teeth, chlorhexidine mouthwash, and clean the oral secretions. S is swallowing and nutrition. So all these things have to be taken care of. So if you go by the mnemonic, it's likely that you're not going to forget any point or miss out on anything. Okay. All right. So when would you consider decannulation?
Ma'am, once the patients require, the reason for patient's tracheostomy has been resolved, or the patient can tolerate without a ventilator support, and patient can have adequate respiratory reserve. Patient requirement for FiO2 has been decreased reasonably. He can manage, he can maintain a patent airway, have an adequate cough reflex, can swallow effectively. And the new chest X-ray is showing no new infiltrates. In these cases, we can consider decannulation.
Okay, see, basically, you have to see that a patient is able, the amount of secretions coming are less, patient is able to generate a very good cough, okay? Protective laryngeal reflexes are there. And then there is no further intervention in the form of a head and neck surgery that is required. Suppose a person requires a head and neck surgery. So you're not going to, decannulate, you will wait, okay? Then if the upper airway is not obstructed and there is a normal fiber optic examination of the upper airway, it's a good thing. Patient is stable hemodynamically, there's no active infection. Yes, you can decannulate. And for decannulation also, one is you can just immediately decannulate, and then you can put a, you can just put a dressing and put tape over there, and then besides that, you can even sometimes you can go size down the tracheostomy tube. You can put a smaller size tracheostomy tube, okay, and after downsizing you can cap it and see can tolerate for 24 hours. You can decannulate. Okay, so what, suppose there is this tracheostomy tube gets blocked. So how will you manage a blocked tracheostomy tube?
First, I have to listen and feel the tracheostomy stoma site and mouth, whether the patient is breathing or not. And an ETCO2 waveform will help me in identifying whether the patient is having a patent tracheostomy, patent airway. Then I have to increase the FiO2 and high flow. And then if a suction tube can be passed, and if there is any speaking valve or inner cannula is there, I have to change it. And then suction tube to be passed through the tracheostomy tube to and do the suctioning. If it is not still the patient is not getting ventilated, then I have to deflate the cuff and see whether the patient is getting ventilated. And still it is not being able to get ventilated, then I have to start resuscitating the patient and remove the tracheostomy tube and do primary emergency oxygenation through oral airway. And it is better to go for an oral endotracheal intubation.
See, Nufia, when you have this problem that the tube has got blocked, okay, and patient is having respiratory distress. So first, quickly what you do is disconnect the ventilator, remove the circuit, quickly remove whatever is there, HME, filter, if there's a speaking valve, if there's an inner cannula, you just remove all that. Put oxygen on the stoma, put oxygen on the face, pass a suction catheter. If you can suction good enough, it might be a partial obstruction. And if you can't, then you need to again deflate the cuff. But always remember that never ventilate against resistance, because it could be a pneumothorax and you must check the patient for that. Then in case even this doesn't work, then you might have to take out the tracheostomy tube. Now, once you have had to take out the tracheostomy tube, or if the tracheostomy tube has got accidentally decannulated, in that case, you have, what you can do is, again, you can put oxygen on the stoma and the mouth. And now, if the patient is not maintaining, with your hand, you can just put a gauze. With your hand, you can close the stoma and use the upper airway to put LMA, endotracheal intubation, do bag mask ventilation. You can do those procedures. Otherwise, through the stoma, you can put an LMA around it with the cuff around it and ventilate from there, or put a small pediatric mask and ventilate, or you can even put a small tracheostomy tube or an endotracheal tube through the stoma. Okay. So now just tell me, if there is bleeding, then how will you manage bleeding from a tracheostomy side?
Mostly the bleeding will be a minor one, and it will get cleared by applying pressure or by placing gauze piece like soaked with adrenaline, or other sometimes if it is a major one, then by deflating the inflating the cuff itself, it can do a pressure tamponade effect. And sometimes surgical exploration may be required if the patient go for hemodynamic intolerance.
See, that's very right. So you can hyperinflate the cuff. You can put digital pressure on the bleeding, and you may need surgical exploration. But besides that, you must sit the patient up, give oxygen, take IV access. If there are any clotting abnormalities, you need to reverse those, right? And okay, and if there is a sentinel bleeding, you should know that it can be this bleeding, it can be a dangerous bleeding. I mean, there might just be a spurt and it stops, and later on you might be in for a big trouble. So you need to investigate as to what the cause is and involve the surgeons, and it may require surgical exploration. So now, besides all this, just one last question that I would like to ask you is, how is it different from pediatric tracheostomy? How is pediatric tracheostomy different?
Pediatric tracheostomy is challenging since the pediatric tracheal cartilages and laryngeal cartilages are soft, and tracheal lumen is narrow, and there is a higher risk of false tract formation, and difficulty in recannulation will be there, and difficulty in weaning off also, and there is increased risk of tracheal stenosis and subglottic stenosis also there, and the tracheal tube material should be of less tissue reactivity, and its length has to be of adequate size.
Yes, that's right. Okay, so one has to be very careful with small babies, because what happens is when you extend the neck also, the structures from the chest, they are pulled up into the neck. So there are high chances of injury to pleura and inanimate vessels. Okay. All right. So now, besides these questions, I think you should also know about what are the front of neck access and other front of neck access methods which can come for your exam. And what is mini tracheostomy? Can you tell us mini tracheostomy, Nufia?
Ma'am, mini tracheostomy is insertion of a small bore cannula through the cricothyroid membrane, and it is mainly used for pulmonary secretion clearance, ma'am.
Okay, fine. So now I think with this, we have covered most of the questions that may possibly be asked from you in your exam. And this tracheostomy, it may come as a short case in your exam. It may be asked in your equipment viva, or it may be a part of a difficult airway case. So please prepare these questions well, and wish you all best of luck for your exams. So let us see if there are any questions. I'm free to answer.
There is one question, ma'am.
Hanji?
While performing skin.
Sorry?
So wait a sec, ma'am. While performing skin incision, cuff can be ruptured. So whether advancing the ET tube inside is recommended or not. I think you have already answered that.
It is recommended because you have to push the tracheostomy tube with the cuff down below the site of incision. So the tube may go even endobronchial. So let it, no matter. Okay. But you just push it below. Anything else?
No, ma'am. No more questions.
Okay. Fine. I think then this should be all.
Thank you, ma'am. Thank you so much.
Okay.
For this wonderful discussion. I'm sure it will immensely help our postgraduate students.
Okay. Thank you.
Thank you so much.
Thank you.
So before we move on to the next session, we quickly have some announcements to make. Yesterday, there was a quiz in the end where 10 MCQs were asked to the postgraduate student, and the winner of yesterday's quiz is Dr. Komal Dhingra. She's a postgraduate student from PGI Rohtak. Congratulations to Komal Dhingra. And the quiz that was there in the morning, can we have the questions, please? Quiz 1. Yeah. Okay, so we'll answer the question. The first was, a young patient with incurable disease has which of the following types of pain? So the answer is D, all of them. And the second question, all of the following are true for a child with congenital diaphragmatic hernia, except the answer is D again. Surgical management takes precedence over medical management. That's false, right? And the winner of this quiz is Dr. Shreya Sharma. Congratulations, Dr. Shreya. So we have the second quiz for the day. Can we have the questions for the second quiz? Okay, so here they go. So the first question is, which of the following is a benefit of enteral nutrition when compared to parenteral nutrition? A, decreased cost. B, decreased length of mechanical ventilation. C, decreased rates of infection. Or D, all of the above are benefits of enteral nutrition. The second question is, synchronized intermittent mandatory ventilation was an improvement on intermittent mandatory ventilation because A, can provide full ventilation support to an apneic patient. B, can utilize volume present or pressure present ventilation. C, allows the patient to breathe spontaneously. Or D, reduces the likelihood of breath stacking and volutrauma. Okay, let's move ahead with our next session. Can we have the CD, please? To chair the next session, I would like to invite Dr. Nisha Banerjee. Ma'am is professor with the Department of Anesthesia at RML Hospital, and her areas of special interest are critical care, neuroanesthesia, ATLS, and CCLS instructor. Over to you, ma'am, for the proceedings of this session.
Welcome, delegates, back again to the didactic lecture sessions. You have already learned the basic mechanical ventilation modes. They were explained so beautifully by Dr. Devatya, and Dr. Sheila also explained you the management of ARDS patients. Now, Dr. Anupama Gill Sharma, who is Associate Professor at ABV IMS and Dr. RML Hospital, where she has special area interest in critical care, difficult airway management, regional blocks, and transplant anesthesia. She'll be talking about newer modes of mechanical ventilation. Over to you, Dr. Anupama.
Thank you. A very good afternoon, everyone. So to the topic of my talk today,
is newer modes of ventilation. And I thank Dr. Andika ma'am and the organizing team to have given me this opportunity. As you to start the talk before, I would like to tell the postgraduates that this can come as a short note or it can come as a long question for you to enumerate the various modes of ventilation. So one has to know these modes because of that, especially ASV, NAVA modes can come. So to going upon the history, the first mechanical apparatus, just to tell you briefly about how the new modes have come now. So the initial mechanical apparatus, which was as a ventilator, was designed in 1780, and it was based on an IV with a bag and mask. And first, subsequently, a more sophisticated bellows with the mask was introduced in 1887 by Fell. In 1911, Tracker's pulmotor was the one which was introduced and which has saved a lot of lives during those times. So this is how unsophisticated model of the ventilator, how it was. And now this is some of the crude ventilators. You can see all the apparatus parts outside. So now we have moved on. Now we have these sophisticated ventilators in which all the artificial intelligence is with the AI and with the feedback. So we don't have too many hardware outside, and they're very efficient, very precise. So the equation of motion, this is just to tell you about how the ventilator ventilates a patient. So P muscle is the effort which is put by the patient. P vent is the effort pushed by the ventilator in order to ventilate and provide the ventilation to the patient. So it is the combination, is the sum of the resistive load and the elastic load. The resistive load is the resistance which is offered by the larger airways. It is the resistance into flow, and the elastance into volume is the load which is offered by the smaller airways, say the alveoli. This is a very rough way of understanding. So it's just the interplay between the muscle and the ventilator, between the patient and the ventilator. The one decreases, the other increases. So that is how the patient progresses from a fully controlled mode to a spontaneous mode. So then we go to the ventilatory variables, what causes switches from inspiration to expiration. This is very important to understand before we go on to the modes. This is how a mechanical breath looks like. So here you can see that this is a baseline pressure which is there. This is the one in which it is so there is a baseline pressure which is there, which is maintained here. So on that there is a trigger. This is the patient trigger. So it can be a patient trigger, it can be a machine trigger that goes into the inspiration. This time here is the inspiratory phase. And what causes the switching from inspiration to expiration is the cycling phase and vice versa. And this time here is the expiratory phase. So the trigger variable can be machine. What triggers the inspiration is the trigger variable. So it can be time in control modes where no spontaneous breath is allowed. So the inspiration, the breaths are given at regular intervals. It can be pressure or it can be flow. Pressure is basically when the patient draws a certain amount of pressure from negative pressure. The ventilator can detect that it wants to take a breath, it will sink into the inspiration. Flow uses a combination of continuous flow and demand flow. Continuous bias flow is maintained to the ventilator, and when the patient wants to take a breath, it will draw a certain amount of flow from that, and by which the ventilator would understand that the patient wants to take a breath, so it will cycle into inspiration. Now the neural sensing in this is a part of NAVA, in which an electrode is detects the electrical activity of the diaphragm and causes the ventilator to switch to the inspiration. This is about the limit variable is the one which this is the variable which is not allowed to rise during the inspiration. It can be pressure, it can be flow, it can be volume, it can also be time. So mostly it is the pressure which we do not want to allow, and then also it's not the volume, it's usually the pressure and the time and also flow. So so this is a variable. This is not the variable which causes the respiration to grow from inspiration. It is not the cyclic variable is different and the limit variable is different. The cyclic variable is the one which is measured by the ventilator, and it is used as a feedback to signal that a certain amount of target variable has attained. So ventilator can cycle from inspiration to expiration and the other way. So it causes what causes the breath to end and terminate the phase of respiration is the cyclic variable. Usually it's the flow which is there. It can also be time in completely controlled modes. It can be the pressure. The baseline variable is the variable which is controlled during the expiratory phase. Say if certain amount of PEEP or CPAPs is kept at the expiration, so that becomes the baseline variable. Then others are the conditional variables which are detected by the ventilator when a certain threshold is met, and they can kind of work as a feedback to alter the designated output. So this is some of the graphical symbols of various breaths. This is a volume control breath in which you can see that this is a machine triggered. A certain volume is attained at the pressure and goes into expiration. This is a volume assist in which you can see that there is a trigger of volume by the patient, and then it gives the full volume. So it's a volume assist breath. This is a pressure support breath in which the effort by the patient is supported by a certain pressure support to reach up a particular volume, and then it cycles into. So you can go through them later. This is just for your understanding. So one has to talk, when you talk about the newer modes, the patient has to be brought from a controlled ventilation phase to a transition phase to a spontaneous respiration. So transition phase is the one in which the patient gets better and is going to be ready for weaning. So these are the phases in which the new ventilator modes have come up, so that the transition is smooth, more physiological, more early. These are the conventional modes that you have already read: pressure support ventilation, PCV, IMV, CPAP. So you can compare it to this diagram, in which in the first one is like a control breath. The whole of the work is done by the ventilator, and there is no effort by the patient. So, and as and when the patient is getting better, the ventilator just assists its breath, and then it's a support breath. So major work is done by the patient. So there are two. Why do we need new modes? Older modes were the open loops in which the feedback loop is absent. That means if the clinician sets a particular tidal volume or respiratory rate, an FiO2, peak pressure, and that is the one on which on those values around that only the ventilator would operate. So there was no way of taking feedback from the patient's lungs mechanics and then feeding it to alter the variables which now maybe we do not want. So that is the new modes. This is the way the new modes work. They target to make alterations with the changing lung mechanics, taking feedback from the patient parameters. So they are closed loop. So the problem with the conventional modes were that setting which you have set for the patient today may not be appropriate for him tomorrow. So the clinician has to every time stand near the bedside of the patient, understand the mechanics, and every time make alterations in each parameter. So in the newer modes are the ones which they try to do that work for you. It will just kind of assess the patient's ventilator mechanics, patient's lung mechanics, and alters it. So they complete the feedback loop. Like this is the algorithm for not the algorithm. It's a way of understanding. So operator's command is the one the clinician what it sets the control in the ventilator, and it's executed in the form of giving breath to the patient. And from the patient, the output is interacted. The feedback is monitored and it is fed back into the controller to alter the output. So this loop is missing in the open loop conventional modes, and this is how the newer modes are different from the older ones. So the conventional modes, the pressure modes, if one guarantees the airway pressure, the volume might change, causing volutrauma. If it is a volume mode and one is targeting the volume only, then the pressure may rise high, causing the barotrauma. So the newer modes trying to find some common ground in between, in which both pressure and volumes are met at optimum level. So in the newer modes, ventilators have complex computer-based algorithms. They simultaneously control both the variables pressure and volume. So a very convenient way of convenient way of classifying them is dual control. What is dual control? Dual control means controlling both the pressure and the volume within a single breath. And examples are volume assured pressure support. Other one is pressure proportional assist ventilation. I'll talk about them later. Dual control in subsequent breaths mean the patient's breath and pressure and volume are controlled in subsequent breaths. The examples are volume support and PRVC, that is pressure regulated volume control. The other modes are mandatory minute ventilation, adaptive support ventilation, PCIRV, and NAVA. NAVA is newly adjusted ventilator assist. So among these modes, you can also say proportional assist ventilation and mutually ventilator assist are also similar in the way that they provide a proportion of the ventilation to the patient depending upon his condition. So these are also called as proportional modes. Bilevel ventilation modes are the ones which operate at the bias for the pressure. There are two pressures which are set in the ventilator, and it switches between these two pressures cyclically, and the I ratio varies. So the various ventilators are given a different name: BioVent, Bilevel, Duopap, PPRV. So they are very similar to each other. I'll talk about them later. Then we have high frequency ventilation. Part of it you must have studied already, just ventilation and HFOV. Let's going on to the individual modes. Proportional assisted ventilation, you just need to understand that it's a proportion, or it's when the ventilator functions as an additional muscle, proportionately assigning the instantaneous efforts of the patient. So ventilatory assist ceases as the patient efforts also ceases. So it gives a good harmony between the patient and the ventilator. It is a promising new mode which synchronizes the partial ventilator assistance. So just nothing, basically it can be applied to any mode. It is a kind of a promising mode. So as and when the patient gets better or worse, so it will unload the patient's work of breathing. So it's recommended in early and late ARDS, hypercapnic respiratory failure and weaning. This is how it will be like in a passive patient. The whole work is being done by the patient, so the effort from the patient is zero. By the ventilator, the effort by the patient is zero. As the patient gets better, the ventilator, the part which is being controlled by the ventilator decreases, and more unloading is done to the patient, and slowly the patient weans off. Then we come to VAPS, that is volume assured pressure support. This is a dual control within a same breath. This is a modified pressure control mode. So the trigger can be the patient, it can be the machine, depending upon the condition. And there is a feedback loop on the volume. What is the feedback loop? So to start with, it is like a PCV mode. PCV mode means so the pressure limit is set and the tidal volume is delivered based on the set inspiratory pressure. And then it looks at the tidal volume, whether with this inspiratory pressure, the tidal volume is being met, and this is happening within the same breath. So if it is not, then it quickly switches from a pressure mode to a volume control mode to achieve the tidal volume. So the pressure target is overridden and at minimum tidal volume is guaranteed. So if the tidal volume delivered is through the preset volume that we want, then it works like a PCV. If it is not, it will switch to a volume control mode. So it is switching from PCV to VCV based upon the tidal volume to assure a tidal volume. So this is how a graph would be. Here you can see the patient has triggered a breath, and then it is giving a breath at a particular pressure, but then the volume has not been attained. So now the pressure trigger is overridden in order to attain a certain tidal volume. So here you can see that tidal volume was not met, so the pressure has now gone to volume control, and the adequate tidal volume is delivered. And how is it doing that? It is maintaining the inspiratory set flows for some time, so to attain the tidal volume. Okay, so the advantages are so the disadvantages, some precautions. If the pressure high limit here, the upper limit alarm that you have set is too high, it will keep on overriding the pressure limit, ultimately giving a too large pressure can cause bladder trauma. Again, the second is if the flows which you have set are too low, the inspiratory flows are too low, then the switch from a PCV to a VCV takes a longer time. Unnecessarily, the inspiratory time would get prolonged. So one should set an appropriate P high and a good flow rates. Then, so it is a pressure limited flow cycle ventilation. It is a modified pressure support And then we come to the volume support mode. So volume support mode is a pressure limited volume flow cycle ventilation. This is nothing but a pressure support mode in which the pressure support is changing in subsequent breaths and to attain a certain tidal volume. So it is a completely spontaneous mode, unlike the previous one, which can be both patient and machine control. So spontaneous mode where target here is the volume. So the trigger is the patient, the limit is the pressure. So the target is the volume which is attained. If that volume is not attained, it will give a feedback to the ventilator. It will keep changing the pressure support in subsequent breaths so that adequate tidal volume is attained. So you can understand by this graph, in the first graph, in the first breath, the tidal volume was not achieved. In the subsequent breaths, the pressure support is increasing. Ultimately, a new set auto set pressure is attained. So this is the tidal volume which is attained. Okay. The advantages are that the patient is comfortable in this mode. He has the option of controlling his IE ratio, inspiratory time. But the one precaution which one should take is that it should be applied only in patients who have a spontaneous breathing. Otherwise, the ventilator would go back to a backup mode, and then the whole idea of breathing gets lost. Indications that has been shown very promising results, especially as part of NIV in pediatric patients with neuromuscular disorders, and spontaneously ready to be weaned patients, and it can very well manage the ventricular synchrony. So the key point here I want you to understand is the VAPS is the volume assured pressure support. This is a mode which is a control mode. It gives an option for the patient also to trigger. And volume support is a spontaneous mode. So VAPS is dual control in a single breath. Volume support is a dual control in subsequent breaths. Pressure regulated volume control is again dual control in subsequent breaths. So it gives some amount. So in this is a mode which has a dual control, patient or time trigger, breath to breath, pressure limited, and time cycle. So the time cycle is the one if the certain pressure with that pressure tidal volume is not attained, it will change the pressure so as to attain the tidal volume. So we can make you understand better with this graph. So first of all, the ventilator would give a test breath to at a certain preset inspiratory pressure, arbitrary, looking at the lungs, maybe something like 20-25 for a healthy patient. And then it sees what is the tidal volume that it is achieving. If one sets and the clinician sets a target tidal volume. If that tidal volume is the same that we desire, then it will continue to give the breath at the same inspiratory pressure that it had started with. If the tidal volume that it measures is more, then the patient does not want so much of inspiratory pressure to decrease the inspiratory pressure. And if it is less, it would increase the inspiratory pressure. So this is the patient. So volume pressure PRVC is a pressure bed as delivered with a very important here is the decelerating inspiratory flow pattern, which is more physiologically more comfortable. So it provides the volume support, keeping the peak inspiratory pressure at the lowest possible levels. Indications are again in the ALI, acute lung injury, ARDS patients, traumatic brain injury patients, patients who are requiring with COPD with high exacerbations. So it guarantees a low tidal volume with minimal risk of trauma. Decelerating bow flow pattern is used here, which is more physiological, better meets the inspiratory demand, less chances of atelectasis. To add on, similarly, as we were also seeing in volume support, if the pressure limit alarm is not set appropriately, to reach the tidal volume, the ventilator will keep on increasing the inspiratory pressure and actually causing a bladder trauma. So one should set a optimum P high. Another disadvantage is that it takes a few breaths to analyze the patient's lung mechanic and before it sets up to inspiratory pressure. So, if the patient is coughing or fighting or is having a suction, then at that particular time, the tidal volume which are being attained are not proper. So it takes some time to adjust. So basically, that is the disadvantage. So it is typically a set it and forget it type of mode, which can be dangerous in patients with high respiratory drives like asthma patients and COPD patients. This targeting scheme of PRVC can lead to decrease. So more amount of slowly unloading is done to the patient, and the patient get exhausted. Then we come to mandatory minute ventilation. Sometimes might be asked in the exam. So a minimum minute ventilation is set. It is nothing but a pressure support mode. So it's a spontaneous mode, pressure support, weaning mode, just like PSV, in which we set a minute ventilation. Now, how the patient, the ventilator ensures that the patient takes this minute ventilation is by changing both the rate and the level of pressure support, automatically changing those. Indication is a spontaneously breathing, ready to wean patient. So the disadvantage here is if the minute ventilation which one has set is not sufficient, it is not met, then the ventilator would keep on increasing the respiratory rate. Because if the patient is taking not very deep breath, the tidal volumes are low, patients with ARDS, then just to match up to the minute ventilation that it wants, it will let the patient breathe at pretty high level. This is also what we do not desire. So one should set an adequate limit for the high alarm rate for the respiratory rate. If the minute ventilation that one has set is less than the one which the patient is taking, so then we are giving inadequate support to the patient. That is called fatigue. Similarly, on the other hand, if the minute ventilation that we want is more, that we have set is more than what patient is requiring, then the whole support is given by the ventilator and less on the patient. So the idea of weaning is, the idea gets lost. So it should be balanced. So one needs to see the limit, the pressure limit, the respiratory limit, and to what level the minute ventilation is set. A very important mode now, adaptive support ventilation, is sometimes now being asked in the exam. It is a patent mode of Hamilton ventilators, and so in this, it works on a principle which was developed in 1950, that for a given level of alveolar ventilation, there is a particular respiratory rate at which the patient would be breathing at lowest work of breathing. Hence, that particular combination would be more energy efficient. So now how does it do it? Let's see it. So this is the whole idea behind. So it is not targeting a pressure. This mode is not targeting a volume. It is not targeting a minute ventilation. It is only targeting that a state at which best possible combination at which the work of breathing is the lowest and more energy efficient. So it is a unique mode which sets the minimal work of breathing as its endpoint. Not the tidal volume, not the pressure support, not the rate. So control variable here is the pressure. Because the pressure control synchronized intermittent mandatory ventilation. The target ventilation, that is the tidal volume into respiratory rate, corresponds to the best combination from energy standpoint. So this is the adaptive support ventilation. So basically it switches between these three modes. PSV is the pressure support volume, pressure support mode, pressure control ventilation, synchronized intermittent mandatory ventilation. So if the patient's respiratory rate is good, he's ready to be weaned, he's ready to be extubated, it will just function, this mode would function like a PSV. If there's no spontaneous breathing, it would function like the pressure control mode, in which the breaths are given at a set pressure. If the respiratory rate is there but is not as adequate as we want still, so it would act like a SIMV, that is synchronized intermittent mandatory ventilation. It would augment the pressure support, pressure triggered breaths, patient triggered breaths. So it is kind of a three-in-one integrated mode. So it will keep on switching. So it can practically ventilate all endotracheal patients at all the stages. Okay, because it can switch from PSV, PCV, SIMV. So what are the settings? One need to set the height and the gender. Based on the height and gender, it will calculate an ideal body weight, and then it will calculate the minute ventilation, and we just have to set the percentage of the minute ventilation that we want. Suppose in a healthy patient it is about 100%. For a patient of asthma, it can be about 90%, because they can be bed starting. In ARDS patients in which hypoxemia is a problem, you can set it up around 120. On others, roughly around 100, 110. And if the patient is febrile, for every 20% extra, one has to keep for the fever and the increased metabolic rate, and 5% for every 500 meters for above sea level. The trigger here is the flow trigger. So it gives the independence to the patient to trigger. So flow trigger and expiratory trigger sensitivity can be kept between 25% to 40% in COPD. Generally, it is kept as 25. Tube resistance compensation is just, I will tell you later, it's not a mode, it's an option which is given in some of the ventilators to overcome the pressure, the resistance by which is offered by the endotracheal tube to overcome the resistance. So P max is the one, the P high, the P limit, upper limit, which is set. And the driving, and though the ventilator basically gives the tidal volume 10 centimeters below the P max, and one gets to set the P PAP as a highest 125. FiO2 is set. So the maximum inspiratory pressure which is delivered is 10 centimeter than the P high limit. I'll tell you this again later. And once the tidal volume, 1.5 times of the desired tidal volume is attained, it would give a high limit. It would abort the ventilation. So this is the interface, the initial starting interface of ASV. So here you can see that the gender is selected, male, the height of the patient is set, and based on that, it has calculated that the ideal body weight should be 70 kgs. And then it sets the net ventilation for an adult, it is 0.1 liters per kg per minute, so around 7 liters per minute. If it's a healthy patient, we want 100% of the net ventilation to be achieved. And a good starting peak can be 5. On the lower side on oxygen can be, we can set it as 50. Other controls which are there is one gets to control the pressure, high pressure alarm. So if this high pressure alarm should be set very appropriately, because the inspiratory driving pressure for ASV is just 10 centimeters below the P high. So the P high is set as 40, then the P inspiratory for the ventilator becomes 30. Okay, as you can see here, so this 30 centimeters of P inspiratory limit at which it will ventilate. The height is 174, and these three parameters we have added, and the flow trigger you can check how much you want the patient. That is depending how clinically the patient is good or bad. The other alarms also there, apnea alarm, tidal volume alarm. So these can also have to be set appropriately. Then this is an idea which I want to give you about, is that based upon the parameters, the ideal body weight which the patient has, this ventilator would plot a graph something like this. It is not so that this is an optimal combination of tidal volume and respiratory rate. For this patient, it has calculated that a rate of 15 at a tidal volume of 400 ml would be very adequate for the patient. So it calculates this graph for every patient and tries to ventilate so that it falls near around this curve. Okay, so this is for you to understand. So if you look at the graph, sometimes this rectangle kind of a thing shows. So this is basically the safety zone in which the ventilator wants the patient to operate at, to conduct its breath at. So on the x-axis you can see is the respiratory rate, on the y-axis is the tidal volume. So and this is the plot which it has drawn for this particular patient, and wants the patient to be ventilated near about this curve only. That's why this safety zone. So here, this is for the safety zone rectangle. The 5 is the ideal combination of the respiratory rate and tidal volume which the ventilator has calculated for this patient. That is 434 and 16. So this is an ideal target minute ventilation combination, and plus 6 is the one at which the patient is now getting ventilated. So the rate here is 22, 15 plus 9, and the tidal volume that must be somewhere like 500. So still it is still falling in the safety zone, so one can continue with it. So the ventilator wants it to be as close as the ideal curve. So then ASV also takes care of the lung protective rules. So you can see as here, so if it does not let the tidal volume rise above certain level, say you can see around 700, 750, 800 is not desirable. So that is the upper limit of this safety zone. Then on the right side, you can see that it does not allow the respiratory rate to maybe go more than 50. Okay, so that dynamic hyperventilation and breath stacking is also taken care of. On the D side is the one in which it does not want a very low alveolar ventilation. So the rate of maybe 1 or 2 can trigger the can be alarmed as apnea, and the patient, the ventilator will take care of it. Okay, so it is also so it is taken by making a safety zone and making the patient operate at this level only. It is taking care of barotrauma, low alveolar ventilation, dynamic hyperinflation, and apnea. Another important thing which ASV does is it calculates the expiratory time constant. What is the expiratory time constant? It is a measurement of how fast or slow the lungs are getting filled and emptied. So basically compliance and resistance. It's a product of the two. The normal values are between 0.6 to 0.9. So this ventilator also shows us this graph. This tells us about how healthy or bad the lungs are. If the borders are flat like this, these are typically ARDS lungs, atelectasis. And here the respiratory expiratory coefficient was less than 0.3. And these are normal lungs with 0.6 to 0.9 respiratory expiratory constant. And these are the lungs of emphysematous, COPD, asthma, bronchospasm patients. And here the expiratory constant is more than 0.9. So by looking at this graph only, it can tell you about the disease process, how healthy or bad the lungs are. So ultimately, to put it all together, this is how the ASV function would look like. These are the lungs parameters. These are the parameters that you have said. The patient set parameters would come over here. And then these are the graphs. As you can see, here is the PEEP is there, and then some amount of air trapping is also occurring probably. So it is similar to PCRV, how it was doing. This particular mode would also give a test breath, like a PCIMB breath, between a rate of 10 to 15 and an idle body weight, and then look at the expiratory time constant. So this tests the system. Okay, it gives the breath, it tests the system, takes the feedback in the form of expiratory time constant, and then come up with the best possible combination of tidal volume and respiratory rate, and accordingly the mode is selected, a patient is ventilated, and then so it is the cycling criteria flow, patient assisted ventilation, time based for mandatory ventilation. Advantages of ASV are it is very effective it is a very versatile mode. All intubated patients passively or actively can be ventilated with this. So there's an effective alveolar ventilation level and minimizing the work of breathing. Optimal ventilatory pattern can be obtained, prevents tachypnea, auto-PEEP, dead space. Again, no machine is flawless. So disadvantages are if a clinician wants to set directly the tidal volume, respiratory rate, and I ratio, so this mode doesn't give us that option. One has to only set the percentage of the minute ventilation. So it does not take into account, apart from ventilation, the shunt, the dead space ventilation, the shunts one patient may be having. That is one of the cause then where that ASV may not be successful. So if it does not take that into account, then the assumption that it makes of the possible combination of respiratory rate and tidal volume might not be accurate. This is something which can be fixed, maybe it gets fixed in the future versions. Limited experience in pediatric patients. Operating algorithm tends to err with such an algorithm that low tidal volume and high respiratory rate are chosen, and then it's a patent mode. And now different other ventilators are also trying to make intelligent modes, and maybe you'll read about them sometime later. Bilevel ventilation means that the bi is for the two pressures. So here the ventilator, this is a mode at which there are two pressures which are set, the P high and the P low, and the two times are also set. So it is a pressure control, time triggered, time cycled mode, which allows unrestricted spontaneous breathing at both the pressures, high pressure and low pressure. So different ventilators are given them different name, BiPAP, biphasic, biwind, duopap. So ultimately they're all similar. So better synchronization, more options for some supporting spontaneous breaths. So in bilevel ventilation, the two pressures are set up P high, P low, two times are T high and T low. Advantages are improved oxygenation, promotes alveolar recruitment. So these are the various modifications, you can go through them. This is how it is. So here you can see that the ventilator is operating at too high, 2 CPAP, this pressure and this pressure. So the mechanical tidal volume is the one with the difference between the these two pressures will be unmechanical tidal volume of the patient. On top of it, there's a spontaneous respiration which is allowed at both the levels for the patient. Okay, so this is which is very advantageous because now the patient can take part in this ventilation. So there are two levels of functional FRC, FRC inspiratory, FRC expiratory, which are derived, which are attained. So this is again bilevel ventilation. So bilevel airway, APRV is the airway pressure release. Airway pressure release, by its name itself, you can understand that a certain high pressure is maintained in the breathing system for a certain time, and then it is suddenly released before re-attaining it. So it is a set of a CPAP which is released intermittently to a low level using it in a time controlled manner. So high CPAP and lung volumes are re-established once the valve closes. The principle of this mode is by it reduces the principle of reducing the lung volume distinguishes it from other modes of ventilation. So here you can see that patient is allowed to take spontaneous breaths at both high level, P high and P low. So this is a typical ARV how it can be. So it's kind of an inverse ratio in which the release for the expiration is very small. But the good part about this mode is that patient can unrestrictedly take part in its respiration. Now we go to advantages of preservation of spontaneous breathing, little hope of breathing. Disadvantages are in asthma patients, severe COPD patients. They are poor candidates for APRV because of the breath stacking. PCIRV is basically in which it is a pressure control mode, completely a control mode in which the I ratio is reversed. It's more than 1:1. So rapid achievement or inflation sets the very high P high, and full inflating pressure reached at the end of the inspiratory cycle, and then it is suddenly released for a very short period, shorter than normal, and then by a rapid deceleration in the flow. Theoretically, it can be more homogeneous because can give more homogeneous ventilation, improve lung compliance. So this is a typical PCIRV mode in which there is no allowed spontaneous ventilation. So the patient needs to be sedated with a neuromuscular blockade. And this is just want to say that PCIRV and APRV are similar here. In APRV, where there are no spontaneous breaths, the two alarm, the two graphs would look very similar. This is PCIRV, this is APRV without spontaneous breathing. So here you can see that in the APRV, it has a common factor with the PCIRV that the I ratio is reversed, the release is of the pressure is for a very short time. But another thing which is important is this APRV gives us the patient an option of breathing at both the pressures. So here the pressures which are set are not too high. Two CPAPs are set maybe say 20 and 5, but in PCIRV with the sedation, with the last resort for hypoxemia, patients are the very high pressures can also be given here. So just want to emphasize how they can look similar but are still different. So deep sedation, neuromuscular blockade is needed. So this is a difference between a PCIRV. This is a PCIRV in this where the ratio is inversed. So certain high pressures attained and then it is released intermittently, very short period. Similarly, in the APRV, same high pressure, low pressure it is going, but then spontaneous respiration is allowed here. Then this is a BiPAP. So in the BiPAP, as you can see, compared to APRV and PCIRV, it gives some time, adequate time for expiration. So this is a BiPAP mode. This is APRV, this is IRV. The principles working are quite similar. By operating at two different levels, it maintains alveolar recruitment and better ventilation. High frequency ventilation can be jet ventilation or oscillation. Jet ventilation is that at which the high pressure gases at around 300 to 300 kilopascals are delivered into the airway by a small bore catheter at high frequencies. Air or supplementary oxygen entrained within the jetted ventilatory breath. Expiration is purely passive. So it can be, this is you must have learned about it already, I think. So this is the apparatus of jet ventilation. How is it? The gauze, the on-off valve, the small bore tubing assembly, the pressure hose assembly. Then high frequency jet ventilation is the one which can be used in the OT when the surgeon wants to operate and share the airway with us, like laser papillomas. So it can also be a part of emergency airway. So disrupted or massive bronchopleural fistula, when the non-bulk flow of gases decreases the amount of gas escaping out of the fistula. So this mode can be used in such situations. And the precaution is that one should be careful about the iatrogenic barotrauma that it causes. because of high pressure. Then for completion sake, now we have HFOV. HFOV is basically small tidal volumes less than the residual volume. The small boluses of flow is delivered from the machine to the patient. To and fro application of also pressure and the flow on the opening at very high frequencies, 100 to 1000. So this what one might ask, that how does the oxygenation is taking place in HFOV? So the mechanism is bulk flow, coaxial flow, Taylor dispersion, pendular, and augmented molecular dispersion. So this is how HFOV. So you can see over here that the small boluses of oxygen of the flow is delivered continuously from the machine to the patient, and on top of it, the patient is also allowed to take its spontaneous breaths. So this maintained HFOV is maintaining the hypoxemia, helps to manage hypoxemia. Similarly, you can say over here, this is the amplitude, this is the frequency, and this is the high frequency oscillatory ventilation. Advantages are lower peak airway pressures, improved PQ mismatching, and the disadvantage is inadequate humidification can cause direct physical airway damage. Other modes which you can read about are tracheal gas insufflation. These are liquid ventilation, ECMO, extracorporeal CO2 removal. It is beyond the scope of my lecture, but do read them before the exams. You can get short questions. So automatic decompensation is basically not a mode. It is an option by which your compensation for the non-linear flow-dependent pressure drop which is there across the endotracheal tube. So within the ventilator, a known static resistance for each type of endotracheal tube is fed, and the measured flow also are calculated and are seen, and then it gives desired pressure both at inspiration and expiration, so as to overcome the resistance offered by the endotracheal tube. So this is the working principle here. And the indication, so the pressure drop at the external airway and the tracheal pressure difference here is taken, and then that is how it works about. The pressures are given in inspiration and expiration. Indication: COPD, malnutrition, respiratory muscle failure patients, difficult to wean patients. Contra, and then so it causes enhanced synchronization between the patient and the ventilator. It is more accurately makes the patient ready for weaning. Then we come to NAVA. NAVA is newly adjusted ventilatory assist. It is a form of partial ventilatory support where the machine applies positive pressure to the airway throughout each inspiration based upon the feedback. So here I'll make you explain. So this is an ideal scenario which we strive to have, that we want to have, that whenever the patient wishes or the central nervous system triggers a breath, it should be detected by the ventilator to give a breath. But this technology has not been developed. So in patients with cervical spine injury, so in as a surrogate for CNS systems stimulation, the nerve goes, the impulse goes down to the phrenic nerve, from there to the diaphragm. So if the diaphragm has some amount of limited activity preserved, so that excitation, that contraction of the diaphragm is amplified with the help of electrodes and fed into the ventilator unit to cycle the patient's ventilation into inspiration. So basically the feedback is obtained from the diaphragmatic contraction and it is fed to so this is the so it basically works on neuroventilator coupling. So as you can see here, there's an EDI catheter, that is electrical activity of the diaphragm is calculated. This particular probe is put just like a nasogastric tube. At the end of it, there are electrodes which take up the activity of the diaphragm, something like this. So this is the electrode here, which can show these electrical activities, which is fed into the ventilator and multiplied by proportional factor, and then it tells the ventilator to go into the inspiration if it is adequate. Then the advantages of NAVA are that in many patients who have, or children or neonates who have cervical spine injury, who are in whom there's disuse atrophy of the muscle slowly, and so they can be weaned off the mechanical ventilation with NAVA. Those patients with head injury, COPD, ventricular dependency, in these patients it reduces or eliminates the incidence of disuse atrophy. So the advantage of NAVA is that it gives it's a synchronous possible with least possible delay. It's a very safe and improved ventilation. It does not cause false initiation of breaths because the signal is coming from the ventricular, from the diaphragmatic contraction. Eliminates man's sleep disturbances, adapts to an altered metabolic demand with constant unloading, prevents disuse atrophy. This is another mode, Smart Care, which is coming up. You can read about it. It is an automated clinical closed loop system, which is designed to maintain the patient's spontaneous breathing in a comfortable zone of normal ventilation. So there are many other modes, Neo Ganesh, and few modes, new modes which are coming, which you can read them up. I'll put them in my handout. But now we are short of the time, so I would like to wind up my lecture. And if you have any doubts, you are free to contact me anytime. I hope I'm able to make you understand something so that you can write in your exam. These are the references which I have taken. And at the end, before concluding, I want to say that it is one should familiarize oneself with the technology. Just because you have a technology at hand does not mean that if you are not aware, if you are not comfortable, do not use that. You have to work for the patient best benefit. So choose wisely your mode. It is not what the technology does to us. It is what we do to the technology, how intelligently we behave with it. Get smart with the technology, choose wisely, and use it in a manner that benefits both your patient and is your comfort is also attained. Thank you so much for listening patiently to my talk. I think it was a very monotonous topic, but I tried to make it as interesting as possible. Thank you so much. I wish you best for your exams.
Thank you, Dr. Anupama. It was a very exhaustive and lucid presentation. It's a very difficult topic. I hope the postgraduates have listened it because she has taken great pains to explain each ventilatory mode. There was a postgraduate who had asked question regarding APRV mode and PRVC. I hope the concept is clear because some basic concept was explained earlier, but she has really explained it in great details. NAVA has also been explained, and this short note on NAVA has come multiple times in your PG exams. So please, she has given you the key points. She has told you in great details. A lot of things ASV has been like really dealt with very well. Anybody who is handling Hamilton ventilator will know how to manage it. In fact, they have kept it as a default mode. So get familiarized with these. They may sound new, but remember the first basic concept, the first slide which she showed was closed loop ventilation. If you get a short note on newer mode, if these few keywords, if you use, which she has used in a lecture, they go a long way in fetching the marks for you. So please see this presentation. It's very, very informative. Thank you, Dr. Anupama.
Thank you,
Do
ma'am.
we have any questions? I didn't see any questions. Are there any questions, Dr. Nitin? There are no more questions.
Thank you,
It
ma'am.
was self-explanatory lecture. Thank you, Dr. Anupama.
Thank
Very
you.
exhaustive.
Thank you, ma'am.
Our next speaker is Dr. Anuj Jain. Dr. Anuj Jain is Associate Professor at All India Institute of Medical Sciences, Bhopal. His area of interest is chronic pain management and palliative care. He's taking the lecture also on his area of interest, that is management of cancer pain. Over to you, Dr. Anuj Jain.
Hello, friends. Today we shall be talking about cancer pain and its management. So, I am Dr. Anuj Jain, and I'm Associate Professor in Anesthesiology at All India Institute of Medical Sciences, Bhopal. So, the scenario for today's discussion and lecture would be a 36-year-old female who has been diagnosed with renal cell carcinoma, and this renal has been RCC has been labeled inoperable, and the patient is having severe abdominal pain for about 2 to 3 months. For past 2 to 3 weeks, he has started to have backache along with leg pain, and this leg pain is pricking in nature, and is associated with lower extremity weakness, the power grade being 4/5. She has come on wheelchair. So since past 1 week, she's also having painful swelling in the forehead, and this swelling reduces upon this is a reducible swelling. She has 2 children, she knows of she knows about the diagnosis, and it's the diagnosis of cancer and it being inoperable and incurable, but she is mentally composed. Of late, she has been having difficulty in sleeping because of headache, which is predominantly in the night. She has got good appetite. She is accompanied by her brother. Her husband is too shattered to attend the hospital along with her. Ever after knowing the diagnosis, he is not in a good mental status. So to initiate the discussion, first of all, we need to classify the cancer pain, and cancer pain has been classified into two categories in the current guidelines of ICD-11. It has been classified into primary and secondary cancer pain. Primary cancer pain is cancer pain, pain arising due to the cancer itself or due to its metastasis, and secondary pain is due to pain arising because of treatment associated with cancer. That is, it may be in the form of chemotherapy, radiotherapy, or surgery. So from this, we can say that our patient, which we discussed in the scenario, is having primary cancer pain, and probably because of the primary and due to the metastasis also. Another useful way of classifying cancer pain is the origin of the pain sensation. That is, whether the pain is originating from any viscera. In that case, we call it visceral pain, or it is arising from the bony or the musculoskeletal system, or whether it is arising from nerves. In that case, we call it neuropathic pain. It is important to make this distinction between the three, because the treatment of all the three type of pain is different and is not interchangeable. So first of all, about visceral pain, since we have seen that the cancer is in the kidney, and we all know kidney is a viscera, right? So any tumor arising from a viscera will definitely lead to visceral pain, and this visceral pain travels by way of autonomic nerves. The characteristic of visceral pain is that it is ill-localized. It is associated with autonomic features like nausea, vomiting, perspiration, syncope, etc. It responds poorly to conventional analgesics. By conventional analgesic, I mean to say NSAIDs. And quite frequently, this pain is referred to a contiguous site. Okay, like a gallbladder pain may be referred to the shoulder, or angina may be referred to the jaw. So referral of visceral pain is referral in visceral pain is quite common. Then the next type of pain is musculoskeletal pain. This pain travels by way of somatic nerves and is characterized by being well localized with external signs of trauma and respond well to NSAIDs. Okay, so we see that the patient is having a forehead swelling, which is externally visible, and probably and it is painful, and probably it is because of metastasis of the primary to the calvarium, and it is a well localized pain. Then another component of pain is neuropathic pain. We see that the patient is probably because of the metastasis to the spine. There is something going wrong with the spine, vertebral column, and the spinal cord. So that is generating the low back pain that our patient is experiencing, and along with that, there is nerve compression, which is leading to weakness in the limb, and pin-pricking type of sensation and dysesthesia in the lower limb. So we see that our patient has got all the three components of pain. Okay. Then after having diagnosed, we need to formulate a treatment strategy. The step one for treatment strategy would be to differentiate between somatic and visceral component of pain. So we have already done that, because why we need to do it is because visceral pain responds well to opioids, but does not respond well to NSAIDs. While somatic pain, it responds very well to NSAIDs and not that well to opioids. So having taken care of step one, now we need to move to step two. We need to inquire for any neuropathic component of pain. So in our case, we have inquired. We have got a clear indication that the patient is having a neuropathic component of pain as well. Then the third step, and it is of this step is very important, is look into the functional status of the patient. For determining functional status in a cancer patient, we use the ECOG status, that is the physical status as determined by the Eastern Cooperative Oncology Group classification status. And if the patient is having a ECOG status of 3 or more, it is suggestive of a poor functional status and short survival of the patient. So in such patients, you need to manage the patient. A patient with ECOG status of 3 or more is considered to be frail and likely to develop side effects quite frequently and easily. So the dose quantification has to be quite methodical and carefully the drug titration has to be done quite judiciously in such patients. Then another thing is quantification of the pain. Quantification can be easily done with help of available tools like numerical rating scale and visual analog scale. Once we have determined once we have followed the 3 steps, now we can see that mild pain, by definition, a mild pain is a pain on NRS between 0 to 3. Okay, and moderate pain is a pain of 4 to 6 on the NRS, and severe pain is a pain of 7 or more on the NRS. So for mild pain, non-opioid drugs like NSAIDs, paracetamol can be used. For moderate pain, the weak opioids like tramadol, tapentadol can be used, and for severe pain, strong opioids like morphine, fentanyl have to be used. Commonly available opioids in Indian market are codeine, morphine, tramadol, tapentadol, buprenorphine, and fentanyl. Various preparation of these compounds are available. We shall see in little detail a few of them. Codeine. Codeine is basically a prodrug and is converted by cytochrome to D6 into the active form, that is morphine. And important thing to consider is that 7% of the Caucasian and 3% of Asian population lack this enzyme in the liver, and they are the candidates who are less likely to benefit from codeine. So if you have initiated a patient on codeine and the patient is not getting any relief, in that case you can think this part of information can be useful for explaining the things. Then another important thing with the cytochrome P2D6 is that it gets inhibited by antipsychotic drugs like haloperidol, levofloxacin, and antidepressants like amitriptyline and fluoxetine and paroxetine. And all these category of drugs are used quite frequently in palliative care setting may not be as antipsychotics, but for their antiemetic and antidepressant properties. codeine is available in fixed dose combination in tablet form along with paracetamol. Paracetamol strength varies from 500 milligram to 650 milligram, but the codeine strength remains the same in both type of tablets, that is 30 milligram. And codeine is, whenever codeine is to be given, it has to be given 4 hourly, and the maximum dose to be given in 24 hours is 240 milligram. Then I think this much information about codeine is good enough for initiating the treatment with codeine. Then initiation of treatment on oral morphine. As far as palliative care and cancer pain management is concerned, morphine is the reference drug against which all the other drugs are compared. And this is the most easily available and the cheapest preparation available for treatment of cancer pain. And it is available in 2 forms, that is normal release preparation and controlled release preparation. And the one thing to be kept in mind is the treatment initiation has to be always has to be done with the normal release preparation, never with the controlled release preparation. For treatment initiation with normal release, if we are considering an adult patient, the usual dose of normal release preparation is 10 milligram, and it has to be given every 4 hourly. So if we see a 24 hours cycle and we are giving the first dose at 8 AM in the morning, then the next dose would be at 12 PM and so on. At the bedtime, the patient has to be given 2 tablets simultaneously, so that the patient does not have to get up in the night to take the medication. If in between these 4 hours the patient has inadequate pain relief, then the patient can take the same dose of the medication after 1 hour of the previous medication. So suppose the patient has taken one tablet, 10 milligram tablet at 8 AM and is not having good pain relief till 9 AM, then he can take take another pill and then again wait for 1 hour. If the patient achieves good pain relief, then the next dose has to be taken at 12 PM as it was pre-scheduled. If the patient does not get good relief even with the 9 AM medication, then he can take another pill at 10 AM, and but the 12 PM dose has to be taken as usual. The intermittent the dose that is being taken intermittently does not change the fixed the dose that is to be taken at the fixed predetermined schedule. So once we have once the patient has been managed in this way for about a week, and the baseline and the breakthrough pain or the incidental pain has reduced to less than 1 or 2 episodes per day, then we can say that okay, the 24-hour morphine baseline requirement has been determined. And suppose the patient is taking 6 tablets of 10 milligram morphine normal release in 24 hours, then this 24-hour requirement can be divided into 2 parts, that is 30 milligram each, and this 30 milligram can be given in the form of controlled release preparation twice a day. So in this way we can scientifically determine the 24 hours requirement, and then for convenience of the patient, we can convert this dose to controlled release preparation, so the patient does not have to take pills every 4 hours, and this patient can now be shifted to 12 hours regime of controlled release preparation. So this is the way how we determine the morphine requirement, morphine dosing for controlled release preparation. Then Some subgroup of patients may not be in a condition to take medication orally, but they may be having severe pain. In that case, parenteral morphine can be initiated, and the dose conversion from oral to parenteral morphine is such that 30 milligram of oral morphine is equivalent to 15 milligram subcutaneous morphine, and 30 milligram of oral morphine is equivalent to 10 milligram of intravenous morphine. And these parenteral morphine has to be given in the form of infusion and never as a single dose. So if 10 milligram has to be given, it has to be say a 10 normal adult morphine requirement, oral morphine requirement per day is 60 milligram. In that case, the intravenous requirement for 24 hours would be 20 milligram, and so 20 milligram has to be given as a continuous infusion for the drug 20 milligram drug has to be given as a continuous infusion for 24 hours rather than 2 boluses of 10 milligram each. Then another very important thing, after having converted to after having determined the 24-hour morphine requirement, some patients do have compliance issues. They forget to take medicines, and if they skip one dose of morphine, then the blood levels of the morphine would reduce drastically and the patient would have breakthrough pain. If you find that your patient has got compliance issues, these are the patients who are good candidate for fentanyl patches. So fentanyl patches should never be used for treatment initiation. They have to be used only for the sake of convenience of the patient and for compliance issue if the patient is having compliance issues. Right? Okay. So how to determine the adequate strength of the fentanyl patch? So if suppose the patient is requiring 24-hour morphine requirement for the patient is 60 milligram, then divide this requirement by 2.4 to determine the fentanyl strength strength of the fentanyl patch. So 60 milligram divided by 2.4, it is 25 micrograms. So 60 milligram of oral morphine is equivalent to 25 microgram per hour of fentanyl patch. Certain things need to be taken care of when fentanyl patches are being used. Fentanyl patches do not start acting instantaneously. They first form a depot in the subcutaneous and intradermal space, and then from there the drug starts seeping into the blood, and that takes around 4 to 6 hours to happen. So this time of 4 to 6 hours should always be bridged with co-administration of oral morphine as per the schedule that was existing. And second thing is 25% patients require change of patch in less than the expected duration. Expected duration of action for fentanyl patch is 72 hours, but 25% of the patient require change of patch in 48 hours. Okay, so this has to be taken care of during the latter part of the fentanyl patch duration, if the patient is having a poor pain control, then you can think of changing the patch more frequently. Then patients who have been on long-term morphine, when they are converted to fentanyl patch, they may experience withdrawal symptoms. But the special thing about this withdrawal symptom is that it is not associated with pain. So because fentanyl, as we all know, it is highly selective at the mu receptors, and the mu receptors are responsible for analgesia. So once the patient is shifted from morphine to fentanyl, the analgesia part is taken care of, but the other the other actions of morphine, like sedation, the sleep, the effect of morphine on sleep, or other aspects, may not be the patient may have withdrawal symptoms with respect to those symptoms. So this has to be taken care of, and during that time, certain drugs like benzodiazepines may be added if you feel that the patient is having symptoms of opioid withdrawal after initiation of fentanyl. Then one thing that, although not of much practical importance but of theoretical importance, is are the oral transmucosal fentanyl citrate lollipops or the fentanyl lozenges. The most important thing about these lozenges is that they are meant just for breakthrough pain. They are not meant for regular treatment of cancer pain. So breakthrough pain is the pain that is happening, that is occurring beyond the baseline pain. So they are not to be used as a regular medication. They have to be used only for breakthrough pain. And when starting on OTFCs, the dose titration has to be started from the lowest available strength. That is, the 200 microgram lollipop has to be used. It has to be sucked in 15 to 20 minutes, and no more than 2 lozenges for a single breakthrough episode are to be used, and they should not be repeated before 4 hours. So as per my information, these oral lozenges, when I was doing my residency, they were available in Indian market, but because of the poor demand, they have got discontinued. They have been discontinued by most of the companies. But from theoretical point of view and exam point of view, it is a good piece of information that a postgraduate must have. Then another important thing and practically useful is how to switch between 2 opioids. Okay, so 100 milligram of tramadol is equivalent to 10 milligram of morphine. Okay, and 200 milligram of tramadol is equivalent to 50 milligram of tapentadol. Okay, so now the dose conversion can be done if suppose the patient comes to you and says that I have already been taking say 200 milligram of tramadol, but my pain is not controlled. So, and now you want to initiate the treatment with morphine. Okay, so what dose of morphine to start with? So if the patient had been taking 200 milligram of tramadol, so now you know that the equivalent dose of morphine is 20 milligram. So you can initiate the treatment accordingly. One thing to be kept in mind when one is switching from one opioid to the other is that the suppose you have been using say tramadol, and you have been using tramadol for say about 2 or 3 weeks. Gradually, the patient develops a tolerance for the analgesic effect of tramadol. Okay, so once you take a decision to switch the patient from tramadol to morphine, in that case, the tolerance that the patient has developed is partial for morphine as well, but it is only a partial tolerance for morphine, not a complete tolerance. So the patient who has developed a good amount of tolerance for morphine, for tramadol, may not have that much tolerance to action of morphine. So once you are shifting the patient from one opioid to the other, you have to keep this thing in mind, and you have to reduce the dose of the new opioid by about 25 to 50%. I had one incidence with me when a patient came to me, and at that time the patient was already applying a 50 microgram fentanyl patch, and the pain was not controlled. So what I did was I converted the patient to a equivalent dose of morphine, and by our knowledge till now, we know that 50 microgram fentanyl is equivalent to 120 milligram of morphine. I started the patient on 20 milligram morphine every 4 hourly, and the next day, what the patient tells, that the patient's relative tells that the patient has got overtly sedated. So it happened because I missed this particular point. I should have reduced the dose of the morphine that I was prescribing by approximately 25 to 50%. 50% in the more aged and frail patients, and 25% in the more younger group of patients. So had I reduced the dose of morphine by 50% or 25%, my patient would not have got overtly sedated when I converted from fentanyl to morphine. I hope this point is clear, because this is a nugget that I have brought out from my own experience into palliative care. Then another thing of importance is about the buprenorphine patch, because I have seen people using it left, right, and center, and I consider it a useless drug as far as cancer pain is concerned, because the equivalent dose of buprenorphine for the minimum for the usual dose of morphine, the usual dose is considered to be 60 milligram per day. The equivalent dose of buprenorphine for a 60 milligram morphine is almost 34 milligram per hour patch for buprenorphine, which is not available in the market. At least in India, it is not available. The highest strength available in Indian market is 20 milligram per hour, 20 microgram per hour, and in order to achieve the equianalgesic dose of 60 milligram morphine, we need to put almost 1.5 patch on the patient, and maybe 2 patches, and 1 patch of 20 milligram is costing approximately 2,000 to 2,500. So you can anticipate the cost of treatment. Where would the cost of treatment with buprenorphine patch would go? So this thing has to be kept in mind. Okay, fine. If the patient is can afford, you can place 2 patches of buprenorphine if they are available. Then after dealing with opioids, we need to think about, we need to know about certain other adjuvant drugs, which are also called as anti-neuropathic medications, as we have seen that our patient was having a neuropathic component of pain as well. So the number needed to treat neuropathic pain for various drugs which are commonly used for managing neuropathic pain are such that tricyclic antidepressant has an NNT of 3.6. SNRIs like duloxetine, paroxetine, fluoxetine, they have a NNT of 6.4. Gabapentinoids have a NNT of 7.5. Strong opioids have a NNT of 4.3. So we can see that strong opioids and weak opioids, they have a decent response to neuropathic pain. But the best among them are the tricyclic antidepressant. These are extremely cost-effective way of managing neuropathic pain. and they have got certain other advantages like sleep loss. If you give tricyclic antidepressant amitriptyline is in a small dose at night, the sleep of the patient would improve drastically. So these are good the add-on as an add-on medication. These are good for patients who are having neuropathic pain, as well as in patients who are not having neuropathic pain but have other issues, other associated issues like sleep disturbance, or SNRIs can be good adjuvants in patients who are having depressive symptoms. Okay, so these group of drugs are good add-ons. So our discussion would be incomplete if we do not talk about opioid-associated side effects. Most common side effects associated with opioids are nausea and vomiting and constipation. Nausea vomiting is best treated with metoclopramide and haloperidol. Haloperidol is a broad-acting antiemetic in palliative care setting, and metoclopramide is a prokinetic drug with antiemetic effect. Ondansetron, which is the most commonly used antiemetic among us, or for that matter by any clinician, is not the drug of choice because it has got it reduces gut motility and is likely to worsen the constipation that the patient may be having. So ondansetron should not be used as the primary drug for management of nausea vomiting. Constipation is one thing that that would persist all through the treatment while the patient is taking opioids. Nausea vomiting is something that would the patient would adapt and would become comfortable as the treatment with opioid goes beyond 7 to 10 days. But constipation is one thing which does not have any ceiling effect, and it persist till the patient is on opioids. So it has to be taken care of, because if constipation worsens, then the whole idea of management fails. For management of constipation, all the patients who have been prescribed morphine beyond 30 milligram per day have to be kept on stool softener and irritant purgative. Irrespective of whether they have constipation or they do not have constipation, they have to be kept on these medications. Example of a good example is available in the market with the name of Cremafin Plus, which has got liquid paraffin, which is a stool softener, and along with this there is sodium picosulfate, which is a irritant purgative. So while these anti-constipant medications, these are available in the form of tablets and syrups. If we are prescribing tablets or syrups, we have to take into account that these medications take about 8 to 10 hours to act, and so should be prescribed in the night before. Okay. And if suppositories are used like bisacodyl suppository, a bisacodyl suppository acts in 45 to 60 minutes, and so the patient the suppository can be inserted when the patient is scheduled for bowel evacuation. Okay. And another important thing that the patient need to be reassured about is that that the patient will not have urge to defecate daily. And passage of motion once in 2 to 3 days is absolutely normal and not to be worried about. But if the patient is not passing motion in 3 days, then the physician needs to up titrate the anti-constipant medication. Another important thing that now we come to the concept of total pain management. As we as we know that cancer has got so many paradigms, and so are the suffering of the patient also have many paradigms. The main paradigms in which we discuss cancer related pain is the physical pain, physical component of pain, psychological component of pain, social component of pain, and spiritual component of pain. So till now we have dealt only with the physical component of pain. Okay? We have not talked about psychological component of pain. From the scenario that we were discussing, we know that the patient is a young patient. She is just 36, has got small children. So 36 years is not is no age to say goodbye to the world, right? And the person may be having so many aspirations, so many plannings, which are getting destroyed by the diagnosis. So a lot of psychological, the patient must be undergoing a lot of psychological distress. Then social component of pain, as we all know that cancer is, although it is so rampant now in society, but it's a taboo in the society. So a lot of distress is associated with the outlook of the society. Then cancer treatment is quite costly. It drains the finances of the family. So a lot of financial distress also creeps in. Then spiritual pain is one more aspect because once the patient comes to know about diagnosis of spiritual pain, about the diagnosis of cancer, the faith, his or her faith is absolutely shattered, and once the faith is shattered, it leads to a lot of spiritual distress. So all these components of pain are intricately connected, and one component of the pain does have a bearing on the other component of pain. So by managing physical pain, which seems to be the easiest among management of all the other type of pains from medical point of view, but we should not be ignorant about the other component of pain that the patient might be having. Right? We have to be empathetic towards the patient. We have to be patient with the patient. Patients, we need to deal with the patient in an empathetic manner, so that at least we are not contributing to all the other type of pain which may have a bearing on our treatment. So management of other component of pain like social, spiritual, and psychological pain has to be done in a multidisciplinary manner, getting help from a psychiatrist or a psychologist or a social social worker is beneficial in the management of physical pain as well. Then management of cancer pain is emotionally draining for the caregivers also. So keep an eye on the caregivers also who usually accompany the patient, because you may be treating the patient, but another patient may be in the making in the form of a disturbed caregiver, right? Then another thing that to be taken care of is about yourself. Healthcare workers dealing with palliative care have a high chance of emotional burnout, and so you should be taking care of your own mental well-being while dealing with cancer patients. So with this, I conclude my lecture, and the forum is open for any doubt clearance.
Thank you. Thank you, Dr. Anuj. It was a very detailed description. A lot of practical aspects of treatment were explained, and postgraduates get the table viva is there on opioids. We have covered up in this, but a lot of practical tips of drugs was also given. Very, very informative for them. There's a question I would like to share it with you. The person has asked, while switching opioids, should the dose of new opioids be reduced or increased due to cross tolerance? So you're muted. Muted. Please switch on your.
Am I audible now?
Yes, you are audible.
As I told that cross tolerance is there and cross tolerance is incomplete. So while switching the medication, we have to reduce the dose of the drug, which had the dose of the new drug has to be reduced by about 25 to 50%.
Yes, you had in fact shared your experience also.
Yes.
Your practical experience you had shared regarding fentanyl and morphine. So I've had, it was a very, very practically oriented topic, and a lot of theoretical tips were also given. So it was a very good lecture. Thank you for being here with us and being part of this conference. Thank you, Dr. Anuj. I'll hand over to Dr. Nitin now for further proceedings.
Thank you, ma'am. Thank you, sir.
Thank you, Dr. Nitin.
So we'll continue with the next session. For our next session, I would like to invite the chairperson for the next session. Can we have the CV, please? So we have Dr. Kanta Bhati, who will be chairing the next session. Ma'am is a senior professor at Department of Anesthesiology at Sardar Patel Medical College, Bikaner. Her areas of special interest are regional anesthesia, ENT and surgery, anesthesia for ENT surgeries, and dental surgeries. We welcome you, ma'am. I request ma'am to go ahead with the proceedings of the session. Thank you so much.
Thank you, Dr. Nitin. Hello.
Yes, ma'am.
Thank you, Dr. Nitin. I want permission to start next session.
Yes, ma'am.
Is begun. Although it's the end of the very exhaustive day, but both topics are important. The first topic is local anesthesia systemic toxicity. This lecture will be delivered by Dr. Upma Bhatia Batra. She is Associated Professor at LHMC, New Delhi. Her area of interest are airway and USG guided regional block. Welcome, Dr. Upma Bhatia. Over to Dr. Upma Bhatia.
Thank you, ma'am. Good evening, everyone. Thank you, Dr. MD Kaur and team RML for giving me the opportunity to speak on the topic of local anesthetic systemic toxicity. As we all know, local anesthetics, when placed in correct anatomical locations and in recommended doses, give us great clinical benefits. However, adverse systemic reactions related to their systemic toxicity are also not unknown. The incidence has been determined to be around 0.27 per 1,000 peripheral nerve blocks placed. We will go through the following presentation with the aim of getting these learning objectives. So how does the local anesthetic reach the systemic circulation? It may be due to accidental intravascular injection at the time of placement of the block and the patient will present immediately. Or sometimes the local anesthetic may get accumulated over time and the systemic absorption of local anesthetic leads to the delayed presentation. Recent studies have shown that the incidence of delayed presentation of LAST is increasing. So we must monitor the patient for at least 30 to 45 minutes if sufficiently higher doses of LA has been administered. After the drug comes into the plasma, the ester-linked local anesthetics are mainly exist in the free form and they are metabolized by the plasma cholinesterases. Whereas the amide-linked local anesthetics, they bind to the alpha-1 acid glycoprotein and they are metabolized by the hepatic cytochrome P450. As is evident that it is the free form of the LA which is responsible for their clinical effects, and most of the drugs then gets delivered to the organs which are having high perfusion, such as the brain, heart, lungs, and liver. To understand their toxicity, let's have a look at their mechanism of action. They inhibit the intramembranous portion of the voltage-gated sodium channels and leave them in an open position. This leads to the stoppage of ionic transfer and prevents the nerve impulse transmission. They also inhibit the voltage-gated calcium and potassium channels, various protein kinases, and thus impair the intracellular and transcellular membrane, transcellular conduction. They inhibit the mitochondrial metabolism and inhibit the production and stop the production of ATP. They also inhibit the calcium binding ryanodine receptors, which are present in the sarcoplasmic reticulum, thus lead to the decreased sensitivity of myofilament to the calcium. As a result, the rate of depolarization in Purkinje fibers and ventricular muscles of the heart decreases. So does the action potential duration and effective refractory period also decrease. They cause an increase in the conduction time, leading to an increased PR interval and QRS duration. When the local anesthetic levels remain high to a significant levels, they cause direct depression of the spontaneous pacemaker activity, leading to sinus bradycardia and arrest. They also have negative inotropic effect, which is mainly mediated by their interference with the calcium channels, and it is proportional to the conduction blocking property of the local anesthetics. The cardiovascular toxicity is mainly manifested by bradycardia, hypotension, dysrhythmias, various conduction abnormalities, and ultimately cardiac arrest. CNS toxicity is usually initially mediated by mild prodromal symptoms, which include perioral numbness, metallic taste into the mouth, or tingling and feeling of giddiness and vertigo. The patient may develop twitching of facial muscles and ultimately generalized tonic-clonic seizures. The initial symptoms are excitatory in nature because of the inhibition of inhibitory pathways in the brain and increase in concentration of glutamate, which is the excitatory neurotransmitter. But as higher concentrations of LA prevail, they lead to total silencing of neuronal transmission into the brain, and thus ultimately respiratory depression and respiratory arrest ensues. CNS is the system which presents the earliest in case of local anesthetic systemic toxicity, and in almost 50% of the patients, the CNS symptoms are seen, whereas 1/3 of the patients present with symptoms related to both cardiovascular as well as central nervous system, and isolated cardiovascular systems are seen only in less than 1/4 of the patients. Now, a word about the comparative cardiovascular toxicity of different local anesthetics. For this, we have to understand the concept of CC by CNS ratio. This is the ratio of the drug required to produce symptoms of cardiovascular collapse to the dose of the drug required to produce CNS symptoms. The drugs which are having a higher CC by CNS ratio, they have a higher margin of safety with respect to the cardiotoxicity, because early occurrence of CNS symptoms warns the clinician to take appropriate steps to prevent the further development of fatal cardiotoxicity. The differences in the relative differences in the toxicity of LAs is basically mediated by differences in their electrophysiological effects. Bupivacaine binds to the sodium channels in a very tight manner, and the rate of recovery of sodium channels from this blockade is very, very slow when compared to lidocaine and other local anesthetics. So this means that in between the action potentials, the number of sodium channels that are completely available for transmission is very less when compared to the sodium channel, when compared to the block with lidocaine. This may explain that why bupivacaine is having arrhythmogenic properties, whereas lidocaine is also used as an antiarrhythmic drug. Also, bupivacaine-induced ventricular arrhythmias and ventricular fibrillation are more fatal, and reversal with the antidote is more difficult in case of bupivacaine-induced cardiotoxicity. Pregnant patients, as such, more sensitive to the cardiac effects of bupivacaine. So, a concentration of 0.75% bupivacaine has been prohibited from use in pregnant patients in USA. Now, bupivacaine versus pure S enantiomers, that is the ropivacaine and levobupivacaine. Both ropivacaine and levobupivacaine are less cardiotoxic as compared to bupivacaine. This is again due to the faster recovery of sodium channels and less negative inotropic potency of ropivacaine when compared to bupivacaine. The recovery of muscle that has been blocked with ropivacaine and levobupivacaine is also considerably faster than compared with bupivacaine. This may be due to selective inhibition of calcium currents, which is done only by bupivacaine and not seen in the ropivacaine and levobupivacaine. So what are the factors that predispose to the development of LAS? They may be patient factors, they may be the technique of local anesthetic administration, or they may be our practice settings. In case of patients at the extreme of age are more vulnerable to develop local anesthetic toxicity, as is the case of neonates and infants less than 4 months of age. They have low levels of alpha-1 acid glycoprotein, as well as their hepatic enzymatic system is not mature. So the dose of LA should be reduced by 15% in infants less than 4 months of age. In case of elderly, the levels of alpha-1 acid glycoprotein are normal, but it still calls for a dose reduction because of pharmacodynamic derangements. Since the skeletal muscle acts as a reservoir for LA, so patients who are having depleted skeletal muscle mass, they also call for a dose reduction. Pregnant women as such have increased cardiac output and decreased concentration of alpha-1 acid glycoprotein. So in the pregnant females, there is early onset of peak levels of free LA, and the dose of local anesthetic should also be modified in pregnancy. Now, what about the comorbidities? In case of known cardiac disease with conduction disturbances, more cardio-stable local anesthetic should be used, that is levobupivacaine and ropivacaine, rather than using bupivacaine. If the patient is having mild to moderate cardiac disease, no dose modification is required. However, in case of severe cardiac disease or cardiac failure, drug dose should be reduced. Now a word about hepatic disease. If a single shot injection of local anesthetic is planned and isolated hepatic disease is present, no drug modification is required. But if we plan to use prolonged infusions in case of severe hepatic disease and associated other organ disease such as kidney dysfunction or cardiac dysfunction, a dose reduction is required. In case of renal disease, the circulation is hyperdynamic, but the levels of alpha-1 acid glycoproteins are also raised. So there is no need for dose modification unless the patient is also having uremia and metabolic acidosis. Certain metabolic diseases such as diabetes, carnitine deficiency, and isovaleric aciduria also require that the dose should be modified, as is the case with analgesia is increasingly used by orthopedicians for joint arthroplasty in sick and elderly patients. It should be noted that time of onset of peak plasma concentration in these patients varies from 2 to 6 hours. Nowadays, we are also using a lot of ultrasound guided facial plane blocks. American Society of Regional Anesthesia recommends that the dose calculation for this must be based on the lean body weight rather than the actual body weight of the patient. And we should consider the using LA in the dilute concentration or using adjuvants such as epinephrine. Patient should be monitored till 30 to 45 minutes of after placement of the block. In case of topical anesthesia of oropharynx and airway, a lot of LA gets dissipated by nebulization and swallowing by the patient. So a dose of 9 milligram per kg has been recommended for healthy patients. The dose limit for providing tumescent anesthesia for liposuction has recently been reduced to 45 milligram per kg. Intravenous infusion of lidocaine is used to break pain cycle for acute and chronic pain settings. It has been seen that the 11% of the patients have mild CNS signs and around 4 to 15% of the patients have CVS signs. A word of caution about the Byers block. Severe cases of LAST have been seen during the administration of Byers block, even with an inflated tourniquet and up till 30 minutes of tourniquet deflation. So what are the practice settings? It has been seen that around 20% occur outside hospital settings in case of endoscopy suites, bronchoscopy rooms, or in dental clinics and in A&E areas. And in 50% of the cases, physicians other than anesthesiologists are involved. So how to prevent this? Individualized examination of each and every patient with respect to risk and benefit of regional anesthesia and an adequate explanation of the procedure to the patient. Ensure that before placing the block, there is a availability of complete monitoring, intravenous access and oxygen supply. Availability of LAST checklist according as per ASTRA guidelines should be ensured, and all the equipment that may be required for resuscitation after LAST should be labeled as LAST rescue kit and should be readily available. During the placement of block, ensure the availability of ultrasound wherever feasible, and always see that you give a incremental injection and aspirate needle and catheter each time before giving any top-up of the drug. It should be a habit to pay continuous attention to the ECG while placing the drug so that subtle changes in heart rate, rhythm, or QRS morphology can be identified, which might indicate early intravascular injection. This is the guidelines that have been provided by ASRA and they have been modified in 2020. According to them, on the onset of immediately at the onset of local anesthetic toxicity, we must stop the injection of LA and call for help and consider administering lipid emulsion. The resuscitation gets proceeded in the sequence of airway, breathing, and circulation. Control of airway is the must to prevent further hypoxia, hypercarbia, and metabolic acidosis, which will potentiate local anesthetic toxicity. After securing the airway, 20% intralipid emulsion should be started in the doses of 1.5 ml per kg over 2 to 3 minutes, and infusion should be started at the rate of 0.25 ml per kg per minute. If the patient still remains unstable, you can repeat the infusion and double the rate of bolus. This intralipid acts as a shuttle. It carries the local anesthetic from the site of toxicity, that is from the brain and heart, to the sites of detoxification, that is the liver and the skeletal muscle. It also has direct cardiotonic effect and increases the myocardial perfusion, and it also has post-conditioning effects for the ischemic myocardium. Control of seizures is also must. Early control of seizures should be done to avoid development of acidosis. And benzodiazepines are the drug of choice because of their cardiostable profile. If it is not controlled by benzodiazepine, a small dose neuromuscular blocking agent can also be used provided the airway has been secured. Chest compression should be started and continued until return of spontaneous circulation. The treatment of arrhythmias in case of LAST differs from the standard CPR protocol, as we cannot use local anesthetics, beta blockers, or calcium channel blockers due to their myocardial depressant effects. So amiodarone is recommended for the treatment of ventricular arrhythmias, and consider instituting cardiopulmonary bypass because of if the patient still remains unstable even after complete dose of intralipid has been given. Vasopressin is also not recommended because it causes increase in the systemic vascular resistance. If epinephrine is required, it should be used in titrated doses. When the patient becomes stable, lipid emulsion has to be continued for further 15 minutes, and maximum dose of lipid that can be given is 12 ml per kg. Once the patient is stable, observe the patient for at least 2 hours after the seizures and for 4 to 6 hours after the cardiovascular instability. And monitoring after cardiac arrest is recommended as per the clinical situation. So what are the new drugs in our armamentarium with which we can help avoid the local anesthetic systemic toxicity? One is liposomal bupivacaine. This harbors local anesthetic in a nanoparticle carrier mix, which causes slow release of bupivacaine over a period of 96 hours. And only some amount of drug is free, which will provide for initial analgesia. This drug has been approved by FDA for infiltration and for interscalene brachial plexus block only. The care should be taken that after administration of liposomal bupivacaine, no other local anesthetic should be administered for the first 20 minutes, as it will lead to release of excessive bupivacaine from the liposomes. Other drugs such as neosaxitoxin are under trial, and what they do is they bind to the external pore of the known cardiac sodium channels, and they are not known to cross the blood-brain barrier. So it is anticipated that they will be devoid of the cardiac and neurotoxicity while maintaining the local anesthetic effects. Another thing is to target the specific sodium channel isoforms, which are controlling the somatic pain as well as the visceral pain. Also, there may be targeting of the nociceptive fibers, which can lead to selective analgesia without any toxicity. This table depicts the maximum recommended doses of local anesthetics for conduction block in when the drug is used as a sole drug or in combination with epinephrine. So what is our take-home message? Local anesthetic toxicity can occur anytime, anywhere because of the ubiquitous use of LAs. What we have to do is to enhance the early onset of we have to recognize the early symptom onset at the earliest, and we have to improve the awareness of the practicing physicians and to put systems for effective prevention and effective treatment in its place. That's all for today. Thank you.
Unmute, ma'am.
Please unmute yourself.
If there are any questions, the forum is open for discussion.
Ma'am, we can take the questions in the end of the session.
Okay.
Okay. So we can move for next session. Hello. We
Yes,
move to
ma'am.
next. So the next topic is temperature monitoring, and this will be delivered by Dr. P.N. Shivpriya. She is Associate Professor at Dr. RML Hospital, New Delhi. Her area of interest are ultrasound guided regional block and palliative care. Over to Dr. Shivpriya.
Thank you, ma'am. Thank you, Dr. Kanta, ma'am. Good evening, everyone. My name is Dr. P.N. Shivpriya, Associate Professor, Atal Bihari Bajpayee Institute of Medical Sciences and Dr. RML Hospital. So today I'm going to talk about temperature monitoring. This is a little bit theoretical, but a very important topic from exam point of view. So let's start. So body temperature is basically a vital sign, and temperature is the core temperature. It is tightly regulated for normal physiological function. Normal physiological functions function only at a specific temperature range, and this body temperature is not homogeneous. Deep thoracic, abdominal, and central nervous system temperature, that is core body temperature, is tightly regulated, and it is around 37 degrees centigrade plus minus 1 degree. And it is the single best indicator of thermal status. Whereas much of the skin temperature is 2 to 4 degrees centigrade cooler, and it varies markedly as a function of environmental exposure. So why we need to regulate this temperature? Why this thermoregulation? Because the enzymes of the body, they work only in optimal temperature. And that is a basis for all the cellular functions. And moreover, the speed of chemical reaction also varies with temperature. So as we can see here, ranges, normal range is 36 to 38 degrees centigrade. And when it goes down from 32 to 35, it is called mild hypothermia. 28 to 32 degrees centigrade is moderate hypothermia. And 24 to 28 degrees centigrade, heart goes into fibrillation. Whereas when it goes up 38 to 40 degrees centigrade, we call it hyperthermia as a result of fever or exercise. Whereas further, more than that, 40 to 44 degrees centigrade can cause heat stroke with multiple organ failure, even brain lesions. Now, why do we need to monitor this temperature? Especially I'm talking about under anesthesia. So under anesthesia, this temperature monitoring is very important because a thermal imbalance can happen. But hypothermia is more common than hyperthermia. It is much more common. Even mild hypothermia, like 1.5 degrees centigrade to 2 degrees centigrade lower than normal, can cause severe adverse outcomes. Like it can triple the incidence of morbid cardiac outcomes, triple the incidence of surgical wound infection. It can increase surgical blood loss and prolong the post-anesthesia recovery and hence duration of hospitalization. So core temperature monitoring is very important. As I'll just like to mention more about this malignant hyperthermia in case of anesthesia, because it is a very important topic that is related to temperature monitoring. So this core temperature monitoring, it quantifies hyperthermia and hypothermia and facilitates detection of malignant hyperthermia, which is a life-threatening clinical syndrome of hypermetabolism, which involves the skeletal muscle. It is triggered in susceptible individual primarily by the volatile inhalational anesthetic agent and muscle relaxant, succinylcholine, etc. Therefore, anesthetists must be vigilant for perioperative hyperthermia. It may be marked in this case with increase in core temperature at rate of 1 to 2 degrees centigrade every 5 minutes. Severe hyperthermia, like core temperature greater than 44 degrees centigrade, may occur. This hypermetabolism causes increased CO2 production, metabolic and respiratory acidosis, accelerated oxygen consumption, heat production, activation of sympathetic nervous system, hyperkalemia, disseminated intravascular coagulation, myoglobinuria, and multiple organ dysfunction and failure. So the Outcome Research Consortium guideline states that body temperature should be monitored in most patients undergoing general anesthesia exceeding 30 minutes in duration. Body temperature might ideally be monitored continuously. However, 15-minute intervals are probably sufficient in most patients. Core temperature should be measured even during spinal or epidural anesthesia, not only in general anesthesia, because these patients also likely to become hypothermic. Intraoperative core temperature should usually be maintained more than 36 degrees centigrade unless hypothermia is specifically indicated. So these are the nice guidelines, clinical practice guidelines for management of inadvertent perioperative hypothermia in adults. They say we call it hypothermia when core temperature decreases below 36 degrees centigrade. And they have divided the perioperative pathway into 3 phases. Preoperative phase, that is 1 hour before induction of anesthesia. Intraoperative phase, total anesthesia time. And post-operative phase, that is 24 hours after entry into recovery area in the theater suite. They recommend assessing patient for risk of developing perioperative hypothermia before transfer to the operation theater. And anesthesia should be induced only after core temperature is more than 36 degrees centigrade. IV fluids and blood products must be warmed to 37 degrees centigrade using fluid warming devices. Use of forced air warming system is recommended to prevent and treat perioperative hypothermia. Now, what is thermoregulation? Thermoregulation is a mechanism by which hypothalamus regulates body temperature at a stable level in a specific range. Infants regulate their temperature remarkably well, but it is less robust in neonates and elderly. General anesthesia lowers the threshold. Threshold is the temperature at which response is triggered, like vasoconstriction and shivering. General anesthesia lowers this threshold by 2 to 3 degrees centigrade. Anesthetic-induced impairment of normal thermoregulatory control and resulting core to peripheral redistribution of body heat is primary cause of hypothermia in most patients. Neuraxial anesthesia also impairs both central and peripheral thermoregulatory control and is associated with substantial hypothermia. So let us review about physiology of thermoregulation. I'll just cover it fast. So afferent impulses, that is cold signals by A delta fibers, also called cold sensitive cells, and warm signals by unmyelinated C fibers, warm sensitive cells, and also from spinothalamic tracts, that is anterior spinal cord, they reach to hypothalamus, which is the central control. Some central control is also there in spinal cord and brainstem. Control of autonomic response is 80% from core structures, and control of behavioral response is half from the skin surface input. And it gives out efferent response as vasodilation, sweating, vasoconstriction, this capillary and arteriovenous shunt, shivering, also known as behavioral response. So this is the picture showing how the afferent input is coming as cold signal from A delta fiber, warm signal from unmyelinated C fibers, and spinothalamic tract, anterior spinal cord, it reaches to hypothalamus, that is central regulation, and it manages a behavioral regulation and autonomic regulation. In behavioral regulation, it comes like moving from sun to shade, pressing appropriately, voluntary movement, assuming position that oppose skin surface, altering ambient temperature. And autonomic regulation, also called efferent response, like cutaneous vasoconstriction, non-shivering thermogenesis, shivering, vasodilation, and sweating. And thermoregulation under anesthesia, it is little different. As we can see, under anesthesia, the vasoconstriction, non-shivering thermogenesis, it happens way below 35 degrees centigrade, and sweating, vasodilation above 37.5, 38 degrees centigrade. Whereas in normal, these behavioral response, they occur in a tightly regulated manner, 36.5 to 37.5 degrees centigrade. So under general anesthesia, behavioral regulation plays no role as patients are unconscious and may be paralyzed. So they rely on autonomic defenses and external temperature management for thermoregulation. Marked attenuation of autonomic responses exist as most drugs increase warm response and reduce cold response threshold. The interthreshold range increases up to 10-fold from 0.3 degrees centigrade to about 2 to 4 degrees centigrade. Temperatures within this range do not trigger thermoregulatory defense and patients become poikilothermic. Midazolam slightly impairs thermoregulatory control, and painful stimulation can slightly increase vasoconstriction threshold. Therefore, regional or local anesthesia decreases vasoconstriction threshold. Isoflurane and halothane impair thermoregulatory vasoconstriction in infants and children. Propofol and volatile anesthetic inhibit non-shivering thermogenesis. Infants are at further high risk of hypothermia due to large surface area to body mass ratio. Therefore, sweating is the best preserved thermoregulatory defense during general anesthesia. Its threshold is only slightly increased and maximum intensity remain normal. In contrast, vasoconstriction and shivering thresholds are markedly reduced, and efficacy of these responses is diminished even after being activated. So now we come to the point how to measure this temperature. So combination of core and mean skin temperature required to accurately estimate the body heat content, because there is a difference in core and skin temperature. Though temperature can be monitored at various sites, none of the existing guidelines specify the best device or best site to monitor temperature. The site and device selection depend on physician, type of surgery, accessibility of monitoring site. So there are three basic techniques through which the temperature is monitored or measured rather. Those based on expansion of material as its temperature increase, like mercury thermometer. Second, those based on changes in electrical properties with temperature, that I'll discuss later. And third one is those based on optical properties of a material. So mercury in glass thermometers, these are slow, cumbersome, and no longer recommended. Electronic thermometers, they use thermistors and thermocouples that we will discuss later. They are sufficiently accurate, plus minus 0.5 degrees centigrade, inexpensive and most dependable modality. Infrared monitors detect heat given off by radiation and can measure temperature from tympanic membrane and forehead skin, but are less reliable. Thermotropic liquid crystal incorporated in disposable sheets are also available, but less accurate. So we come to electrical techniques. Electrical techniques for measuring temperature can be subdivided into three categories: resistance thermometers, thermistors, and thermocouple. Resistant thermometers operate on the principle that the electrical resistance of metals increases with temperature. These devices most frequently use a platinum wire as a temperature-sensitive resistor, a battery, and galvanometer to measure current, which can be calibrated to temperature. The platinum wire is incorporated into Wheatstone bridge circuit, which accurately measures very small changes in resistance. Thermistor, it is a semiconductor and displays opposite behavior with regard to electrical resistance. When thermistor is heated, its resistance decreases. Thermistors, being solid-state devices, can be manufactured in extremely small sizes and therefore have a fast response to changes in temperature. That is, little heat is needed to increase their temperature. Most of the temperature probes used in anesthesia, from the ones at the end of pulmonary artery catheters to esophageal probes, are thermistors. Physical problems with thermistors are few, like cracked or broken wires lead to high resistance and incorrect temperature readings. More common are poor probe placement and misinterpretation of the resulting value. For example, placing an esophageal probe in oropharynx and measuring airway temperature rather than core temperature. Now, what are thermocouples? They are conductors that generate a voltage in response to temperature gradient. So this is the picture showing various types of thermometers. In middle, it is mercury, as we all know, digital thermometer, and this is the forehead gun thermometer. So there are various sites to monitor temperature. So basically, core temperature can be monitored from these four sites: pulmonary artery, distal esophagus, tympanic membrane, and nasopharynx. It is reliable even during extreme thermal perturbation, as it is less affected by vasomotor and thermoregulatory mechanism. And there are some intermediate sites like oral, rectum, bladder. It is not reliable during rapid thermal perturbation. And then comes the skin surface, considerably lower than core temperature, gives reasonable reflection of core temperature, provided adequate adjustment for core to skin gradient are made. So nasopharyngeal temperature under general anesthesia and tympanic temperature during regional anesthesia are most frequently measured. This is the picture showing how to use the tympanic thermometer. So this is the picture showing heat loss mechanism during general anesthesia. It can be lost by convection, conduction, radiation, and evaporation. So we'll talk about intraoperative hypothermia. There are some high-risk cases in which risk is much higher for hypothermia, like prolonged surgery, extremes of age in infants and elderly, extensive burns, lower preoperative temperature. Already if patient's core temperature is low, then severe trauma and major intraoperative fluid shifts. So during general anesthesia, hypothermia occurs from a combination of reasons. First and foremost is anesthetic induced impaired thermoregulation. That is from core to periphery, the shift. Second is vasodilation. Third, inhibition of vasoconstriction. Reduced metabolic rate by 20% to 30%. Exposure to cold environment, OT temperature, cold cleaning, irrigating fluids, cold intravenous fluids. Heat transfer from human body occurs in 4 ways, as we have discussed: conduction, convection, radiation, and evaporation. Radiation and convection contributes most to the perioperative heat loss. So this under general anesthesia, hypothermia occurs in 3 phases. First phase is initial rapid decrease. Second phase is slow linear reduction. And third is the plateau phase. Like general anesthesia, neuraxial anesthesia also impairs behavioral and autonomic thermoregulation. Core temperature during neuraxial anesthesia decreases by 0.5 degrees centigrade to 1 degree centigrade. It blocks all thermal input from anesthetized regions and reduces vasoconstriction and shivering thresholds by 0.6 degrees centigrade above the level of block. Reduction in these thresholds is proportional to the number of spinal segments blocked. Hypothermia during neuraxial blocks may be as severe as general anesthesia. Analgesics and sedatives also impair thermoregulation during neuraxial anesthesia. And decrease may not plateau since nerve blocks inhibit peripheral vasoconstriction. Hence, under regional anesthesia, patients often do not recognize being hypothermic. So this is the picture showing phases of hypothermia and the duration. First is redistribution phase, in which 0.5 to 1.5 degrees centigrade fall in core temperature in first hour due to anesthetic-induced vasodilation, which causes redistribution of heat from core to periphery. Peripheral temperature increases from 33 to 35 degrees centigrade. And this redistribution depends on core to periphery temperature gradient, which accounts for 81% of temperature fall. Second phase is linear, that lasts 2 to 4 hours and occur because heat loss exceeds metabolic heat production. Rate of fall depends on difference between heat loss and produce and the size of patient. Third phase, that is the plateau phase, occurs after 3 to 4 hours, in which core temperature stabilizes, subsequently remains unchanged since peripheral vasoconstriction causes restriction of metabolic heat to the core. Peripheral temperature and total body heat continue to decrease, so not a thermal steady state. So as we discussed, the high-risk category for hypothermia: extremes of age, hypothyroid patients, myasthenia gravis, and major surgeries with major fluid shifts. So how to prevent this redistribution hypothermia? So preoperative warming. NICE guidelines recommend preoperative warming if temperature is less than 36 degrees centigrade and keeping patient comfortably warm at 36.5 to 37.5 degrees centigrade. Skin surface warming for only 30 minutes before induction of anesthesia has been shown to prevent redistribution hypothermia. Warm patients for an hour before induction using forced air warming system undergoing spinal surgery under general anesthesia, less fall in core temperature and decreased intraoperative hypothermia. The efficacy of pre-warming children by increasing ambient temperature in the induction room and OT to 26 degrees centigrade for 30 to 40 minutes has been found to be safe and effective. And how to manage intraoperatively, that was a preoperative. Now intraoperatively, we can heat the, we can use airway heating, humidification with use of low flow rates and semi-closed circuit. So heat loss by evaporation from respiratory system is minimal, as less than 10% of metabolic heat produced is lost through the respiratory tract. Heating and humidification of anesthetic gases is not very effective in preventing fall in core temperature. And second is the warming intravenous fluids, as large quantity of cold fluids causes significant heat loss. 1 unit of refrigerated blood or 1 liter crystalloid at room temperature can reduce mean body temperature by 0.25 degrees centigrade. At flow rate less than 35 milliliter per minute, warming of fluid is not required in adults. Fluid warming is the only method that produces direct core warming and is recommended for all intraoperative infusion more than 500 milliliter in adults. And according to WHO guidelines, keeping the patient warm is more important than warming blood. Warming of blood is required in settings of large volume transfusion, like in adults, more than 50 milliliter per kg per hour. In children, more than 15 ml per kg per hour. Exchange transfusion in infants and in patients with clinically significant cold agglutinins. Now we'll talk about some fluid warming devices. These are few names of fluid warming devices. Most commonly uses warming cabinets, which is cheap, simple, convenient, safe, and large volumes can be kept preheated and ready to use for massive transfusion, like in patients of trauma, burns, etc. Others are dry warming systems, counter-current heat exchangers, water bath, convective air system, insulators. This is a picture showing fluid warming cabinet. Operating room temperature. Operating room temperature is the most critical factor that determines cutaneous losses through radiation, convection, and evaporation. So room temperature more than 23 degrees centigrade and 26 degrees centigrade is generally required to maintain normothermia in adults and infants respectively. Revised National Accreditation Board for Hospital and Healthcare Provider Guidelines for air conditioning in operation theatre states that required temperature and relative humidity in operation theatre to be 21 degrees centigrade plus minus 3 degrees centigrade and 40 to 60% of relative humidity. Appropriate display of these conditions and minimum of 25 air changes per hour with minimum of 4 air changes having fresh air component is required. Airflow must be unidirectional and downward to the OT table. So cutaneous warming in OT is achieved by passive insulation and active warming. Passive insulation is provided by layer of still air trapped beneath device like cotton blankets, surgical drape, plastic sheets, reflective composites, and sleeping bags, etc. Single layer reduces heat loss by approximately 30%. Addition of extra layers further reduces heat loss only minimally. And active warming devices includes water mattresses, garments, forced air warming system, resistive heating devices, negative pressure water warming system, radiant heaters. Forced air warming systems are most commonly tested, recommended, and used devices for intraoperative warming. So this is a picture showing forced air warming blanket with bare hugger. This is the picture showing warming blanket. And in post-operative period, usually forced air blankets and radiant heaters are used in recovery rooms. Post-anesthesia shivering. It occurs in up to 40% of patients, and usually younger patients. In younger patients, we find it more incidence. And because increased oxygen consumption, raised intraocular and intracranial pressure and cardiac dysfunction can happen. So we have to manage it vigorously. How to manage it? We have to keep the ambient temperature normal by skin surface warming, and pharmacological options are there like meperidine 25 milligram intravenous, clonidine 75 microgram intravenous, Dexmed, magnesium sulfate, tramadol, physostigmine, and mefopam is also used, in which meperidine is time-tested drug. It reduces shivering threshold twice as much as vasoconstriction threshold. And Dexmed reduces vasoconstriction and shivering threshold and is effective, very effective in reducing shivering. Now we come to hyperthermia and fever. Hyperthermia is more dangerous than similar degree of hypothermia. It causes discomfort and increases metabolic demand and cardiovascular stress. Hyperthermia indicates core temperature exceeding normal values. Fever indicates regulated increase in core temperature targeted by thermoregulatory system. Passive hyperthermia results from excessive patient heating without adequate core temperature monitoring. It commonly occurs in infants and children because sweating under anesthesia is less effective in them. It is treated by discontinuing active warming and removing excessive insulation. Fever develops when endogenous pyrogens increase the set point of thermoregulatory system. Fever is relatively rare under general anesthesia since volatile anesthetics and opioids inhibit expression of fever. Perioperative fever can be due to infection, mismatched blood transfusion, blood in fourth ventricle, allergic reactions. Some degree of fever typically occurs after surgery also. Fever is treated by removing the underlying cause, antipyretics, and finally by cautious active cooling. Now we'll discuss some special scenario like cardiopulmonary bypass, in which potential benefit of hypothermia is there in myocardial infarction, organ transplantation, cardiopulmonary bypass, spinal cord injury, intestinal ischemia, neonatal hypoxic ischemia, etc. There is need for systematic approach in patients on cardiopulmonary bypass, generally divided into 3 groups according to nasopharyngeal temperature. Mild hypothermia groups, that is 32 to 35 degrees centigrade, moderate hypothermia group, 26 to 31 degrees centigrade, and deep hypothermia group, that is 25 degrees centigrade. Usually patients are cooled to 31 to 32 degrees centigrade after beginning the CPB, and rewarming begins 10 to 15 minutes before release of aortic cross clamp. The gradient between heat exchanger and nasopharynx during rewarming will be maintained at 2 to 3 degrees centigrade. Next scenario is deep hypothermic circulatory arrest. To facilitate meticulous and complex cardiac procedure, including aortic arch surgeries, total aortic arch replacement is generally performed with DHCA at 15 to 22 degrees centigrade. Despite low temperature, chances of neurological ischemia coexist. Therefore, adjuvant for neuroprotection, pharmacotherapy, and ice cooling of head is done. So basically, we are trying to protect the brain. The rest of the body can deal fairly well with heat and cold, but brain is the most adversely affected by temperature, especially overheating. Thank you.
Thank you, Dr. Shivpriya, for nice presentation.
Thank you, ma'am.
You cover almost all the parts of thermoregulation and maintenance of temperature. That is the standard of care for any surgery lasting more than 30 minutes, both for general and regional anesthesia. And if the organizer permits, then we can take the questions in chat box.
Yes, ma'am. Sure, ma'am.
Okay. The first question is from the...
Yes.
Hello. Hello.
Yes, ma'am. We can hear you, ma'am.
Okay.
Yes, ma'am.
Okay, Dr. Anupama. The question is, what is the significance of CC and CNS ratio for local anesthesia toxicity?
Good evening, ma'am. Basically, the CC by CNS ratio is the ratio between the toxic dose of the drug which causes toxic symptoms in the cardiovascular system to the dose which causes toxic symptoms in the CNS symptoms. So basically, this is used to determine the relative risk of cardiotoxicity between the local anesthetics. A drug which is having a higher CC by CNS ratio means that the CNS symptoms will be there at a very low amount of drug. The CNS symptoms will be seen. So this will basically warn the clinician so that the local anesthetic systemic toxicity is going to occur, and he can take steps to prevent the fatal development of fatal cardiovascular symptoms. So basically the drugs which have a higher CC by CNS ratio are relatively cardio safe.
Yes, like the lignocaine having the more CC and CNS ratio, it is the more cardio stable
as compared to bupivacaine. Yes,
okay, thank you.
Thank you, ma'am. Thank you, Dr. Kumar, and thank you, Dr. Shivpriya.
Thank you, Dr.
Now we have the thank you. We have the result for the second quiz of the day, and the winner for the second quiz of the day is Dr. Avinash. He is PG from Dr. RML Hospital. Congratulations, Avinash. Now we come to the last presentation of the day. It is a drug viva, which will be taken by Dr. Akhilesh and Dr. Nitin. And Dr. Akhilesh is professor in Dr. RML Hospital and ABVIMS. And the area of interest of sir is pain management and airway. And the second person who will be taking the drug viva is Dr. Nitin. He is assistant professor in Dr. RML Hospital, and area of interest is pediatric anesthesia and obstetric anesthesia. And postgraduate students for this session are Dr. Sahiti and Dr. Sarenu. They are the second year PG students in Dr. RML Hospital. Let's begin.
Thank you, Dr. Anupma, for your kind introduction. Moving on with the drug viva on local anesthetics, I have with me Dr. Akhilesh. He is professor at ABVIMS and Dr. RML Hospital. Sir's area of interest are airway management, pediatric anesthesia, and obstetric anesthesia. As postgraduate students, we have Dr. Sarenu and Sahiti, who are second year postgraduate students of ABVIMS and Dr. RML Hospital. So I would request Akhilesh sir to kindly proceed with the drug viva.
Thank you, Dr. Nitin. As you all know that drugs become a very essential and important part as far as the anesthesia exam is concerned. You can get a short note, you can get a long question on the drug, and again, but there is one table for drug viva. So it is very important how you discuss about the drug, how you tell about the drug. So Dr. Sahiti, can you please pick up the vial of lignocaine?
Yes, sir.
Yeah, please describe it.
This is a vial of lignocaine containing, it's a clear aqueous solution, which has the concentration 2%, which has 20 mg of lignocaine hydrochloride, 6 mg sodium chloride, and 1 mg methyl paraben as preservative.
So why it is dispensed as hydrochloride salt?
The lignocaine drug, the local anesthetics per se are less soluble in water. To make them more water soluble, they are dispensed as hydrochloride salts, and it also makes the drug more stable.
So coming on, going back to history, when was the first local anesthetic discovered?
The first local anesthetic discovered is a natural ester. It is cocaine. It is discovered in 1884 by Carl Kohler.
And when was the first synthetic local anesthetic discovered?
The first synthetic local anesthetic discovered was in 1905 by IAD, and it is procaine.
Okay, good. So tell me about the structure of local anesthetic agents, a general structure.
The general structure of local anesthetic agents have two molecular moieties. One moiety is the tertiary amine, which is lipophilic, and the other moiety is the hydrophilic component, which is the aromatic ring. Both of them are connected by a hydrocarbon linkage, which can be either an ester linkage or an amide linkage, based on which the local anesthetic drugs are classified into two groups, the amino esters and the amino amides.
So you had rightly said that there is one lipophilic part and one is hydrophilic part. Lipophilic part is aromatic amine and hydrophilic part is tertiary aromatic benzene ring, and the hydrophilic part is tertiary amine, and they both are linked together with a hydrocarbon bond, and that depends and that divides further into amide and ester group. Okay, can you tell me differences between amide and ester groups?
The amides are more stable than the ester groups. The esters, when they metabolize, they release para-aminobenzoic acid, which causes allergic type of reactions, which are not seen with amides. And the esters have shorter duration of action compared to amides. And amides are metabolized in the liver, and esters are metabolized in the plasma by pseudocholinesterase.
So rightly said that we have ester group and amide group of local anesthetic. The ester groups are short acting, vis-a-vis amide groups are long acting. Ester groups have more incidence of allergic reactions, vis-a-vis amide groups have less incidence of allergic reaction. Coming on to the metabolism part, ester groups are metabolized in the plasma, whereas amide local anesthetics are metabolized in the liver. Can you tell me one ester local anesthetic which is metabolized in liver?
Cocaine, sir, the natural ester.
That is a cocaine. Okay. Nitin?
Sahiti, can you tell me about the mechanism of action of local anesthetics? How do they act?
The local anesthetic drugs act by blocking the nerve impulse conduction in the nerve by selectively binding to the voltage and sodium channels in their inactivated resting state, so that they further do not proceed into the activated states by stopping to achieve the threshold potential. Thereby, the action potential is not generated, thus blocking the nerve impulses.
And how would you define it in terms of ionized and unionized fractions of the drug?
The drug exists either, it has both unionized and the ionized part. Depending upon the relative concentrations of the unionized and the ionized part, the drug has the effect on its onset of action. If the drug is more acidic, it has more unionized part, which causes it easily passing through the bilipid membrane of the cell. So this is how it affects.
Okay, so basically you want to say that the unionized drug is required to pass it across the lipid bilayer for it to act.
Yes. Yes.
Okay. Good. Can you tell me what is CM?
CM is the minimum concentration of the local anesthetic drug, which is required to achieve the blockade. It is analogous to minimum alveolar concentration seen with inhalational agents.
Good.
It is different for different drugs.
Okay. Can you tell me why sometimes we find that there is sensory blockade when we give the nerve block and there is no motor blockade? What could be the reason for that?
This is due to the differential blockade which is seen with the local anesthetic drugs. It happens because the C fibers or small fibers are present in the periphery of the nerve, and they are blocked first. And the motor part of the nerve, the A fibers are present in the center of the nerve, due to which the motor blockade is achieved later. So the sensory is seen first, then the motor.
In the other terms, you can also say that the CM for motor nerves is almost twice that of CM of sensory nerves. So
Yes.
motor nerves require double the dose as compared to sensory nerves to get blocked.
Yes, sir.
So what are the things which affect the absorption of local anesthesia drugs?
There are various ways, sir, in which the first is dosage of the drug, then site of the injection of the drug, addition of various additives, pregnancy.
Okay. So how dosage affect the absorption of drug or action of drug?
The dosage affects the absorption of the drug. We can do it in two ways, sir. You can either increase the volume of the drug or you can increase the concentration of the drug. The concentration of the drug, for example, if you take 0.125% bupivacaine versus 0.5% bupivacaine, the latency is less seen with 0.5% bupivacaine. The same way, if we use 1% lidocaine 30 ml and 3% lidocaine 10 ml, the better effect is seen with 1% lidocaine 30 ml, which shows that higher volume also has better effect.
Okay.
So in this way, we can change.
Okay. What is the maximum dose of lignocaine which you can use as a part of nerve blocks?
There's 5 mg per kg body weight, sir.
And what if we use it with epinephrine?
7 mg per kg body weight, sir.
Okay. And what's the maximum dose of bupivacaine?
3.5 mg per kg. Sir.
Okay.
3 mg per kg. Sir.
3 mg per. It is written somewhere 2 mg, but as far as Miller is concerned, it says 3 mg per kg is the maximum dose of bupivacaine which you can use. Okay, that's the dosage part. Any other factor which affect the action of local anesthetic?
The site of injection, sir.
Okay. How?
Site of injection. The fastest is seen with intrathecal administration, sir, and the highest with the minor and major nerve blocks. And the peak plasma levels are achieved while giving intercostal blocks due to high vascularization. And with bupivacaine, there is prolonged action as there is a large nerve area which comes into contact with large volumes of drug, and slower onset because of the sheath around the nerve.
Yeah, in case of brachial plexus, the slow onset is because we are giving the drug not exactly on the brachial plexus. There is some distance, and the nerve has to follow various, go across various facial sheets, facial layers, and then it reach the nerve fibers. And the prolonged duration is because we are giving a large volume of local anesthesia, so that exposed to large area of brachial plexus nerve. So that's the reason why it has a late onset and prolonged action. Okay. Why there is early onset in case of anorexia use of local anesthetic?
Because of absence of sheath around the spinal cord, sir, and we also give the drug directly near the spinal cord, so there is faster onset of action.
Okay, good.
Anorexia block.
So you have talked about the dosage, you have talked about the site of injection. Any other factor which affects the action of local anesthesia?
You can also add various drugs, sir, like epinephrine, clonidine, dexmedetomidine, and opioids like fentanyl.
Why we add epinephrine?
Buprenorphine. So epinephrine is a vasoconstrictor which causes less drug to go into systemic absorption, due to which more local anesthetic molecules are available to reach the nerve membrane and increase the depth and duration of the anesthesia.
Okay. So you have told that the action of local anesthetic depends on the dosage, on the site of injection, and addition of various agents. So you have talked about epinephrine. What all other agents can be added in the local anesthetics?
Various other drugs like clonidine, dexmedetomidine, dexamethasone, and opioids like fentanyl are also used to increase the duration of the blockade.
Okay, good. Then what are other factors which affect the action?
The other factors are like pH and pKa of the drug, and also the pH of the surrounding medium and tissue in which it is injected.
So how pH is affecting the action, and why we add sodium bicarbonate in the local anesthetic solution when we give the block?
The pK of the drug, the lesser the pK of the drug, the faster is the onset of the action, because the more acidic the drug is, the more unionized form in which the drug is available, which makes it more faster to enter into the nerve membrane, which is bilipid layer, and this causes faster onset. For example, if like medium like inflamed tissues have highly acidic pH, and this causes slower onset of the action of drug.
Yeah. So the thing is that once we add sodium bicarbonate, it increases the pH of the solution and it becomes more close to the pKa. And when the pH is more close to the pKa, we get more of unionized form of a drug. And it is the unionized form of a drug which penetrates the tissues. So that is why adding of sodium bicarbonate helps. Any other factor?
Pregnancy, sir.
Okay, how pregnancy affect?
In pregnancy, the epidural veins are dilated, giving less space in the subarachnoid region, due to which less drug is required to get the action. And also the increased level of progesterone has direct effect on the action of the drugs. Progesterone is seen to have action.
Okay. Any other factor besides pregnancy? Thing is, they say is you can use a mixture of local anesthetic when you are giving a anesthesia through a catheter, because catheter you are not giving the drug as such immediately in a large bolus. So you can use two anesthetics, but you cannot use two anesthetics thinking that both the toxic dose of both the anesthetics. Like you are using lignocaine and bupivacaine for giving nerve block. So lignocaine, if you are using lignocaine, so do not exceed beyond 5 mg per kg. And if you are using bupivacaine, do not